everyone. We are going to start the rapid revision, the remarkable rapid revision of pathology, right? We are having 2 days, today and tomorrow. So today and tomorrow, we are going to take all the high yielding topics of pathology, which are specifically important for FMG exam. So for FMG exam, we have seen the papers of last 10 years, okay, 20 papers, every 6 months we have an exam, and we took out the list of the topic which are ultra important for you to revise before going your exam. So we are going to cover all those topics here one by one, and I just want your attention. If you are attentive, you will understand as well as learn, and we will solve the PYQs related to that topics in the class only. Today only, here only. The only thing I want from your side is 2 things. Number 1, your time. And your time with attention. With attention, you should sit here. Anytime you feel drowsy, you feel sleepy, you just get up quickly, have a cup of tea, coffee, and recharge yourself and come back and we will continue. Okay, so let's continue with this, full energy, full enthusiasm. We are going to finish the pathology. So in the pathology, we are having 3 sections, right? Just a second. In the pathology, we are having 3 sections: general pathology, hematology, and systemic pathology. And we are having 2 days. So the plan is that we are going to cover entire general pathology and if possible, a portion of the hematology today. And tomorrow we are basically completing the hematology and systemic pathology high yielding topics. So let's start with general pathology without wasting any further time. In the general pathology, we are having all these chapters to be covered one by one. Let's start with chapter number 1 and take the important topics from this. Okay, the first chapter I am starting is cell adaptation, cell injury, and cell death. Let's start with this cell adaptation, cell injury, and cell death, the first chapter. I will cover everything, don't worry. Okay, so first chapter is cell adaptation, cell injury, and cell death. Okay, let's start with the first one. So let me tell you what is cell adaptation, what is cell injury, and what is cell death. Can you see this cell? Can you see this cell? Now, human body from head to toe, we are made up of cells. We have millions of cells in our body. Each and every organ is made up of cells. Cell is the structural and functional unit of life. In human body, all the cells are in homeostasis. Normally, all the cells are in homeostasis. You will say, ma'am, what do you mean by homeostasis? A particular cell performs its function particularly. They have a specific structure and they perform their particular function. For example, the cells of the salivary gland, they do the function of the secretion. The cell of the intestine, they do the function of the absorption. No, the cell of the brain, they do the function of the cognition. So they have different functions allotted by the God and they are doing that. That is homeostasis. But whenever any stress acts on the cell, whenever any stress is acting on the cell will do 3 things one by one. The first thing cell will do is cell adaptation. Cell will try to coop up. Cell will try to coop up the stress by doing adaptation. The adaptations are reversible. Once you remove the stress, it will reverse back. Okay. If the stress is continued, the second thing cell will do is reversible cell injury. The cell will have reversible cell injury. Again, if you remove the cell stress, it's also reversible. The third and the last thing cell will do is irreversible cell injury if the stress is continued. Not even on removing the stress, it's not reversed. As the name indicates, it's irreversible. Why irreversible cell injury is not reversible? Because actually, irreversible cell injury is cell death. And once the cell is dead, you cannot make it alive again. So basically, I want to teach you 3 things here. Okay, maybe the session will be 5 to 6 hours long. Today also, tomorrow also. So we are having 10 to 12 hours. Okay, in which we are going to compact the pathology in a super compact way. Okay, so if you have any doubt, please write down in the chat box. If I'm in the middle of the something, after finishing that topic, I will come on here. I will address your doubt. Okay, but if you have any doubt, if you have anything in your mind which you don't understand, please write down clearly in the chat box. Okay, chalo. So I want to teach you 3 things here. The first thing I want to teach you is cell adaptation. Then I want to teach you reversible cell injury. And then I want to teach you irreversible cell injury or cell death one by one. Let's understand the same thing by taking an example. Okay, let me ask you a question. How many hours you study daily? How many hours you study daily? Can you answer? Some students say, ma'am, 5 hours, some say 6 hours, some say 8 hours. So it is 6 to 8 hours the average medical students study. They self-study daily, routinely. So this is your homeostasis. This is your homeostasis. What about the day before exam? How many hours you study? Let me ask the same question. A day before exam or few days before exam? How many hours you study? Some students say, ma'am, 12 hours, some say 15 hours, some say 18 hours, So you are increasing the number of the hours. Actually, exam is acting as a stress. and you want to cope up the stress. You do not want to fail. So you want to survive over the stress. So exam is acting as a stress and you are increasing the number of the hours. That is your adaptation. But that's reversible. I mean, once the exam is over, you will not continue 15 to 18 hours. You will shift back to 6 to 8 hours. So you will shift back to your homeostasis once the exam are over. Okay, don't say 1 hour. Okay, got it, Anna? But what if the exams are continued for 1 month? For 1 month or for 2 months, daily, you are studying for 18 hours. You will become sick. You will have certain diseases because of lack of sleep and all the things, Anna. So that is reversible cell injury. Your body is having certain injuries, but that's reversible. Once the exam is over after 1 or 2 months, you take treatment. Again, it's reversible. It's still reversible. But what if the exams are continued forever? It's continued forever. Is it possible for any human to study for 18 hours forever, ever? After some time, the person will die, and that is irreversible cell injury. So we have understood the 3 types of adaptation by taking an example. So basically, I want to tell you, whenever the stress is acting on a cell, 3 things happen one by one. The first thing happen is cell adaptations, which are reversible. The second thing happens is reversible cell injury, and the third thing is irreversible cell injury. As the name indicates, irreversible cell injury is actually cell death. Okay, there are 2 types of cell death, apoptosis and necrosis. These are the 2 types of cell death that I will teach you in detail. So let's start with cell adaptation. So my topic to teach you is cell adaptation. Okay, how many types of cell adaptations are there? There are 5 types of cell adaptations: hyperplasia, hypertrophy, atrophy, metaplasia, and dysplasia. These are the 5 types of cell adaptations: hypertrophy, hyperplasia, atrophy, dysplasia, metaplasia. What do you mean by that? Hyper means more, plasia means number. So it is increase in number of the cell. Okay, hyper means increase, trophy means size. So it is increase in size of the cell. So increase in number of cell but not size is hyperplasia. Increase in size of the cell but not number is hypertrophy. A matlab absent or reduced. So atrophy, reduction in size as well as number. Okay, reduction in size of the cell, that is atrophy. Metaplasia is transformation of one type of cell to another. If it is squamous, it converts to columnar. If it is columnar, it converts to squamous. And what is dysplasia? Disordered development. It's a pre-malignant condition. So can you see a cell here? Let me show you the 5 adaptations here. You have to learn quickly their examples. That's it. You have learned the 5 types. Now you have to learn their examples. Can you see a cell? This is a normal cell. Please appreciate this is a normal cell. What you can see here, you see, ma'am, still the size is same, but the number is more. Here I can see 1 cell. Here I can see multiple cell. So this one is hyperplasia because the number is increasing. See this cell, here the size is more. Here still 1, here still 1. The cell is 1, but the size is more. So it is hypertrophy. This one is hypertrophy. Here you can see the size is reduced. So it is atrophy. Here it is convert from squamous to columnar or columnar to squamous. So this one is metaplasia. And dysplasia is disordered development. How many of you got it? You got it, the 5 type of the adaptations. Did you got it, the 5 type of adaptations? So let me give you the examples of all of them. So let's start with the first one, hyperplasia. Please learn the meaning of the plasia. Plasia matlab number. It is increase in number of cell, not the size. Okay, you can see here is 1 cell. Whenever there is a stress, it becomes multiple. But the size of them is same. Size of the original cell and all these cells is same. It is only the number which is increasing. Now, hyperplasia is of 2 types, physiological and pathological. So I want you to learn 3 examples here and 3 examples here because you get questions in MCQs in the form of examples. So let me help you to learn the examples. Can you tell me 3 examples of physiological hyperplasia in human body? And can you tell me the 3 examples of pathological hyperplasia in human body? Let's first start with physiological hyperplasia. The 3 examples are in front of you. The first example is the female breast. Okay, this is a female breast. This is the pectoralis muscle. And this is a female breast, any female breast. Okay, now during 3 conditions, okay, these are the cells of the female breast. Let me draw a few cells. Okay, these are the cells of the female breast. Okay, now during 3 conditions, what are the 3 conditions? During pregnancy, during puberty, and during lactation. Puberty, pregnancy, and lactation. The size of the female breast increases drastically. And it's physiological. This one is physiological. It's not a disease. This one is physiological. So you can see the size of the female breast increases drastically during these 3 conditions. Have you ever thought why it increases? Why? Actually, the number, because during these 3 conditions, what is happening now? During these 3 conditions, there are hormones. There are more hormones in the blood of the female. That is estrogen and progesterone. And that is acting as a stress for these cells. So these cells will divide. They will increase in number. They will increase in number, not the size, number. So if there are 10 cells here, 100 cells here. I'm just saying a number to understand. This is why the size of the breast is increasing. So the first example is the female breast. The same diagram shown to you. Give me a thumbs up. Female breast during puberty, pregnancy and lactation, and the stress is the hormones. The second example is the pregnant uterus. Can you see a diagram here? Can you see this is a non-pregnant uterus of a female, and this is the same female become pregnant. So the size of the uterus increases drastically during pregnancy. The size of the uterus increases drastically during pregnancy to accommodate the fetus inside that. Why it is happening? Why it is happening? Now take a biopsy of both of them. See the biopsy here and see the biopsy here. Okay, here you can see the cells which are small and whatever is the number. Here you can see the cells of the same uterus, but it is pregnant. I know this one is non-pregnant and this one is pregnant. Got it? This one is pregnant. Okay, so but here I can see the size of the cell is also increased, and if you count, the number is also increased. So basically the pregnant uterus is an example of physiological hypertrophy as well as hyperplasia. Very important PYQ, repeated many times. So what is the example which is common in hypertrophy as well as hyperplasia? The answer is pregnant uterus, and you repeatedly get questions on that. So you can see, Hannah, this is non-pregnant, this is pregnant. Let's take the slide of both of them. Let's biopsy. So you can see this is non-pregnant uterus biopsy, this is pregnant uterus biopsy. And you can see the size of the cell is also increasing, and if you count the number, it is also increased. So it is the pregnant uterus, number 2. And number 3, the compensatory hyperplasia. What do you mean by compensatory hyperplasia? We know humans have a pair of kidney. We all have 2 kidneys. Okay, imagine if one of the kidneys lost. It is donated, it is having a tumor, it is having a disease, so it is lost. So what about the other kidney? The other kidney will increase in size automatically to compensate the loss. And this is physiological. It don't occur only in kidney, it occur in liver also, in partial hepatectomy. So it is compensatory loss. Here the loss of the organ is acting as a stress. Here in pregnancy also hormones is acting as a stress. So learn the stressor. What is the stressor in each of them? Got it? Give me a thumbs up, everyone. So these are the 3 examples of physiological hyperplasia. Coming on pathological hyperplasia. Can I come on pathological? Now tell me 3 diseases. Pathology matlab diseases. These are not diseases. These are physiological condition. Now tell me 3 diseases where hyperplasia is taking place. You know, in the females, uterus is there, and in the uterus, there are 3 layers. What are the 3 layers? Endometrium, myometrium, and perimetrium, that is serosa. This is endometrium. Okay, you can see this is endometrium. The myometrium is the thickest layer, and outermost is the perimetrium or the serosa. This one is the outermost. Now during menstruation, every 28 days in a healthy female, menstruation take place, and during menstruation the endometrial lining get degenerated and it is lost in the form of the bleeding. The female have vaginal bleeding during menstruation. It's not a disease, it's physiological condition, and the endometrium comes. And again, it regenerates in the next 28 days and again it happens. So it is getting degenerated and shaded in bleeding. This happens normally. Now some females are taking estrogen, exogenous estrogen in the form of some drugs, tablets or food. So estrogen act as a stress for the endometrium. So whenever the female is taking estrogen, it is acting as a stressor. Now what will happen in the same female? See the endometrial lining. There is no change in myometrium and perimetrium. I'm not drawing in that. But the endometrium cells will divide, and they will make a thicker lining of the endometrium. Now such female will bleed heavily. They have heavy bleeding during menstruation also and intermenstrual also. So they present to the gynecologist that, doctor, I'm having a complaint, I'm having heavy menstrual bleeding, and between the menstruation also I bleed. So she is having a thicker endometrial lining and it's a disease. The name of the disease is endometrial hyperplasia. It's a disease. Endometrial hyperplasia, the stressor is the estrogen. So the first example I taught you here, endometrial hyperplasia, the stressor is the estrogen. See the lining of the endometrium in a normal healthy uterus and see the lining of the endometrium here. So these females are bleeding heavily. So this is an example exclusive in females. Now let me tell you example exclusive in males. You know, males have a gland around the urethra of the bladder. Okay, this is the bladder and this is the urethra. The males have a gland. The name of the gland is prostate. Females don't have that gland. Okay, in the prostate gland, you can see this gland is prostate gland. Okay, in the center, there is a opening from which the urethra is passing. This is prostate gland. And these are the cells of the prostate gland. Now sometime in old males, testosterone is more in the blood. Actually, it is dihydrotestosterone. Dihydrotestosterone acts as a stressor for these cells. So basically, these cells will divide. They increase in number. they increase in number, and because they increase in number, the size of the gland increases drastically. And the cells are increasing. So here if 10 cells are there, here 100 cells are there. So basically they will compress the urethra. It will compress the urethra. It will compress the urethra and urine cannot be passed from here. That male will present to the genitourinary emergency that I cannot urinate, or I'm feeling my bladder is full, and sometimes rupture can also happen. The name of the disease is benign prostatic hyperplasia, BPH. This is the name of the disease you have to learn here. So these are the diseases. Okay, so here male, there is the disease that is benign prostatic hyperplasia. Okay, and one disease is common in male and female. One in female, one in male. One is common in both. In the skin, है ना? Have you heard about a virus, HPV virus? नाम सुना है क्या? Have you heard about the name of the virus HPV? Human papilloma virus. It is known as human papilloma virus. Okay, this virus enters the skin cells. In the skin, we have cells that is keratinocytes. Okay, imagine this is one of the keratinocyte of human skin cell, that is keratinocyte, and this is HPV virus, which is entering inside it. So it acts as a stress. Now this cell will divide, and it will form a mass of cells. It will form a mass. The same cell divide, and this one is known as wart. It will produce a nodularity. Can you see small nodules? These are warts because the cell is dividing like anything. So you can see this is the HPV. It is entering in one of the skin cell, and that cell divide and produce a wart over here. So skin warts is the name of the disease. So I am summarizing whatever I taught you till now. I'm teaching you the 5 types of adaptations. I have started the first one. Okay, the first one is the hyperplasia. Okay, remaining I will teach you one by one. In the hyperplasia, I want you to learn 3 examples of physiological hyperplasia and 3 examples of pathological hyperplasia. Okay, tell me the 3 examples here with their stress, and tell me the 3 examples over here with their stress. Okay, here 3 examples I told you. What are the 3 examples I told you here? The first example I told you, female breast. Female breast. Okay, the second example I told you, this is the female breast, yeah, pregnant uterus. And the third example I told you, compensatory hyperplasia. So here the stress during puberty, pregnancy and lactation, the hormones are acting as a stress. Here in uterus during pregnancy, again the hormones are acting as a stress. And here loss of organ, partial loss of organ is acting as a stress. You have to learn the summary. Okay, the details are for your understanding. Okay, in the pathological, again I taught you 3 examples. Yes, very good. What are the 3 examples in the pathological? One in female, endometrial hyperplasia. One in male, BPH, benign prostatic hyperplasia. And the third one is common in both of them, the warts, the skin warts. Tell me the stressor. Here the stressor is the estrogen. Here the stressor is dihydrotestosterone, and here the stressor is human papillomavirus HPV. So how you get the question in your exams? You get a question that BPH is an example of what? Is it example of hyperplasia, hypertrophy, atrophy, metaplasia, like that? You get simple. Warts is an example of what? Pregnant uterus is an example of what? So I told you pregnant uterus is an example of both. Hyperplasia as well as hypertrophy. How many of you got it? How many of you got it? I will share the PDF with the team, and you will get it on the Telegram group and with the team only. Okay. So just understand, PDF will be provided to you. Everyone got it? Say yes if you got it. You have any confusion till now? Let's come on the second type of adaptation, hypertrophy. What's the definition? Here, hyper means increase, trophy means size. Trophy in pathology matlab size. So it is increase in size of the cell, not the number. Increase in size of the cell, not the number. Can you see a cell? This is in homeostasis. Now, whenever the stress is acting on the cell, due to adaptation, it increases in size, but not the number. Here also we have one cell, here also we have one cell. So the size is increased, but not the number. It's also of 2 types, physiological and pathological. I want you to learn 2 examples here and 2 examples here. You have to learn the examples, that's it. Definition you already know. You have to learn the examples. In the end, we will summarize everything. So tell me 2 examples. Let's start with physiological. One you already know, pregnant uterus. I told you it's a common example. So physiological hypertrophy, one example we already know. You can see this is a non-pregnant uterus and this one is a pregnant uterus. Okay, I will take a section here, I will take a section here. So this is non-pregnant, this is pregnant. See the cells here? See the cells here. So cells here are increasing in size as well as number. So pregnant uterus is an example of hypertrophy as well as hyperplasia. We are proving it again. Number 1. Number 2, some of you do gymming. You go to the gym. Some athletes, have you seen some athletes or manual laborers worker? So why you go to the gym? You want to make your biceps, triceps, six-apps. Why? So have you ever thought whenever we do a laborious exercise, why does the skeletal muscle increase in size? For example, this is the bicep of this person. This is the bicep. These are the cells of the bicep. Just suppose it is having few cells. Now the manual work, the manual exercise is acting as a stress. For these cells, it is acting as a stress. So these cells will increase in size, not number. Mind my words. Here, if we have 10 cell, here also we have the same 10 cell. But the only thing, number is same. Here the size is increased. Size is increased. That's why the muscle is increased. Got my point? So the second example is the hypertrophy of the skeletal muscle. So we have two examples here. One is uterus, which is common, and skeletal muscle. Physiological is done. Let's come on the pathological hypertrophy. Can I start pathological hypertrophy? Okay. Can I start pathological hypertrophy? Yes. How many type of muscles human have? Human have three type of muscles. Skeletal muscle, which you have seen already here. Skeletal. We have smooth muscle and cardiac muscle. Skeletal, smooth and cardiac. So smooth muscle and cardiac muscle are coming in the example of pathological. Skeletal muscle is coming in the example of physiological hypertrophy. The remaining two muscles are coming here. Can you see the heart? Can you see the left ventricle of the heart? You know, when the left ventricle pump, it do the systole. The blood comes in the aorta and get distributed in all the organs. Say yes. Okay, Hannah. Now here we have aortic wall. Can you see? Here we have aortic wall from which the blood is coming. Now imagine the person is having aortic stenosis. What will happen? The left ventricle will contract, but the wall will not open. The blood is not going in the aorta, or less blood is going in the aorta. So basically more blood is left in the left ventricle even after systole. Even after systole, the blood is not ejected in aorta. It remains in the left ventricle only, and that will cause us the stress. The increased volume of the blood causes the stress on the wall of the left ventricle. So these are the cells of the wall of the left ventricle. Let me show you the cells of the wall of the left ventricle. This is left ventricle. This is the thickness of the left ventricle, and these are the cells over here. So these cells will increase in size and the wall of the left ventricle become thickened. The name of the disease is left ventricular hypertrophy. So it's a disease. I'm telling you the details just for your understanding. You don't have to learn the details. You have to learn the summary, the examples. So left ventricular hypertrophy, where the stress is more volume of blood in the left ventricle because of aortic stenosis. So that is a disease. Say yes. So it's an example of hypertrophy. Here the cells increase in size, not the number. The second example, let me tell you. Do you know we all have esophagus and we all have stomach? Of course we know. What is the lining of the esophagus and stomach? What is the lining of esophagus and stomach? The esophagus is lined by squamous epithelia. I guess most of you may be knowing. It is lined by squamous epithelia. And the stomach is lined by columnar epithelia. We know that. This is normal. This is normal. Now, have you ever thought why God has given two different lining in the continuation organs? Why? God is great. There is reason behind everything. If we have different lining over here and different lining in the stomach, there may be a reason behind that. It is not ki aise hi hai. It is not like that. Why? The reason is very simple. We have hydrochloric acid, HCl, in the stomach. We don't have HCl in the esophagus. At the junction of esophagus and stomach, we have a sphincter. The name of the sphincter is lower esophagus sphincter. Normally it is closed. Only at the time we eat and we swallow, it opens. Otherwise, it is closed. In me, it is closed now because I'm not eating anything. Okay. So, HCl is present in the stomach. So, columnar lining can bear the stress of the HCl very easily. But squamous is very delicate. It cannot bear the stress of the acid. So, that's why God has given the columnar in the stomach and squamous in the esophagus. Now, in some people, this LES become loose. It become open. It becomes open even without eating. So, what happened to them? The HCl get the reflux. Reverse reflux. It is known as gastroesophageal reflux disease, GERD. That is acting as a stress. So GERD is the stress. What is the full form of GERD? Gastroesophageal reflux disease. So when the HCl is doing the reflux, it is hitting the wall of the esophagus. It is hitting the wall of the esophagus. It is hitting. So because it is hitting the wall of the esophagus, okay, it is hitting. So the lower esophagus, the lining will change from squamous to columnar. It converts from I'm sorry. I was telling you about the metaplasia. This is an example of metaplasia. This is Barrett's esophagus. This is coming in the next metaplasia. Currently, I am teaching you hypertrophy. Sometime what happened, this LES, the cell of this LES become increase in size and it closes it permanently. So even on swallowing, it is not opening. And the name of the disease is achalasia. So we have two diseases, Barrett esophagus and achalasia in the esophagus. Achalasia is an example of hypertrophy and Barrett esophagus will come in the example of the metaplasia. Okay, yes. Metaplasia next step. Filal, I want to teach you achalasia. The next is Barrett esophagus. Here it is achalasia. You can see here LES is opened and here the cell become increase in size, it become closed. it become closed. So here the food can pass, but here food cannot pass. The food cannot pass. So food will accumulate in the esophagus and esophagus will dilate. It is megaesophagus. The name of the disease is achalasia. How many of you got it? Let me summarize till now. Can I do the summarize? Huh? There are 5 types of adaptations. Say yes. How many types of adaptations we have? We have 5 types of adaptations. What are the 5 types of adaptations we have? The first is the hyperplasia and second is the hypertrophy. I taught you 2 till now. 3 more to go. Okay. Now each of them is of 2 types. Physiological, pathological. है ना? This one is also 2 types. Physiological, pathological. I want you to learn the examples because you get questions on that. So learn the examples 3 over here and 2 over here. That's it. Just learn the summary. The details are for your understanding. Ultimately, you have to learn the summary. Okay. Now tell me the examples of physiological hyperplasia. One example is common. है ना? Here also we have pregnant uterus. Here also we have pregnant uterus. During pregnancy, the hormones act as a stress. And pregnant uterus is a common example of physiological hypertrophy as well as hyperplasia. Okay, let me modify it. This one is hypertrophy. Okay, okay. So you tell me, first you should know their definition. And plasia means increase in number, not the size. And trophy means increase in size, not the number. We know it very correctly. So uterus is coming in a common example. Here one more example is female breast during puberty, pregnancy and lactation. And third example is compensatory. Compensatory, loss of the organ. On loss of the organ, there is compensatory hyperplasia. Here one more example we have is athletes. है ना, athletes or the one person who is doing the gymming, that is skeletal muscle. Skeletal muscle, है ना. Now what about the pathological? Tell me the examples of pathological also. Here we have 3 examples. One in female, that is endometrial hyperplasia, in which the female bleed heavily. That is one disease in females. One is benign prostatic hyperplasia in males, where male cannot pass the urine. Okay, and one is common skin warts due to HPV. Here the stress is estrogen, here the stress is testosterone, and here the stress is HPV virus. Learn the stressor. Now tell me the 2 examples in pathological. One is cardiac muscle, one is smooth muscle. Cardiac muscle mein the example is left ventricular hypertrophy. It's a disease. The stressor is the aortic stenosis, which is causing more blood in the left ventricle, which is putting a stress. Okay, and the second example is achalasia. Achalasia in the esophagus. Okay, where the lower esophagus sphincter, the cells inside that closed permanently. They increase in size and they close, they don't open. So it will lead to megaesophagus. Everyone give me a thumbs up. This is a summary till now what I taught you. Now I'm coming on the third type, that is atrophy. Can I start the third type? Here also it is of 2 types. So let's come on the third type. Learn example. That's it. You are going the question either on definition or example. That's it. That's it. You have to understand the example. Don't even learn. Coming on the third type, atrophy. What is atrophy? Reduction in size. Can you see this is a cell? It's in homeostasis. Whenever the stress acting on it, it shrinkage, not is reducing in size. So reduction in size is known as atrophy. It is also of 2 types, physiological and pathological. Okay, so I'm having 4 examples over here and 6 examples over here. So you have to learn the examples. There is no other way. You have to learn the examples. I'm trying to super simplify it by explaining the details. Yes, absolutely right. Hannah, I cannot read your names, but yeah, absolutely right. It is decrease in size as well as number, you can say. Hannah, so increase in size of the cell known as what? Increase in number of cell known as what? And decrease in size as well as number. We have same term. We don't have different terms. It is known as what? So increase matlab hyper. Increase matlab hyper. Okay, hyper. Size matlab trophy. Hypertrophy. And number matlab plasia. So this is hyperplasia. And decrease in size as well as number. It's atrophy. It's atrophy. We don't have the term aplasia. We have atrophy only. Yes. Atrophy. Atrophy is reduction in size as well as number. Absolutely right. Now, let me come on the physiological and then pathological. In the physiological, we have 4 examples. The first, we have a thymus whenever we are fetus, but in adult life, it just disappears. The thymus, it shrink and disappear. So, it's physiological atrophy. It's physiological atrophy. Females have ovary, but after menopause, when the menstruation is stopped at the age of 45 to 55 years, the menstruation is stopped. It is known as menopause. After menopause, the ovaries shrink in size. So shrinkage of the size of the ovary is because of atrophy. Hannah, the third example is the brain. Okay, this is the brain of a young person. This is the brain of the same person when the person becomes old. Now compare the 2 brains. Hannah, I want you to see the gyri and sulci. gyri and sulci. Can you see the elevation, depression, gyri and sulci? Can you see that? Now you see here during aging, when the person become old, the gyri thinned out, the sulci deepens. The gyri thinned out, I can see deep sulci, and gyri are very thin because it is atrophied. Hana? So during aging, the brain get atrophied. Maybe after 60, 70 years, sabke brain, all of our brain will be like this. Currently, my brain is like you only. I'm not very old than you. Okay. So currently we have brain like this, and later on, after aging, so it's physiological. It's not a disease. We cannot stop it. It's aging. So this is the brain. Okay. This is the brain. And fourth is the best example I can give you. I told you this is a normal uterus in a female. During pregnancy, I told you it increases in size because of two things, because of hypertrophy as well as hyperplasia. So there is increase in number as well as size of the cell. So it increases in size. But now the delivery happened. The fetus is out. The delivery already happened. The fetus is out. That is parturition happened. Now what about after parturition? After delivery, after parturition, what happens? It will not remain in the same size forever. No. It will again shrink and become normal size. So after parturition, it is atrophy. So uterus is coming in 3 examples. I say uterus during pregnancy. What is your answer? And if I say uterus after parturition matlab delivery, parturition, the baby came out. So what is the example? So during pregnancy, it is hypertrophy as well as hyperplasia. But after parturition, it is the atrophy. So here increase in size, here reduction in size. How many of you got it? So uterus is coming in 3 examples of the adaptation out of 5. Uterus triple example mein aata hai. Okay. So this is the 4th example, the uterus after parturition. How many of you got it? So I told you the 4 examples of the physiological. Learn the organs. Hana? Thymus get atrophied in adult life. Hana? Brain get atrophied in the old age. Okay. Ovaries in the female get atrophied after menopause. Okay, and uterus get atrophied after parturition. So this is after parturition, this is after menopause, this is after aging, and this is in adult life. So this is physiological, it's not a disease. ये सब में होता है, आप में भी, मुझ में भी, in all healthy humans it happens. That's why it's not a disease. This is physiological, atrophy. Now coming on pathological, I want to give you 6 examples over here. Don't learn the numbers, just hear it. In the exam you have the options. Looking at the options, you can easily recognize. Okay. Now coming on pathological atrophy. Pathologic atrophy. Okay. Now look at this person. This person is chronically ill, or it is having some end stage disease. It is having an end stage cancer. Okay. And the person is unable to eat since last many days. The person is not eating anything. So all the organs from head to toe shrink. And the complete person is shrink like anything. It is known as cachexia. It is known as cachexia. Now, cachexia is due to starvation atrophy. The person is not eating. It is deprivation of the food. And all the organs get atrophied because of deprivation of the food. It is known as cachexia. It is known as cachexia. Now, see the second example. Can you see aorta? Yes. From the aorta, can you see the 2 renal arteries are coming, supplying the 2 kidneys? Okay. See, this renal artery is obstructed. It is having atherosclerosis or it is obstructed. So, this kidney is getting less blood. So, see the size of this kidney is less as compared to this kidney. So the organ which get less blood, not only kidney, any organ which get less blood, it will shrink in size. So this is an example of ischemic atrophy. Here the atrophy occurs because of deprivation of blood. The organ is not getting blood. Here the organ do not get the fluid, it's a starvation atrophy. Here the organ do not get the blood, it's ischemic atrophy. See, yes, if you got it. The second example. Okay, see the third example. Have you seen the polio patients? See the limbs of the polio patient. They are very thin. Why the limbs, arms and feet are very thin? Why? Polio is a disease which is caused by a virus. The virus kills the nerves supplying to the muscles. So the muscles are normal, but the nerves supplying the muscles, they are damaged by the virus. Okay, so this atrophy is known as, in polio, it is known as neuropathic atrophy. It is due to deprivation of the nerve. There is no nerve supply. So deprivation of food is starvation atrophy. Deprivation of blood is ischemic atrophy. Deprivation of nerve is neuropathic. You can get a question like polio is an example of. The answer is neuropathic atrophy. It is neuropathic atrophy. Okay, got it? Say yes if you got it. The second, for example, I'm having a fracture over here. In the humerus. What you will do? You will put a cast and you will ask me, ma'am, do not use this limb for the next 2 months, 3 months. We will put a cast. Once you remove the cast after 2 months, I will find this limb is the thinner as compared to this. Why it become thinner? Initially, these both are equal. But now if I measure the circumference here, it is less as compared to this because I have not used it. For a long time, I have not used it. So if we don't use an organ for a long time, that organ gets shrinked. So it is known as disused atrophy. It is deprivation of the use. If we are not using it, it's disuse atrophy. See this limb, see this limb. This limb is having fracture and it is not used since long. Got it? So this is disuse atrophy. The fifth one, you know, humans have an axis. The first we have a hypothalamus over here. Then we have a pituitary over here. Okay, you can see this is pituitary, and we have three organs. We have adrenal, we have thyroid, and we have gonads. By gonads, I mean ovaries in females and testes in male. So from hypothalamus, there is the TRH, for example. Here we have TSH, which is coming from here. Here we have ACTH, which is coming from here. And here we have FSH and LH, which is coming from here. So these organs will secrete the certain hormones in the blood. This is the complete axis, we know that. Now imagine in someone the pituitary is damaged. The pituitary is non-functional. Either there is trauma, or there is accident, or there is cancer, or congenitally it is hypopituitarism. The God has not given the pituitary. For God to give the pituitary, or it's very small. So these hormones are absent. If these hormones are absent in such a child or a person, the size of these organs is reduced. So they have small adrenal, small thyroid, and small gonads. Okay, so this type of atrophy is due to deprivation of hormones. It is known as endocrine atrophy. You can see if the pituitary is damaged, the adrenal, thyroid, and gonads, they all are small in size. So it is known as endocrine atrophy. It is due to deprivation of hormones. It is seen in hypopituitarism. Say yes. Okay, so this is the fifth. And the sixth and the last one, you can see pressure atrophy. Pressure by one organ to another. For example, can you see? This is the skull. You all can see this is the skull. Now see, this is the meningioma. Can you see the white color skull bone? This is the skull bone, white color. I can see everywhere except this portion. This portion, the white region is absent. Why? The white skull bone get atrophied because it is getting a pressure from the meningioma. Meningioma is a tumor. It is putting a pressure on the skull bone. It gets atrophied. So this is pressure atrophy, and if no cause is known, it's idiopathic. So if deprivation of food, it's starvation. Deprivation of blood, it's ischemic. Deprivation of nerve is neuropathic. Deprivation of use, it's disuse. Deprivation of hormones, it's endocrine, and pressure atrophy. And idiopathic is there. Say yes if you got it. So we are done with three adaptations till now. Out of 5, 3 are done, 2 more to go. How many of you are with me? So first I taught you is hypertrophy. Then I taught you is hyperplasia. Okay. Second we have seen is hypertrophy. And third we have just finished is atrophy. And the fourth and the fifth I want to teach you is metaplasia and dysplasia. Okay. Got it? Anyone have any confusion till now? Okay, so here it is of 2 types, physiological, pathological. We have already seen the 3 examples. I'm not repeating. Here we have seen again physiological, pathological. We have already seen 2 examples. I'm not repeating. Just you have to keep in mind which example is coming here. I want to revise the examples over here. Physiological hyperplasia, atrophy, and pathological atrophy. Okay, I want you to revise here. So I want you to tell me 1, 2, 3, 4 example in physiological and 6 examples in pathological. Can you help me out? Anyone? So what are the 4 physiological? Atrophy of thymus in old age, in adult life. Atrophy of brain in old age. Atrophy of ovaries in females after menopause. And atrophy of uterus after parturition. So you can easily identify. Coming on pathological. If there is no food, it is starvation atrophy. That is example is cachexia. If there is no blood, example is ischemic atrophy. Example is atherosclerosis of the renal artery leading to renal atrophy. Okay. If there is no nerves, okay, it is neuropathic atrophy. Example is polio. Okay. If there is no use, it is known as disuse atrophy. Example is fracture, and we are putting a cast over the fracture. If there is no hormones, it is known as endocrine atrophy. Example is hypopituitarism. Okay. And last is pressure. This is how you have to learn. Coming on the 4th one. How many of you are with me? Coming on the 4th one, metaplasia. Let's start metaplasia. Can I start metaplasia? So let's start the next adaptation, metaplasia. What is metaplasia? It is replacement of one type of adult cell to another type of adult cell. So initially if it is squamous, it get converted to columnar. And initially if it is columnar, it get converted to squamous. Because of adaptation, it is vice versa. So it is of 2 types. Listen. I taught you hyperplasia is of 2 types, physiological, pathological. Hypertrophy is also of 2 types, physiological, pathological. Atrophy is also 2 types, physiological and pathological. But metaplasia is always pathological. It's never physiological. So what are the 2 types of metaplasia? We have 2 types, squamous and columnar. We don't have physiological and pathological. We have squamous and columnar, 4 examples over here, 2 over here. Okay, so I want to teach you metaplasia now. It is not physiological, pathological like others, because it is always pathological. I want to stress this point, highlight this point. But it is of 2 types, squamous and columnar. What do you mean by squamous and what do you mean by columnar? Listen. You have to see, please understand, huh? It's confusing. Please understand. You have to see finally what is formed. What do you mean by finally? Listen, there are 2 options now. Either columnar get converted to squamous or squamous get converted to columnar. There are 2 options. See finally what is formed. Finally here squamous is formed now. So this conversion is known as squamous metaplasia. What is formed finally? That is the name given. That is the nomenclature. Okay. And here finally what is formed? Finally columnar is formed. So this type of metaplasia is columnar metaplasia. We have 4 examples here and 2 here. How many of you got it? How many of you got it? Yes. So please understand the nomenclature is based on what is formed finally. Here squamous metaplasia, you don't even understand ki is it conversion of columnar to squamous, ki squamous to columnar. So see what is formed finally. Based on that we are giving the name. And here columnar metaplasia, finally columnar is formed. How many of you got this concept which I am stressing? Okay. So there are 2 types of metaplasia. We will take them one by one. So let's first take squamous metaplasia. Give me 4 examples of squamous. Rather than reading the text, see them in the form of the diagram. There are 4 diagrams, 4 examples, 4 diagrams. Squamous metaplasia. They all have one thing in common. What is the common thing? They all have columnar epithelia. God has given columnar epithelia in these 4 organs. But because of the stress, they get converted to squamous. They get converted. Now stress is different. Now this thing is common in all of them, but the stress is different. There is 4 stress in the 4 organs. Are you getting it? Are you getting? I'm trying to super simplify it. Okay. Now see the 4 organs. You know, the first organ is the lungs. You know, respiratory tract. The God has given us trachea, bronchi, bronchioles, lung. What is the lining? The complete lining of the respiratory tract is pseudostratified columnar epithelia. The complete lining is the columnar. Now why God has given the respiratory tract? To do the respiration, to do inhalation and exhalation. Like this. Hannah, it is not given for smoking, but unfortunately some people smoke. But it is not given for smoking. Hannah. So some people smoke. Can you see? The smoke is going inside. The smoke. So whenever the person is smoking, the smoke will irritate the mucosa. The smoke will irritate the mucosa. Okay. The smoke is going inside. And because of the smoke, the columnar get converted to squamous. The stress here is the smoke. Smoke is doing this conversion in the lungs and the respiratory tract. Smoking is the stress which is converting columnar to squamous. You can see columnar converted to squamous. The second example is the gallbladder. Do you know what is the lining of the gallbladder? This is a gallbladder. Can you see? Gallbladder is also columnar. Hana. But in some people, the gallbladder have stone. That is calculus. Calculus ka meaning has stone. That will act as a stress here. And it will convert squamous to columnar. It will convert columnar to squamous. Okay. So here the stress is the calculus. Calculus. The thing is same. Columnar get converted to squamous. But the stressor is different. The third organ is the prostate gland in the males. This is the prostate gland in the males. What is the lining? Again, the lining is columnar. And here, the stressor is the inflammation, prostatitis. Due to prostatitis, the columnar get converted to squamous. Here also, due to prostatitis, the inflammation. And the last organ is difficult to understand is female cervix. Let me draw this female cervix on the next page. Can you see this is uterus? Okay, can you see this is cervix? And can you see this is vagina? Now, I'm telling you the lining of the uterus is columnar. We all know. It's columnar, the uterus. The lining of the vagina is squamous. Okay, this one is squamous. We all know vagina is squamous and uterus is columnar. What is the lining of the cervix, which is connecting uterus and vagina? What is the lining? I'm asking you, what is the lining? Does anyone know? What is the lining of the cervix? You see, ma'am, it's both. We divide the cervix into 2 portions. This is known as ectocervix. And this one is known as endocervix. Okay, because it is outside, this is inside. So ectocervix is the continuation of vagina. So this one is squamous. Ectocervix is squamous. Hai and endocervix is the continuation of uterus. So this one is columnar. So in the cervix, we have both lining. We have columnar. So it's an organ which is having both lining. So there is a possibility of both type of metaplasia. Okay. So basically in endocervix, due to some stress, columnar can convert to squamous. So it is known as squamous metaplasia. It can happen in endocervix. And in ectocervix, the squamous can convert to columnar due to certain stress. I will tell you the name of the stress. So in ectocervix, we have columnar metaplasia. Okay, I will tell you the name of the stress also. Now listen the stress. Hana, imagine the uterus is tied with the ligaments. The ligaments are teared. So uterus will prolapse. Hana, the uterus will fall in itself. The prolapse of the uterus will hit the endocervix, not the ectocervix, and it will produce a stress. So this lining will convert from columnar to squamous. So here the stressor is the prolapse of the uterus. And here the stressor is the estrogen and progesterone. Excess of estrogen and progesterone in the blood will change this lining from squamous to columnar. So here estrogen or progesterone is the stress. Got my point? So please, you have to understand. Don't learn. If you know this concept on the spot, you can draw and understand. You have to understand endocervix is an example of squamous metaplasia. And ectocervix is an example of columnar metaplasia. Learn the stressor. In the endocervix, the stressor is the prolapse. And in ectocervix, the stressor is the estrogen. Give me a thumbs up if you got it. Give me a thumbs up. Okay, Hannah, now you don't have to learn. Absolutely, Leo, you don't have to learn. Now you have to understand. This is the basics. Pathology is a subject you don't have to learn at all. Okay, so same thing I have shown. Currently, I am teaching you squamous metaplasia. So I will say endocervix is an example here. Endocervix. Okay, the uterus prolapse is the stressor because of which it is changing. So I taught you 4 organs. Okay, so I taught you, Hannah, all the 4 organs have columnar epithelia, and because of some stress, they get converted to squamous. So there are 4 examples of squamous metaplasia. This is known as squamous metaplasia. This is known as squamous metaplasia. So there are 4 examples. The first example is the lung or respiratory tract. The second example is the gallbladder. The third is the prostate, and third is endocervix. Hannah, now tell me the stressor in all of them. In all of them, the same thing is happening. I'm sorry. In all of them, the same thing is happening. In all of them, this is happening. Squamous get converted to columnar, but the stressor is the different. Hannah. So in lung, the smoke is doing this conversion in the lung. Okay, this conversion is caused by smoke. In the gallbladder, the same conversion is caused by calculus. Hannah, the name of the disease is cholelithiasis. Cholelithiasis. Okay, in the prostate, the same conversion is done by the inflammation, that is prostatitis. Prostatitis, chronic prostatitis or inflammation. And in endocervix, the same conversion is done by uterus prolapse. So basically, the thing is the same in all of them. One thing is happening. Squamous is given by the god, but because of some stress, the lining get converted to columnar. So this is the example of squamous metaplasia. Everyone give me a thumbs up. Can we go ahead? Can we go ahead? So this is squamous metaplasia. Now coming on columnar metaplasia. Can I come on columnar metaplasia? So let's start columnar metaplasia. Here reverse will happen. Hannah. So here God has given squamous metaplasia, but because of some stress, it converts to columnar. So tell me 2 organs in which the God has given squamous metaplasia. Tell me 2 organs. The one you already know, ectocervix. It is squamous metaplasia. And second is esophagus. Basically lower esophagus. Now because of the stress, there is some stress in both of them. The conversion of squamous convert to columnar. The stress is different. In ectocervix, you already know the stress, it's estrogen. I told you because of the estrogen axis, it is happening. This conversion. In esophagus, the stress is the GERD. Gastroesophagus reflux disease. So you can see this is the esophagus. Can you see the lining of the esophagus? See the first diagram normally. So this is my esophagus, this is my stomach. So lining of esophagus is squamous and the lining of stomach is columnar. And there is acid here. But sometimes the acid reflux. Appreciate the reflux here. In the second diagram, appreciate it is refluxing upward. The name of the disease is GERD. Gastroesophageal reflux disease. It's GERD. So the lower esophagus is exposed to acid. So can you see the lower esophagus here? The lining is squamous. The same lower esophagus converted to columnar. So this portion of the esophagus is known as Barrett esophagus. Got it? This is the first example. And cervix I already told you. So learn the cervix in both example. Endocervix is an example of squamous metaplasia and the stressor is the prolapse. And ectocervix is an example of columnar metaplasia. The stressor is the estrogen. How many of you got it? There are confusing MCQs over here. So we are done with metaplasia. So I'm teaching you 5 types of adaptations. 4th one is done. The first I taught you is hyperplasia. The second I taught you is hypertrophy. The third I taught you atrophy. The fourth I taught you right now is metaplasia. And the fifth one and the last one is dysplasia. So the first topic will be complete, and damn sure frequently you get questions on that, either on definitions or on example. So we have seen physiological, pathological over here, here and here. But in metaplasia, we do not have physiological and pathological. We have squamous metaplasia and we have columnar metaplasia. What do you mean by squamous? What do you mean by columnar? Here, columnar get converted to squamous. This is the meaning. And here, squamous get converted to columnar. This is the meaning. So you have to learn the examples. Here we have 4 examples. You already know. Just learn the organ. That's it. Learn the organ. We have lung, we have gallbladder, we have prostate, and we have endocervix. You know, in all of them, there is columnar. Because of some stress, it get converted to squamous. Am I right? Am I right? Huh? I am right. Anna, you know the stressors. Here it is smoke, here it is calculus, here inflammation, here prolapse. Now tell me the 2 organs in which the God has given squamous. It is esophagus and actocervix. Anna, now stress here is GERD and stress here is estrogen. In both of them, squamous get converted to columnar. This is the most simplified version I can tell you. Most simplified version. And these are the heights. No one will tell you more simplified version than that. Okay, coming on the last one is the dysplasia. Can I start the dysplasia? So let's start the last one. The last type of cell adaptation is dysplasia. What is dysplasia? Dysplasia is disordered cellular development. It's a pre-malignant condition. You will say, ma'am, what do you mean by that? We don't understand dysplasia or disordered development. This is dysplasia. Okay. Yes, MCQ discussion will also be there after the topic. Wait. Okay, let me finish this topic, then we will do the MCQ discussion. Can you see the 2 diagrams? You can see the 2 diagrams, the 2 type of the tissues. Okay, this is normal and this one is dysplastic. This is normal and this one is dysplastic. So basically, there are 7 changes which describe dysplasia. If any cell have these 7 changes, I will say the cell is dysplastic. I will show you all 7 here. Don't learn the 7 like this. No, if you read, you will forget. But if you see the diagram, you will never forget. So I will show you all 7 over here. Got it? Now see the first thing. Count the number of the layers over here. Say, ma'am, only 1 layer. But count the number of the layers over here. They are multiple layers. So number of layers, the first thing. Here number of layers is 1. Here number of layers is increased. You can see, rather than learning, see in the diagram. Number 1. Number 2, here the cells are very orderly arranged. Neat, clean, orderly. And here they are very haphazard. Here they are very haphazard, disordered. So second point is arrangement. Here the arrangement is ordered. Here it is disordered. The second point, arrangement is ordered and disordered. Say yes. Okay. Got my point? The second point is that. The third point is the basal polarity. You will say, ma'am, what is basal polarity? See the normal cells. These are the normal cells. This is the basement membrane. Okay. And this side I'm drawing the dysplastic cell. They are haphazard like this. They are haphazard like this. Okay. Now where is the nucleus in them? Where is the nucleus? Here this is the basement membrane. Here this is the basement membrane. Here the nucleus is away. Here the nucleus is towards the basement membrane. Normally, nucleus is always towards the basement membrane. It's not at the center. And here it's away from the basement membrane. It's away from the. So here basal polarity is maintained. This is known as basal polarity. The nucleus is towards the basement membrane. It is maintained. And here basal polarity is lost. Basal polarity is lost because nucleus is away from the basement membrane. So this is, in dysplasia, basal polarity is lost. Learn this. If you understood, it's good. If you didn't understand, learn it. In dysplasia, the basal polarity is lost. So the third point is about the basal polarity. Here basal polarity is maintained. Here it is lost. You can see the nucleus here. They are all towards the basement membrane. And if you see the nucleus here, they are away from the basement membrane. Say yes. So the third point is that. Fourth point is pleomorphism. Pleomorphism means size of the cell. See here, all the cells are same size. So here pleomorphism is absent. But here some are small, some are moderate, some are large. So here pleomorphism is present. So the fourth point is regarding pleomorphism. The fifth point is the ratio, NC ratio. What do you mean by NC ratio? See, this is a normal cell here. I'm drawing. These are the normal cells. I'm drawing only one cell. This is the normal cell where the nucleus is towards the basement membrane. And this is a dysplastic cell. Okay. The nucleus is away from the basement membrane. I want to calculate NC ratio over here and NC ratio. The nucleus in the numerator, the size of the cytoplasm in the denominator. Here you can see nucleus is very small and cytoplasm is very large. And here you can see the reverse. The nucleus is very large and the cytoplasm is small. So here NC ratio is less, here NC ratio is more because numerator is more here. So in dysplasia, the NC ratio is more. Learn that. You can see the same. In all these cells, see the nucleus is very small, but cytoplasm is large. But here you can see the nucleus is the large, cytoplasm is small. So here NC ratio is more. The fifth point is the NC ratio. How many of you got it? Learn the NC ratio. Okay. The next point is hyperchromatism. What do you mean by chroma? The word chroma. Pathology is a language. You know, chroma means color. What do you mean by chroma? The dictionary meaning of chroma is color. See the color of nucleus here and see the color of the nucleus here. If you see the color of the nucleus here, it's light color. And if you see the color of the nucleus here, they are dark. They are compact because the chromatin is compact. So here, hyperchromatism is absent and here hyperchromatism is present. The color is dark. And lastly, here known mitosis, here multiple mitosis. In some of the cell, I can see the spindle formation. So mitosis is present here. So these are the 7 findings which describe dysplasia. What are the 7 findings? Now imagine. Number of layers is increased, yes or no? Yes. Number 2. Arrangement is disordered, yes or no? Yes, the arrangement is disordered. Basal polarity is lost. Pleomorphism is present. Hyperchromatism is present. Mitosis is present. And NC ratio is high. Can you see the features, the 7? Don't learn. In the option, you will get it. I don't recommend you to learn. Just see it so that if it is coming in one of the 4 options, you can pick it. You will get a question, which of the following is a feature of dysplasia or which of the following is not a feature of dysplasia. So if you know these 7, you can easily pick it up. Say yes, respond, people respond. Keep talking, keep saying. Hannah, in the chat box, please writing. Hannah, keep writing, I mean. Okay, what are the 7 features? Increase number of layers, number 1. Okay, disordered arrangement. Arrangement is disordered, number 2. Okay, number 3, the basal polarity is lost. Okay, basal polarity is absent. Basal polarity is lost, but it's okay. One thing is lost, 4 things are present. Hannah, pleomorphism is present. Hannah, hyperchromatism is present. Okay, mitosis is present. Okay, and NC ratio is high. So these are the features. Okay, say yes, everyone got it. This is dysplasia. Okay, this is dysplasia. So now read the question. We are done with the first topic. Now we are not revising. We have done the 5 types of dysplasia. Hannah, all 5 types of dysplasia is done. So now we will solve some question. Read the question and tell me the answer. Read the question. Both hypertrophy and hyperplasia is present in what? The 4 options are in front of you. Is it present in breast enlargement during lactation? Is it present in uterus during pregnancy, skeletal muscle during exercise, or left ventricular hypertrophy during heart failure? Say the correct answer. Everyone, please respond. If you understood, you have to tell me the answer. Yes, everyone is right. The correct answer is pregnant uterus. It is an example of both. The second question is in front of you. Transformation of one type of epithelia to another. It is what? It is known as what? Is it dysplasia, hyperplasia, neoplasia, or metaplasia? What is the correct answer? What is the correct answer? Yes, transformation of one type of cell to another. Yes, absolutely right. It's metaplasia. Either squamous to columnar or columnar to squamous. Okay. All are true about metaplasia except what is not true for metaplasia. Tell me what is false for metaplasia. For metaplasia. Is it slow? Yes or no? What is false? Is it reverts back to the normal with appropriate treatment? Is it irreversible? Or if persist may convert to cancer? What is wrong? What is wrong? It can convert to cancer. Metaplasia can lead to this. It is never irreversible. I told you there are 5 types of adaptation and all 5 are reversible. I told you now there is a cell which is in homeostasis. Okay, if you give the stress, 3 things will happen one by one. I start my lecture from this. First thing is cell adaptation, and I told you all 5 adaptations are reversible. Metaplasia is a type of adaptation and it is reversible. Okay, yes, all adaptations are reversible. Absolutely right. So this cannot be irreversible. So this is wrong. Hannah, all of them are reversible. The next question is very easy. All of the following are adaptations except, which is not an example of adaptation. Hypertrophy, hyperplasia, necrosis, metaplasia. What is not? So hypertrophy is there, hyperplasia is there, metaplasia. But necrosis is a type of cell death. It's not adaptation. So I will cross out. So necrosis is not a type of cell adaptation. Okay. So we are done with first topic. Can I come on the second topic? The second topic is the cell death. Okay. Very important. Here I will teach you 2 topics quickly. Okay. So cell death, I told you all the cells are in homeostasis. This is a cell of human body. From head to toe, it can be any cell. It is in homeostasis. Whenever the stress is acting on the cell, maybe physiological or pathological, 3 things happen one by one. The first thing is cell adaptation. There are 5 types of cell adaptation and we have seen them. They all are reversible. If you remove the stress, the cell will become again normal. Hannah, if the stress is continued, the second thing is reversible cell injury. Okay, if the stress is still continued, finally it's irreversible cell injury. Irreversible cell injury is irreversible. Even on removing the stress, the cell cannot be normal again. No, no, because irreversible cell injury is actually cell death. Once the cell is dead, anyone is dead, you cannot make it alive again. So cell is dead. That is irreversible cell injury. There are two mechanisms. The cell can be dead. The cell can be dead by apoptosis and by necrosis. The cell can be dead either by apoptosis or by necrosis. Hana? We compare apoptosis with suicide and we compare necrosis with murder. Why? I will tell you the details when I will explain you the mechanism. You will understand one is suicide, one is murder. Okay, if suicide or murder, ultimately the person dies. Ultimately, by suicide se mare ya murder se mar to gaya, the person is dying. So it is a type of, the cell is also dying. Either by suicide or by murder, the cell is dying. So there are two ways of the cell death. One by one we will see. Let's start with apoptosis. Let's start with apoptosis. You will say, ma'am, what is apoptosis? I told you simply it's cell death, cell suicide. Cell suicide. Hai na? So here I will tell you what does it mean. So for example, this is the cell. This is the nucleus of the cell. This can be any cell from head to toe in human body. Now this cell want to commit suicide. Hana, you will say, ma'am, why the cell want to commit suicide? First tell me why. Why? I do not want to commit suicide. Why any cell of my body will commit suicide? Why? What's the reason? There can be two possibilities. Either this cell have done its function in the body and it is no more required. The body is giving the signal, you commit suicide, your function is done. Your function is done now. You are not required. You go away. Or the nucleus of the cell, the DNA of the cell is damaged to such an extent that it cannot, persist now. So DNA is damaged beyond repair. It cannot be repaired. So the nucleus is damaged. So this cell has to commit suicide. So because of these two reasons, the cell has to commit suicide. Anna, so this is the reason why the cell is committing suicide. I told you two reasons. Either it is not required or the nucleus is damaged. Nucleus is damaged. Now you will say, ma'am, how does the cell commit suicide? What is the mechanism? How does? Okay. How does it commit suicide? How does it commit suicide? Okay. So what is the mechanism? You will say, inside the cytoplasm of the cells, there are certain enzymes. The name of the enzyme is caspase. Hana, this caspase is present in our cell from head to toe in all the cells, but it is inactive. Normally, it is inactive. It is not active. When the cell receives the signal for the suicide, when the cell will receive the signal that you have to commit suicide, at that time, the caspase will become active. The caspase will become active. Okay. Once the capsases are active, what does they do? They convert the entire cell into multiple small cells. They convert this cell into multiple small cells. These are known as apoptotic bodies. Each apoptotic body contains a small portion of cytoplasm and a small portion of nucleus. The complete cell is converted into small cell. These are known as apoptotic bodies. During the entire process, there is no leakage of cytoplasm outside. No leakage outside. There is no leakage. Since there is no leakage, inflammatory cells do not come to know that anything is happening. So there is no leakage, there is no inflammation. There is no leakage, there is no inflammation. In the end, a phagocyte will come and engulf all of them. A phagocyte will come and engulf. So basically the cell disappeared from the body, disappeared from the world. Chup chop, silently. Nobody come to know that the cell disappeared. Suddenly the cell disappeared. Okay, it is not causing shore sharaba. It is not shouting. It is simply quietly because there is no leakage and no inflammation. That's why I said it's suicide. Imagine a person want to do suicide. Person will not take a mic or loudspeaker and announce everywhere, oh, I'm committing suicide. No, it's a silently done in a closed room, silently without knowing anyone. So it is like the suicide because there is no leakage, no inflammation. In contrast to necrosis where the cell burst. So the cytoplasm leak out everywhere and it caused the inflammatory cell. So in necrosis, the leakage is present, the inflammation is present. If someone is murdered, the person will shout, help, 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 and accumulate everyone. So that's why I compare the necrosis with the murder. Because leakage is present, inflammation is present in necrosis. But here there is no leakage, no inflammation. Okay, one more difference between them. Suicide is done by one person. It is not the complete village is doing the suicide. So apoptosis is always done by a single cell. But murder can be done of a multiple person at the time. Necrosis is always a group of cell. Okay, so apoptosis is of single cell, necrosis is a group of cell. In apoptosis, no leakage, no inflammation, it's silent. In necrosis, there is cell bursting, there is leakage, there is inflammation. Say yes. So that's why I compare apoptosis with suicide and I always compare necrosis with murder, although both of them are the type of the cell death. One is suicide, one is murder. How many of you got it? How many of you got it? Okay. Yes. So this is apoptosis. I'm teaching you apoptosis. So the main thing is there is no leakage, no inflammation. The caspase get activated. The main enzymes are the caspase. They convert the cell into multiple apoptotic bodies. In the end, a phagocyte will come and engulf all of them. There is no leakage, there is no inflammation. What is the mechanism of apoptosis? What is the mechanism of apoptosis? Can you tell me the mechanism of apoptosis? There are two mechanisms of apoptosis. Listen. Extrinsic pathway, intrinsic pathway. It's very interesting. Extrinsic pathway and intrinsic pathway. What do you mean by that? Now this is the cell. This is the nucleus of the cell and this is the DNA of the cell. Now there are two possibilities. Either the cell is receiving the signal from outside that you have to commit the suicide. If the signal is coming from outside, it's extrinsic pathway. Extrinsic matlab outside. Extrinsic. The signal is coming from outside. Sometimes the nucleus get damaged and nucleus only giving the signal to the cell that you commit suicide. So signal is coming from inside of the cell. Here the signal is given by the nucleus only. It's the inside of the cell. That's why known as intrinsic pathway. So extrinsic pathway, the signal comes from outside. And in intrinsic pathway, the signal comes from inside. So first understand the extrinsic and intrinsic, the meaning of that. In extrinsic pathway, the signal comes from outside. And in intrinsic pathway, the signal comes from inside. Please understand it and learn it. Say yes. Now in each of them, there are two phases. Initiation, execution, initiation, execution. There are two phases. Listen. Now I will teach you 3 movie stories based on which I will explain you this. Okay. First, I will teach you the initiation of extrinsic pathway. Okay. I will leave the movie at intermission. Okay. The second half I will tell you later on. Then I will teach you another story, that is initiation of intrinsic pathway. Okay, then again I will leave at the intermission. Okay, then I will combine the 2 intermissions together and make a third story. The third story, that is execution. I mean, execution is common for both of them. I will combine the 2 stories together and make a third story, that is execution. So I hope you got it, what I mean to say. So initiation is different for both of them, but execution is common for both of them. Give me a thumbs up on this point. Give a gesture that you are getting it, because I'm too fast. You know, every time I cannot ask you, samajh mein aaya, you got it. So whenever I'm giving you a concept, give a thumbs up that you got it. Or if you have any doubt, vice versa, write down that, ma'am, please repeat. Okay, so it will be in a good way. Okay, G, can we go ahead? Yes. So see, the signal is coming from outside, the signal is coming from inside. In each of them, there are two phases: initiation, execution, initiation, execution. Initiation is different in both of them, but execution is common in both of them. So let's do the initiation of both of them and then come on the execution, which is common. So let's start. Okay. Let's start from initiation of the intrinsic pathway. I will continue in the English only, Rosanna, because there are many students here which don't understand Hindi, but I think the English is very simple and you can easily understand it. I'm not using any difficult vocabulary and words here. So English is very simple and any student can easily understand it. So just pay attention. Okay, listen. So coming on the extrinsic pathway, the initiation of the extrinsic pathway. Okay, extrinsic pathway initiation phase. Okay, can you see a cell? Yes, this can be any cell of human body from head to toe. This can be any cell. Now in human body, there are many cells. The cells have death receptor on their surface. Can you see the red color receptors? These are death receptor. They're inactive. We have it on our cells. These are death receptor. Whenever they become active, the cell will commit suicide. That's why known as death receptor. So currently they are inactive. So it can be any cell of mine from head to toe, and it is having death receptor which are at a distance from each other. You can see. You will say, ma'am, what is the name of these death receptor? What is the name of these? There can be 2 types of death receptor. There can be 2 types of death receptor. Fast, which is known as CD95. It's a very important PYQ. And second is TNF. Fast and CD95 is one and the same thing. Fast, CD95 or TNF. It can be any. It is a death receptor. Now this cell has committed its function in the body. It has already committed its function in the body. It is no more required. So the body is giving the signal to the cell, please die, please commit suicide. We do not require you more. Your function is done. Your function is done in the body. Okay, got it? So the signal is coming from outside. See, it is coming from outside in the form of the ligand. That's why I'm proving its extrinsic pathway, because the signal is coming from outside. In intrinsic, I will show you it will come from inside. Here it is coming from outside in the form of the ligand. Let me zoom this diagram. Can I zoom it? Okay, this is the zoom version. Okay, you can see this is the ligand. It is coming and binding with the death receptor. So once the ligand will come and bind on the surface of the death receptor, multiple death receptor come closer. Multiple death receptor come closer. See, the ligand is coming, binding with the death receptor. Multiple death receptor come closer and they form a domain. It is known as fast associated death domain. What it is known as? Fast associated death domain, FADD. Now in the cytoplasm, how many caspase we have? You see, ma'am, we have many caspase. Caspase 1, 2, 3, 4, 5, 6, 7, 8. Multiple caspase. Because of the formation of this FADD, caspase number 8, and you can write 10 also. 8 and 10 become active. Caspase 8 and caspase 10 are the first two caspase which get activated in extrinsic pathway. It's a PYQ. You have to understand it. You have to learn it. Okay, got my point? So caspase number 8 and 10 got activated. You will say, ma'am, what's ahead? How this cell will... So this is intermission. This is intermission or climax of the movie or intermission. The later half I will tell you in later on. So this is the thing which I taught you right now. Fast ligand is coming, binding with the fast receptor. Multiple fast receptor come closer and they form a domain which will activate 8 and 10. Caspase 8 and 10. Now, coming on intrinsic pathway. Yahan se I will continue the story in execution pathway later on. Hai na? So there are two mechanisms, extrinsic, intrinsic. Each of them have initiation, execution, initiation and execution. So I just finished the initiation. I'm ending the story at activation of 8 and 10. I will continue here later on. But let me tell you one more story, the initiation of the intrinsic. Then I will combine the two stories. Hai na? So let's come on the initiation of the intrinsic. Initiation of the intrinsic pathway. See a cell in front of you. I want you to see this cell. It's a normal cell. It can be any cell of my body. Okay. It is having the nucleus. Inside the nucleus, it is having the double-stranded DNA. All my cells have this. Hana? We all have mitochondria in all the cells. The mitochondria have two membranes, inner and outer. Between the two membranes of the mitochondria, there is a molecule. The name of that molecule is cytochrome C. Cytochrome C. It is present between the two layers of the mitochondria. It is always present there. Hana? If it comes out, no, the cell will commit suicide. The cell will do the apoptosis. So you will say, ma'am, who is preventing cytochrome C to come out? Because mitochondria have the door, no? It is having the exit. Why not cytochrome C come out of that door? Now see, let me zoom out. Let me zoom out. Can you see here the mitochondria? Concentrate on the mitochondria. Concentrate on the mitochondria. You can see in the mitochondria, this is the transit of the mitochondria. It is known as mitochondrial transit. By mitochondrial transit, I mean the door, darwaza, door. So my question to you, why not cytochrome C come out of this door? By walking, it is coming out. Why? Who is preventing? There are three guards. Teen chowkidar hai. There are three guards who are sitting here. Jo usko danda maar ke andar karte hain. You just go inside, you cannot come outside. There are three guards. What is the name of these three guards? It's BCL2, BCLX and MCL1. These are the three guards. These are known as anti-apoptotic proteins. Anti-apoptotic proteins because they are preventing apoptosis. They are closing the door. These are anti-apoptotic proteins. They are closing the door. They do not allow cytochrome C to come out in a healthy cell. In a healthy cell, they do not, allow the cytochrome C to come out. Right? Now, imagine the DNA is damaged. Till now, the DNA is okay. It's healthy. But imagine the DNA got damaged due to physical, chemical or biological agent, any agent. This DNA got damaged. Oh my God. The P53 will try to repair it. But if it is beyond repair, the DNA will give the signal to the mitochondria that I am gone. Please commit suicide. This cell cannot survive now because I am gone. Nucleus ke bina cell thodi survive kar sakta hai. There is no cell which can survive without nucleus. So this cell has to commit the suicide now. Okay, now see the signal is coming from inside. It is not outside. That's why it is intrinsic pathway. The signal is coming from inside, not outside. That's why it's intrinsic pathway. As soon as mitochondria receive the signal, the intrinsic signal, mitochondria will do the change of duty of the guards. Hana? Initially, we were having these three guards which closes the door. Hana? Now, these guards are replaced by another four guards. They will open the door. What is the name of those guards? It's box, bark, BIM and BAD. You get question on that. Okay. So these are replaced. These are known as pro-apoptotic proteins. So anti-apoptotic proteins are replaced by pro-apoptotic. On receiving the signal, anti-apoptotic are replaced by pro-apoptotic proteins. They will open the door. They will open the door. Cytochrome C will come out. Once they open the door, the cytochrome C is leak out and come out. Once the cytochrome C will come out, now in the cytoplasm, there are many caspase 1, 2, 3, 4, 5, 6. There are many caspase. One of them is pro-caspase 9. It's inactive. Pro-caspase 9 is always in association with APOF1. They are best friend. They travel together. They are the best friend. APOF1 is apoptotic activating protein. Now there is a rule. Till they are together, no one can activate pro-caspase 9. If you want to activate it now, you have to break the pair. You have to break the pair, then only pro-caspase 9. Once it is alone, it will get activated. Till it is with APOF1, it will not get activated. So what does the cytochrome C will do? Cytochrome C will come और ये APOF1 को पटा के अपने साथ ले जाएगा. You come with me. I'm a better friend. You leave pro-caspase 9. It's not a good person. I'm just telling you a story. You just come with me. You do friendship with me. You leave pro-caspase 9. So this cytochrome C is taking APOF1 with him. And pro-caspase 9 become alone and it will become activated. So caspase 9 is the first caspase which get activated in intrinsic pathway. It's also PYQ. Caspase 8 and 10 are the caspase which get activated there. Okay. And caspase 9 is the caspase which get activated here. So what I taught you, as soon as there is DNA damage, The anti-apoptotic are replaced by pro-apoptotic. Anti-apoptotic are replaced by pro-apoptotic. Anti-apoptotic is BCL2, BCLX and MCL1. They are replaced by Bach's bath Bimbach. So learn the examples. You get many questions. Who is anti-apoptotic? Who's pro-apoptotic? Once the pro-apoptotic are there, they open the door. They increase the permeability. They increase the transit. Cytochrome C will leak out. You have a question on cytochrome C also. Once it come out, it will take APOF1 with him and caspase 9 will get activated. Caspase 9 will get activated. Okay. Now you'll say, ma'am, what's ahead? Aage kya? Now let's combine the two stories together. It's time to do the execution, which is the convergence point of both the pathways. Now, what we have learned in extrinsic pathway, in extrinsic pathway, caspase 8 and 10 were activated because of the death receptor, CD95, where the signal was coming from outside. And in intrinsic pathway, it is a caspase 9 which is get activated because of cytochrome C. So from here, caspase 8 and 10 are the first caspase which get activated. In extrinsic pathway, it's the PYQ. In intrinsic pathway, caspase 9 is the first caspase to get activated. It's the PYQ. Now, they both will activate 367, the next caspase. And they will activate all other caspase. Ultimately, all the caspase are activated. Can you see a cell? Can you see a cell? In the cell, all the caspase are activated. In the cell, all the caspase are activated. All the caspase 1, 2, 3, 4. Ultimately, they all are activated. Now, either by extrinsic pathway where the signal will come from outside, or by intrinsic pathway where the signal will. Ultimately, summary is that they all get activated. So all the caspase convert the cell into multiple small apoptotic bodies. Multiple small apoptotic bodies are formed. In the end, a phagocyte will come and engulf all of them. Okay, in the end, a phagocyte is coming and engulfing. So the cell is disappeared from the world. We are done with the mechanism of apoptosis. You get many questions on that. How many of you got it? I want a thumbs up from each of you. Whosoever is live. You got it? Either give a thumbs up or write down your doubt. Do one thing, but react. Reaction is important. Do something. Okay. So tell me, you got it, everyone? PYQ means previous year question. CT, it's previous year questions in the FMG I'm talking about. It's PYQ, previous year questions. So we have seen the previous year questions of the last 5 years, 10 years, and we have seen the topics which are important and which questions are repeatedly asked. Okay. I guess you all are learning well. Very good. Very good. Okay. So let me tell you the morphological features in apoptosis. Okay. Can I tell you the morphological features in apoptosis? There are 6 morphological features in apoptosis. You have to learn them in a sequence. Okay. You have to learn them in a sequence. You have to understand them in diagram. It's very easy. See, this is a normal cell. This cell is a normal cell. It's a normal cell. Now it want to undergo apoptosis. Either by extrinsic pathway or intrinsic pathway, the morphological features are same. Extrinsic, intrinsic, the morphological features are same, Got it? Now this is a normal cell. The first thing it will do is shrinkage. There is cell shrinkage. The cell gets shrinked. The first thing. You can see in the diagram also. It's a question. The earliest feature in apoptosis is cell shrinkage. Now the cell have organelles inside that. No? The cell have endoplasmic reticulum, ribosome, mitochondria, many organelles. If the cell gets shrinked, all the organelles come closer. They become compact. Since the organelles come closer, they become compact. The cytoplasm look more pink in color. So the second feature is eosinophilia, which is due to cell shrinkage only. Once the cells get shrinked, the organelles come closer, and that's why the cytoplasm become pink in color. That is known as eosinophilia. So the second thing is eosinophilia. Yes, I will summarize in the end. Okay, I will summarize both the mechanism including morphological. Let me finish it. Okay, got it? So second is eosinophilia. The second feature. The third is the nuclear feature. See the nucleus here. Now the nucleus become more compact, more blue in color. It is known as pycnosis. Pycnosis is compactness of the nucleus or condensation of the nucleus. Condensation or compactness of the nucleus. That is pycnosis. After that, the nucleus becomes fragmented into multiple pieces. The nucleus becomes fragmented. The fragmentation of the nucleus into pieces, it is known as karyoraxis. So first there is pycnosis and karyoraxis. They together are known as nuclear features. The third, pycnosis and karyoraxis. You must understand their definitions also. What is pycnosis? What is karyoraxis? After that, on the cell membrane, multiple small blabs are formed. Can you see? These are the blabs. Blabs are formed. Blab formation. Now each blab will carry, it will separate from the main cell. It will separate from the male cell and from a small body. Each blab separate hote jayenge. They will carry a small portion of the cytoplasm and nucleus with them. So multiple small apoptotic bodies are formed. In the end, a phagocyte will come and engulf all of them. So these are the 6 features. These are the 6 features. Okay, got it? Got it or didn't got it? So tell me the 6 features. Who will tell me the 6 features in a sequence? Tell me the 6 features in a sequence. What is the earliest feature? Say, ma'am, cell shrinkage. The first thing is cell get shrink. Cell shrinkage. The second is eosinophilia. The second is eosinophilia. The first cell gets shrinked, then the cell organelles come closer, eosinophilia, then nuclear features. Pycnosis, that is condensation of the nucleus, and karyoraxis. The pycnosis and the karyoraxis, that is fragmentation of the nucleus. Then bleb formation. Now each bleb will separate and form an apoptotic body. And finally there is phagocytosis. Now these are the 6 features you can see. You get 3 questions over here. Let me ask you the 3 questions. The first question, earliest change. Everyone can see what is the earliest. It's a very important question, earliest. The last step of apoptosis, it's phagocytosis. Everyone know last. All apoptosis end at phagocytosis. So everyone knows the earliest, everyone know the last. The third question, the specific feature or characteristic feature of apoptosis. So what is specific or characteristic among the 6? So specific or characteristic is the nuclear feature. So specific or characteristic change is the nuclear feature. These are the 3 questions over here. This is the 3 questions over here. Say yes if you got it. So please learn all 3 questions. What is the earliest feature? What is the last feature? What is the specific or characteristic feature? I'm coming on the marker. Wait a while. I'm coming. Okay. Can we go ahead? So please learn these 6 features. Okay. Now coming on the diagnosis of apoptosis. There are 2 ways to diagnose. Finally, apoptosis is over. There are 2 ways of diagnosis of apoptosis. Can I tell you the 2 ways? Okay. Okay, ma'am, you forget, but you have to learn. Chalo. There are 2 ways to diagnose the apoptosis. For example, if I'm giving you a slide, H&E slide, and it contains many cells, it contains hundreds of cells or thousands of cells on that. And if I'm asking you to identify the apoptotic cell, you see under microscope, now you have confusion which cell is apoptotic or which is not apoptotic. There is a marker available. So what do? The name of the marker is annexin 5. Annexin 5 is the name of the marker. You spread it over the slide. Over this only, and after that keep it there for some time and then wash it. Only apoptotic cell will take that marker. Other cells will not take that marker. Now watch it, see it under the microscope. You will see apoptotic cell get highlighted and other cells are not highlighted. So who is the marker of apoptosis? It's annexin 5. It's the question. Annexin 5. Okay. Annexin 5 is the marker of the apoptosis. It's the apoptotic marker. You have to learn. It's also a question. Now you may be thinking, ma'am, why only apoptotic cell is taking annexin 5, not others? So I have to draw the diagram. Can you see this is a normal cell membrane? This is a normal cell. And during apoptosis, it is forming the blebs. So this is an apoptotic cell. Normal cell have a phospholipid on the inner surface of the cell membrane. Okay, inner surface of the cell membrane. It is known as phosphatidylserine. What is it known as? It is known as phosphatidylserine on the inner surface of the cell membrane. But during apoptosis, there is flip-flap, ulta-pulti. There is flip-flap of the cell membrane. So inner membrane become outer, outer become inner. So basically phosphatidylserine comes on the outer side. Now you spread annexin 5 over both of them. Annexin 5 form a bond with phosphatidylserine. So it cannot bind here. It will bind here. So that's why it highlight only apoptotic cell, not others. So principal is phosphatidylserine. You can see same in the diagram. Can you see here? The cell membrane of the 2 cells, the normal cell and apoptotic cell. This is a normal cell and this is a apoptotic cell. See where is phosphatidylserine. Here phosphatidylserine present on inner side. So annexin 5 cannot bind. And here flip-flap occurs. So phosphatidylserine comes on the outer side. So it's forming a bond with annexin 5 and getting highlighted. So this is the principle of annexin 5 if you got it. Okay, got it. So annexin 5 repeated ask question. The next is electrophoresis. It is agarose gel electrophoresis. Let me explain you. Okay, now see, this is a normal cell and this is the nucleus of the normal cell. Okay, and this is the apoptotic cell. This is the nucleus of apoptotic cell. The nucleus is fragmented because of karyoraxis. I told you, the fragmentation of the nucleus is the karyoraxis. The fragmentation of the nucleus is done by an enzyme known as endonuclease. Ye bhi question hai. The karyoraxis is done by an enzyme known as endonuclease. Now do the electrophoresis of both of them. Can you do the electrophoresis? Do the electrophoresis, agarose gel electrophoresis. So here nucleus is in one piece. So you will get only one band. The nucleus, the complete nucleus is in one piece. And here the nucleus is in multiple pieces. So you will get like this. So in apoptotic cell on agarose gel electrophoresis, you get this pattern. It is looking like a ladder. CD ke jaisa lag raha hai. It is known as step ladder pattern. So in agarose gel electrophoresis, apoptotic cell shows step ladder pattern due to the enzyme endonuclease. The normal cell do not show. See this diagram. See this diagram. In this diagram, can you see the cell? It is showing ladder-like pattern. So this is apoptotic. And these are the healthy cells, which is having some fragmentation in between, but not much. Say yes or say no, respond. So step ladder pattern is seen in apoptosis. So these are the two ways of diagnosis of apoptosis. So what we have learned, what are the differences between apoptosis and necrosis? What are the differences between apoptosis and, so apoptosis is a suicide. Now I'm going to teach you necrosis next. Necrosis is murder. Apoptosis is suicide, necrosis is murder. Apoptosis takes place of single cell, necrosis takes place of a cluster of cell, because suicide is done by one person, but murder can be done of multiple person at a time. Okay, in apoptosis the cells shrink. That's why cell membrane remain intact, no leakage, no inflammation. But in necrosis the cells swell. By swelling it will just burst out. It will burst out. So cytoplasm leakage is there, inflammation is there. Since there is no leakage, no inflammation, it's silent like suicide. And here leakage is there, inflammation, it's calling everyone. It's like the murder, it's shouting. Say yes. Now you get many questions over here. Everyone give me a thumbs up. Got it? Can we go ahead? Huh? So we are done with apoptosis. We will solve some question. I want each and every one of you to answer. Don't keep silent here. Just answer. Okay? Read the question and tell me the answer. CD95 is a marker of. Is it intrinsic pathway of apoptosis or extrinsic pathway of apoptosis? What is CD95? Let me give you a clue. CD95 is the other name of the FAS. You know, FAS ligand. It's the other name of the FAS. So CD95 is the other name of the FAS. So it is the marker of intrinsic pathway or extrinsic pathway. It is the marker of which pathway? Intrinsic pathway or extrinsic pathway? I'm asking you. Yes. So it is a pathway. It is involved in extrinsic pathway. I told you two death receptors. CD95 FAS and TNF. If I change the question over here, instead of CD95, if I ask you cytochrome C, it is a marker of which pathway? Now what is your answer? Cytochrome C, where it was involved? It is present between the two layers of the mitochondria and it leaks out and causes apoptosis. So that is involved in intrinsic pathway. The same question we can change multiple times. So in that case, your answer will become A. Okay. The next question, in apoptosis, cytochrome C acts through what? After leaking out from the mitochondria, between the two membranes of the mitochondria, when cytochrome C is coming in the cytoplasm, it is acting through what? It is acting through APOF1, BCL2, FADD or TNF. How does it act? I'm asking you. Yes, how does it act? So it takes APOF1 with him so that caspase 9 become alone and it get activated. So mechanism of action is APOF1. It acts via APOF1. The mechanism of action is APOF1. The next question is in front of you. The following is an anti-apoptotic gene. Which of the following is an anti-apoptotic gene? Can you tell me which of the following is an anti-apoptotic gene? So I told you there are two types of genes, anti-apoptotic and pro-apoptotic. Anti-apoptotic are the one which closes the door and they do not allow the cytochrome C to leak out. And pro-apoptotic are the one which open the door and they allow the cytochrome C to leak out. So tell me the examples. Here we have three examples, BCL2, BCLX and MCL. Okay, and MCL1. Here we have BARC, BAD, BIM and BARC. Now tell me the answer. You get many questions over here. Everyone tell me. They are asking which of the following is anti. So yes, BCLX. The remaining three are pro-apoptotic. So we can flip the question multiple times. The next question, what is the earliest change in apoptosis? Earliest. Yes, what is your answer? What is the earliest change in apoptosis? Can you tell me the answer? What is the earliest change? Yes. The earliest change in apoptosis is cell shrinkage. The cell is getting shrinked. This is the earliest change. Okay. If I change the question, instead of earliest, if I ask you specific or characteristic change of apoptosis, what is the answer now? I'm asking characteristic or the specific change instead of earliest. What is your answer in that case? In that case, your answer will become pycnosis. Pycnosis and karyoraxis will become answer in that case. Absolutely right. So please understand the question well. Instead of learning, understand the question. The next question is in front of you, characteristic feature of apoptosis. Can you tell me the characteristic feature? What is the important feature? Cell membrane remain intact, yes or no? There is basophilia, yes or no? Nuclear molding, yes or no? And cell swelling, yes or no? Who will tell me? What is the correct answer? Yes, cell membrane remain intact. That's why there is no leakage, no inflammation. But basophilia nahi hota. There is no basophilia. There is eosinophilia. There is no nuclear molding. There is pycnosis and karyoraxis. Okay? There is no cell swelling. There is cell shrinkage. The cell gets shrink. The other three options are wrong. So correct answer is A. Nuclear molding is not there. No. No bus. Nuclear molding is not there. Nuclear pycnosis and karyoraxis is there. So cell membrane intact is the only correct answer here. We are done with apoptosis. Anyone have any confusion till now? Anyone have any confusion? Can I start necrosis? Can I start necrosis? Anyone have any confusion in apoptosis? Let's continue with necrosis. I don't think anyone have any doubt. So let's continue with necrosis. The next topic is the necrosis. So I told you there are two ways of the cell death. Okay, apoptosis and necrosis. This is the suicide we have done. Let's talk about the murder now. So that is necrosis. Necrosis is equivalent to the murder. So let's start necrosis. Let's start necrosis. Necrosis is the cell death. It is equivalent to murder. Not, we have to understand 5 types of necrosis. I will teach you these 5 types of necrosis in detail. But to understand the difference between the 5 types, you have to understand a cell. Please understand a cell. Can you see a cell in front of you? Please see a cell in front of you. In this cell, you can see 3 details. What in any cell of human body, you have to see 3 details. How many cells human body have? You say, ma'am, we have hundreds or 1,000 type of the cell. RBC, WBC, brain cell, liver cell, kidney cell, ye cell, wo cell, skin cell, fat cell. Can you identify different type of cells? If I give you a particular diagram, can you identify ye kaun sa cell hai? Can you identify what is the cell? What is the cell? What is the cell? This cell. Can you identify? If you want to identify any cell, you have to see the 3 details. What are the 3 details? Number 1, see the outline of the cell. Number 1, see the outline of the cell. It is known as architectural detail. Architectural detail is the outline of the cell. That is architecture. Shape of the cell, I mean. Number 2, see its cytoplasm. The color of the cytoplasm, the amount of the cytoplasm. Is it pink? Is it blue? Is it granular? It is non-granular. It is abundant. It is scanty. See the details. And number 3, see its nucleus. Again, what is the color of the nucleus? How does it look like? Is it central or eccentric? Looking at the 3 details, you can identify a cell. Now see the 3 details. See their shape is different. See their color of cytoplasm is different. See their color of nucleus is different. So looking at the 3 details, we can identify a cell. We have to see the architectural detail of a cell. Okay, we have to see the cytoplasmic detail and nuclear detail. By looking at the 3 details of a cell, we can identify a cell. If I have to do identity of any human, I will ask 3 questions. Number 1, the country of the origin. Number 2, what is your name, surname? And number 3, what is your address? Like that. So we can identify, okay, this person belonging to this country, residing here, and that is the name of the person or whatever. So in this way, we are asking 3 details to the cell. What is your shape? What is your cytoplasmic detail? And what is your nuclear detail? Okay, got my point? So you have to understand these 3 details. Yes, I'm going to take all 3 portions one by one. Okay. Chalo. So there are 5 types of necrosis I will be teaching you. Okay. Coagulative necrosis. There are 5 types of necrosis. Coagulative necrosis, liquefactive necrosis, caseous necrosis, fat necrosis, and fibrinoid necrosis. These are the 5 types. Liquefactive is also known as colligative. It is also known as colligative necrosis. So we can learn a mnemonic. There are 5 types of necrosis, triple C, double F. One is coagulative, one is colligative, which is liquefactive. The third is the caseous. The fourth is the fat. Fifth is the fibrinoid. So triple C, double F, these are the 5 types of necrosis. I want you to understand the definition of each of them. They all are murders, but they are not suicide. They are murder, but the murder is of 5 types. You will say, no, ma'am, murder is of 5 types. What do you mean by that? I will explain you what I mean. So there are 5 types of murders. Say yes, I'm going to explain you 5 types of murders. They all are murders. They all are necrosis. They are not suicide. They are not apoptosis. So first thing, you have to understand the difference between the 5 types of the murders, the definitions. Then tell me the causes. Gross is not important. You can skip and see the diagram of their microscopy. You can get an image-based question in the microscopy, the diagrams. Okay, so let me start with coagulative necrosis. Among the 5, this is the most common. Among the 5, this one is the most common among the 5. Coagulative necrosis. This is the most common among the 5. Got it? This is the most common among the 5. Now, can you see a group of live cell here? This is a group of live cell. Can you see here? Yes, this is a group of live cell. Now it undergo coagulative necrosis here. It undergo coagulative necrosis here. What you can see? See, ma'am, I can see it is having architecture, it is having cytoplasm, it is having nucleus. See the 3 details over here. Architecture, cytoplasm, and nucleus. You see, ma'am, architecture is still same. Whatever shape we have, outline we have here, the same shape and outline we have here also. So architecture is still maintained. Even after necrosis, the architecture is maintained, but cytoplasm color is changed. So cytoplasmic details are lost and nuclear details are also lost. You can see nuclear details here. We have a uniform nucleus. Here nucleus is either fragmented or it's disappeared. Pycnotic, fragmented and disappeared. So only architectural detail is maintained. Cytoplasmic nuclear details are lost. Say yes. So only architecture is maintained, but cytoplasmic and nuclear details are lost in coagulative necrosis. So that's why the cells undergoing coagulative necrosis, they are compared with a ghost. है ना. What do you mean by ghost? Have you seen a ghost? भूत कहते हैं भूत. भूत देखा है कभी? The ghost. मैंने तो नहीं देखा. I have never seen a ghost or भूत. But we have seen in the movies, है ना. So the ghost have only outline. It don't have inner detail. That's why we are comparing this cell with ghost cell. So please learn. So coagulated necrosis, the cells are known as ghost cell. It's a question. It's a question in your exam. Okay. Or else we compare it with tombstone. What is a tombstone? Tombstone is a stone which is placed over graveyard. है ना. Stone have only outline. Stone don't have inner detail. It don't have. Again, the same thing. It's have only outline, no inner detail. That's why we call them tombstone. So either say ghost cell or tombstone. So this is a definition. So can you tell me what is coagulated necrosis, people? People, what is coagulated necrosis? Say, ma'am, it's a necrosis in which architectural detail is persists, but cytoplasmic and nuclear detail is lost. Since only architecture is there, outline is there, no other detail, the group of the cell is known as ghost cell or tombstone cell. One and the same thing. Give me a thumbs up if you got it. Everyone. Why only 2-3 people reply? Others are not sitting silently. Keep interacting. Now it's a live session. I know. Chalo. What are the causes of the coagulated necrosis? There are 3 causes. I know. If any organ of human body, any organ of human body do not get blood, the cells of that organ start dying. Imagine if the kidneys are not getting blood, the spleen is not getting blood, the heart is not getting blood. है ना? If any organ do not get blood, the cells of that organ start dying because of coagulated necrosis. Except brain. Brain is an exception and you get many questions on that. Brain may be never have coagulated necrosis. In brain if do not get the blood, the cells of the brain will also die. But not of coagulated necrosis. It is because of liquefactor necrosis, the second one. So in the brain, there is liquefactor necrosis. है ना? So ischemia of any organ leads to coagulated necrosis, but ischemia of brain leads to liquefactor necrosis. So you get questions on that. Okay? You get questions on that. Okay? So this is the first example. Second is burns, thermal injury. Imagine I'm cooking and I have a burn over here in my finger, or there are deep burns someone is having. So burn means the group of the cell is dead. It is dead because of coagulated necrosis. Okay, number 2. Number 3, Zanker's degeneration you can learn. So these are the 2 or 3 examples you have to learn in coagulated necrosis. So definition is done, examples is done. Coming on gross. We will fill this table in the end. Okay, coming on gross. Gross may don't learn, it's pale yellow. You can just see it's pale yellow, nothing important. Microscopy. The last is the microscopy. Can you see this diagram? In this diagram, this portion I can see, it is a diagram of kidney. I can see the glomerulus. Okay. This is a kidney, healthy kidney, viable kidney, live kidney. And this is a coagulated necrotic kidney. Compare the 2 kidneys. Compare the 2. And at the junction of the 2, I can see inflammation. Because there is no necrosis without inflammation. All 5 necrosis will have inflammation. Inflammation is a hallmark feature of necrosis. All 5 necrosis have inflammation. It is the murder. You know, inflammation is always there. It is not apoptosis. It differentiated from the apoptosis, having inflammation. So at the junction of the 2 kidney, I can see the lymphocytes, it's inflammation. Okay, so on one side there is viable kidney and on one side we have dead kidney. Now compare the 2. You can compare. Can you do the comparison for me? Now see the cells over here. These are the tubules. See the cells. See the outline, cytoplasm, nucleus, and see the cells here. I can see only outline. Cytoplasm color is changed, and the nucleus is absent. So only outline is maintained. See the cells over here and see the cells over here. You can see only outline is same, but cytoplasmic and inner details are lost. So same thing, whatever I told you in the definition, same thing I'm showing you in the microscopy. So here also I'm saying only the outlines are maintained, but cytoplasmic and nuclear details are lost. That's why the cells are known as tombstone. So the same thing I'm showing you in the diagram. The same thing I'm showing you in the diagram. Okay. Okay. Okay, so coming on this is the first type of necrosis we have completed, the coagulated necrosis. Okay, coagulated necrosis. Now I am coming on liquefactor necrosis, the second type. Liquefactor necrosis also known as colligative necrosis. Now see, this is a group of live cell and see it is undergoing coagulated necrosis. This is also a group of live cell. This is undergoing liquefactor necrosis. Can you see? Now see, tell me the change. Can you tell me the change? Here at least architecture was maintained, but other 2 details are lost. Cytoplasmic detail is lost and nuclear detail is lost. We have seen in coagulated necrosis. But in liquefactor necrosis, here I can see the cell, outline, cytoplasm, nucleus. But here I can see nothing. I can see dot, 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 dot. That's it. I can see nothing. All 3 details are lost. Architecture is also lost. I can't see even outline. No cytoplasm, no nucleus. I can see nothing. So basically a group of live cells is getting converted into a gel-like material. It is getting converted into a gel. It is getting converted into a gel-like material. Okay, so this is ultimately converting into a gel-like material, semi-liquid. That's why it is known as liquefactive necrosis. It is a semi-liquid. It is known as liquefactive necrosis. So learn the definition. All three details are lost. No architecture, no cytoplasm, no nucleus. All three details are lost, and ultimately a gel-like material is formed. That is liquefactive. That's why it is known as liquefactive. One example you already know, the ischemia of the brain. Ischemia of all body organs leads to coagulative necrosis, but ischemia of brain leads to liquefactive necrosis. So ischemia of brain is already there. First example. Second example you have to learn is the pyogenic bacterial infection. The second example is the pyogenic bacterial infections. Anywhere we have pus. For example, I'm having pus here, anywhere. So pus is a semi-liquid. Now it's a gel-like material. So actually, what is pus? The cells of that area undergo liquefactive necrosis, and they are forming a gel-like material, that is pus. So pyogenic infection, the second example. Grossly, you can see this is a diagram of brain. Intentionally, I'm showing you brain to learn that in brain we have liquefactive necrosis. See, it's like a cavity inside which the gel is filled. The gel-like material, liquefied material is filled here. That is the gross. Hannah, now microscopy. Can you see the microscopy? See, this is a normal brain. And see, this is a liquefactive necrotic brain. And see, at the junction, you have the inflammation. At the junction, we have the inflammation. Say yes. Okay, got it, Hannah? So at the junction, there is inflammation. On one side, there is healthy tissue. On other side, it's liquefactive necrosis. And at the junction, we can see the inflammation. See the normal brain. In the normal brain, I can see the cells having all three. These are the neurons, oligodendrocytes. I mean, these are the brain cells having all three details. I can see their outline. I can see their cytoplasm. I can see their nucleus. I can see everything over here. I can see everything over here. Hannah, now during liquefactive necrosis, it get converted into what? A dot like thing. No cytoplasmic detail, no outline, no nuclear detail. All three details are lost. What I can see is the gel-like material. It is the liquefactive necrosis. We can see it here. And at the junction, I can see the inflammation. Okay, coming on the third necrosis, the caseous necrosis. Can I start caseous necrosis? Say yes, everyone. Say yes. Can we go ahead? The caseous necrosis. In the caseous necrosis, you can see what's the difference now. Tell me the definition first. This is a group of live cell. This is a group of live cell. This is a group of live cell. Hannah, here in coagulative necrosis, architecture was maintained, but other two details are lost. So only architecture is there. That's why the cells are known as ghost cell or tombstone cell. Here, all three details are lost. No architecture, no cytoplasm, no nucleus. Here in caseous also all three details are lost. No architecture, no cytoplasm, no nucleus. Then you may be thinking, ma'am, what is the difference between liquefactive and caseous necrosis? You are saying all three details are lost here also, all three details are lost here also. But see, what is the group of cell it is forming? The group of cell here, it is forming a liquid material, a liquefied material, And here the group of cell getting converted into granular material. So if it is liquefied material, it is liquefactive. But if it is granular dry material, it's caseous because it looks like cheese. Cheese, मतलब caseous का मतलब होता है cheese. So have you seen cheese? This is the cottage cheese. How does the cheese look like? Remember, it's dry and granular. Dry and granular. It's not liquid. It's dry and granular in appearance. So here the group of cell get converted into dry and granular. That is caseous necrosis. What are the causes? Two causes are bacterial and two are fungal. There are four causes, two bacterial and two fungal. The two bacterial is TB and syphilis, and two fungal are histoplasma and coccidiomycosis. Learn the four causes. Grossly, it look like cheese. See, the caseous necrosis in the lung, having TB in the lung. You can see it's look like cheese. It's dry, yellowish, granular. That is, Hannah. Microscopy, what I can see here. In this diagram, I can see it is a diagram of a lymph node. This is a normal lymph node. This is a necrotic lymph node. And at the junction, I can see the inflammation. On one side, there is normal lymph node. On one side, there is necrotic lymph node. And at the junction, there is inflammation as usual. So see the normal. In the normal lymph node, I can see the lymphocytes. They have architecture. They have cytoplasm. They have nucleus. They have beautiful all three details. But here, all three details are lost. No architecture, no cytoplasm, no nucleus. I can see the granularity. They have granular appearance. That's it. And at the junction, there is a special type of inflammation, that is granulomatous inflammation, in which giant cells are there. Hannah, coming on the fourth type of necrosis, the fat necrosis. Can I come on the fat necrosis? The fourth one is the fat necrosis. What do you mean by fat necrosis? It is the death of the adipose tissue in living body. Death of adipose tissue in living body. That is the fat necrosis. Naam mein hi hai matlab uska. It is the necrosis of the fat. Now tell me the human three organs in which abundant of fat is present. Can you tell me in human body, what are the three organs in which abundant fat is present? Yes, one is mesentery, in which abundant fat is there. One is pancreas, in which abundant fat is there. And one is female breast, in which abundant fat is there. So if death occurs in of cell of any of this tissue, it is fat necrosis. In the breast, it can be trauma. In the pancreas, it can be pancreatitis. In the mesentery, it can be inflammation. So it will lead to fat necrosis. Grossly, it looks yellowish deposits, yellowish white deposits, and microscopically, it's look cloudy. Can you see it's cloudy in appearance? It's cloudy in appearance. That is the microscopy. The last one, the fifth one, is the fibrinoid necrosis. What is the fifth one? The fifth one is the fibrinoid necrosis. It occurs in the wall of the blood vessel. That's it. It occurs in the wall of the blood vessel. Blood vessel के walls में होता है. In the wall of the blood vessel, we are having three layers: intima, media, and externa. है ना? This is the lumen of the blood vessel containing the blood. Okay, this is intima. Now this is complete media. This is complete media. In the media, I can see a ribbon-like material. Can you see a ribbon-like material? It is fibrinoid necrosis present in the media. It is fibrinoid necrosis. A ribbon-like material is present. It is the fibrin-like material, pink color. So it is present in vasculitis. It is present in vasculitis. We are done with 5 types of necrosis. We will revise them quickly. Can you please help me out? Please everyone participate. Okay. So please, can you see? Tell me the 5 types of necrosis. Tell me their names first. What are the 5 types of necrosis we have? We have coagulative necrosis, liquefactive necrosis, caseous necrosis, fat necrosis, and fibrinoid necrosis. Okay, triple C double F. In coagulative necrosis, only architecture is maintained. The other 2 details are lost. That's why the group of the cell is known as ghost cell or tombstone cell. In liquefactive, all 3 details are lost. In caseous also all 3 details are lost. Then what is the difference between them? Here all 3 details are lost, but the group of cells converted into gel. Here all 3 details are lost, but the group of cells converted into granular debris. Okay, fat necrosis, fat-rich location, the 3 fat-rich location. And fibrinoid necrosis occurs in the media of the blood vessel. Say yes if you got it, everyone. Okay, so this is the definition. Now see the causes. Here ischemia of all organ except brain. Here ischemia of brain along with pyogenic infection. Here, you know, the 2 bacteria and the 2 fungus, TB, syphilis, histococcidio. Here, the 3 fat-rich organ, breast, mesentery or omentum is one and the same thing, and pancreas. And here we have blood vessels, vasculitis. Okay, gross is not important. Microscopy, I told you the diagram of all 5. We are done with necrosis. Read the question and tell me the answer quickly. Read the question and tell me the answer. Quick, fast. We have many important topics to be covered. So in a short span of time, we have covered many important topics yet. I have taught you the 5 types of adaptation. I have taught you the cell death. I have taught you the apoptosis. I taught you the necrosis. Ultra important topics we are taking in a short span of time. What is the correct answer? Necrosis, in which the cells are retained as ghost cell. What type of necrosis it is? Everyone please participate. Yes. So ghost cell, it is seen in coagulative necrosis. If I change the word ghost cell to tombstone appearance, what is the answer now? Tombstone appearance is also seen in coagulative necrosis. It is also seen in coagulative necrosis. The next question is in front of you. All of the following organs likely undergo coagulative necrosis except. Tell me the organ in which coagulative necrosis never happened. Tell me an organ in which coagulative necrosis never happened. What is that organ? Is it spleen, heart, kidney, or brain? Yes, the correct answer is D. In the brain, coagulative necrosis never happened. Okay, so coming on the next topic, gangrene. Can I start gangrene? Someone was asking now, what is gangrene? Gangrene is one step ahead of necrosis. Necrosis to hai. Along with necrosis, the putrefaction also occurs. The combination is known as gangrene. So basically, gangrene is equal to necrosis plus putrefaction. What do you mean by putrefaction? Hindi में कहना degradation. हिंदी में कहूँ तो सड़ना. Dead body सड़ जाती है ना, सड़ना. The degradation, decay and degradation. So whenever there is a necrotic tissue, it's dead tissue and it attracts the bacteria. Whenever there is a necrotic tissue, by necrotic tissue, I mean the dead tissue. It's murdered, it's dead, and it attracts the bacteria. All dead tissue attract the bacteria. Now there are 2 possibilities. If less bacteria get attracted or more bacteria get attracted. If less bacteria get attracted, there is less putrefaction. They will do less putrefaction. कम सड़ाएंगे क्योंकि bacteria कम है. Less bacteria get attracted, less putrefaction. More bacteria get attracted, more putrefaction. So there are 2 types of gangrene. Here putrefaction is less, so organ look dry. It's dry. This is dry gangrene. And here putrefaction is more. कभी देखा है? If some dead body इतनी सड़ गई कि it get converted into a gel-like material. You know. So here putrefaction is abundant. What I mean here, the putrefaction is abundant and it look wet. That's why known as wet gangrene. So what are the 2 types of gangrene? Tell me what is gangrene. Gangrene is equal to necrosis is already there, but it is superimposed by putrefaction. Now it depends. It depends how much is the putrefaction. है ना? So whenever there is a necrosis, the bacteria get attracted. Now less bacteria, less putrefaction, and the organ look dry. That's why dry gangrene. More bacteria, more putrefaction, the organ look wet. That's why known as wet gangrene. People respond quickly. Okay, got it? So this is the definition. There are basically two types of gangrene, the dry gangrene and the wet gangrene. And the third type of special gangrene is gas gangrene. Gas gangrene is a variant of wet gangrene. I will explain you that also. Okay, so see the two type of gangrene. See, this is dry gangrene and this is wet gangrene. I will explain you both. So see the difference. Dry gangrene occurs in limbs. Can you see it? Usually occurs on the limbs. And wet gangrene occurs in the bowel. It occurs in the bowel. The wet gangrene occurs in the bowel. The dry gangrene occurs in the limbs. The wet gangrene occurs in the bowel. Dry gangrene occurs due to artery occlusion. The wet gangrene occurs due to occlusion of both artery and vein. Here only artery get occluded. Here artery plus vein both get occluded. This one occurs in limbs. We can see in the diagram. No need to learn. And this one occurs in bowel. No need to learn. It's seen in the diagram. Okay. This one also black in color. This one also black in color. Both important nahi hai. Here bacteria are less. That's why putrefaction is less. है ना? Putrefaction is less because bacteria are less. Here bacteria are more, so putrefaction is more. Obviously, bacteria less putrefaction. That's why organ is dry. Here bacteria is more, putrefaction is more. That's why it is wet. The most important question which you get here is the line of demarcation, LOD. है ना? In the dry gangrene, I can make out a line. I'm sorry. I can make out a line that this tissue is dead and remaining is viable. I can make out a line. I can make out a line of demarcation. This is dead, this is viable. This is dead, this is viable. But here I cannot make a line. It is haphazard. I cannot make a line. So here LOD is present. We can make line of demarcation. But here LOD is absent. We cannot make line of demarcation. You usually get question on line of demarcation. So here line of demarcation is present in the dry gangrene. It's absent in the wet gangrene. Say yes if you got it. Hana? So this is the two type of gangrene and a special type of gangrene. Special type of gangrene is gas gangrene. Yes. So diabetic foot. Very, very good question. Diabetic foot is an example of what? You know, in diabetic foot there is gangrene. Is it dry or wet? I'm asking you, is it dry or wet? First you answer. Health first. You first answer. You are asking, no? Dr. KP. You first answer. Diabetic foot. Diabetic gangrene. You know, diabetic foot in which there is a very frequent gangrene in the diabetes in the foot. It is an example of which type of gangrene, dry or wet. So you will say, ma'am, ये foot है, तो foot के हिसाब से तो dry होना चाहिए. You said कि dry occurs in the limbs, है ना? But it's wet. It's not dry. So please learn why it's wet. I will explain you. Diabetic foot is an example of wet gangrene, not dry. It's an example of wet. Although it's a foot, but it's wet. Because what happens in diabetes? Diabetes में क्या होता है? Tell me the definition of diabetes. Tell me the definition. Diabetes में there is more glucose in the blood. More glucose in the blood. That's the disease diabetes. Na? More glucose in the blood. More glucose attract more bacteria. Because there is more glucose, it attracts more bacteria. More bacteria means more putrefaction and it will lead to wet gangrene. This is the reason. Although it's a foot, but it's an exception. It's an example of wet gangrene, not the dry. Say yes if you got it. Say yes if you got it. Everyone. So it's an example of wet, not dry. Take in consideration. The third type of the gangrene is the gas gangrene. You know, it's wet gangrene only. But the bacteria, which abundant bacteria are present, abundant putrefaction because it's wet gangrene only. More bacteria, more putrefaction. But the only thing, the bacteria is a gas forming bacteria here. Which bacteria is there? Here the bacteria is a gas forming bacteria. Which bacteria form the gas? It's Clostridium. Which bacteria form the gas? It's Clostridium. It's Clostridium. Got it? It's Clostridium. So imagine this person was traveling on a motorcycle and he got an accident, road traffic accident. So he fell down in the soil. The soil was contaminated with Clostridium perfringens spores. So he got a wound over the thigh and the spores get infiltrate into the wound. After going in the wound, the spores get germinate and the bacteria start forming the gas. And so it's a necrotic tissue having the gas in that. It's a gas gangrene. So we are done with this topic also. Give me a thumbs up if you got it. Huh? Can we go on the next topic? The next topic is pathologic calcification. I guess this is the last topic of this unit and we quickly move to the next unit. Pathologic calcification. What do you mean by pathologic calcification? What do you mean by pathologic calcification? I'm asking. What is pathologic calcification? What do you mean by pathologic calcification? What is pathologic calcification? Where is calcium present in human body? In organ. In which organ? Calcium is present in the blood. Okay. Where is calcium present in human organ? Only two organs. My teeth have calcium, the enamel of my teeth, and my bones have the calcium. Bones, है ना? The osteoid of the bone. So calcium is present in the teeth and the bone, nowhere else. If calcium present in any other organ, it's abnormal, and it is known as pathologic calcification. So pathologic calcification is the deposition of calcium anywhere else apart from these two. any other organ of my body, if it is having the calcium deposition, it's pathological calcification. So calcium deposition apart from the bone or the tooth, the osteoid of the bone and enamel of the tooth. If anywhere else is the calcium is calcification. There are two types of calcification: abnormal calcification, pathological calcification, dystrophic and metastatic. You have to understand the difference between them. What is dystrophic calcification? What is metastatic calcification? In our blood, calcium is present. What is the normal concentration of calcium? It's 9 to 11 milligram per deciliter. See, this is calcium flowing in the blood vessel. Can you see the blood vessel inside which the calcium is there? Now it never comes out. Okay? Here, the tissue is dead and degenerated. Imagine a dead and degenerated. So calcium loves dead tissue. As soon as it is traveling from here and calcium saw outside, oh my God, there is a dead tissue, it jumps out. It jumps out. It comes extravascular and get deposited over this tissue. And get deposited this tissue. This tissue can be any tissue. It is apart from bone and tooth. This can be any tissue. So this type of calcification is dystrophic. Here, the tissue is dead and degenerated. So that's why dystrophic. D for dead, D for degenerated, D for dystrophic. So dystrophic calcification occurs in dead and degenerated. Dystrophic calcification occurs in dead and degenerated tissue. Here the blood calcium level is normal. Here it's 9 to 11 milligram per deciliter. Still calcium comes out of the blood because it loves dead and degenerated tissue. It's jumping out. It's just jumping out. Say yes. See the second possibility. Tissue is absolutely healthy. It's absolutely healthy. Yes, it's not dead. It's not degenerated. Still the calcium is jumping out and getting deposited here. Now why it is jumping out? Why? Because see the concentration of calcium in the blood is more. Here it's hypercalcemia. Here the concentration of the calcium in the blood is more than 11 milligram per deciliter. It's hypercalcemia. Here calcium level was normal. There was a problem in the tissue. Here the tissue is normal, but there is a problem in the calcium concentration in the blood. Why the calcium concentration will be more? For absorption of calcium, two things are required in the blood. Vitamin D. So either vitamin D is more, hypervitaminosis, or parathormone. Hyperparathormone is there. Or the parathormone is more. So vitamin D is more or parathormone is more, it will lead to hypercalcemia. And if it leads to hypercalcemia, more calcium, it will be spitted out from the blood and get deposited. This type of calcification is metastatic. So I'm teaching you two type of calcification. What are the two type of calcification? People say fast: dystrophic and metastatic. What is the difference between them? Tell me. What about the tissue? And what about the blood level of calcium? Tell me the two things in both. Here tissue is dead and degenerated. Here tissue is normal. Okay? Here calcium level is normal, but here calcium level is more because of more vitamin D or more parathormone. How many of you got it? So this is dystrophic and metastatic. Please learn it. Okay? Got it? Can we go ahead? Metastatic and this thing. What you are asking some question to me? Please write it again. I skipped the chat, I guess. If you are asking something, write down again. Okay. Now, what are the sites of dead and degenerated? Tell me some sites of dead and degenerated tissue where the dystrophic calcification take place. So, dead tissue like any necrotic tissue, caseous necrosis, dead parasite, fat necrosis, infarct, thrombi, these are the dead. And degenerated tissue is the atherosclerosis, monkey bug atherosclerosis. These are the dead and degenerated tissue. Okay, and what are the sites of the metastatic calcification? These are all the sites where, here the tissue is healthy, but its pH is alkaline. So calcium level is more in the blood. So as soon as it see alkaline pH, it just jump out. So all these tissues have alkaline pH. So don't learn the list, have a look on that. Okay, so we are done with calcification also. Okay, so can I come on the next chapter? Everyone is satisfied till now? Everyone, can we go ahead? Can we start second unit with the same method? You want any change? Can we start? So I want to teach you the important chapters here, the big chapters, not the small one. So we are done with the biggest chapter. Now inflammation and neoplasia. These two are ultra important and they are very big. Okay, so let's start with inflammation. Okay, so let's continue with the second chapter, inflammation. Let me start with inflammation. What is inflammation? Okay, if any microorganism enters human body, it can be a bacteria, it can be a virus, it can be a fungus, it can be a parasite. What does it causes? Once it enters the human body, it will cause infection in human body. And just suppose if any of them is entering in me, they will cause infection in me. I do not want to have infection. So my body will oppose it. And that is known as inflammation. So my body will oppose it. And that is known as inflammation. So inflammation is the defense. So what the microorganism is causing to the human body is infection. And what the body is causing to the microorganism is inflammation. So inflammation is a defense reaction. Inflammation is a body's defense reaction. It's like the army. In the body, we have the army. The army is the WBCs. WBCs, God has provided us an army. Imagine I call the microorganism as terrorist. Who's a terrorist? Terrorist is the person who is foreign and causes harm to the country people. So in the same way, microorganism is foreign, and after entering in human body, it causes harm to us. It causes infection. So can I say microorganisms are terrorist? The terrorist can be bacteria, virus, fungus or parasite. They are the terrorist. So we have army in us. God has provided us army. In the army, we have the soldiers, the B and the T lymphocytes. They are our soldiers. What does they do? They fight with the terrorist. Now look who is winning in the fight. If the terrorist win in the fight, the person have infection. If the army is winning in the fight, the person have inflammation. Okay, if you have a good immunity, you will have inflammation. Got my point? So this is the thing. This is the basic you must understand. There are two types of inflammation: acute and chronic. Let's start with acute inflammation. I'm starting with acute inflammation. Can I start with acute inflammation? So let's start with acute inflammation. Please start with acute inflammation. Listen, acute inflammation can occur in any organ from head to toe. Let's start with the head. It can be meningitis, it can be encephalitis, it can be endophthalmitis, it can be rhinitis, it can be tonsillitis, it can be pneumonitis, it can be any organ, appendicitis, gastritis, it can be any organ. So from head to toe in all organ we have acute inflammation. But I always consider the example of tonsillitis because we have it in our life now. I guess everyone have tonsillitis till now, once, at least once. So we are aware of it. How does tonsillitis occur? But it can occur in any organ. So whenever you think about the acute inflammation, think about tonsillitis, you can imagine it better, although it can occur in any organ. Now there are 5 things occur in all acute inflammation. In all acute inflammation, 5 things occurs. It is known as cardinal sign. Organ become red in color. Can you see the tonsils become red in color? Number 1. Number 2, the temperature of that organ, the tonsil, is more as compared to surrounding temperature. So increase local temperature. Number 2. Number 3, the tonsil swells up. The organ swells up. Number 3 is swelling. Number 4, there is pain in that organ. We have pain in the tonsils. And number 5, temporary loss of function of that organ. Number 5 is the temporary loss of function of that organ. These are the 5 signs you have to learn. These are known as cardinal signs. But you don't have to learn them in English language. You have to learn them in Latin. Latin. Does anyone know Latin among the audience? Kisi ko Latin pata hai kya among the audience? Do you know Latin? You have to learn that. Redness in Latin is known as rubor. Okay. Increased temperature in Latin is known as calor. Calor. Swelling in Latin is known as tumor. Tumor is not neoplasia here. Tumor in English is neoplasia. In Latin, it is a swelling. Pain in Latin is known as dolor. And loss of function is functionalisia. So you have to learn the 5 cardinal signs. If acute inflammation occur in any organ from head to toe, 5 things happen in that organ. What 5 things? Say the 5 things. Say the 5 things. Okay. So 5 things are rubor, that is redness. Calor is increased temperature. Tumor, matlab swelling. Dolor means pain. And functionalisia means temporary loss of function. So please learn the 5 cardinal signs. You get simple question on that. Okay. Now let's start acute inflammation. Okay. So I will teach you acute inflammation ke steps. Quickly, we will revise. And chronic inflammation ke steps. Quickly, we will revise. So in acute inflammation, there are 11 steps. It's a big topic. In chronic inflammation, only 3 steps are there. Chronic inflammation में granuloma बनता है. That's why chronic inflammation also known as granulomatous inflammation. Acute में never granulomas are formed. So I'm going to teach you the 11 steps here and 3 steps here. Can I start? Can I start the 11 and the 3 steps? So let's start with the 11 steps of the acute inflammation. One by one, we will see the 11 steps. Okay, Ji, say yes. Say yes, respond, say yes. So let's start with acute inflammation, the 11 steps. There are 5 vascular and 6 cellular. I will tell you like a movie story again. It's very interesting if you understand with the help of my story. So there are 5 vascular, 6 cellular, total 11 events are there. These are the 5 vascular you can see in front of you. These are the 6 cellular you can see in front of you. So 5 plus 6, total 11 events are there. I don't want to read it. I will explain you directly. I will explain you all 11 events. All 11 events in one master diagram. Now, please understand this master diagram. If you understood this master diagram, the next 11 events you can understand. If you didn't understand, it's wastage for the next half an hour. You will not understand anything. So please, everyone, concentrate on your gadgets and please have a look on this diagram. What is this diagram? The master diagram. Now see, can you see a yellow color thing in this? This yellow color thing. This yellow. It is my skin. It can be any part. Just suppose it is skin of this area. It is the skin of this area. Okay, just below the skin we have the blood vessel. We have blood vessel everywhere. So just below the skin we are having a blood vessel over here. You can see this is the blood vessel. The blood vessel is lined by the endothelial lining. So this is the endothelial lining, you can see. The blood vessel is lined by endothelial lining. Inside the blood vessel we have RBCs also, platelet also, but I'm not interested in RBC platelet. I'm interested in WBC currently, the army. So this is my army. By army I mean WBC. That is the army. Hana? Now some terrorists have entered. Who's the terrorist? This one is a terrorist. It can be bacteria, it can be virus, it can be fungus, it can be parasite. I will call it a terrorist. I will call it a terrorist. Hana? So the terrorist is present, the army. This is the army. You can see the WBCs are the army. Hana? I want to make them fight. Let's see who is winning. If the terrorist is winning, the person have infection. If the army is winning, the person have inflammation. So we say, what is the problem? Let them fight. Let's see who is winning. Let them fight. There is a problem. The problem is that the terrorist is extravascular and the army is intravascular. That is the problem. The problem is that the terrorist is extravascular and the army is intravascular. How I can make them fight till they can't meet? If we want to make them fight, we have to meet them. We have to meet them. Then only they can fight. Otherwise, they cannot fight. So there are two possibilities to meet them. One is extravascular, one is intravascular. Either take the terrorist inside, take the bacteria inside. No, it's a bad idea because bacteria will spread everywhere in all the organs. It will cause the infection. That is sepsis. We cannot afford that. The other way around, take the army out. Yes, it sounds good. So take the army out. Take WBC out. For taking WBC out, I require 11 steps. And that's the steps. So I will teach you 11 steps one by one. Okay. Got my point? I will teach you all 11 steps one by one. Anyone have any doubt what you are asking? Good teaching, almost covered like live session. Oh. Okay, listen. So I am going to teach you all 11 steps one by one. Hana, in this master diagram, we will understand with the help of the terrorist and WBC. So it is not one step, just take the WBC out and make them fight. It requires 11 steps. Hana? So there are 5 vascular. First, let's finish them. And then 6 cellular. Let's first after come on that. So start with the vascular events. Okay, now understand this. Listen, this is the terrorist. Now you can see this is the terrorist. So the portion of the blood vessel just below the terrorist, just below the microorganism. Jaise hi microorganism aaya, this is the microorganism or the terrorist. So this portion of the blood vessel, it get afraid, it get vasoconstricted. It is transient. Only for few seconds, vasoconstriction is there. Transient vasoconstriction. So the step number 1 is transient vasoconstriction of the blood vessel. It is focal blood vessel just below the terrorist. Step number 1. Step number 2, the same blood vessel undergo vasodilatation now, which was first undergoing vasoconstriction. So first reaction is vasoconstriction. This is the earliest change. But the point is that it's transient. It's transient in nature, only for a few seconds. After that, it's vasodilatation and this one is persistent and prolonged. It is for many years. It is persistent and prolonged. Just suppose this is the point. Hannah, I'm talking about this is my skin. Imagine just below that there is a terrorist and just below that there is a blood vessel. So blood vessel of that portion undergo vasodilated. So if I'm looking from above over here, this area will look more red to me as compared to surrounding area because it is having more blood. It is vasodilated. So this area will look redder to me. And if I touch this area, it is more warm. The temperature is more as compared to surrounding areas because this area is having more blood. So because this areas have more blood as compared to surrounding area, it is red and it is warm. So out of the 5 cardinal signs, I have proven 2 here. I have proven 2 here, rubor and calor. Rubor and calor. You got my point? So rubor and calor, I have proven it here out of the 5 cardinal signs. Have you ever have experience of mosquito bite? I'm having many. So everyone have, at least you have seen if the mosquito is biting or any insect is biting, what happens. So that area become red. Imagine that area is warm as compared to, so it's the best example you can imagine here, mosquito bite. Hannah, so whatever happening to you one by one, it's like this only. Hannah, it is the best example. You can imagine it here. Okay, can we go ahead? So persistent vasodilatation. Persistent vasodilatation is there. The second step is vasodilatation, in which that portion of the blood vessel undergoes. So first there is vasoconstriction, then there is vasodilatation. Now the third step, you have to understand Starling's law to understand the third step. You know there are 2 types of pressures in a blood vessel who are holding: outward pressure and inward pressure. Outward pressure is hydrostatic pressure. Inward pressure is oncotic pressure. Now I'm saying there is vasodilatation. Vasodilatation means more blood. More blood means more water. More water means hydrostatic pressure will rise. Oncotic pressure is due to protein. Protein wala nahi बढ़ रहा है. Hydrostatic pressure is due to water. It is rising. So outward pressure increases and inward falls. Normally outward and inward they cancel each out. But here, the outward is more, inward is less. So you know the fluid is coming out. The fluid will come out and it will accumulate over here. The fluid will accumulate over here. It will lead to edema. It will lead to edema, that is tumor. Only fluid is coming out. So it will lead to edema or tumor, step number 3. Anna? So till now we have seen 3 steps. Can you summarize? Out of the 5, I want to teach you 5 vascular events. Anna? Then 6 cellular. I want to teach you 5 vascular. I taught you 3. I taught you 3 till now. Okay. So what is the first event? Say ma'am, vasoconstriction, which is transient. Second is vasodilatation, which is persistent. Okay. And third is increased hydrostatic pressure. Till now I taught you 3. Anna? The first don't have any consequence. Second step lead to rubor and calor. And third step leads to edema. Edema. That is transudate type of edema. I will explain you what do you mean by transudate type of edema. Got it? Anyone have any confusion? Can I go to the next one? The 4th step. Now I'm saying you why we are doing all this. Why? What is the purpose? You say that, ma'am, you told us we want to take WBC out. We want to take the army out so that it can fight with the terrorists. We want to take this WBC or army out so that it can fight with the terrorists. That's why we are doing all this stuff. Anna? So I will say, is it possible to take WBC out? Because if you see the wall of the blood vessel, it's continuous. There is no gap. There is no gap. If there is no gap, how you will take the WBC out? You have to create the gap. The 4th step is the main step. The main step is the 4th step. That is creation of gaps. Can you see the diagram? Can you see the blood vessel? Can you see the wall of the blood vessel? I have created the gaps. I'm not taking the WBC out right now. I will take it further in the next step. But currently I'm creating the gaps. From this gap, I will take the WBC out later on. So creation of gap is known as increased vascular permeability. Increased vascular permeability is creation of gaps. Creation of gaps is known as increased vascular permeability. Creation of the gaps from which this WBC will come out. This is the hallmark of acute inflammation. Out of the 11 steps which I am teaching you, this is hallmark step. You get a question on that. Out of the 11 steps, what is the hallmark step? It is increased because creation of gap is ultra important. If you can't create a gap, you cannot take the WBC out. है ना? Now WBC तो बाद में बाहर आएगा. We will take WBC later on. The gaps are created right now. है ना? So before the WBC come out, the protein is coming out. The protein from the gap leak out. है ना? So we already have the fluid over here. है ना? Initially we have only fluid. So it was transudate edema. Now the fluid में protein भी आ गया. The proteins are also leaking out. So the fluid along with protein, such a edema is known as exudate edema. Now the edema from transudate get converted to exudate. So now we have exudate type of edema. Can you see the 3 diagrams? I will explain you. See the first diagram. See the wall of the blood vessel. It's continuous. There is no gap. I can't see any gap. I can't see any gap. I can see the endothelial lining. It's continuous. No gap. And outward pressure is equal to inward pressure. So no edema. No edema. See the second diagram. Still the wall is continuous. There is no gap. I can't see any gap. The wall is continuous. I can see, but outward pressure is more, inward is less. You can see the arrow size. Outward is more and inward is less. So it will create an imbalance. And that's why the fluid is coming out. Not anything else. Only the fluid is leaking out. So you can see the fluid is accumulating over here. Accumulating over here. The fluid is leaking out. And this edema is known as transudate edema. It contains only fluid. Only fluid is coming out. Now see the third diagram. See the third diagram. You will understand. See the gaps are created. I want you to appreciate the gaps. I want to appreciate these small gaps. From which the protein will also leak out. Fluid to tha hi tha. Fluid was already there. But along with the fluid, you can see the dot is there. Okay. The protein will also leak out. The protein will also leak out and accumulate in the background. So now fluid with protein with cells will also leak out. Such a edema is known as exudate. So still edema is there. Yahan bhi edema hai, yahan bhi edema. But it will exaggerate. How many of you got it? How many of you got it? Say, everyone? Everyone got it? Okay. So please say. So this is the thing. Just a second. Okay. So I taught you 4 steps out of the 5. 1, 2, 3, 4, 5. The first step I taught you is vasoconstriction, which is transient. The second is vasodilatation, which is persistent. Third is increased hydrostatic pressure. And fourth is increased vascular permeability. Hannah, what is the consequences of this? Here we don't have any. Here it will lead to rubor and calor. Here it will lead to edema. Here it will lead to edema. But this one lead to transudate edema and this one lead to exudate edema. So you have 2 questions over here. 2 PYQs over here. So which step lead to transudate edema? Answer is increased hydrostatic pressure, step number 3. And which step leads to exudate type of edema, which contain protein and cells also. So this is increased vascular permeability. That is 4th step. Out of all the steps, this step is the hallmark step. Ye bhi question hai. This step is the hallmark step. Okay, what is the question, Amit? Please write down your question. Amit, Raj, you want to ask some question? Please write down specifically. Okay, I'm sorry if I'm missing some question. In the chat, please write down relevant stuff. If you have some query, write down. Otherwise, you can give what you say, emojis, Hana, that you got it. You can give a thumbs up. I will get that you got it. If you have any query, otherwise your doubts will get diluted. Hana, I will miss some. Okay, if you have any doubt, please write down. Okay, so till now we have covered the fourth step, Hana, and now I'm coming on the fifth and the last. The fifth and the last step in the vascular events is the stasis of the blood. The blood have stasis over here. Blood ruk jayega. It is stasis. So these are the 5 steps we are done. We are done with the 5 steps. Now read the question and tell me the answer. Can you read the question and tell me the answer? Yes, please read the question. We are done with 5 vascular events. And now I will start with 6 cellular. First, we will complete the questions of the 5 vascular and then we will come on 6 cellular. Chalo, read the question and tell me the answer. Can you tell me the sequence of events in the acute inflammation? What is the sequence of event in the acute inflammation? Quick, fast. I told you that this is a very favorite question. Repeatedly asked. Yes, what is the correct answer? So first there is vasoconstriction, then vasodilatation, then increased hydrostatic pressure is not given. Step number 3 is missing. Step 4 is increased permeability. Step 5 is stasis. So this is the correct answer. Answer is D. Hana, can you identify? No, not C. Vasoconstriction is there. Vasodilatation, stasis is the last step. Na? You have to learn the sequence. Hana, first is vasoconstriction, then vasodilatation, then increased hydrostatic pressure, increased vascular permeability and stasis. Learn it. I've shown you the diagrams, the corresponding diagrams and their consequences also. Please learn the sequence. Please. I request you to learn the sequence. Okay. So you get a question on the sequence very frequently. Okay. The next question. First to appear in the acute inflammation. Can you tell me what appears first? What is the earliest step? Is it vasodilatation, vasoconstriction, increased vascular permeability or decreased vascular permeability? What is first to appear? What is first to appear? The first to appear is the vasoconstriction. Although it's transient, but it is the earliest step. Okay, it is the earliest step. Okay, all of the following are vascular events except. Which of the following is not a vascular event? All of the following are vascular events except. Which is not a vascular event? Can you tell me which of the following is not a vascular event? All of the following are vascular. So vasodilatation occurs. Yes, step number 2. Stasis occur. Yes, step number 5. Increased vascular permeability. Yes, it's the hallmark step number 4. But is it decreased hydrostatic pressure? No. It is increased hydrostatic pressure which occurs in step number 3. So incorrect among them is D. Yes, it should be increased hydrostatic pressure. Absolutely right. So we are done with 5 vascular events. Let's quickly finish 6 cellular. So total 11 are done. Okay, let's come on the 6 cellular events quickly. Okay, what are the 6? What is the summary of the 5 vascular? First tell me. This is the summary. In the vascular events, we have already created a gap. Gap is already there. We have already created a gap. Okay, here the gap is already there. Now we want to take WBC out of this gap. And for that we require 6 steps. Okay, that's the cellular 6 steps. You got it? Now gap is already there. You will say, ma'am, why 6 steps are required? You already have the gap now. Just take the WBC out. Why you require 6 steps over there? There is a problem. The problem is that Bernoulli's theorem. Have you heard about Bernoulli's theorem? What does the Bernoulli's theorem says? Now this is the hollow vessel. For example, this is a pipe. In a pipe, whenever any fluid travel, the Bernoulli's theorem says that heavy portion in the fluid travels at the center and the light portion travels at the periphery. The light portion travels at the periphery. This is the Bernoulli's theorem. Now let's imagine the blood vessel is also a vessel. The blood vessel is also a hollow vessel inside which we are having 4 things: RBC, WBC, platelet and plasma. Who is heaviest? Unfortunately, heaviest is the WBC. So WBC travels at the center. Surrounded by RBCs, which is lighter, relatively lighter. Surrounded by platelets, which are more lighter. This is platelet, and most surrounded by plasma, the lightest. So here we have plasma at the most periphery. Now here is my gap. I want to take WBC out, which is present at the center. So if it was good, if the WBC present at the periphery, we can take it directly, but we cannot take it from the center to the outside. First, we have to take the WBC from the center to the periphery, and then we have to take it outside. That's why it requires 6 steps. What are the 6 steps? Now see, all 6 steps are shown in this master diagram. Please have a look. Concentrate. Please concentrate. Can you see? This is the WBC present at the center. This is the WBC which is present at the center of the blood vessel. First, WBC leave the center and come at the periphery. leave the center, come at the periphery. So when the WBC is at the center, it's known as axial blood flow. It is leaving the center and coming at the periphery, it's reverse axial blood flow. है ना? So this step is known as margination. The first step is margination because WBC is coming at the margin. This is margination. This one is margination. After that, we have a gap at certain distance. This is the gap, but it is at certain distance. So WBC has to roll till there. So second step is rolling. WBC is rolling, 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 rolling. Rolling like a tire on a road. Again, I repeat. Rolling like a tire on a road. है ना? So this is the second step, rolling. Okay, second step is always rolling. You can see just before the gap, it will stop. है ना? It will stop. That is adhesion. Okay, that is adhesion. After that, it comes out. This is known as transmigration, also known as diapediasis. Transmigration or diapediasis is one and the same thing. है ना? So fourth step is transmigration or diapediasis. It's coming out, the most important. Now, after coming out, WBC don't have eyes. है ना? It's a three-dimensional space. WBC don't have eyes. Here is the bacteria, here is the bacteria. I have to move here. I don't have to. How does WBC come to know ki this way I have to go, this way I do not have to go? How does WBC come to know? So bacteria will secrete certain chemicals. The microorganism, the terrorist will secrete that will attract the WBC. That I am here, just come and fight me. So the movement is towards the chemical. It is known as chemotaxis. Can you see the next step? It's chemotaxis. The WBC is moving towards the organism, which is a chemical gradient oriented movement. Chemical oriented movement. That is chemotaxis. And finally, the WBC will eat the bacteria. Can you see the WBC is engulfing the bacteria? It is engulfing the bacteria. So last step is phagocytosis. Can you close your eyes and tell me the 6 steps? First, tell me the sequence. Huh? First, WBC leave the center and come at the periphery. That is margination. After coming at the periphery, it will roll. Rolling. Just before the gap, it will stop. That is adhesion. Okay. After that, it comes out. That is diapediasis. Diapediasis. It will come out. After coming out, it will move towards the bacteria, which is a chemical oriented movement. That is chemotaxis. And after that, it will eat the bacteria. That is phagocytosis. Phagocytosis. So 1, 2, 3, 4, 5, 6. These are the 6 steps. I hope everyone got it. So learn the sequence of the 6 steps. You get the question on the 6th. Hana? Margination. We will see the little bit detail and end it. Okay. So margination, I told you, axial blood flow convert into reverse axial blood flow. Reverse. You see WBC leaving the center and coming at the periphery. Axial convert into reverse axial. After that, rolling. Can you see the WBC is rolling like a tire on the road. And then adhesion. Just before the gap, it's stopping. So margination, rolling, adhesion. Now, how does rolling adhesion takes place? Huh? And the next is the transmigration. It's coming out. It's coming out of the gap. How does rolling adhesion and transmigration takes place? It's with the help of the receptor. It's with the help of the receptor. You have to learn the pairs of the receptor. You know, I always say road and tire. Now, listen, this is the road and the tire. Who's the road? Who's the road? The road is the endothelium. Please understand, the road is the endothelium. This is the endothelium. This is the road. This is the road. Okay, the cells of the endothelium. And who's the tire? Who's the tire over here? The tire is the WBC. The WBC is the tire. So can you see there are pairs? Can you appreciate the pairs of the receptors? These are the pairs. These are the pairs of the receptors. Hana? So because of the bond formation between them. So the bond form between them, then again break. Then again the bond form, then again break. In this way, transient bond formation, it will roll, adhesion and comes out. So it is with the help of receptor. You have to learn these pairs. There are 6 pairs. You have to learn the pairs. In each pair, which component, which receptor present over the road and which component is present on the tire in each pair. So learn the pairs. So let's talk about the first 2 pair on the endothelium, that is on the road. And this is the tire. The WBC is the tire. Hana? On the road, we have P-selectin and E-selectin. Hana? They will form bond with silyl-Lewis X. Let me show you. Can you see here is P-selectin, here is E-selectin. Can you see this is P-selectin, this is E-selectin. They are forming bond with silyl-Lewis X there. Silyl-Lewis X on the tire. On the tire, it's silyl-Lewis X. Silyl-Lewis X. So you have to learn the 2 pair. First pair is P-selectin silyl-Lewis X. Second pair is E-selectin silyl-Lewis X. You have to learn the 2 pairs. The third selectin, there are 3 selectin. The third selectin is L-selectin, which is present on the WBC. L for leukocyte. So the third selectin present on WBC and it form a bond with glycan. So see, L-selectin. These 2 selectins are present on endothelium. The third selectin present on the WBC. It form a bond with the glycan. Glycan के 2 बड़े भाई हैं. Glycan के 2 बड़े भाई हैं, ICAM and VCAM. है ना? They form bond with the beta-2 integrin. Beta-2 and beta-1 integrin. So glycam, ICAM, VCAM, beta-2 and beta-1 integrin. And finally, last pair is PCAM with PCAM. The last pair is common, PCAM CD31 or PCAM with CD31. So there are 6 pairs. You have to learn first 6 pairs. Say yes if you got the 6 pairs. Can you help me in writing? Tell me what is present on endothelium, that is rod, and what is present on WBC, that is tire. First tell me the pairs. So I will write 3 selectin, P selectin, E selectin, and third is L selectin. Okay, now tell their pairs. P selectin and E selectin, they form bond with silyl Lewis X, silyl Lewis X. This is how I learn. L selectin will form a bond with glycam. Glycam के 2 भाई, ICAM and BCAM, है ना? They form bond with integrin, है ना? Beta 2 integrin and beta 1 integrin. And last pair is very simple, PCAM with PCAM. PCAM also known as CD31, CD31 with CD31. Now you have to learn which pair is responsible for what. Okay, which pair is responsible for what. Okay, the first and the third pair is responsible for rolling. The fourth pair is responsible for, fourth and fifth is responsible for adhesion. Okay, है ना? And last pair is responsible for diapediasis, PCAM wala, diapediasis. And the second pair is responsible for both rolling and adhesion. You get many questions on this. E selectin and silyl Lewis X is responsible for both. This one is responsible for both. This is rolling, this is adhesion, and this is, you can see, the PCAM wala pair. It is responsible for transmigration. Okay, if you got it, it's good. You get many questions out of that. Okay, okay. It's not very hard to remember. Dr. A, Anna, if you make the table and don't change the sequence, it's easy. It's easy to go. It's easy to go. So these are the, this is how transmigration takes place. Now the next is the chemotaxis. How does the chemo, once it is out, name the chemical which is secreted by the bacteria which is attracting it. Name the chemical. There are 4 chemicals. Hana, there are 4 chemicals. One is leukotriene, one is interleukin, and 2 are complement. Leukotriene is B4, interleukin is 8, and complement is C3A and C5A. You have to learn the numbers. Out of it, C5A is most potent. Ye bhi PYQ. So please learn, Hana. So leukotriene B4, interleukin 8, C3A and C5A. These are the 4 chemicals secreted by the bacteria which attract it. You get questions on that. And finally, there is phagocytosis. You know, the WBC is eating the bacteria and the job is done. All of them are done. Okay, we are done. Finally, read the question. Tell me the answer. What's the correct sequence? I'm asking. Yes, first there is margination, then rolling, then adhesion, then transmigration. Absolutely right. The last 2 are not given. After that, chemotaxis and phagocytosis. Okay, which is important for diapediasis? Very important question. It is PCAM. PCAM with PCAM. The bond between PCAM and PCAM. Okay, chemotaxis ke liye, I told you 4 chemicals now. Leukotriene B4. Okay, interleukin 8. Complement C3A and C5A. So what is the correct answer among them? You can match. So it is leukotriene B4 and C5A. C5 is the most potent. You have to learn the name of the chemicals. Okay, we are done with acute inflammation. Now one more thing I want to teach you here is the granulomatous inflammation. So inflammation chapter will be over. So today I will teach you granulomatous inflammation, that is chronic inflammation. After this I will start, I will teach you main points in the genetics. I mean the examples of autosomal dominant, autosomal recessive, X-linked dominant, X-linked recessive, only example portion. Hypersensitivity, again the mnemonics and the example wala portion, because it is a last time revision. I cannot give you the mechanism of each of them. And from the neoplasia, I want to teach you few important topics. That is the differences between benign versus malignant, metastasis, and tumor markers. So these all findings will be more important in the general, but currently we will take a break. So we will take a small break, 30 minutes break, and after that we will continue with the session. So currently I'm going to teach you 3 hours more, approx 2 to 3 hours more after the break, in which I will try to finish all these topics so that general pathology may say any question coming, you can do it. And tomorrow we are going to start with the hematology and systemic pathology. Important topics. Say yes if you all got it. So let's take a small break. Currently it's 12:05. I will come again at 12:35. So there is break till 12:35 for half an hour, 30 minutes. I request you to have a cup of tea, coffee, refresh yourself for 30 minutes and come back after 30 minutes. After 30 minutes, we will continue with the chronic inflammation, granulomatous inflammation, which is an ultra important topic. After the break, we are having 2 to 3 hours more in the lecture. All the topics still it is not finished. We are not going to end it. So please come back. Okay. So I'm not ending it. In the same link, you will get it. Okay, Ji. After 30 minutes, we will meet again, each and every one of you. Okay, so let's continue with the inflammation. So we have already covered acute inflammation, and now we are coming up with The chronic inflammation. So we are studying the general pathology as a compact crash course in which we are covering all the important topics of general pathology today, Hannah, for the FMG preparation. So acute inflammation is over. I taught you the 11 steps of the acute inflammation, and now I am teaching you the 3 steps of the chronic inflammation. In chronic inflammation, the granulomas are formed. That's why chronic inflammation is also known as granulomatous inflammation. Okay, so what are the 3 steps? I will draw the 3 steps for you. Imagine there is an antigen enters in human body. The property of this antigen, it's a non-degradable antigen. Hannah, for example, it is Mycobacterium tuberculosis, Mycobacterium leprosy, or talcum powder, or any non-degradable antigen when enters in human body. The first cell with which it comes in contact, is antigen presenting cell, APC, antigen presenting cell. The antigen presenting cell will engulf it. The first step is engulfment. The antigen presenting cell is engulfing the antigen, try to degrade it, but unable to degrade it because it is a non-degradable antigen. If it was a degradable antigen, the story was over. But here it is a non-degradable antigen. So it will carry this antigen to the next cell. Who's the next cell? That is the second step. The next cell is helper Th1 cell. CD4 lymphocytes, helper Th1 cell, that will get stimulated. So APC is giving the signal to the helper Th1 cell that there is a non-degradable antigen who entered human body, and I have engulfed it, I am unable to degrade it. So this helper Th1 cell will secrete 3 cytokines from it, the third step. It will secrete 3 cytokines from it. I will tell you the names of the 3 cytokines. You have to learn the name of the 3 cytokines. The first cytokine is interferon gamma. The first is interferon gamma. The second is interleukin 1, 2, 12. Many interleukins are there. And third is TNF. These are the 3 cytokines which is secreted by helper Th1 cell. What does these cytokines will do? All these cytokines will take one cell out of the blood vessel and accumulate and form a granuloma. So which cytokine is taking which cell out? Let's talk about interferon gamma. Interferon gamma will take the monocyte out. In the blood we have monocytes. We have 5 types of WBC. One of them is monocytes. So interferon gamma take the monocytes out of the blood vessel. Once the blood vessel monocytes are out of the blood vessel, they are known as macrophage. They are no more monocytes now, and they are known as macrophages. So once the monocyte out of the blood vessel, they are known as macrophages. Interferon gamma not only taking the monocytes out, they are modifying it also. So making their nucleus more vesicular and causing the vacuoles in the cytoplasm. So a modified macrophage is known as epithelioid cell. So they convert the macrophage into modified macrophage, that is epithelioid cell. And after that, multiple epithelioid cell fuses together and they form the giant cell. So all this work is done by the interferon gamma. So can you tell me the summary of the interferon gamma? What does the interferon gamma is doing? The interferon gamma is taking the monocyte out of the blood vessel, converting into macrophage, modifying the macrophage, converting into epithelioid cell, and fusing the epithelioid cell together and form few giant cells. So this is all done by interferon gamma. Let's come on the next cell, the next cytokine, that is interleukin 1 and 2. Interleukin 1 and 2 take the T lymphocytes out. They just take the T lymphocytes out and they cause the migration and proliferation of the T lymphocytes there. And finally, let's come on the TNF. TNF take the fibroblast out. They just do the proliferation and migration of the fibroblast. So finally, we are having all these cells. They will rearrange themselves and they form a granuloma. So basically, the epithelioid cells and the giant cells, they form the center of the granuloma. Okay, I will draw on the next page. The T lymphocytes will form the middle zone of the granuloma, and finally the fibroblast will form the outermost zone of the granuloma. So end result is granuloma. This is chronic inflammation. These are the 3 steps of the chronic inflammation. So how does the granuloma is formed? In the center, we have epithelioid cells, and few of them fuses together to form the giant cells. So this is the center. The center is formed by epithelioid cells and giant cells always. The middle zone is formed by the T lymphocytes. You can see this is the middle zone. It is formed by T lymphocyte. And outermost zone is formed by fibroblast. You can see this is outermost zone, and this one is formed by, this is the outermost zone. It is formed by fibroblast. So you can see the 3 layers in front of you. The central zone is formed by epithelioid cells. The middle zone is formed by T lymphocytes, and outermost zone is formed by fibroblast. And you know the which cytokine is responsible for which of them. This is granuloma. Granulomas are of 2 types. This is a hard granuloma. It don't have caseous necrosis at the center. Sometimes the center have the caseous necrosis. It is known as soft granuloma. Granuloma or tubercle, whatever you say. So this is the pathogenesis of the chronic inflammation. Everyone give me a thumbs up if you got it. So what is chronic inflammation? The 3 steps. The first step is the engulfment by the macrophage. The same story is shown to you. You can see this is a granuloma. So first engulfment by the macrophage. So as soon as the antigen is coming, macrophage antigen presenting cell is engulfing it, try to destroy it, but unable to destroy it. Then it is presenting to CD4 T lymphocyte helper Th1 cell, and it is secreting 3 cytokines. It is secreting interleukins, interferon gamma, and TNF. All the 3 cytokines accumulating the 3 type of cells. Interferon gamma accumulate the macrophage and convert into epithelioid cell. Interleukins accumulate the T lymphocyte, and TNF accumulate the fibroblast. And finally, they form a granuloma. The structure of a granuloma is in front of you. Okay, how many types of giant cells you know? How many type of giant cells you know? There are three type of inflammatory giant cells. The fourth one is the giant cell in tumor, not important. 3 type of inflammatory giant cells are there. What are the 3 type of giant cells? Foreign body giant cell, Langerhans giant cell, and Totten giant cell. What is foreign body giant cell? In foreign body giant cell, all the giant cell have multiple nucleus. But in foreign body, the nucleus is present haphazard anywhere in the cytoplasm. Can you see it's haphazard? Anywhere in the cytoplasm. There is no fixed pattern. That is foreign body giant cell. In Langerhans giant cell, the nucleus is present at the peripheral two-third. It is at the periphery two-third. Peripheral two-third. It is known as horseshoe ring-shaped nucleus. Horseshoe ring-shaped nucleus. Or it is present at the 2 poles. Or it is polar in nature. It is present at the 2 poles. It is present at the 2 poles. Langerhans. And third is Totten. In the Totten, the nucleus is forming a ring. Can you see? The nucleus is forming a ring at the center and the cytoplasm contains the vacuoles. This is Totten type. So there are 3 type of giant cells. Sometimes you get an image-based question or theory question on the giant type of the giant cells. So foreign body giant cells, the nucleus is scattered through the nucleus, throughout the cell. Langerhans giant cell, the nucleus is present either in the horseshoe or at the 2 poles. And in Totten giant cells, the nucleus will form a ring and the vacuoles are present in the cytoplasm. That is the 3 type of giant cells. Now, sometimes you get an MCQ on special type of granuloma. I told you the structure of the granuloma. In the center, we have epithelioid cells. In the middle zone, we have T lymphocytes. And in the outermost zone, we have fibroblasts. There are no neutrophils. Normally, granuloma don't have neutrophils. But there is a special type of granuloma which is known as naked granuloma. Okay. They have only epithelioid cells and giant cells at the center. Okay, they don't have T lymphocytes and fibroblasts. That's why they are known as naked. They have only central zone. They don't have middle zone and outer zone. So there is only epithelioid cells and giant cells at the center, and they don't have the outer rim of the T lymphocytes. Okay, the second is a stellate granuloma. Stellate का मतलब होता है star shaped. What do you mean by stellate? Stellate का मतलब होता है star shaped. Can you see here? The granuloma star shaped. The granuloma is star shaped. It is seen in cat scratch disease and lymphogranuloma vanorum, LGV. Learn 2 examples, you get question on that. Anna, and this is a special granuloma, the center contain the neutrophils. Normally granuloma don't have neutrophils, but it is a granuloma in which the center have the neutrophils. So it is a special type of granuloma. And finally, you have to learn the examples of granulomatous inflammation. How many examples you know? Of granulomatous inflammation के कितने examples तुम्हें पता है? How many examples you know? There are 8 bacterial. You can read the names. It is TB, leprosy, syphilis, LGV, brucella, cat scratch, tularemia, glandus. These are the bacterial. There are 4 fungal examples: actinomycosis, blastomycosis, cryptococcidio. There is 1 parasite, schistosomiasis, and there are many miscellaneous like sarcoidosis, Crohn's disease, silicosis, berylliosis. These are the foreign body, these are the miscellaneous granulomas. So these are the examples of the granulomatous inflammation. Sometimes you get questions on the examples. Read the question. We are done with chronic inflammation also. Read the question. Granulomatous inflammation is seen in all of the following except. So the question is based on the examples. You can read the question. Is it Mycobacterium TB, Mycobacterium leprosy, Yersinia pestis, and Mycoplasma, which is not present in this list? Which is not present. So Mycoplasma is not coming. Okay, I told you the name of the 8 bacteria and these are among them. Okay, so you have to learn the list. Okay, I'm skipping the questions. This question is very common, very frequently asked. Stellate granuloma is a feature of. Is it seen in Crohn's disease, cat scratch disease, Hodgkin's disease, or berylliosis? So very frequently asked, stellate granuloma is seen in cat scratch disease and LGV. It is a special type of star-shaped granuloma. The center contains the neutrophils. It's a very common question. Okay, so we are done with the important topics here, and now I'm teaching you few important topics in the hemodynamics followed by neoplasia. Okay, chalo. So let's come on hemodynamics. Let me teach you the next important topic, edema. What is edema? Okay, human body is made up of organs. From head to toe, we have multiple organs. Imagine this is any organ. Let me draw organ. Imagine this is any organ. All the organs are made up of cell. These are the cells of that organ. This can be kidney, this can be spleen, this can be liver, this can be any organ. I want to teach you the space between the organ is known as interstitial space. Can you see the space? I'm talking about this space. The space between the cells in any organ, the space between the cells is known as, interstitial space. Can you see? So this is interstitial space. Normally nothing is present in the interstitial space. The interstitial space is dry. Normally the interstitial space is dry, person don't have edema. If fluid comes in the interstitial space, it is known as edema. So what is the definition of edema? Edema in layman language, it is known as swelling. Swelling of any part of the body. You can see swelling. हिंदी में कहते हैं सूजन आ गई. So person is saying कि डॉक्टर साहब मुझे सूजन आ गई है, मुझे swelling है. At any part of the body there is swelling. है ना? So what actually edema is? Edema is accumulation of fluid in the interstitial space. Can you see? This is the interstitial space. So if there is accumulation of fluid in the space between the cell, it is known as edema. So first you learn the definition. It is abnormal and excessive accumulation of fluid in the interstitial space. That is known as edema, number one. Okay, what is effusion? Effusion is the term related to the edema. Okay, you know human body have certain cavities. We have pleural cavity around the lungs. We have pericardial cavity around the heart. Okay, if the fluid get accumulated in any cavity, like the pleural cavity, like the pericardial cavity, it is known as effusion. So edema and effusion, the pathogenesis is same. Whether I say edema or whether I say effusion, the pathogenesis is same. Edema is accumulation of fluid in interstitial space, and effusion is accumulation of fluid in cavities. So pathogenesis of both of them is same. Now the thing is that why does edema occur? Or why does effusion occur? To understand this, you have to understand the Starling's law. There are 5 causes of edema. Frequently you get questions on that. So we will see the 5 causes of edema. Let me tell you the 5 causes of edema. Listen, please understand. Can you see? This is the organ. These are the cells of the organ. You know all organs are supplied by capillary. Hana? So organ is supplied by artery. Let me draw organ for you. So this is the organ. Okay, the organ have the cells in that. Hana? This is the artery supplying blood to this organ. This is the artery coming to this organ. So after supplying the blood, it is the vein which is coming out. And in between the organ, artery will split into the capillaries, and capillaries combine together to form the vein. So basically organ have the capillaries. So on the next page, I'm drawing the capillary inside the organ. So this is the organ. These are the cells of the organ. And this is the capillary. Let me draw a capillary. This is a capillary. Anna? So capillary have 2 ends. This is the arterial end of the capillary from which pure blood is entering. Hannah, supplying the blood to this organ. And this is the venous end of the capillary. It is meeting with the vein from which impure blood is coming. So my question to you, how does pure blood, oxygenated blood, get converted to deoxygenated blood while it is passing through the organ? Why the blood convert from oxygenated to deoxygenated in a capillary? Capillary have 2 ends, the arterial end and the venous end. How many of you got it? The capillary have 2 ends, the arterial end and the venous end. And how does the blood get converted from the oxygenated to deoxygenated? I'm asking you. Does anyone know the answer? Does anyone know the answer? Yes or no? So listen, you have to understand 2 types of pressure. Hydrostatic pressure and oncotic pressure. Hydrostatic pressure is due to water. Okay. And oncotic pressure is due to protein. So oncotic pressure everywhere is 25. Here also it's 25 mm. Here also it's 25 mm. Oncotic pressure is always same. But hydrostatic pressure changes. At arterial end, the hydrostatic pressure is 38. Don't learn the figures, it's for your understanding. And here, the hydrostatic pressure is only 12. By reaching here, hydrostatic pressure fall and it is only 12. Hydrostatic pressure is outward and oncotic is inward. Now you tell me here which is more. Of course, hydrostatic is more than oncotic. So outward is more than inward by a figure of 13. 38 minus 25 is 13. So by 13 mm, the fluid will go out. The fluid will go out. Hana? The fluid will go out, and here, which is more? 25 is more. I mean oncotic pressure. Again, the difference is 13. But this time, this 13 is inward. This 13 is inward. So basically, as soon as the blood is coming, listen, as soon as the blood is coming and entering here, the blood is coming and entering here. After entering with 13 mm, the fluid goes out, does the exchange. Gives oxygen to the cell, take carbon dioxide. Give oxygen, take carbon dioxide. Does the exchange, and here the same 13 mm, it is coming in. So with whatever pressure the fluid goes out, after exchange, the fluid comes in. So tissue remains dry in the end. We don't have edema. This is the reason we don't have edema. You know, the outward and inward pressure is balanced. Outward pressure is hydrostatic and inward pressure is oncotic. How many of you got it? Give me a thumbs up if you got this. So this is normal. At each and every level in our organ, this is happening. You know, the net outward is equal to net inward. It is 13 mm. With 13 mm, the fluid goes out, does the exchange. With 13 mm, the same fluid comes in. So 13 is equal to 13, they cancel each out. Hana? Now imagine a person in which outward is more. Outward pressure, hydrostatic pressure is more. So more fluid will come out, but the inward is less. Less will. Imagine the fluid is coming with 20 mm and going back by 13 mm. So you know the remaining fluid will accumulate. Or else, the outward is normal, but inward is less. Either the outward pressure is more, so more fluid is coming out, or inward is less. Inward is less. In any of the reason and any of the cause, there is accumulation of the fluid. So what are the two causes of the edema? The two causes of the edema is increased hydrostatic pressure or decreased osmotic pressure. Any of them, if there is accumulation of the fluid. We want outward is equal to inward. But if outward is more and inward is less, it will lead to edema. How many of you got it? Please give a gesture that you got it. So these are the two. So same story. You don't have to learn. This is the physiology. You may have read this in physiology. So normally outward is equal to inward. With whatever pressure the fluid is coming out, with the same pressure it goes in. 13 mm is equal to 13 mm. But if outward is more or inward is less, I mean increase hydrostatic pressure or decrease osmotic pressure, that will lead to edema. These are the two causes of the edema. You know, there are lymphatics. What is lymphatics? The lymphatics is the backup. Imagine if there is little bit of increase or decrease in the edema. God has given us backup also. Thoda sa zyada kam hai to backup bhi hai. So lymphatics will take care of the edema. The third reason, if the lymphatic got obstructed. By any reason, if the lymphatic got obstructed, the person can have edema. The backup, the lymphatics got obstructed. So I taught you three reasons. The outward is more, the inward is less, and lymphatic got obstructed. Now the fourth cause, outward is normal. Inward is normal, and lymphatic is open. Still the person can have edema. You will say, ma'am, now why the person is having edema? You are saying outward pressure and inward pressure, they are equal. And the lymphatic is also open. Still the person can have edema. The fourth cause, the person can have more sodium in the body and more water in the body. More sodium and water, that will cause the edema. Still the pressures are normal and lymphatic is open. This is the fourth cause. And the fifth and the last cause of the edema, everything is normal. Outward, inward, lymphatic, normal sodium, normal water. Still the person have edema if there is gap in the capillary. You know, capillary mein gap. I told you in inflammation, increase vascular permeability. If the gaps in the capillary is there during inflammation, fluid will leak out. Fluid, that is known as increased vascular permeability, that is inflammatory edema. How many of you got it? Can you tell me the 5 causes of edema? You frequently get questions on that. What are the 5 causes of edema? Acha, before that, you tell me what is edema. What is edema? Who will tell me what is edema? What is the definition of edema? Edema is accumulation of fluid in interstitial space. Why does the fluid get accumulated in the interstitial space? Tell me the 5 reasons. 1, 2, 3, 4, 5. So first cause is, yes. What is the first cause? Increase hydrostatic pressure. The second cause is decrease osmotic pressure. The third cause is lymphatic obstruction. The fourth is sodium and water retention. And last is increased vascular permeability in inflammation. Due to any cause, the fluid get accumulated and it will lead to edema. You have to learn. You get a frequent question, MCQ, which of the following is a cause of edema? You will get one of them. Or which of the following is not a cause of edema? You will get 3 options from here and one something else. Okay, so you have to learn the causes of edema. Very correct, very correct. Please everyone reply, no? Please everyone reply. So these are the 5 causes of edema you have to learn. Now edema is of 2 types. Whatever cause it is of 2 types, transudate and exudate. These 4 leads to transudate type of edema. The last one, this one, leads to exudate type of edema. Let me explain you what is transudate and exudate. These are the 5 causes of edema we have seen. Okay, now what is transudate edema and what is exudate edema? Let me explain you. So I told you if only fluid is coming, you can see the 3 diagrams. I've already explained you this thing in the inflammation. You can see here the blood vessel is continuous. It is continuous. The wall of the blood vessel and outward is equal to inward, so there is no edema. In the second, you can see still the wall is continuous. But outward pressure is more, inward is less. So only fluid is coming, nothing else. So this is transudate. You can see only fluid is coming. Nothing else is coming. This type of edema is transudate, which contains only fluid, nothing else. But see the third possibility. There are gaps. In the wall of the blood vessel, there is gap. It's not continuous. So along with the fluid, you can see the protein is also coming and the cells are also coming. So if only fluid is coming, it's transudate. But along with protein, fluid, protein and cells are also coming. It's known as exudate type of edema. So this edema is known as exudate. So there are 2 types of edema. Transudate, exudate. Transudate is protein poor, cell poor. So it is having less protein and less cells. Less protein and less cells. But exudate is protein rich, cell rich. It is having more protein, more cells. Since here protein and cells are less, specific gravity is also less. है ना? Specific gravity is also less and LDH is also less. Here specific gravity is more and LDH more. है ना? And you have to learn the pH is opposite. Here pH is more and pH is less. pH is opposite. How many of you got it? So there are two types of edema. What are the two types of edema? Transudate and exudate. These are the two types of edema. Tell me their definitions. What is their definitions? Tell me protein किसमें ज़्यादा किसमें कम, cells किसमें ज़्यादा किसमें कम, specific gravity किसमें ज़्यादा किसमें कम, है ना? LDH किसमें ज़्यादा किसमें कम and pH किसमें ज़्यादा किसमें कम. हाँ? So this is protein poor, cell poor. This is protein rich, cell rich. So here protein is less, cell is less, specific gravity is less, LDH is less. Everything is more here apart from pH. Here pH is more and here pH is less. So pH is something that is opposite. Got my point? Got my point? Thank you so much for the compliment. Thank you. So can we move? So this is the two type of edema. Now read the question and tell me the answer. Increased accumulation of fluid in the interstitial space is known as. Of course, the question is very simple. Very simple. What is the correct answer here? The accumulation of fluid in the interstitial space is known as edema. It's very correct. The correct answer is edema. Okay. But if I change the question, instead of interstitial space, if I give you cavity, what is the answer now? If there is accumulation of fluid in the cavity, what is it known as? If there is accumulation of fluid in the cavity, what is it known as? Yes, it is known as effusion. In that case, the answer will become effusion. Okay. So the next question, edema is due to. I told you 5 causes of edema. Na? Which one of them is given here? Is it increased oncotic pressure? Oncotic and osmotic pressure is same. Or is it decreased hydrostatic pressure? Or is it both of them? Or is it both of them? Or is it decreased lymphatic flow? What's the correct answer? What is the correct answer? What do you say? Let's see who is telling me the correct answer. What's the correct answer? No, you got confused. Dr. Amir? No, Dr. Amir is right. Dr. A. C is not the answer. I told you increased hydrostatic pressure and decreased osmotic pressure are the causes of edema. Here opposite is given. Here they are saying increased osmotic pressure. No, it cannot cause edema. And decreased hydrostatic pressure. No, it cannot cause edema. So both of them is incorrect. The only correct is decreased lymphatic flow, that is lymphatic obstruction. So lymphatic obstruction can cause the edema. So correct answer is D. Okay. So in this way you get many questions on that. The next topic I am teaching you here is thrombosis. What is thrombosis? Let me explain you what is thrombosis. Okay, what is a thrombus? Imagine I got a cut over here. So what will happen? I will bleed. And anyone have any injury over the body, the person will bleed. But for how long I will bleed? I will bleed for the next few seconds or few minutes. After that, the bleeding will stop automatically. Why the bleeding will stop automatically here? Because here there is a clot formation that will cause the sealing of the injured blood vessel. Otherwise, imagine if there is no clot formation, I'm having 5 liters of blood and all of that will leak out of the injured area. But that doesn't happen, thankfully. Thankfully, the God has given us the mechanism in which the clot is formed at the injured area. So whenever we have injury to the CVS, the clot is formed. This is known as hemostasis. This is a physiological phenomenon. It's not a disease. Hemostasis. Hemo means bleeding. Stasis matlab stoppage. It is stoppage of bleeding. Thankfully, we have this mechanism. Hana? So that is clot formation. Hana? If the same clot is formed without injury, imagine a blood vessel. This one is injured. Here there is an injury. You can see this is injured. And imagine a blood vessel which is not injured. This one is not injured. So if a clot is formed in an injured blood vessel, it's good. The platelets are coming and sealing it to stop the blood vessel bleeding. This is known as hemostasis. This one is good. It's physiological. But if the same clot is formed in an uninjured blood vessel, it's a disease. It's a disease. It's not good. It's harmful because it is causing obstruction in the way. In the way of the blood vessel, it's producing obstruction. And this one is known as thrombus. This one is known as thrombus. So thrombus is the clot formation in an uninjured blood vessel. How many of you got it? Give me a thumbs up. What is thrombus? Thrombus is the formation of the clot in an uninjured blood vessel. Hemostasis is formation of clot in an injured blood vessel. But thrombus is the formation of clot in an uninjured blood vessel. That is thrombus. You can see the clot is formed by the same mechanism. But the blood vessel is uninjured here. So what is the reason? What is the pathophysiology behind that? So there is a Virchow triad. We learn there is a triad which is known as Virchow triad. Virchow is the scientist who explained the 3 causes of the thrombus. What are the 3 causes? Now sometimes what happens, this is a blood vessel and this is the endothelium. Endothelium got injured. This is the reason where the endothelium is injured. It's not bleeding who's taking place. It's just endothelium injured. If the endothelium get injured, the platelet get activated and it will form the clot. Sometimes the platelet get activated and form the clot in a injured, only endothelium is injured. So endothelial injury is one of the cause. If the blood keep on moving, I told you Bernoulli's theorem. So plasma is at the periphery. At the periphery, we have plasma. At the center, we have WBC, and surrounding this, we have RBCs and platelets. So my point is that when the blood is flowing, platelet don't come in contact with the endothelium, but there is stasis of the blood. Due to any reason, if there is stasis of blood, the platelet will fall. Due to the gravity, the platelet will fall, and platelet will come in contact with the endothelium and form a clot here. So stasis is the second reason. The second reason is stasis. And third, sometimes the blood is hypercoagulable. So there are three causes. What are the three causes? Number one, endothelial injury, stasis of the blood, and hypercoagulability. These are the three causes which is known as Virchow triad. Very important question. Repeated MCQ in your exam. Which of the following is not a component of Virchow? They will give you three options as this, and fourth is something else. So please learn. Now I'm teaching you thrombus. I hope you all got what is thrombus. So imagine this is the organ. This is the artery of the organ. Okay, and this is the vein of this organ. Neither the artery is injured nor the vein is injured. Nothing is injured. So if the clot is formed in an uninjured artery, it's a thrombus. It is arterial thrombus. It is formed in the artery. And if the clot is formed in the vein, in an uninjured vein, it's a venous thrombus. This one is venous thrombus. So the clot can be formed in the artery. It can be formed in the vein. It can be arterial thrombus. It can be venous thrombus. They are not injured. If they are injured, it is good to form. It is hemostasis. But in an uninjured blood vessel, they can be formed. So thrombus are of two types. Arterial thrombus, venous thrombus. If it is formed in the artery, it's arterial thrombus. It is formed in the vein, it's venous thrombus. Tell me the effects. Here, arterial thrombus, pure blood cannot come to this organ. So the organ will have ischemia. It will result in ischemia and infarction. And here, if vein got obstructed, the impure blood cannot leave the organ. The organ will have edema. So arterial thrombus leads to ischemia, venous thrombus leads to edema. No need to learn, you can understand. How many of you got it? There are two types of thrombus, arterial and venous. Can you see the same diagram? It can form in the artery and it can form in the vein. Please respond. It can form in the artery, it can form in the vein. You can see the arrow. Artery is carrying pure blood towards the organ. Vein is carrying impure blood away from the organ. Okay, tell me the differences. Arterial one is white in color. Can you see I have drawn with yellow or white? So it is pale or white in color because it is having more platelets inside that. And venous one is red in color because it is having more RBCs inside that. So color is different. Here it is yellow or pale color, white color, here red color. Okay. Arterial one partially obstruct the lumen. Can you see it's partially obstructing? Still we have a space over here. But venous one is obstructing through and through. Packed through and through. So mural matlab partial. This one is partial. And occlusive matlab complete. This one is completely obstructing, the venous one. The third is the lines of Zahan. Can you see arterial one? In the arterial one, you can see alternate light, dark, light, dark, light, dark lines are there. These are lines of Zahan. So arterial one have lines of Zahan. But in the venous one, I can't find any lines. So lines of Zahan are absent in venous. These all are your questions. If the arterial one is there, it will lead to ischemia of the organ because pure blood is not coming. If the venous one is there, it will cause edema of the organ because impure blood cannot leave the organ. Say yes. Listen, one more difference. See the point of the origin. This is the point of the origin. Okay. The arterial one is arising from here and it is growing in opposite direction to that of blood flow. It will propagate, grows in opposite direction to that of blood flow. It is retrograde in propagation. But the venous one grows in the same direction as that of blood flow. So this is antegrade. How many of you got it? So you get many questions on that. The two type of the thrombus. Arterial thrombus and venous thrombus. Venous thrombus. So we have two type of thrombus, arterial and venous. Tell me their color. Tell me how does they obstruct, complete or partial, obstructing the lumen. Tell me their effects. Tell me lines of Zahan. Lines of Zahan are present or absent in which of them? Lines of Zahan. One more difference we have now. Color, obstruction, lines of Zahan, effects and propagation. In which direction they propagate. Tell me, you get questions on that. Tell me, the color, this one is pale or white in color because it is having more platelet. This one is red in color because it is having more RBCs. है ना. Obstruction, this one is partial, that is mural, and this one is complete, है ना, complete, that is occlusive. ठीक है. Lines of Zahan, I told you, we have present in artery and these are absent in venous. Propagation, I told you, this one arterial one propagate retrograde. It's very important question. And this one propagate antegrade in the same direction as that of blood flow. And finally, we have seen the effects. Effects of arterial one is ischemia and infarction. And effects of venous one is edema. Effects of venous one is edema. So you get questions on that. Please, rather than learning this table, can you see the lines of Zahan here? Let me show you the lines of Zahan. Can you see alternate light, dark, light, dark? Here also alternate light, dark bands. These are lines of Zahan. Instead of learning this table, I request you to learn the diagram. You will get all the things from this diagram. Can we solve some questions? We are done with thrombus also. Read the question and tell me the answer. Can you read the question and tell me the answer, please? Virchow triad for thrombus includes all of the following except. It includes all of the following except. What is not present in Virchow triad? I'm asking what is not present in Virchow triad. I told you 3 components: stasis, endothelial injury, hypercoagulability, and platelet thrombus. Yes, Dr. Amir, absolutely right. I told you Virchow triad, these are the 3 causes of the thrombus without injury, but platelet thrombus is not in them. The next topic I'm teaching you is the embolism. What is the embolism? Embolism is any solid or liquid or gaseous mass which is freely flowing in the lumen of the blood from here to there, here to there. That is a detachable mass, intravascular mass, solid, liquid, or gas. That is an embolism. It can be solid, it can be liquid, it can be gas. The best example of solid is thromboembolism. You know, I told you what is thrombus. Can you see this is a thrombus? Can you see in this blood vessel, this is a thrombus. It is attached to the blood vessel. The point it is attached, it is a thrombus. The point it will get detached, it is no more thrombus, it is freely moving thrombus. It is known as thromboembolism. So best example of solid is thromboembolism, the same diagram. है ना? Liquid में it can be amniotic fluid. It can be fat or amniotic fluid. And gaseous में it can be air. So that is embolism. That is embolism. Got it? So just remember this one. Just a second. What is the definition of the shock? You know, human body from head to toe, we are made up of organs. Organs are made up of cell. All cell require blood. Why all cell require blood? Because blood provides oxygen to all cell, and without oxygen cell cannot survive. And blood, the pure blood via artery, it is supplying the oxygen to all my cells from head to toe. Oxygen is required for ATP synthesis. If no blood to the organ, they will not get the oxygen, they will not synthesize the ATP and they will die. And without energy cell cannot survive. That's why blood is required in all the organ. From head to toe, we have blood in all the organ that is supplied via aorta. The pure blood is supplying through all the organs. Now imagine if all organs simultaneously do not get the blood. That is poor perfusion. What is the reason? I will tell you. There can be multiple reasons. In shock, all the human body organ from head to toe, they are not getting the blood. They are getting less blood or not getting the blood. Poor tissue perfusion. So what will happen? The cells of that organ become non-functional, of that particular multiple organ. So cells of that organ start dying. Multiple organ. So multiple organ failure will be there. The complete body failure will be there. And ultimately it's a death. So shock is a syndrome. Shock is a syndrome. It's not a disease. The main thing in the shock is poor tissue perfusion from head to toe. Poor tissue perfusion. The cells are not getting the blood. Multiple organ. There are 3 types of shock. What are the 3 types of shock? Hypovolemic shock, cardiogenic shock, and septic shock. There are 3 types of shock. Hypovolemic, cardiogenic, and septic. Let me tell you what do you mean by that. Let's start with hypovolemic shock. What is hypovolemic shock? Naam mein hi hai. How much blood we have? We all have 5 liters of blood. The adult human body have 5 liters of blood. Imagine someone got an accident. Someone have a surgery. Someone have diarrhea. Someone have vomiting. Or someone have diuresis. Due to any reason, if the blood or the fluid is lost, diarrhea, vomiting, accident, it can be dehydration, it can be surgery, the blood is lost. So less than 5 liters of blood is present, either 2 liter, 3 liter, 4 milliliters. So it is hypovolemic. Naam mein hi hai. The volume is less. So if I'm having 5 liters of blood, so when my heart is pumping, it is doing the systole. The left ventricle eject blood and it is distributed with a fixed proportion to all the organ. Whenever I am having 5 liters, the brain is getting this percentage, the kidney is getting this percentage, lungs are getting this percentage. There is a fixed percentage out of the total 5 liter, how much each of them is getting. But if the blood is less, all organs will receive less blood. So poor tissue perfusion. The complete body will get less blood. The complete body, all organs get less blood. So multiple organ failure. The cells in multiple organ will die. Multiple organ failure, that will lead to shock. So that is the meaning of hypovolumic shock. The name itself depicts its meaning. Hypovolumic shock. So in each shock, I want you to learn the causes, pathogenesis, and symptom. Let's start with the first one, hypovolumic shock. This is the most common shock among the three. Hypovolumic shock, most common. I told you here the volume of the blood is less than 5 liters of blood is present. Hana, it is not 5, either due to surgery or due to accident, due to hemorrhage, due to diarrhea, vomiting, burns mean the water get evaporate. Hana, diuretics, due to any reason. The ultimately less than 5 liters of blood is present. If less blood is present, less venous return, less cardiac output, less blood flow to all organ. By blood ही नहीं है तो आएगा कहाँ से? All the organs are receiving less blood. है ना? Less blood मतलब less oxygen. So all the organs are receiving less oxygen. Less oxygen मतलब anoxia. It's anoxia and that will lead to shock. So such a shock is known as hypovolemic shock. How many of you got it? Huh? What are the symptoms? What are the symptoms of such shock? If my all organs are receiving less blood, my heart will try to compensate. It will pump fast. It will eject the blood fast. So tachycardia. The heart rate will rise. To compensate, the heart is doing so. Hana. But if I'm having 5 liters of blood, my blood pressure is 120/80. If I'm having 5 liters of blood in my blood vessel. Now, if my blood vessel don't have 5 liters of blood, it is having less than 5 liters of blood. So blood pressure will fall. Obviously, less blood, less pressure. So the blood pressure will fall. BP will fall. So heart rate will rise, but BP will fall. Tachycardia with hypotension. Hana. Now, all organs are not getting blood, but 2 organs are ultra sensitive. Brain and kidney. Hana. If brain don't get blood, the person will go in confused state and the person can be comatose. Okay, and if the kidneys are not getting blood, the kidney will go in acute renal failure and the person can have oliguria and anuria. So these are the symptoms. Got it? Hana. Now there are 3 stages in hypovolemic shock. How much blood is lost? Hana. Less than 20%, matlab 1 liter is lost. Still the person is having 4 liters. Hana. 20 to 40, matlab 2 liters are lost. Still person have 3 liters. Hana. More than 40% is lost. So mild, moderate and severe. The second type of shock is cardiogenic shock. Can I come on cardiogenic? Here person have exactly 5 liters of blood. Still the organs are not receiving the blood. You will say, ma'am, why? Why the organs are not receiving blood? What is the problem now? The problem is not in volume. The problem is in the left ventricle. Left ventricle is not pumping. Left ventricular failure is there. Left ventricle is not pumping. If the left ventricle is not doing the systole, blood is not going in the aorta. If the blood is not going in the aorta, all the organs are not receiving blood or they are receiving less blood. Less blood in all organ, less oxygen in all organ. So multiple organ failure and that will lead to shock. The cause of the shock is the heart, the left ventricle, and that's why it is known as cardiogenic shock. Here the volume is 5 liters. Hana? But the problem is inadequate pumping from the heart. Hana, it's not hypovolumic, it's normovolumic. Got it? Now why the left ventricle is not pumping? Maybe the wall of the left ventricle have MI. The most common cause is the MI. It can be cardiomyopathy, it can be rupture, arrhythmia, it can be any cause. The left ventricular wall is damaged. More than 40% damage. That's why it's not pumping. Got my point? So that is cardiogenic shock. How many of you got it? That is cardiogenic shock. है ना? So here all the symptoms which are present there वो तो यहाँ भी होंगे. All the organs are receiving less blood. Kidney receive less blood, so oliguria. Brain receive less blood, so comatose and confusion. But here the left ventricle is not pumping. The problem is that the left ventricle is not pumping. So blood is not going in aorta. So where does it go? Where does it go? It's going backward. Come on, it's going backward. It's not going forward because the left ventricle is not pumping. It is accumulating and getting backward. From left ventricle, it is going to left auricle. From left auricle, it is going in pulmonary vein. From pulmonary vein, it's going backward, and it is accumulating in the lungs, producing pulmonary edema that is leading to dyspnea. So dyspnea is the additional finding here. Hana? If the person have tachycardia, Hana, hypotension, oliguria, anuria, coma. So this is hypovolemic shock. But if I say all these symptoms plus dyspnea bhi hai, so it is cardiogenic shock. So cardiogenic shock, dyspnea, which is differentiating it from hypovolemic shock. How many of you got it? How many of you got it? Yes. So this is cardiogenic shock. The third shock is very difficult to understand. The third and the last shock is septic shock. Hana, what is sepsis? The bacteria in the blood. If the bacteria is present in the blood, the person has sepsis. वो तो समझ में आता है. We understand that. But why sepsis lead to shock? What is shock? Shock के लिए one thing is compulsory. All the organs from head to toe, they do not receive oxygen. They do not receive blood simultaneously. If there is less than 5 liters of blood, all organs are receiving less blood. It's hypovolemic shock. If the heart, left ventricle is not pumping, all the organs receive less blood, it is cardiogenic shock. But why? The infection in the blood leads to shock. The sepsis lead to shock. So that is my question to you. Let me explain you. Hana, there are two type of bacteria: gram-positive bacteria, gram-negative bacteria. So there are two type of septicemia: gram-positive, gram-negative. Both of them can lead to shock. Hana, let me explain you. Hana, listen. Gram negative, make it negative. Gram negative bacteria have lipopolysaccharide in their cell wall, and gram positive bacteria have lipoticoic acid in their cell wall. Whether it is gram positive or it is gram negative, the lipopolysaccharide and lipoticoic acid correspondingly, they stimulate macrophages present in the blood. Macrophage will secrete certain cytokines that will do two things. Please understand, it's difficult. First, they cause vasodilatation, then cause increased vascular permeability. Let me explain. Imagine this is a blood vessel of a human being, inside which the person has sepsis. Now, one of them will be present, either gram-positive bacteria or gram-negative bacteria. Any of them. Gram-positive bacteria have lipoticoic acid in the cell wall. Gram-negative bacteria have lipopolysaccharide in the cell wall. Whatever it is stimulating the macrophage. It is stimulating the macrophages present in the blood. The macrophage gets stimulated. Macrophage will secrete certain cytokines that will cause two things. Very important है, two things. Number one, this is the organ, to which this blood vessel is supplying. Number one, it is causing vasodilatation. What is vasodilatation? Vasodilatation may, you tell me this is an organ. So by causing vasodilatation, this is vasodilatation. I have dilated the blood vessel. I am supplying more blood to the organ or less blood to the organ? I am asking you. Can you answer? Anyone? Organ is receiving more blood or less blood? By causing vasodilatation, what we are doing? We are giving more blood to the organ or less? Common sense. We are doing vasodilatation. Vasodilatation means more blood. I am providing more blood to the organ. You will say, ma'am, are you mad? You are telling that on one hand, you are saying that in shock, all the organs are receiving less blood. And on the other hand, you are saying here the organ is receiving more blood. So septic shock is something unique. Here the organ receives more blood at the initial phase. Instead of getting less blood, it is receiving more blood. Yes, it's hyperdynamic shock. This shock is known as hyperdynamic, which is in contrast with the other two type of shock, which I have taught you. That is hypovolemic and cardiogenic. Here the blood supply initially increases. Initially there is more supply to the organ. So if another two shock, that is hypovolemic and cardiogenic, if you touch the extremities are always cold. Haath aur pair ekdam thande hote hain. But in septic shock, if you touch the extremities, they are warm. Initially they are warm. Later on, there is increased vascular permeability. What do you mean by increased vascular permeability? Due to cytokines only. Increased vascular permeability means creation of gap. So gaps will be created here. In the wall, in the endothelial lining, the gaps will be created, so fluid will leak out. Fluid will leak out. The fluid will leak out. So less fluid will remain. Now the organ will receive less blood and now the person will go in shock. So initially there is hyperdynamic stage in septic shock and later on the person goes in the shock. इस पे बहुत question आता है. So first there is vasodilatation followed by increased vascular permeability, finally leading to shock. How many of you got it? So in septic shock, there are two stages. Initially hyperdynamic stage, in which organ receive more blood. The extremities are warm. But later on, hypodynamic stage. How many of you got it? We are done with the shock also, the three type of shock. We are done with this unit. Bade मैंने 3 unit कराए. In a compact span of 3-4 hours, I have taught you maximum chunk of general pathology. Appreciate my efforts. Are you getting it? Is it useful for you? Is this lecture? It is a compact version of complete pathology. Okay. So maximum questions will be from this portions only, which I am teaching you in your exam. Okay, we have one more day tomorrow. Okay, chalo. So we have completed the 3 type of shock. Hypovolemic shock is due to blood loss. Less than 5 liter of blood is present due to any reason. Cardiogenic shock is due to destruction of the wall of the left ventricle. The left ventricle is not pumping. And septic shock is due to infection. So that is the main thing here. Okay, read the question and tell me the answer. Read the question and tell me the answer. Perioperative shock is an example of. Perioperative shock. During operation, during surgery, the blood loss is there. The person have blood loss. We all have 5 liters of blood. But during operation, during a surgery, the more blood can be lost. So person have hypovolemic shock or septic shock or cardiogenic shock or neurogenic shock. Which shock the person will have? Yes, the person will have hypovolemic shock. Absolutely right. Okay. In shock, what is the characteristic feature which is present in all 3 type of shock? Tell me a unique thing which is present in all 3 type of shocks. Is it cardiac failure, poor tissue perfusion, cyanosis or edema? What is the correct answer? What's the correct answer? What's the correct answer? Yes, poor tissue perfusion. Whatever shock it is, ultimately poor tissue perfusion of multiple organs simultaneously. That is the shock. Okay, so poor tissue perfusion is there. So we are done with all these important topics right now. In the genetics, I will hardly take 5 minutes. I just want to show you the 4 mnemonics. I will not read the mnemonics. I will give you the PDF. You can learn by yourself. So in genetics, I just want to do that. And after that, I want to come on the neoplasia directly. So maximum chunk of the general pathology we are covering. So coming on the genetics, in the genetics, we know humans have cells. Inside the cells, inside the nucleus of the cells, how many chromosomes we have? We all have 46 chromosomes in every cell. Rather than saying 46 chromosomes, it's better to say 23 pairs of chromosomes. How many chromosomes we have? We have 23 pairs. So this is pair number 1, pair number 2, pair number 3, pair number 4. Likewise, we have 23 pairs. So you can see this is the 23 pairs of the chromosome. Out of the 23 pairs of the chromosome, we all have the first 22 pairs. You can see the first 22 pairs is common in all the persons. It's common. But the last pair decides the gender of the person. Whether the person is male or female, that is decided by the last pair, that is sex chromosome. In males, it's XY, in females, it's XX. We know that. So these are the sex chromosomes. So total 23 pairs are there. Now, there are 4 types of diseases in genetics you have to learn, on which MCQs come in FMGE exam specifically I'm talking about. There are 4 types of inheritance: autosomal dominant, autosomal recessive, X-linked dominant, and X-linked recessive. These are the 4 types of inheritance we are talking about. So you have to learn the pedigree and the example of each of them. Let's start with autosomal dominant. Now, autosomal dominant and autosomal recessive, they are not related to gender of the person. But X-linked dominant, X-linked recessive, they have the gender bias. First start with autosomal dominant. This is autosomal dominant. Have a look at the pedigree. You know, in the pedigree, the square is a male and the circle is a female. I guess everyone knows. If you don't know, learn the basics. Okay, here in this pedigree, you can see in this generation there is infection to some person. There is the disease to some person. This next generation also have the disease person. The next generation also have the disease person. So there is no generation skip. There is no generation skip. All the generations have the disease. It is transmitted to all. So grandfather is giving to father, father is giving to the son, and grandfather is giving to the mother, mother is also giving to son and all. Like it is generated in all the, it is transmitted in all generation. There is no generation skip. You can see it. The next thing you can see, the male is giving disease to male and female both. And the female is also giving disease to male and female. So there is no gender bias. Both can transmit disease to both. So there is no gender bias. And it is heterozygous. We know dominant conditions are heterozygous. This is examples you learn by yourself. I will give you the mnemonic in the end. Autosomal recessive, there is generation skip. You see, disease person is present in this generation, not in this, and again in this. So 2 generations are skipped. So generation skip is common here. So based, if this pedigree is given, you can identify it's autosomal dominant because there is no generation skip. But here clearly I can see beech mein generations are skipped. Generation ki generation chhoot gayi. There is none of the person having the disease in this generation. Okay, so generation skip is present. Gender bias yahan pe bhi nahi hai, but this one is homozygous. How many of you got it? So this is the second thing. Examples I will teach you. The third is X-linked dominant. We have seen autosomal dominant, no generation skip, autosomal recessive, generation skip. And there is no gender bias in both of them. Now coming on X-linked dominant and X-linked recessive. Can I come on X-linked dominant? Please respond, people. Keep responding. If you want my energy levels to be high, you have to be interactive. So see, X-linked dominant. See here. See the mother. If the mother is having the disease, she got married with a normal husband. I mean, the husband don't have the disease, the wife is having. The mother is giving, there are 4 children. This mother is having 4 children, 4 pregnancies. 2 daughters, 2 sons. Okay. She is giving the disease to 50% of the daughters. 1 daughter is affected, 1 is normal. Out of the 2 sons, 1 is affected, 1 is normal. So she is giving disease to 50% daughters, 50% son. Okay, the mother. And what about the father? If the father is infected, out of the 4 children, the disease is given only to daughters. What I said, fathers transmit disease to daughters only. 100% daughters. Father is doing a bias. And the mother is not doing any bias. Mother is giving disease to 50% daughters, 50% son. This is a typical inheritance seen in X-linked dominant disease. How many of you got it? The father gave disease to 100% daughters. And the mother gave the disease to 50% of the son and 50% of the daughter. Please respond. Ankit, Mukutraj, Prince, Ramaya, Vasudev. You got it? Or others, anyone who is watching me live. Give me a thumbs up. Got it? So what I said, the affected father, father is doing a partiality. Father don't like the daughters. And I'm taking an example. Father liking son only. So father is giving the disease only to the daughters, not to the son. Father is loving the son. So father is giving the disease to 100% daughter. But mother is not partial. Mother is giving the disease to 50% daughters and 50% sons. You can get a pedigree like this. And last is X-linked recessive. The last one is X-linked recessive. In X-linked recessive, you know, the females are always carrier. You know, the dot at the center is carrier and males are the cases. Disease never occur in females. See, none of the circle is black. The circles have a dot inside that, that is their carrier. So females are carriers. So if this pedigree is coming to you with a dot in a circle, it's X-linked recessive. If this pedigree is coming to you with a partiality, it's X-linked dominant. This pedigree in which generation skip is there, it's X-linked recessive. And this pedigree, if there is no generation in between, it's X-linked dominant. So you can get a question on the pedigree. Pehli baat. Now learn the 4 example and I will give you 4 mnemonic. So come, I will give you 4 mnemonic. Autosomal dominant, autosomal recessive, X-linked dominant and X-linked recessive. So I'm going to give you 4 mnemonics one by one. Let's start with autosomal dominant. The mnemonic is in front of you. वो familial hypercholesteremia autosomal DOMINANT dominant है. So this is the mnemonic. V stand for वो. V stand for von Willebrand. Familial stand for familial adenomatous polyposis. Hypercholesteremia is hypercholesteremia. A stand for adult polycystic kidney. D stand for dystrophica myotonica. O stand for osteogenesis imperfecta. M stand for Marfan. I stand for intermittent porphyria. So please you read the full form by yourself. I'm not wasting the time because there is nothing to understand, but you get many questions out of that. Hannah, with the mnemonic at least it will be easy and you can apply it on the spot and try. Okay. Autosomal recessive, the mnemonic is ABCD, EFGH, SPW. A stand for albinism and alpha antitrypsin deficiency. B for beta thalassemia. C for cystic fibrosis. D for deafness, sensory neural deafness and Dubin-Johnson. A, B, C, D. E, F, G, H. E for enzyme deficiency, that is glycogen storage disorders. F for Friedreich ataxia and Fanconi. दोनों पे question है. G for galactosemia, है ना? H for hemochromatosis. S for sickle cell. P for phenylketonuria and W पे Wilson पे भी PYQ. So please learn it, है ना? X-linked dominant, only 4 examples are there. Pair, जिसमें maximum question is on Alport. And X-linked recessive, the mnemonic is Graham Bell. G stand for G6PD, it's having a PYQ. और ये जो Graham Bell का B है, it's color blindness, इस पे भी PYQ. So please read the full form. I'm not reading it because the time is limited. I wish if I could read और मैं तुम्हें learn करवाती, है ना? I wish. लेकिन time is limited now. What to do? Okay, this is not a conceptual thing. It's simply facts are there. You have to learn that. Learn the 4 mnemonics and try to say their full form. Okay. वो familial hypercholesteremia autosomal dominant है. This is the mnemonic. Autosomal recessive is ABCD, EFGH, SPW. Okay जी. X-linked dominant is fair. Fair का A is Alport, never forget. And X-linked recessive is Graham Bell, GRAHAMBELL, Graham Bell. Okay, please learn. And G is G6PD deficiency, never forget. So you get many questions out of that. So that is about the genetics, है ना? So I'm skipping like tuberous sclerosis. It is which dominant? So वो familial hypercholesteremia autosomal dominant का T है ये. So answer will be autosomal dominant, है ना? Wilson's SPW, ABCD, EFGH, SPW का W है ये. So answer will be autosomal recessive. Apply the mnemonic, you will get the answer. Which of the following is X-linked recessive? So which of the following is coming in Graham Bell? G6PD deficiency is coming in Graham Bell. If you know the mnemonic, it's very easy. They will give you the pedigree to analyze. है ना? You can see the partiality. You can see the partiality. The father is giving to daughters only and the mother is giving to 50% son, 50% daughter. है ना? So it's X-linked dominant. Okay, so you get many questions out of that. Hello, learn 3 more things here. Trisomy 21 is down, trisomy 13 is Patau, and trisomy 18 is Edward. I guess you know that. If you don't know, I'm just revising you. See it. Yes? Can you see it? Huh? So what is transplant? What is transplant? In the transplant, in all transplant, है ना? Whatever, it is a kidney transplant, it is a lung transplant, it is a heart transplant. Nowadays, we can perform many transplant. There is a donor, there is a recipient. The recipient is known as host. So we take the tissue, the graft from the donor and transmit it to the recipient. So donor to recipient transmission is there. From the donor to the recipient, we are doing the transmission. That is the transplant. That is the transplant. What's the main problem in the transplant? The main problem, just suppose we are doing kidney transplant. So we take the kidney from the donor and we transmitted, transplant inside the recipient. For recipient, this is foreign. For recipient, this is foreign tissue. So the immune system for the recipient, it will reject it. We do not want the rejection because in this patient, both the kidneys are failed. That's why we are doing a transplant. We do not want the rejection. But rejection will occur because it is a foreign thing. Yes, rejection is the main thing here. Anna. So tell me the types of the transplant. Who's the best donor? In which rejection chances are nil. Who's the best donor? In which there is 0% rejection chances. कोई ऐसा donor है? Who's the best donor? Based on the donor, there are 4 types of transplant. The best donor is myself. I mean the patient self. खुद का ही खुद में ही लगा दो. So take a tissue from the same person and transmit it to the same person. So you say, ma'am, how it is possible? For example, I am having burns over the face or anywhere. I can take the skin of my back or thigh and transplant it from one side to another. So this type of transplant is known as auto. So I am taking my skin only and transmitting it to me only. So my body will not found it foreign. It will not do the rejection. So such a transplant is known as autograft. This is autogenic graft. The best transplant, है ना? No rejection. ठीक है? But it is not always possible. In case of plastic surgery, skin, it is possible. It is not always possible. Who's the second best donor? The second best donor is the identical twin. Imagine if someone is having identical twin. I'm not talking about non-identical twin. I'm talking about monozygotic twins. Monoamniotic, monochorionic, monozygotic twins. So they are genetically exactly same. So if we take the organ from the genetical identical twin and transmit it to the person, there will be no rejection. Because they are genetically identical, na, body will not find it foreign. It is known as syn graft or isograft. The donor is the twin, but identical twin. है ना? But very few people have identical twin. No, I don't have identical twin. I'm having my siblings, but we are not identical twins. है ना? So if someone don't have identical twin and the person require a transplant, who's the next best donor? The next best donor is any human. Any human. At least the species is same. है ना? It is any human. The same species. है ना? If multiple donors are available, it can be a relative, it can be a non-relative, it can be a friend, it can be anyone, but a human. If multiple donors are available, we will do the HLA testing and we will see maximum matching जिसमें होगी, the chances of rejection are minimal in that. We will choose that donor. है ना? So such a graft is known as allograft, in which same species is there. And the worst graft are the xeno. We don't perform them. We take the organ from the animals and transmit to the person. These are known as xeno or heterograft. How many of you got it? So based on the donor, we are having 4 types of transplant. Based on the donor, we are having 4 types of transplant. What are the 4 types of transplant? If the donor is the self, if the donor is the identical twin, if the donor is same species, that is human, or if the donor is different species, that is any animal. Name the transplant. Name the transplant. Here it is known as autograft. Here it is known as iso या फिर syn graft. Here it is known as allograft, also known as homograft because the species is same. And here it is known as xenograft or also known as heterograft because the species is different. So you have to learn the type of the graft based on the transplant. This is the type of the graft. In these 2, rejection is 0. There is no rejection at all. In these 2, rejection is there. Maximum rejections are seen here. So you get simple questions over there. Read the question and tell me the answer. Tell me the graft between identical twin is known as. Graft between identical twin is known as. Yes, what is the correct answer? Identical twin. Yes, the correct answer is autograft. Absolutely right. I'm sorry. Identical twin, it is known as isograft. Isograft or syn graft. I know. Best example of syn genetic graft. The same question is asked in a different way. So is it between dizygotic twin or monozygotic? Of course, we all know it is between the monozygotic twin. So you get simple questions out of that. Let's come on the last topic, that is neoplasia, ultra important chapter. And a few more minutes, then we are going to pack it. So at least general pathology, all the important topics we have covered today. And tomorrow my target is to cover the important topics, high yielding topics for your exam from hematology and systemic pathology. So don't dare to miss tomorrow's session also. Okay, can I come on the neoplasia? What is neoplasia? The cancer, the tumor. What is neoplasia? Can you see this is a normal cell? Hannah, how to differentiate a normal cell? How does a normal cell get converted into neoplastic cell? How does a normal cell get converted to neoplastic cell? Can you see this is a normal cell? What do you mean by normal cell? All the normal cells have receptor on their surface. Can you see this is a receptor? They have a receptor on their surface. So whenever a growth factor is coming, binding with the growth receptor, whenever growth factor is coming, binding with the growth receptor, then only cell is doing mitosis and divide into multiple cell. Hai it is forming 2 cell out of 1. So that is mitosis occurs only if the growth factor is coming. That is stimulus is coming. Otherwise mitosis do not take place. This is a normal cell. Can you see this is a neoplastic cell? Please tell me what is the difference between this cell and this cell? Here also mitosis takes place. Here also you can see. But here there is absence of growth factor. So even without growth factor is not present. It is not binding with the growth receptor. So here even without stimulus, the cell is dividing. You know, the mitosis is uncontrolled. So from 1 cell to 2 are formed, 2 to 4, 4 to 8, 8 to 16, 16 to 32, 32 to 64, and so on. A bunch of cell is formed. That is uncontrolled mitosis. Uncontrolled mitosis leads to cancer. So what is a neoplastic cell? The neoplastic cell is such a cell in which mitosis is not under control. The cell division is uncoordinated, it's not controlled. Even after cessation of stimulus, it keeps going. Even after cessation of the stimulus, it keeps dividing. How many of you got it? Say yes. So this is a definition of cancer. Okay, neoplasia. Now there is a special type of cancer that is known as teratoma. There is a special type of cancer which is known as teratoma. You know, in human body, we have many organs. During embryonic life, there are 3 germ cell layers. There are 3 germ layers, from which the complete organs are formed. Ectoderm, mesoderm, and endoderm. So all the organs are formed from one of the layer. Ectoderm or mesoderm or endoderm. From one of the layer, most of the organs are formed. So in each organ, we have 1 germ layer. So for example, the blood vessels, the cardiovascular system is derived from the mesoderm. The central nervous system is derived from the ectoderm, like that. So one organ have 1 germ cell layer. So whenever we have cancer, humans have cancer in any organ, it is derived from 1 germ cell layer. Teratoma are the tumors of totipotent cell. What are totipotent cell? Totipotent cells are the cell which divide, which can differentiate into any of the germ cell layer. They can differentiate into ectoderm or mesoderm or endoderm. They can differentiate in anyone. So the tumor have all 3 germ cell layers. So only tumor which have all 3 germ cell layer, it is known as teratoma. So it is a tumor which have technically anything inside that. If you cut the tumor, now where does it occur? It occurs in gonads. In females, it is in ovaries. In males, it is in testes. Okay. So just suppose it is a female who is having an ovarian mass and I'm a surgeon. I'm operating the lady. I'm taking the mass outside. If I cut the mass, I can find anything inside that mass. You can see I can find the hairs, I can find the bone, I can find the tooth. So technically anything, I can find the brain, salivary gland, fat, or anything inside the mass. That is teratoma. So usually it comes as a spotter image in your exam. They will give you a spotter image and they will ask you to identify what is that. So identification, it's a teratoma because it contains, usually they will give you hairs to identify. So that is the teratoma. Okay. So that is the teratoma I taught you. The biggest thing I want to teach you here, the benign versus malignant tumor. The most important thing I want to teach you here is the benign versus malignant tumor. There are 2 types of tumor, benign and malignant. How to differentiate them? Benign tumor requires only surgery as a treatment. Malignant tumor, after surgery, they require chemotherapy, radiotherapy, targeted therapy, hormonal therapy. Here no chances of recurrence. And here there is always a chance of recurrence. Here they have very good prognosis. They never recur. Here the prognosis is sometimes poor. They can reoccur and they can cause the metastasis. So that's why we want to differentiate. Is it a benign neoplasm, benign tumor, or malignant? How to differentiate? How to differentiate between a benign cancer or tumor and a malignant tumor? Does anyone know what are the differences? How to differentiate between the 2? Between a benign tumor and a malignant tumor. What are the differences? Can you tell me? So in benign tumor, the rate of growth is slow. They are very slow growing, but malignant tumor are very fast growing. The doubling time is very less. They just grow very fast. So we have to see the doubling time. Here doubling time is very high. Just suppose there is a lady coming to my clinic that, doctor, I'm having a lump in my breast. I'm feeling since last. So the first question I will ask, since how long you are feeling it? If the lady is saying it, I'm feeling it since last 1 year, 2 years, so it's going to be benign, mostly, because it is very slow growing. But if the lady is saying, no, it's growing very fast, within a 1 week, I have felt, when I felt it was like a very small, like a peanut, and not the size of 2 to 3 centimeter, so it's growing very fast. So usually malignant tumors are fast growing. This is usual. Exceptions are there, but this is usual. Benign tumors are usually asymptomatic and malignant are usually symptomatic. Again, exceptions are there. This is again a rough criteria, है ना? Grossly, benign tumors are circular, spherical in shape, and they have a capsule over them. I will show you the diagram. Malignant are irregular in shape, and they infiltrate inside the organ. They don't have any capsule. So this is the third difference, है ना? Let me come on the fourth and fifth. Let me show you these three. So first thing is the rate of growth. Benign tumors are slow growing. Malignant tumors are very fast growing. है ना? Benign tumors are slow growing. Malignant are fast. Benign tumors are asymptomatic. Malignant are symptomatic. Benign tumors are spherical, encapsulated, they are irregular, and they invade the tissue. They invade. Can you see the breast? Both of them are the breast. Can you see a tumor in the breast here and there? In both of them, there is a tumor. Let me show you this tumor. Can you see? It's circular, spherical, well encapsulated. This is the benign tumor of the breast, that is fibroadenoma. Can you see this tumor? It's irregular, infiltrating into the tissue, no capsule. This is malignant tumor of the breast. Hannah. So grossly also we can identify. Hannah, but these are the rough criteria. Rough. The main criteria is the microscopy. Cut it and make a slide. Cut and make a slide. Cut and make a slide. On the slide, we will look for anaplasia. Hannah, what is anaplasia? These 10 features are known as anaplasia. Hannah, in benign tumor, all the 10 are absent. In malignant tumor, all 10 are present. So this is anaplasia. So anaplasia is the hallmark of malignancy. First learn that. Anaplasia matlab malignancy. Anaplasia is the hallmark of malignancy. है ना? These 10 features are absent in benign and these 10 features are present in malignant. Got my point? The 10 features together is known as anaplasia. Anaplasia. So anaplasia is the hallmark of malignancy. Hannah, in the slide, now I'm a pathologist, you are a surgeon. There is a lady coming to you that, doctor, I'm having a lump in my breast. Hannah, you are doing a biopsy. You are doing a wise decision. You are just taking a biopsy and sending it to the pathologist. You are sending it to me. Okay, ma'am, you are giving a call. Ma'am, have a look and tell me whether it is benign or malignant. If you say benign, I will just operate the lady and let her go. If you say it is malignant, Hannah, I will look for other options also. After surgery, I will give the chemo, radio and all that. So my plan of action will be different and prognosis of both will be different. So it is the pathologist who is going to decide whether it is benign or malignant. Hannah, based on the gross, based on the rate of the growth, based on the symptoms, the surgeon can only guess whether it is benign or malignant, but ultimately it will be the pathology. Hannah, so if you are giving me the slide, I will look for these 10 features. Hannah, all these 10 features together known as anaplasia. If the 10 features are absent, I will make my report that anaplasia is absent, that's why it's benign. If the 10 features are present, I will make my report that anaplasia is present, that's malignant. So what are the 10 features which define anaplasia? No, most of them are same as that of dysplasia. Today morning I told you, na, basal polarity. In benign tumors, basal polarity is maintained. In malignant tumors, it's lost. The second is pleomorphism. In benign tumor, pleomorphism is absent. In malignant, the pleomorphism is present. The NC ratio here low, here high. Here nucleus is of same size. Here nucleus is of, here can you see all the nucleus are of same size. Here some are small, some are large. That is anisonucleosis. Here anisonucleosis is absent. Here it's present. Hannah, here the color is normal. Here it's dark color, hyperchromatism. Hannah. So all the features, don't learn the features, just learn anaplasia. Anaplasia is absent in benign and present in malignancy. That is the feature which is going to differentiate benign and malignant. Fourth and the fifth and the last. Let me explain you the fifth and the last. Hannah. So what are the differences between benign and malignant? I'm teaching you 5 differences. Listen. The ultra important among all these is the fifth. Let me explain you the differences again. So if there is a lump at any organ in any person, how you are going to decide is it benign or malignant? How you are going to decide is it benign or is it malignant? How you are going to decide? Is it benign or malignant? How you are going to decide? Just suppose again the breast, the female is having a lump in the breast. So first is rate of growth. If it is slow growing, it's benign. If it is fast growing, it's malignant. Second is clinical feature. Usually, if it is asymptomatic, it's benign. If it is symptomatic, it's malignant. Again, exceptions are there. Grossly, if it is spherical, well encapsulated, pushing the surrounding tissue, it's benign. But if it is irregular, non-capsulated, infiltrating the surrounding organ, it's malignant. The fourth is microscopy. Hannah, here anaplasia is absent and here anaplasia is present. Anaplasia is the 10 features, the cluster of the 10 features. Read the list, don't learn it. The most important and the fifth feature which differentiate benign and malignant is the spread of the tumor. Spread of the tumor. There are 2 types of spread of tumor. Hannah, local spread and distant spread. What do you mean by local and distant? For example, there is a person having a stomach cancer, gastric cancer. Hannah, let me draw. There is a person who is having the gastric cancer. Okay, there is a person. This is the gastric cancer. है ना? These are other organs. Maybe this is pancreas. Maybe this is the intestine. This is spleen. है ना? Other organs. Now this cancer, and this is the blood vessel. This is the blood vessel. So this cancer will spread, it will grow. And in continuity, it is involving other organs. So it is known as local spread. Local spread, matlab in continuation, it is involving multiple organs. That is local spread. It is a possibility few of the tumor cells will leave the tumor cell and go in the blood or in the lymphatic. And via blood or lymphatic, it is spreading to multiple organs and forming multiple secondaries. This is known as distant spread or metastasis. So there are two types of spread. If it is continuous, it's local. And if it is discontinuous, multiple secondaries are formed via blood or lymphatic, it is spreading throughout the body. It is distant spread or metastasis. Both the things are absent in benign, both the things are present in malignant. I repeat my words. Local spread and distant spread are absent in benign. And local spread and distant spread both are present in malignant. Say yes if you got it. Both the things are absent in benign. Benign tumors neither show local spread nor show distant spread. Malignant shows both. Got it? Now, among the 5 differences, I told you 5 differences between benign and malignant, which is the most reliable feature. Which is the most reliable feature to differentiate the two. Not a guess. मतलब वो है तो पक्का ही benign or malignant है without any confusion. Which is the most reliable feature? I'm asking you. Which is the surest sign of malignancy? In other words, it's the question. So it's metastasis. If metastasis is present, it has to be malignant. So most important feature to differentiate benign and malignant is metastasis. Second most reliable is the local invasion. Third most reliable is the anaplasia. This is the sequence, and these are rough criteria based on which I can differentiate benign and malignant. No, anaplasia is not the surest sign. The surest sign is the metastasis. But we do not wait. Just suppose a lady is coming to me. The lady is saying that, doctor, I am having a lesion in my breast. I feel a mass in my breast, one of the breast, maybe right, maybe left. She is having a mass. So I cannot say ki, okay, there can be 2 possibilities. It can be benign, it can be malignant. But I cannot say ki, wait, dekhte hain, metastasis hua to it will be malignant. Nahi hua to benign hai. Dekhte hain, local invasion hua to it's malignant. Nahi hua to benign hai. We cannot wait till that stage. We will do a biopsy and based on anaplasia we decide. But it's the third most important criteria that will differentiate. Most important is metastasis and local spread. How many of you got it? So this is the metastasis. It's a very frequent question aata hai. So these are the 5 differences I told you. The 5th one is ultra important. Spread of tumor. The 2 type of the spread, local and distant. Benign tumor neither show local nor show metastasis. And malignant tumor show local invasion as well as metastasis. Both of them are present in the malignancy. Both of them are absent in benign. Both of them are present in malignancy. Metastasis is the most reliable sign of malignancy. Second most important feature is invasiveness, local invasiveness. Got my point? Anyone have any confusion? So same difference table is given to you. You have to read this table. You get many questions out of that. Okay. What are tumor markers? Let's come on tumor markers. Can I come on tumor markers? What are tumor markers? Listen, I told you whenever any patient present with any mass, for example, the same patient present with a colon cancer. The patient is having a colon cancer. Okay, here is the cancer. So what I will do? Of course, I will do the biopsy. The most important feature to diagnose a cancer is do the biopsy. Do the biopsy. See for anaplasia. If anaplasia is absent, it is benign. If it is present, it is malignant. So best is do the biopsy. Once I have done the biopsy, now I started the patient treatment. Chemotherapy, radiotherapy. Now I want to see whether the tumor is responding or not responding. Whether it is regressing or not regressing. Or if the patient is completely treated, I want to do the follow-up. Follow-up mein mujhe dekhna hai ki it is coming again or not coming. It is regressing. So I cannot do biopsy multiple times. Once I can do for confirmation, but every time I cannot do the biopsy because it is a very lengthy procedure. I have to admit the patient, I have to give anesthesia. It's costly also. Repeating also takes time. So there are many drawbacks. So I cannot offer biopsy every time. It's invasive. So what I can do, some tumor cells, what they do, they secrete, this is a blood vessel. They secrete a protein in the blood. I will take the blood sample. Taking blood sample again and again is very easy. Doing biopsy again and again is not easy. I will ask the patient, give a blood test. Blood ka ek janch kara lo. So we will take the blood sample and look for that marker, the protein secreted by the tumor in the blood. If that marker is present, I will do a baseline and I will start the treatment. Now after treatment, I will again test for that marker. Like colon cancer secretes CEA in blood. So before starting treatment, I will check the CEA, and after finishing or meanwhile the treatment, I will again check the CEA. If CEA is falling gradually, it means the tumor is responding. So this is how we use them as an adjuvant We don't use them for diagnosis. Tumor markers. These are the markers that are secreted by the tumor cells into the blood. Hannah, these are the biological indicators of the tumor. How many of you got it? You have to learn the list. That which tumors secrete which protein in the blood. You have to learn the list. Most important is CA125. Ovarian cancer secreted in the blood. Hannah, CA19.9. It is secreted in the blood by colon cancer. It is an indicator of colon cancer. And CA15.3, it is an indicator of breast cancer. Okay, PSA, it is an indicator of prostate cancer. Okay, CEA, it is an indicator of colon cancer. I told you. Alpha fetoprotein and beta HCG, they are the indicators of the testicular tumors. You have to learn this list. How many of you got it? How many of you got it? Huh? So you get many questions on the markers. You have to learn all these markers. Okay. So today I have covered general pathology. General pathology ke high yielding topics. First, how was the session? You find it useful? I taught you all the high yielding topics of general pathology which are important for specifically FMGE exam. You need to revise them before going to your exam. I try to compact them as much as possible. In a less span of time, we covered many things in the fastest way possible. Was it useful? What is the feedback? So in the same manner, you want one more session? One more session of pathology tomorrow, in which I am going to cover entire systemic pathology and hematology. In the hematology, I will focus on the leukemias, the 4 leukemias, because you frequently get an image-based question on the leukemia and anemias. Few important anemias, not all. And in systemic pathology, there are 15 important topics which are very frequently and repeatedly asked in your exam. So we will revise those 15 important topics, one from each system, the ultra important topics. Okay, we have completed general pathology, all the high yielding points, all the high yielding topics I have covered in a short span of time, and I have given you a compact revision of entire general pathology. So today we are going to continue with the hematology and systemic pathology. Are you people ready? Can I start? Are you people ready? Can we go ahead? Huh? So I welcome you all for today's session, the remarkable rapid revision. I am Dr. Priyanka Sachdev here, and today we will be covering the hematology and systemic pathology, the compact revision specifically for the students who are going to appear in FMGE exam this January. Okay, so without wasting any further time, let me continue. Okay, so let me first continue with hematology. The plan is that, and after that we will move on systemic pathology. So we will be doing this revision for the next 5 to 6 hours. So maybe 2 or 2.5 hours I will be taking for hematology, and remaining 3 and 3.5 hours I will be taking for the systemic pathology. The plan is that, so broadly, we will be covering the hematology and systemic pathology in the next 6 hours. The compact revision, the high yielding topics we are going to cover, which are most frequently repeated in the exam. So let me start. Okay, are you people ready? Can you give me a thumbs up? Everything is good to go. Let me start with hematology. In the hematology, first I will be taking the anemias, and then I will be taking the leukemias in a super fast manner. So let me start with anemias. Before starting anemias, the various types of anemias, let me tell you what is anemia. How can you define anemia? What's the definition of anemia? Anemia is defined when the hemoglobin concentration in any person is below the lower limit for that person, for that age and for that gender. So hemoglobin varies with the age. Hemoglobin varies with the gender. I cannot give you one cutoff that below this, the person is anemic. Because the cutoff is different for male. The cutoff is different for female. It depends on gender. And the cutoff is different in adults and in neonates. So it depends on age. So I cannot give you one cutoff. You have to learn multiple cutoff. So for the definition of anemia, you have to see the hemoglobin concentration. Okay, got it. So in males, the cutoff is 13.6 gram per deciliter. Any male whose hemoglobin is below that, the person is said to be anemic. Okay. Any female whose hemoglobin is below 12, the cutoff is 12 in female, 12 gram per deciliter, the female is said to be anemic. So these are adult male and female. These are adult male and female. If we talk about the newborn, so the cutoff is 15, whether male or female. If we talk about the newborn, it is 15 gram per deciliter. So let me ask you a question. If you have understood this, let me ask you a question. So my question is in front of you. There is a person. There is a person whose hemoglobin is 12.5 gram per deciliter. My question is the person anemic, yes or no? Can anyone reply in the chat box? Can anyone say yes or say no? Is the person is anemic? Yes, anemic is there, or no anemic? I'm giving you a detail. There is a person whose hemoglobin is 12 gram per deciliter. So some students are saying yes, some are saying no. I'm waiting for the correct answer. Neither the answer is yes nor the answer is no. You should ask me, ma'am, what is the gender and age of this person? Without knowing gender and age, it's not possible to comment whether the person is anemic or not anemic. I cannot comment. I cannot say that should be your answer. Ma'am, how can I tell you whether the person is anemic or not? Unless until you don't tell me the age and the gender. You should tell the age and the gender. Now, if I'm saying the person is adult, this person is an adult, okay? So the age is adult and the person is male. What is your answer? And the person is female. What is your answer? Now compare. See, if the person is male, what is the cutoff for male? For male, the cutoff is 13.6, but here hemoglobin is 12.5, which is less than the cutoff. So I will say yes, the male is anemic because the hemoglobin of this male is less than the cutoff for the normal healthy male. And if I consider it a female, the cutoff for the female is 12. And here I am saying the person is having hemoglobin 12.5, which is more than cutoff. So I will say female is not anemic. The female is healthy. That is not anemic. She is healthy. So it depends on gender. Based on the figure, you cannot say. How many of you got it? Yes, absolutely right. How many of you got it? So this is the approach. Okay, this is anemia. This is the definition of the anemia. Now to understand the anemia in detail, you have to understand RBC. Now RBCs have hemoglobin inside that. Can you see this is human RBC? So I want three details. What is the shape of RBC? What is the size of RBC? What is the color of RBC? Comment on shape, size and color. Can you see what is the shape of the RBC? If you see from front, from the top, it's a circle. It's a circle from the top, like a coin. Have you seen a coin? The coin is a circle from the top. If you see, I know it's like a circle. But if you see from the side, from a side view, the coin is uniform everywhere. But the RBC is not uniform. It's biconcave shape. So from the side view, it's biconcave. From the top view, it's a circle. Now, what about the size? If it's a circle, it should have a diameter. What's the diameter of RBC? The diameter of RBC is 7.5 micrometer. The diameter of RBC is 7.5 micrometer. Since it is a circle, it is having a diameter 7.5 micrometer. So we commented on the shape, we commented on the size. The third thing is the color. What's the color of the RBC? You may be knowing that RBCs are the cell which don't have nucleus inside that. They are non-nucleated cell in human body. They don't have nucleus. So inside RBC, we can see hemoglobin is present. Nucleus is not present, but hemoglobin is present. So where is the hemoglobin? I guess everyone can see the hemoglobin is present at the periphery. Hemoglobin gives red or pink color to the RBC. Hemoglobin is a colored pigment. It is giving red or pink color. It is present at the periphery. It is not present at the center. So it is always present at the peripheral 2/3. Central 1/3 is empty. So central 1/3 is pellar. So peripheral 2/3 is colored and central 1/3 is empty. That is known as pellar. Pellar. Peripheral 2/3 is colored. This is normal. So this is normal color. Hannah, you know normal color. You know normal size. Normal size is 7.5 micrometer. And you know normal shape. Normal shape from the top, it's a circle. And from the side view, it's biconcave. So you should know the shape, size, and color of RBC. If you know this, now you can understand anemias. You are ready to understand anemias. How many of you got it? Got it? So normal, shape, color, and size of RBC. Now, based on the size, RBCs are of three types. What is the normal size of RBC? I told you. Normal RBC is such a RBC whose diameter is 7.5 micrometer. I will say the size is normal for a healthy adult human who is not anemic. Like me, I'm not anemic and my RBCs are of this size. If you say, got my point? Broadly. So this is the size of a normal RBC. Got it? Now just suppose I'm taking my blood sample in a test tube and I'm making a smear out of it. I'm making a smear, taking one drop here and making a smear. You can see my RBCs. These all are my RBCs or a healthy individual RBC. So how can you comment what is the size of this RBC? Now, while watching this, while examining this slide under microscope, we don't measure a scale. We don't take a scale and measure each and every RBC, the diameter of each and every RBC. It's very tedious to measure the diameter of all the RBCs using a microscopic scale. Whether the RBCs are 7.5 micrometer, yes or no. How to do that? Now, we don't use a scale. So basically, the concept is that in the blood, we have lymphocytes also. This is a lymphocyte. The lymphocytes are also present in the blood. The size of lymphocyte is also 7.5 micrometer like a healthy RBC. Hannah, RBC can shrink, RBC can swell. You know, the size of the RBC can be less than that, more. But lymphocyte is always 7.5 micrometer. So on a slide, we always compare the size of the RBC subjectively with that of mature lymphocyte. And we comment whether the RBCs are equal to lymphocyte it means they are 7.5. If they are less than lymphocyte, they are looking smaller, they are less than 7.5. And if they are looking larger than lymphocyte, they are more than 7.5 micrometer. This is how we compare. So we compare the size of RBC with a small lymphocyte, the mature lymphocyte. So if I give you a slide, can you see the 3 slides in front of you? This is a slide, this is a slide, this is a slide. All the slides show one lymphocyte. Without lymphocyte, you cannot comment on the size of the RBC. If I give you a slide which don't show lymphocyte, and if I ask you what is the size of RBC, you say, ma'am, I cannot comment. Give me a lymphocyte to compare, then only I can comment. Now, based on the size, the RBCs are of 3 types. Listen my words. Size and pathology is known as cytic. Pathology is the language, I told you. So size and pathology is known as cytic. Okay, based on this, RBCs are of 3 types. Hana, if the RBCs is normal size, it is known as normocytic. Normocytic means normal size. They are equal to 7.5 micrometer, the diameter is. Sometimes RBCs are less, they are smaller. Hana, these are known as microcytic. Microcytic, the size is less than 7.5 micrometer. And sometimes they are larger, they are big, they are large. Hana, these are known as macrocytic RBCs. So here the size is more than 7.5 micrometer. Here we are comparing all the 3. We are comparing the size with a lymphocyte. If they are equal to lymphocyte, they are less than, smaller than lymphocyte or larger than lymphocyte. So I want you to concentrate on the word cytic. The suffix is cytic. And I want you to understand cytic means size and pathology. In hematology, cytic ka matlab hai size. So microcytic, normocytic, macrocytic. These are the 3 types of RBC. How many of you got it? Okay. Yes, this is more than sufficient whatever I am teaching you for the FMG exam. All high yielding topics will be covered here. Repeatedly asked topics. Listen. Now can you see the first slide? Where is the lymphocyte? Here is the lymphocyte. See. Here is the lymphocyte. Here is the lymphocyte. Here is the lymphocyte. Now see the size of the RBC in the first slide. In the first slide, I can see RBCs broadly, they are equal to lymphocyte. I will say it's normocytic. In the second slide, I can see they are smaller. They are smaller as compared to lymphocyte. So I will say they are microcytic. And in the third slide, they are larger than the lymphocyte. I will say they are macrocytic. So based on that, we will see normocytic, microcytic or macrocytic. How many of you got it? So this is based on size. The RBCs are of 3 types. Now, based on color, RBCs are of 2 types. What I am saying, please mind it. I am saying based on size. Size is known as cytic. The RBCs are of 3 types. I told you what are the 3 types. Now, based on color. Color in pathology is known as chromic. You know, chroma means color. The dictionary meaning of chroma means color. So, in pathology, color means chromic. Based on that, RBCs are of 2 types. Hana, let me tell you what are the types of the RBCs. What is normal color? I told you. Now, this is a RBC. This is also a RBC. Hana, I told you normally peripheral 2/3 is colored. Let me draw peripheral 2/3, approx. Peripheral 2/3 is colored and central 1/3 is empty, which is known as pallor. This is normal. Sometimes hemoglobin is less, so color is less. Hardly any color at the periphery. Hana, only a rim, hardly any rim is colored. So pallor is more and color is less, right? So this is normal. I told you color is known as chromic, not cytic, chromic. So this is normochromic. What do you mean by normochromic? I will say peripheral 2/3 is colored and central 1/3 is pallor. This one is known as normochromic. This is the definition of normo. And what is the second one is known as? This one. Here color is less. Pallor is more. Color is less. So this is known as hypochromic. This one is known as hypo. No, don't say the word micro. Say hypochromic. So I will say peripheral 2/3. More than peripheral, less than peripheral 2/3 is colored. And more than central 1/3 is pallor. So this is the definition. And there is no condition when hemoglobin will increase. There is no such condition. So my summary. Can you see the 2 slides? See the 2 slides and I will tell you the summary. And I will answer if you have any query. Listen. Normochromic, hypochromic. The word chromic matlab color. Normochromic, see the slide. Now here I don't require a lymphocyte. For color, I don't require a lymphocyte. For size, I require a lymphocyte. But for commenting color, no lymphocyte is required. Please mind it. So I can comment the color. Although this first slide don't have any lymphocyte, but I can comment on the color. Now look at the RBCs. Any RBC you look, I can see central 1/3 is pallor. Any RBC, approx. Central 1/3 is pallor. Peripheral 2/3 is color. So I will say it's normal. But see the second slide. I see hardly any color at the periphery. Most of it is pallor only. So I will say this one is hypochromic. How many of you got it? Now see the summary. Everyone on the screen. Everyone, please concentrate on your gadgets. Listen. So I told you, based on the size, RBCs are of 3 types. And based on the color, RBCs are of two types. I'm telling you the classification of anemias. Concentrate. Listen. Based on the size in pathology is known as cytic. Okay. And color in pathology is known as chromic. Okay. Hannah. Now tell me the three types here. Here RBCs are of three type. Here RBCs are of two type. Can you tell me the names? Huh? So here it is normocytic, microcytic, and macrocytic. Use the suffix cytic. Okay. Chromic. Based on the chromic, that is color. RBCs are of two type. Normochromic and hypo. We don't use micro word. We use hypochromic. And there is no condition as hyper. It don't exist. So these are the type of RBC. Listen everyone on the screen. Let's classify anemia. Anemias morphologically are of three types. The first anemia in which RBC's color and size both is normal. Still the patient have anemia. Such anemia is known as normocytic normochromic anemia. The RBCs are of normal size, normal color. Still patient is anemic. Such anemia is known as normocytic normochromic anemia. The first type of anemia. The second type of anemia in which RBCs are small. The size is less. And color is also less. Both the things are less. So the second type of anemia is microcytic hypochromic. So the second type of anemia is microcytic hypochromic in which size is less, color is less. And the third type of anemia in which RBCs are large in size. So they are microcytic, but there is no corresponding hyper word. So I will combine the macrocytic with normochromic. So macrocytic normochromic anemia. So can you tell me the three types of the anemia? Quickly, say it. Without any hesitation, without any confusion, say it. Say ma'am, normocytic normochromic anemia, microcytic hypochromic anemia, and macrocytic normochromic anemia. How many of you got it? So we classify anemia morphologically into three types. Hannah, based on the size, based on the color. Based on the size and based on the color, there are three types of anemia. The first type of anemia in which both the things are normal, normocytic normochromic. The second type of anemia in which microcytic hypochromic, the color is less, the size is less. And third type of anemia, macrocytic normochromic. Give me a thumbs up here, come on, respond. Keep responding. Give me a gesture that you got it. How I know that you got it or you didn't got it? Everyone, yes, that is the three types of anemia. Everyone whosoever is watching me live, give me a thumbs up in the chat box. And give a comment that you got it. Come on. And if you didn't got it, kindly write your specific query. So this is morphological classification of anemia. Okay. Now I'm giving you a table. You have to learn that table in which I will give you various shapes of RBC. Normal shape of RBC, I told you. From the top, it's a circle. And from the side view, it's biconcave like this. This is normal. But there are certain abnormal shapes of the RBC. Have a look. And you have to learn the corresponding conditions also. See. Normally, RBC, peripheral two-third is colored and central one-third is pellar. I told you, peripheral two-third is colored, central one-third is pellar. But sometimes there is a dot at the center. It's known as target cell. You know, bull's eye hit. So it is known as target cell. So it is seen in thalassemia and post-splenectomy. If you remove the spleen of any person, the spleen is traumatized, having cancer or having any tumor. If you remove the spleen, then it can be target cells are seen. So learn the two conditions and learn the diagram. So target cells are seen in thalassemia and post-splenectomy. It's the PYQ. It's your MCQ frequently asked in your exam. Okay, bite cell. What is bite? Just suppose it's a circle. It's a cake. It's a slice of a cake. You like cake? It's a slice, circular slice. And I have taken one bite of it. One bite. So the remaining cell, this is a circle, this is a cake or anything, it is a circle, it's a pie. And I have taken a bite off of it. So the remaining cell is known as bite cell. It is looking that someone have taken one bite out of it. So this shape is known as bite cell. I'm explaining you what do you mean by bite shape. So this shape is known as bite cell because it is looking someone have taken one bite. Got my point? So bite cells are typically seen in G6PD deficiency, very important MCQ. They ask you and they give you the peripheral diagram also in which you have to identify and tell the G6PD deficiency. Sickle cell, everyone know. This shape is known as sickle cell. It is seen in sickle cell anemia. Everyone know. Teardrop. Sometimes the RBC looks like this. Teardrop यानी आँख का आंसू. We cry, we have tears. The shape of the tear is like that. So teardrop RBCs are seen in myelofibrosis. Please learn the condition. Now I'm telling you two conditions. Please see. Everyone see. I'm telling you two conditions. Now see, this is the RBC. This is the RBC. On the surface of the RBC, I'm drawing projections. These are the sharp projections. Sometimes RBC have sharp projection and sometimes the RBC have blunt projection. So here the projections are sharp, and here the projections are blunt. Both have projections. These are known as spur cell and these are known as burr cell. You can learn S for S. spur cell have sharp projection and burr cell have blunt projection. This is very easy to learn, but you have to learn their other names. है ना? Other name of spur cell is acanthocyte. है ना? You have to learn it. है ना? And the other name of burr cell is echinocyte. Okay, you have to learn it. You have very frequent questions on that. So first thing is to identify what is acanthocyte or spur cell, one and the same thing, and what is echinocyte or burr cell, one and the same thing. The first thing you should identify in their diagram. They can give you an image-based question. Hematology is a very vital area where image-based questions are very frequently asked. The second thing you have to learn one condition in which they are saying. So spur cells basically they are seen in A beta lipoproteinemia. A beta lipoproteinemia. It's a condition in which it is seen. And burr cells are basically seen in uremia, when the person have uremia. So you have to learn one condition in which they are seen. So see, this is spur. Can you see the RBC? Say yes. Can you see the sharp projection on it? This is spur cell or acanthocyte because the projections are sharp and it is seen in A beta lipoproteinemia. See the next RBC. This one. See, here the projections are blunt. They are blunt. So it is burr cell or echinocyte and it is seen in uremia. The spelling mistake is there, it's uremia. Hana. What is those? Multiple RBCs are forming a train. The bogies of a train attached with each other. So RBCs are sticking with each other. Okay. It is known as Rowlatt's formation. It is known as Rowlatt's formation and it is seen in multiple myeloma. Can anyone tell me the cause of Rowlatt's formation in multiple myeloma? What is the cause of Rowlatt's formation in multiple myeloma? Huh? You know the RBCs. This is RBC, this is RBC. Normally RBCs have negative charge on them. That's why they repel each other. Normally in a healthy individual, all of us, all those person who are healthy, RBCs repel each other. Because they have negative repel each other. They don't come closer, they don't form Rowlatt's. But what is happening in multiple myeloma? So multiple myeloma is the condition in which the person is forming abnormal light chain. You know immunoglobulin. In immunoglobulin, there are two light chain, two heavy chain. This is known as antibody or immunoglobulin. Multiple myeloma is a condition in which B lymphocytes have some mutation. So they form only light chain, no heavy chain. I repeat my words. They form only light chain. No heavy chain. So I cannot call it immunoglobulin. This is immunoglobulin having two light, two heavy. But if only light are there, no heavy is there, it's not immunoglobulin. I will call it abnormal protein. It's an abnormal protein, and the name of abnormal protein is light chain. This light chain it's positively charged and it will neutralize the charge on the RBC. It is present in the blood. It will neutralize. So RBCs become neutral and now they stick with each other because the negative charge is neutralized and they will form the Rowlatt's. So this is the reason it's also a question. Okay, say yes. So multiple myeloma have Rowlatt's formation. So I want you to learn all these shapes. You get frequent questions in FMGE exam out of that. Say yes. Got it? Say yes. Okay. So let me come on the inclusion bodies now. RBCs. We are studying RBCs, all about RBCs. Before coming on the anemia, you should have an overview. Bhai, RBC mein hota kya hai? Now there are 5 inclusion body. This is a RBC. Inside the RBC, we have nothing. No nucleus even. We don't have nucleus. We have only hemoglobin at the peripheral 2/3. And central 1/3 is empty. This is normal RBC. But sometimes inside the RBC, we have certain dot-like structures, which are known as inclusion bodies. So there are 5 types of inclusion bodies. You have to understand the differences between them. You have to understand their diagram. You have to understand their composition. And you have to learn one condition in which they are seen. So from this page, this is the master page. There are 15 MCQs I can frame. 15. Out of 15, at least 1 will come in your exam. So this is a very important page. Please concentrate, please. So the first inclusion body is Howell-Jolly body. Howell-Jolly, HJ. Howell-Jolly body. What is Howell-Jolly body? I will show you. See this one, the first diagram. All 5 are shown here. First one, listen. See the RBC. It is 1 and 1. One RBC have 1. See here. It is always one RBC have one Howell-Jolly body, not multiple. This is the first feature. I have drawn diagrams very specifically. Okay. Now the Howell-Jolly body can be central, can be peripheral. Sometimes it is at the center, sometimes it's at the periphery. That's why I've drawn 2 RBC. And it is 1 and 1. Now see the diagram. See. Can you see the arrows? The diagram is although small, I guess you can see, but see this RBC, see this one, this one. All these RBC have a dot. Here it's central, here it's peripheral, here it's peripheral, here it's central. So sometimes it's central, sometimes it's peripheral, but it is 1 and 1. 1 and 1 RBC. Okay. So this is Howell-Jolly body. I guess everyone can identify it. Okay, number one. And what is it is made up of? I told you RBC don't have nucleus. How does the RBCs are formed? RBCs are formed in the bone marrow. So this is a bone marrow. It is formed from the hematopoietic stem cell. So hematopoietic stem cell give rise to various precursors, and finally RBC formed and it comes in the blood. Finally, after formation, RBC it is coming in the blood. The precursors of the RBC have the nucleus. These are known as normoblast, early normoblast, intermediate normoblast, late normoblast, reticulocyte. They have the nucleus, and nucleus is lost, and then RBC is coming in the blood vessel. It is normal. Sometimes a remnant of the nucleus it is carrying with it, a remnant of the nucleus, and that is Howell-Jolly body. So basically, Howell-Jolly body is the nuclear remnant. It is made up of DNA. So it's a very frequent MCQ. What is Howell-Jolly body? Say, ma'am, Howell-Jolly body is a nuclear remnant. Okay, it is a nuclear remnant. And it is seen in the condition splenectomy. Whenever the spleen of some person is removed, the surgery is done, or spleen is present but non-functional, like in sickle cell anemia, then it is seen. So it is seen in splenectomy. So this is the first question. Now you can get this image. Image-based question. 3 questions on this. The first question is very simple. Identify the inclusion body. It's very simple answer, Howell-Jolly. The second question is a second level question. They will not ask you to identify. Identify apne man mein karo and tell me the composition. Tell me the composition. So answer is DNA or remnant nucleus, whatever is given in the option. DNA or remnant of the nucleus. And third question is, don't identify. They are not asking to identify. Don't tell the composition. वो सब मन में करो. Tell me the condition in which it is seen. Whatever it is, tell me the condition in which. So answer is splenectomy. You got my point? So same image, I can frame 3 questions on that. So on each image, you have 3, 3, 3, 3, 3. Total 15 questions. Got my point? You frequently get image-based question in FMGE specifically. Got it? Say yes. So this is, okay. Yes, so in autosplenectomy also it is seen, in sickle cell anemia it's autosplenectomy only. So whatever splenectomy it is there. Okay, the second is the papillimer body. Papillimer body, it's also seen in RBC. You can see this is the RBC, but they are multiple in one. There are multiple bodies in one RBC in contrast to Howell-Jolly body, which is 1 in 1. And it is always present at the periphery. At the periphery forming a rim. Now see this diagram. In this diagram, can you highlight this RBC? In this RBC, can you see multiple dot-like structures are there at the periphery? This is papillimer. You can differentiate Howell-Jolly from the papillimer. This is 1 in 1. This is multiple in 1. This is can be central, can be peripheral. This is always peripheral. Now, this is actually made up of ferritin. Hemoglobin is made up of heme. Heme is iron. So, sometimes iron is an axis and it forms the ferritin. So, ferritin aggregates are there. So, whenever there is ferritin axis inside the RBC, it will aggregate and form papillimer body. So that is papillimer body, the composition and the condition. The third is the Haynes body. Haynes body. They are also multiple in the RBC. You will see, ma'am, then how I will differentiate the papillimer and the Haynes. Both of them you are saying multiple. Number 1, the papillimer is present only at the periphery. The Haynes body are present haphazardly. Number one. And number 2, papillimer body is seen in Romnowski stain. This is not seen on Romnowski. On Romnowski stain, the RBCs are pink. See, this is Romnowski, this is Romnowski. This is not Romnowski stain. Your RBCs are looking green in color. This is supravital stain. So it is only seen on supravital stain. It is not seen on Romnowski. If they're giving you a diagram in your exam in which the RBCs are looking green color, तो पहली चीज तो समझ में आना चाहिए, it's not Romnowski, it's a supravital stain. So on supravital stain, the Haynes bodies are seen. They are multiple and they are haphazard. So this is single 1 in 1. They are multiple but at the periphery. And they are also multiple but they are haphazard and they are seen on supravital stain. And what they are made up of? Actually, the hemoglobin is denatured. They are the denatured hemoglobin and they are seen in G6PD deficiency. Very important question in your exam. The Haynes bodies are seen in G6PD deficiency. Actually, it's the denatured. So again, the same image and 3 questions. Let me frame. So identify the inclusion body. Answer is Haynes body. Second, tell the composition. Say, ma'am, it's denatured hemoglobin. It's not DNA. It's not nucleus remnant. It's not ferritin. It's denatured hemoglobin. And third, tell me the condition. Is it seen in splenectomy? No. Is it seen in ferritin axis? No. It is seen in G6PD deficiency. So same image and 3 questions. Composition, identify, composition and condition. तीनों चीजें. The next is the Cabot ring. It's a figure of 8. The 1, 2, 3, 4, 5, 6, 7, 8. So see the RBC? Inside the RBC, it's like a 8. It's very easy to identify. So they never ask you to identify. They tell the condition in which it is seen. So it is seen in pernicious anemia. Very frequent question. And it is made up of iron and arginine rich histone. Okay, you can learn the composition also. And finally, it's basophilic stippling. It's punctate stippling. Can you see this RBC? This one. It is having dot, punctate. Punctate means multiple thousands of dot, like small dot punctate like structure is there. It is seen in lead poisoning. It is seen in lead poisoning. It is seen in lead poisoning. It is made up of ribosomal RNA and lead poisoning. So tell me the 5 type of inclusion body. First thing you have to identify them. Number 1, है ना? Number 2, you have to tell their composition. पांचों का composition बताओ. Can you tell me the composition? One by one. Who will help me? चलो, tell me the composition of all. Howell Jolly body made up of DNA. है ना? DNA or remnant nucleus. Papinimer body made up of ferritin. Haynes body, they are made up of denatured hemoglobin. है ना? Cabot ring, they are made up of iron and arginine rich histone. And basophilic stippling, it is made up of ribosomal RNA. Please learn by heart. Identify them, learn their composition. Now tell me the one condition. So Howell Jolly body is seen splenectomy. After splenectomy, okay, it is seen. Papinimer body is seen in ferritin axis only. Haynes bodies are seen in G6PD deficiency. Cabot ring is seen in pernicious anemia, and basophilic stippling is seen in lead poisoning. Please learn it. Say, got it? Can we go ahead? So I have covered 15 questions here, and there is high probability out of the 15 are image-based questions. The 15 theory questions are also there. Instead of image, I can ask you direct one-liner question. Okay, so 15 plus 15, 30 questions are based on this page. It's a master slide. You cannot afford to miss it. You cannot. Being a medico, you cannot afford. Okay, so this is the inclusion bodies I have summarized in a compact way. Okay, G. So can we go ahead? Okay, can we do certain questions based on that? Okay, let me do certain questions. Just a second. Why? Okay, annotations were not going. Okay, read the question and tell me the answer. You want me to take certain questions also in between, or only theory will work? Huh? The image shows the presence of what? Can you see this image? 1 in 1 RBC. It's 1 in 1. Either central or peripheral. Write down your answer in the comment box. Quick. 1 in 1. I can see Romanowski stain. It's not supravital, so it cannot be Haynes. Cabot ring are a figure of 8. It's not looking like 8. Papinimer are multiple and at the periphery. They are 1 in 1. So answer is Howell Jolly body, and you all are correct. Very correct. This is a way to identify. Hana. Now same question I'm changing. I'm giving you 4 different options. I'm not asking to identify. I'm asking you to tell me the composition. Your 4 options in the same image are, is it ribosomal RNA? Is it denatured hemoglobin? Is it ferritin? Or is it DNA? What is the correct answer now? The image is same. The options are different. Now what is your answer? ABCD. What is the correct answer? Quick. Yes, in that case, your answer will be D, because it is the remnant of the nucleus. It is a nuclear remnant of the precursor cell. Again, I'm changing the 4 options. The image is still same. I'm changing the 4 option. Now your ABCD option, tell me the condition in which it is seen. Is it seen in pernicious anemia? Is it seen in lead poisoning? Is it seen in G6PD deficiency, or is it seen in splenectomy? What is your answer now? So you can get confused in the exam. The options will be related only from the inclusion bodies. In that case also the answer will be D, that is splenectomy. So I'm explaining you the same image, the 3 questions. In every image there are 3 questions. The second, I can skip the questions. I guess you can do it. Okay, read it. One more we will do. There is a 6-year-old child having lethargy. Lethargy always indicate anemia. If they give you the word lethargy, it means they are talking about the anemia. See, the hemoglobin is 8. So person is severely anemic. Person have excess iron in the blood and excess ferritin in the blood. And peripheral smear is showing this. So here in this image, I can see a RBC, inside which at the periphery, I can see multiple dot-like structures. So it is definitely a papinimer body, because in the image also I can see it's a Romanowski stain, multiple inclusion bodies and 1 RBC, that too at the periphery, and in the question the biggest clue given to me, excess of ferritin. So correct answer is the papinimer body, and you all are right. You all are absolutely right. Okay, the third question is in front of you. The following RBC inclusion body is composed of. The biggest clue given to me, the image, the RBCs are green color. So it's not Romanowski stain. It's a supravital stain. So I can see the green color RBCs are there having blue dots inside that. They all are basophilic dots. The blue dots are there. So of course, first identify what is it. So it is Haynes body. It is Haynes body. It is seen in supravital stain, and they are multiple, haphazardly arranged. And Haynes body are made up of denatured hemoglobin. So my answer is denatured hemoglobin. I hope you got it. I guess everyone knows it is Cabot ring. I'm not explaining. And it is seen in pernicious anemia, the figure of 8. So here the correct answer is this. So I'm skipping the question and coming on the next, the classification of the anemias. And then I will give you detail of few important anemias and quickly move to the leukemias. आज बहुत सारा पढ़ना है. चलो, anemias. There are two types of classification of anemias. The first classification, I have already covered the morphological classification. Based on the morphology, anemias are of three types. I already told you in the beginning of the session, based on the size, RBCs are of three types. And based on the color, RBCs are of two types. Size in pathology is known as cytic. And color in pathology is known as chromic. Learn these words. Size matlab cytic, color matlab chromic. So based on the size, what are the three types of RBC? RBCs can be normal in size, so normocytic. Smaller in size, that's microcytic. And larger in size, that's macrocytic. So I mean to highlight cytic, cytic, cytic. Okay, the three type of cytic you have to learn. Based on the color, RBCs are of only two types. Normochromic. Chroma means color. It's normochromic. And hypochromic. Use the word hypo. Don't use the word micro. It's hypochromic. Got it? Now tell me the three types of anemia. Who will tell me? The first type of anemia in which RBC is normal in size, normal in color. Still the person is anemic. It's normocytic, normochromic anemia. The RBCs are normal in size, normal in color. Still the patient is anemic. Normocytic, normochromic anemia. RBC is normal size, normal color. The second, RBCs are small in size and color is also less. So it is microcytic hypochromic anemia, the second type. And third type, the RBCs are big in size. They are large in size. But the color is normal. So third type of anemia is macrocytic normochromic. So first thing, please learn the three types of anemia. Students always have a confusion in the cytic and the chromic. It's a simple language, cytic and chromic. Now see this slide. I want you to see this second slide first. Now see the lymphocyte. Where is the lymphocyte? I guess in all three slides you can highlight a lymphocyte. Compare the size of the RBC with the lymphocyte. We always compare. So here you can see the RBCs are of same size as that of lymphocyte and see the color also. Color peripheral 2/3 is color, central 1/3 is color. In each of them, peripheral 2/3 and central 1/3. So it is normocytic normochromic. The size is normal, the color is normal. Now see the slide. Your RBCs are small as compared to lymphocyte. So it's microcytic. And see the color. I hardly see any color. Most of them are empty. The pallor is more. Color is only at the periphery. A thin rim is there. So I will say they are hypochromic. So microcytic, hypochromic. And see this slide. The RBCs are big in size as compared to lymphocyte. So they are macrocytic, but color is normal. So based on the slide, you can decide and you get very frequent image-based question out of that. Okay, so first classification everyone knows. It's not a rocket science. It's very easy to understand. Morphological classification, the three type of anemia. But the second type of classification is a little bit difficult to understand, but I will help you. So that is etiological classification. What is the cause of the anemia? Listen. To understand the cause of anemia, you have to understand how does RBC get synthesized. The RBCs are synthesized in the bone marrow. Please understand. So this is the bone marrow I am drawing. And this is the blood vessel I am drawing. So in the bone marrow, the first cell, the ancestor of all cells is hematopoietic stem cell, which gives rise to all the cells. The RBCs also, the WBCs also, the platelet also. From the hematopoietic stem cell, various precursors arise, the normoblast. And finally, the RBC will come in the blood once it is formed. The precursor don't come in the blood. Finally, mature RBC come in the blood. Mature RBC come in the blood. Now you can see this is bone marrow and this is blood vessel. Now I'm saying the person have anemia. There are two causes of anemia. Listen. The first cause of anemia, there can be a problem in the marrow. In the bone marrow, there is a problem in the marrow. The marrow is doing less production. So decreased production is the first cause. The first cause of anemia, there is decreased production. There is some problem in the factory. The marrow is the factory. The bone marrow is the factory of the RBC. It is synthesizing, it is manufacturing. It is manufacturing RBC and liberating in the market. So blood vessels is the market. The second problem, the production is normal. The factory is normal. It is liberating it normally. It is delivering in the blood vessel normally. But there is something in the blood vessel that is destroying it. It can be antibody. It can be a parasite like malaria, plasmodium. It can be a drug. It can be anything which is destroying it. It can be complement. It is destroying the RBC. So here destruction is more. So either decreased production or increased destruction. So these are the two types of anemia. Broadly we say. Either the production is less. There is problem in the marrow. Okay, there is some problem in the bone marrow. In the bone marrow, the production is less. Or there is some problem in the blood vessel. There is some problem in the blood vessel. The marrow is normal, but there is some problem in the blood vessel. Something is present in the blood vessel that is destroying the RBC. So destruction is more. So the second type of anemia in which destruction is more, these are known as hemolytic anemias. Hemolytic anemias, as the name indicates, hemo matlab RBC and lytic matlab rupture of RBC. So someone is causing rupture of RBC. Maybe it is a complement, maybe a parasite, maybe a drug, maybe an antibody. Something is destroying the RBC. Here we don't have any particular name for them, but these one are known as hemolytic anemia. First thing, give me a thumbs up if you got it. Everyone. Now let me tell you the first thing. Whenever an anemic patient coming to you, doctor, I'm having lethargy. I'm feeling very fatigued, loss of concentration. I cannot concentrate. And I always feel like, lethargic and tired. You first thing is order is CBC, either CBC or you do only hemoglobin. You come to know that patient is anemic. Now what is the cause? Patient के लिए तो बहुत simple है, anemia. Very good, है ना? Even a layman know if hemoglobin is less, I am anemic. But what is the cause of anemia? It's for you to know. It's not always it's iron deficiency anemia. It can be any anemia. Now first thing you should know is it the cause lies here or the cause lies here. Because treatment will be different, the prognosis will be different. Got my point? The first thing, so how to know what is the cause? I mean, there is a problem in the marrow or there is a problem in the blood vessel. How to know that? The immediate precursor of RBC is known as reticulocyte. You know the complete sequence? Let me tell you. So first cell is hematopoietic stem cell. Okay, hematopoietic stem cell give rise to myeloblast. Then there is pro-normoblast. Then early normoblast, intermediate normoblast, late normoblast. Finally, there is reticulocyte, and finally there is RBC, and RBC come in the blood. RBC come in the blood. Retic is the immediate precursor of RBC, reticulocyte. Immediate precursor. There are many precursors, but retic is the immediate precursor. RBC comes in the blood. Normally 1 to 2% retic also come in the blood. Normally, I'm having it, you are having it. Only 1 to 2%. Remaining is not. And none of the normoblasts come in the blood. None. I don't have any normoblast in my blood, but I'm having it in my marrow. I'm not having in blood. Okay, got it? Got it. Now, imagine if there is a problem. Now, normally we have 1 to 2% retic also. So retic is the clue. Listen. If there's a problem in the marrow, so everything will be less. Now, RBC will be less, but everything, the complete series will be less. So retic will also less than 1%. So look at the retic. If the retic is less, RBC to hoga hi hoga kam. If the person is anemic, RBCs are less. So along with the RBC, if retic is also less, the problem is in the marrow. But imagine if the problem is not in marrow, so retic will be normal. Something in the blood is destroying only RBC, not the retic. So rather in hemolytic anemias, retic will be more. The marrow will try to compensate the loss. If someone is destroying the RBC in the blood vessel, marrow will do more synthesis of RBC, so more retic will come. So if retic is less, the retic in the blood is less, the problem is in the marrow. If retic in the blood is more, the problem is in the blood vessel, it's hemolytic anemia. So all hemolytic anemias, the retic is more. So retic is the clue. So whenever, what is the approach? Any anemic patient come to your clinic, doctor, I'm having lethargy, tiredness, fatigue. The first thing, order a CBC. If the hemoglobin is less, you find the person is anemic. The second thing you have to order is retic. Based on the retic, you decide what is the cause of the anemia. If retic is less than 1%, the person having some problem in the marrow. Production is less. That's why the person have anemia. And if retic is more, the problem is in the blood vessels. So destruction is more. Here the problem is destruction. How many of you got it? Give me a thumbs up. Give me a thumbs up. How many of you got it? So this is the approach. So there are two main causes of anemia. Blood loss is third cause. Everyone can understand. Just suppose neither the problem is in the marrow. I'm a person. I don't have any problem in my marrow. I don't have any problem in my blood vessel. I'm a healthy individual. But if some individual got accident, just suppose I got accident. Fortunate if I didn't have. But if someone have accident, someone has surgery. So if blood loss is there. Acute or chronic blood loss. So it can lead to anemia. Apart from that, decreased production, here the problem is in the marrow, and increased destruction, here the problem is in the blood vessel. Okay, so based on that, we classify anemias. So let me take one by one. Let me take, you tell me, ma'am, what are the causes in the marrow? What are the causes in the marrow? Why production is less in the marrow? There can be some problem in the marrow, no? What are the problems in the marrow? So there can be three type of problem. The first problem, the God forgot to give the hematopoietic stem cell. Either congenital absence, hereditary, or acquired. Some drug is killing the hematopoietic stem cell. So the father is absent. If the father is absent, all the ancestors are absent, no RBC will be formed. So such anemia is known as aplastic anemia. So problem in the marrow. Aplastic anemia. So in aplastic anemia, the hematopoietic stem cell is absent. Either hereditary, God forgot to give, or some drug or some parasite or some agent, some virus is killing it. Okay, some biological agent is destroying it. Okay, like parvovirus do so. Okay, so it is the hematopoietic stem cell. Okay, it is known as aplastic anemia. Okay, now if the aplastic anemia is not there, then what else can be the problem in the marrow? In the marrow, three problems are there. The first problem, the stem cell is absent. Okay, the stem cell. So it can lead to anemia. Such anemia is aplastic anemia. You can ask me a question, ma'am. If the stem cell is absent, you are saying either hereditary or acquired, whatever is the cause. It gives rise to all three series. Now it gives rise to RBCs also, WBCs also, platelet also. If the ancestor is absent, there should be absence of all three. So yes, actually in aplastic anemia, it's pancytopenia. Person don't have RBC, don't have WBC, don't have platelets, sometimes 0, 0, 0. So it is pancytopenia. It is not only anemia. Aplastic anemia is not anemia, it's pancytopenia. So everything is conceptual. If you understand the things, it's very easy to understand everything. Got it? Start from the beginning. Got it? Listen. The second problem is that, can you see the cytoplasm of all the precursors? Name the precursors. This is myeloblast. This is pronormoblast, early normoblast, intermediate normoblast, late normoblast. At late normoblast, the nucleus is extruded. Finally, this is reticulocyte, and finally, this is RBC. Have a look on the precursors if you can't learn it. It's okay. Now, there can be problem in the cytoplasm of all of them. The cytoplasm contain the hemoglobin. Cytoplasm contain the hemoglobin. So, hemoglobin is absent. So, RBC cannot be synthesized. So, hemoglobin. So, hemoglobin have two components, heme and globin. So, either heme is absent, globin is present, or globin is absent, heme is present. Got it? Heme is absent in 3 anemias. Iron deficiency anemia. Iron ही नहीं है तो heme कहाँ से बनेगा? है ना? Sideroblastic anemia. है ना? Heme cannot be synthesized. And anemia of chronic disease. Anemia, AOCD. In these 3 anemias, iron deficiency anemia, sideroblastic anemia, and anemia of chronic disease. है ना? In these 3 anemias, the iron is absent. That's why the heme cannot be synthesized. There is a problem in the heme. And there are 2 anemias in which globin either absent or defective, thalassemia or sickle cell anemia. Hana. So there is problem in the cytoplasm. Hana. And the last thing is that there is some problem in the nucleus. Hana. The stem cells are normal. The cytoplasm, I mean the hemoglobin is normal. Finally, there is a problem in the nucleus. You'll say, ma'am, RBCs don't have nucleus. Why you are bothered about the nucleus? I know RBC don't have nucleus. I know that. But the precursors of the RBC have the nucleus now. Imagine if the precursors ka nucleus kharab hai. Hana. Precursors ka nucleus is defective. So RBC is going to be defective. Got it? So nucleus is made up of DNA. And for the synthesis of DNA, we require vitamin B12 and folic acid. If someone is having vitamin B12 deficiency or folic acid deficiency or both deficiency together, DNA cannot be synthesized, nucleus cannot be synthesized, the precursors have defective nucleus, so RBC cannot be synthesized. So these are the causes of anemia due to decreased production. Ye marrow ka problem hai. Hana. So this is the problem in the marrow. Okay. Now the problem is in the blood vessel. Hana. So there is something who's destroying the RBC in the blood vessel. The marrow is absolutely normal. The factory is normal. The manufacturer is normal. And it is releasing it in the market. The market is the blood vessel. Now there is something in the blood vessel that is destroying it. So there are 2 types, hereditary or acquired. In the acquired, Hana, if the antibody is destroying the RBC, it's AIHA. AHA. Autoimmune hemolytic anemia. It's autoimmune. Body is forming antibodies against the own RBC. Autoimmune hemolytic anemia. Okay, let me draw it. Okay, so see, this is a blood vessel. Let me draw a blood vessel. Inside the blood vessel, let me draw 3 RBCs to explain you the 3 causes. Okay, this is RBC, this is RBC, this is RBC. The marrow is normal. It is releasing the RBC in the blood vessel. Now, there is something in the blood vessel that will destroy it. Hana, if the body is forming autoantibodies against own RBC, Hana, so all the RBCs are destroyed by the autoantibodies and the person will have anemia. Such anemia is known as AHA. What is the full form of AHA? Autoimmune hemolytic anemia. AIHA. AHA. है ना? Sometimes, you know, there is a thrombus formation in the blood vessel. So RBC is coming and colliding with the thrombus and getting ruptured. है ना? So there is problem in the blood vessel. There is thrombus in the blood vessel which is causing the fibrin in the blood vessel. The thrombus in the blood vessel causing the rupture of the RBC. So it will also have anemia. This is known as MAHA. This was AHA. This is MAHA. What is MAHA? MAHA, the full form is microangiopathic hemolytic anemia. Here the cause of hemolytic anemia is microangiopathy. By microangiopathy, I mean the thrombus. There is a defect in the wall of the blood vessel. Okay. And the third cause, there is sometimes complement. You know, humans have complement C1 to C9. That is causing the destruction, auto-destruction of the RBC. So such anemia, here also the person have anemia. It is known as paroxysmal nocturnal hemoglobinuria PNH. I will explain you the details. Please understand. Hana. So these are the 3 causes of acquired causes of autoimmune hemolytic anemia. So there is something present in the blood vessel that is causing destruction of the RBC. The marrow is normal. The production is the normal. But something is present in the blood vessel that is destroying the RBC. It can be antibody. It's known as AHA. It can be thrombus. It is known as MAHA. And it can be the complement mediated destruction of the RBC. It is known as paroxysmal nocturnal hemoglobinuria, that is PNH. So these are the 3 causes of acquired hemolytic anemia. Acquired. Hana. And there are 4 causes of hereditary also. Hana. Hereditary spherocytosis, hereditary G6PD deficiency, sickle cell anemia and thalassemia. So sickle cell anemia and thalassemia are such anemias which are coming both sides. They have problem in the marrow also and they have problem in the destruction also. Hana. Got it? So this is final classification of anemia. Let's write it together. Chalo. Who will help me? Anemia. I don't want morphological classification. Morphologically, everyone knows normocytic, normochromic, microcytic, hypochromic, and macrocytic, normochromic. I guess everyone knows. I'm not interested in that. I am interested in etiopathological classification of anemia, and I want you people to participate and tell me the answers. Quick now. Chalo. Who will tell me? Anemia, the two types of anemia. What is the main two causes of anemia? Say, ma'am, either there is a problem in the bone marrow, that is production is less. Decreased production. So there is a problem in the marrow, bone marrow. Or there is a problem in the blood vessel, the destruction is more. Destruction is more, there is a problem in the blood vessel. These type of anemias are known as hemolytic anemia. Okay, here we don't have any particular name. Okay, now further classify them. Can you classify them further? Say, ma'am, yes. Here there are three causes. 1, 2, 3. And here we have only two causes, hereditary and acquired. Hana? So broadly we are classifying. Here the problem can be in the stem cell. Hana? The stem cell is absent. Hana? Here the problem can be in the cytoplasm. Cytoplasm matlab hemoglobin. The problem is in the hemoglobin. And the problem can be in the nucleus. The nucleus of the precursors. Okay. If the problem is in the stem cell, the anemia is known as aplastic anemia. Hana? The problem is in the hemoglobin, again of two types. The problem is in heme or the problem is in globin. Specified, to be specific. The problem is in the heme. So there is some problem in the iron. Iron is deficient, so heme cannot be synthesized. It is iron deficiency anemia, number 1. Sideroblastic anemia, number 2. Anemia of chronic disease. Okay. In the globin, there are two problems. Hana? Globin absent hai, so it is thalassemia. Or globin present hai, but the quality is not good. It is sickle cell anemia. So both of them are known as hemoglobinopathies. This one is called quantitative hemoglobinopathy, in which the quantity of globin is less, but quality is good. Here the quantity is normal, but the quality is not good. It is structurally defective. So these two are hemoglobinopathies or globinopathies. Finally, there is problem in the nucleus, matlab DNA cannot be synthesized because vitamin B12 and folic acid are deficient, and this anemia is known as megaloblastic anemia. So these are all anemias in which there is problem in the production. Now coming on the anemias in which there is a problem in the destruction. The production is normal, but there is destruction. So again, we divide them into category, the hereditary and acquired. Acquired means very easy to say. Who is destroying? Is it antibody who is destroyed? Is it thrombus who destroy? Or is it complement C1 to C9 who destroy? If it is antibody who is destroyed, it is known as AHA, autoimmune hemolytic anemia. If it is thrombus who is going to destroy, it's MAHA, microangiopathic hemolytic anemia. And if it is complement who is going to destroy, it is PNH, paroxysmal nocturnal hemoglobinuria. Okay, these are the three acquired causes. In the hereditary, somehow you have to learn here, the hereditary spherocytosis is there. G6PD deficiency is there. And if you wish, sickle cell anemia and thalassemia, you can include here also. How many of you got it? This is the classification of anemia from which you get many questions. Got it? Say yes. Apart from that, wait. Anna, climax abhi baki hai. Wait. Apart from that, we have one more classification of anemia. You have to tell me that also. Tell me that. Tell me the morphological classification. Say, ma'am, normocytic, normochromic. Microcytic, hypochromic. And macrocytic, normochromic. So tell me, out of all these anemia, which is normocytic, which is microcytic, and which is macrocytic? That is the combination of the two classifications. Jisme se you get many questions in your exam. Take my words. How do you classify? I will give you mnemonics. So let's combine the two classification finally. And this is the thing which I want to tell you. So out of all these anemia, how many of them are microcytic? In which RBC is less than 7.5 micrometer. How many of them are normocytic? The RBC size is normal. And how many of them are macrocytic, in which RBCs are big in size? So you have to learn. Three mnemonics here. Okay. So microcytic anemias are 4. The mnemonic is SITA. S-I-T-A, SITA. SITA. You can say SITA, S-I-T-A. S stand for sideroblastic anemia. I stand for iron deficiency anemia. T stand for thalassemia, and A stand for AOCD, anemia of chronic disease. So these 4 are microcytic anemia. There are 5 anemias, or all hemolytic anemias. They are normocytic. So the mnemonic is SHAPE, S-H-A-P-E. Whatever hemolytic anemias I told you, it can be sickle cell anemia, hereditary spherocytosis, autoimmune hemolytic anemia, AHA, PNH, and G6PD deficiency. E for enzyme. Enzyme matlab G6PD deficiency. And finally, macrocytic anemia. The RBCs are big in size. How many of them? So I'm having a mnemonic, Lady Harding Medical College, LHMC, Lady Harding Medical College. L stand for liver diseases, H stand for hypothyroidism, M stand for megaloblastic anemia, and C for certain cytotoxic drugs like methotrexate and phenytoin. Okay, so tell me how many anemias are microcytic, how many anemias are normocytic, and how many anemias are macrocytic? Can you tell me the mnemonic? Here the mnemonic is SITA, here the mnemonic is SHAPE, and here the mnemonic is Lady Harding Medical College. Now please say the full form by yourself. If I say it will take time, so please learn it. You are going to get MCQs out of that. Okay, you have many MCQs. Let's start hemolytic anemias. Okay, now I will not teach you all anemia. So if you count together, we are having in total 20 anemias to be discussed. I taught you the names, classification. At least you know the classification. Maximum questions are from classification, but I cannot give you the detail of all 20. So I will give you ultra important 6-7 anemias which are frequently asked, and we will quickly move on the leukemias after that. So stay tuned, Hannah, till end. Okay, chalo. So let's start the hemolytic anemias. I told you now the two broad causes of anemia. The problem is in the marrow, that is decreased production. I will teach you this later on. Or the problem is in the destruction. The destruction is more. So I am first teaching you the hemolytic anemias. The hemolytic anemias, the problem is in the blood vessel. The destruction is the more. Hana? So if RBC get destroyed, more and more bilirubin is formed. Normally, listen now, listen. It is of two types. Listen, hemolytic anemias. Please everyone understand in this master diagram. This is the bone marrow. This is the blood vessel. And this is the reticuloendothelial system. That is liver and spleen. Inside liver and spleen, we have macrophages. So macrophages and liver and spleen is known as reticuloendothelial system. Listen, start from the beginning. How does RBC synthesized? Say, ma'am, from hematopoietic stem cell present in the marrow. Many precursors are there. Normoblast, early, intermediate, late. Finally, retic is formed, and finally RBC is formed, and it comes in the blood. So this is the RBC which is coming in the blood. It remains in the blood here for 120 days. What happens after 120 days? The half-life, the lifespan of the RBC is 120 days. What happens after 120 days? So, ma'am, it get destroyed. So, my next question to you, how does it get destroyed? How does it get destroyed? Where does it get destroyed? Where? Bata do pehle to. How ki baat mein. How does nahi? Where does it get destroyed? So normally in me, in you, in healthy individuals who are non-anemic, who don't have any hemolytic anemia, so it get destroyed in the reticuloendothelial system. So this RBC after 120 days plus minus 10 days, it moves to the macrophages of the liver and spleen. This is known as reticuloendothelial system and get ruptured inside the macrophage of liver and spleen. So it do not release freely in the blood. Okay, so it is moving here in the liver and spleen, and it is getting destroyed. And meanwhile, new RBCs are going to come here. So RBC count in the blood is more or less constant. It is 4.5 to 5.5 million per deciliter. So they are destroying and new are coming. They are destroying, new are. So there is an equilibrium maintained. Jitna destroy ho raha hai, utna hi ban raha hai. So rate of production is equal to rate of destruction in a healthy individual who is non-anemic. Rate of production is equal to rate of destruction. Okay, so this is more or less equal. So person is non-anemic. Say yes, this is the equilibrium. Got it? Now, I'm saying the person is not normal. The person is having hemolytic anemia. So there is something present in the blood vessel that is destroying the RBC before 120 days. So it is known as premature destruction of RBC. So in hemolytic anemia, the person have premature destruction of RBC. It is premature destruction of RBC. The RBC are destroying before 120 days. That is the problem. RBC to destroy वैसे भी होता है ना after 120 days. But here the problem is that RBC is destroyed as soon as it is coming in the blood vessel from the marrow. As soon as it is coming, it is getting destroyed. As soon as it is coming. So before 120 days, it is premature destruction. So either it is the antibody, or it is the complement, or it is the thrombus, which is getting destroyed. Whatever it is destroying, it is destroying. Now, this is known as hemolytic anemia. But hemolytic anemias are of two types. Normally, our RBC get destroyed in reticuloendothelial system. But in hemolytic anemia, where does it destroy? It is destroying before 120 days. But where does? So there are two possibilities. Sometimes the RBC get ruptured in the blood vessel only. It is ruptured here only. So all the hemoglobin is released freely in the blood. This is known as intravascular hemolytic anemia. This one is intravascular hemolytic anemia. And sometimes it is moving to the reticuloendothelial system only and getting ruptured inside the macrophage of liver and spleen. This is known as extravascular, like normal. But you will say, ma'am, then what is the difference between extravascular and normal? Extravascular is before 120 days. And normally it is after 120 days. So it is premature destruction. So it can be intravascular, it can be extravascular. How many of you got it? So there are two types of hemolytic anemias, intravascular and extravascular. Say yes. Now tell me the properties of each of them. What are the differences and what is the difference in the clinical feature in each of them? You will say, ma'am, does it matter? Is the RBCs destroying in the blood vessel or in the liver and spleen? Yes. The clinical features will be different now. Patient will present to you with different clinical features. So can I take the next page and tell you? Okay. Yes, the lectures are more than enough for the FMGE exam. You can just watch this for a crisp revision. Okay. So this is the blood vessel and this is the reticuloendothelial system. Okay, this is the macrophage. Intravascular, extravascular. Let me draw RBC here and get it ruptured in the blood vessel. This is intravascular. And let me draw RBC here, get it ruptured in the extravascular. So let's first talk about intravascular. In the intravascular, This is intravascular, this is extravascular. In both of them, the RBC get destroyed before 120 days. Here when the RBC get destroyed, you imagine what is happening. Say, ma'am, hemoglobin will come in the blood. Free hemoglobin. So patient have hemoglobinemia. The hemoglobin present in the blood. Patient never have free hemoglobin in the blood. Normally, I don't have because hemoglobin is present inside the RBC. The free hemoglobin is toxic. It is not present freely in a normal individual. Here the person have free hemoglobin in the blood. It is known as hemoglobinemia. And this hemoglobin will go in the kidney and get excreted in the urine. That is hemoglobinuria. So urine will be red in color. Patient will run to you, doctor, I am having a smoky urine. I am having red urine. I am having blood in my urine. Hemoglobinemia followed by hemoglobinuria. Hemoglobinemia, nemia means blood, and hemoglobinuria. These are the two properties here. Now this hemoglobin will convert into hemosiderin. So patient have hemosideриnemia and hemosideриnuria also. And sometime it get convert into math hemoglobin. So patient have math hemoglobinemia and math hemoglobinuria. So hemoglobinemia, hemoglobinuria, hemosideриnemia, hemosideриnuria, math hemoglobinemia, math hemoglobinuria. These are all features of intravascular. These are all. Here the RBC get ruptured. In extravascular, it is rupturing in a macrophage. It is in a closed system. So here the hemoglobin will present in the macrophage only. It will not come in the blood. No. So all these findings are absent in extravascular. No hemoglobin, no hemosiderin, no math hemoglobin. The biggest difference between intravascular and extravascular. Understand the basics. Not only this. Here RBC contain an enzyme known as LDH. It will also released in the blood. So patient have increased LDH in intravascular. Here also LDH will not come in the blood because it is a closed system. Not only this, in the blood, there is a protein which is known as haptoglobin. Normally we all have it. If the hemoglobin is released freely, hemoglobin make a complex with the haptoglobin. So haptoglobin, the free haptoglobin concentration will fall. If you see the free haptoglobin concentration, it will fall. Haptoglobin will fall. So hemoglobin in the blood, in the urine, hemosiderin in the blood, in the urine, math hemoglobin in the blood, in the urine. LDH will rise and haptoglobin will fall. These are the features of intravascular. And there is little bit of hemoglobin convert into bilirubin. So mild jaundice. These are the features of intravascular. Let me summarize the features of the extravascular. In extravascular, all these are absent. No hemoglobin in the blood or the urine, no math hemoglobin, no hemosiderin, no rise in LDH, no fall in haptoglobin. All these are absent. Say, ma'am, what will be present in extravascular? Hepatomegaly and splenomegaly will be the biggest feature there. वहाँ पे सबसे बड़ा problem क्या है? The RBC get destroyed in the liver and the spleen. So hepatomegaly and splenomegaly will be the features there. And there will be severe jaundice. Most of the hemoglobin get converted into bilirubin, so severe jaundice. Here there is mild jaundice, here there is severe jaundice. Say yes if you got it. So these are the features. So RBC get destroyed at two places, intravascular or extravascular. In the intravascular, it is destroying inside the lumen of the blood vessel. In the extravascular, it get destroyed inside the macrophage of the liver and the spleen. The same thing is shown to you. You can see a blood vessel. So RBC get ruptured here only and all the features I taught you. And here the RBC get destroyed inside the macrophage of liver or spleen. So this is intravascular, extravascular. Intravascular mein I told you hemoglobinemia, hemoglobinuria, math hemoglobinemia, math hemoglobinuria, hemosiderin not written here, hemosideриnemia, hemosideриnuria, haptoglobin will fall, LDH will rise and mild jaundice. So these are the features of intravascular. Extravascular, all these features are absent. No hemoglobin, no hemosiderin, no math hemoglobin, no LDH rise, no haptoglobin fall. No LDH rise, no haptoglobin fall. Patient have severe jaundice, patient have hepatomegaly and splenomegaly. These are the features of extravascular. How many of you got it? Can you summarize the features? Hemoglobin, blood urine, hemosiderin, blood urine, math hemoglobin, blood urine, rise in LDH and fall in haptoglobin. All these are absent here. Here the unique feature is hepatomegaly, splenomegaly, but jaundice is a common feature in both of them. But here the jaundice is mild and here the jaundice is severe. Now you imagine how many questions you get out of that. You want some questions? Read the question, tell me the answer. If you understand the basic, nothing to learn, only thing to understand. I can challenge, pathology mein kuch bhi learn karne ka nahi hai. Only thing, the complete pathology is to understand. Okay, chalo, read it. Read the question, tell me the answer. Quick, fast. All are features of intravascular hemolysis except, I'm asking the word except. What is the correct answer? Thrombocytopenia, yes or no? Hemosideриnuria, decrease haptoglobin or rise bilirubin. So bilirubin rise, yes, but mildly, but it do. Haptoglobin will fall, hemosideриnuria, but thrombocytopenia ka kuch lena dena nahi hai yahan pe. So there is no thrombocytopenia. Okay, the next question is in front of you. Extravascular hemolytic anemia causes what? Extravascular ka feature batao. Is it hemoglobinemia, hemosideриnuria or hemoglobinuria? or is it jaundice? What is present in extravascular? In extravascular, all these things are absent. Only jaundice, which is severe, is present. So correct answer is C, and you all are absolutely right. Hannah, I hope you understood the concept. Okay, the next question is in front of you. All are features of hemolytic anemia except they have not mentioned intra or extra. So consider both. Consider both. So hemoglobinuria is present in intravascular. Jaundice is present in both. Hannah, hemosideриnuria is also present in intravascular. But it is not increased haptoglobin. It is decreased haptoglobin which is present. Decreased haptoglobin which is present in intravascular. So I will go with C because it is decreased haptoglobin. So this is how you get the questions. Now I will explain you the details of few anemias here. Hannah. So I will give you the details of, hereditary spherocytosis, ultra important, you get many questions, and PNH. These two I will give you the details, Hannah, because the time is limited. Okay. So let's start hereditary spherocytosis. What is the problem in hereditary spherocytosis? What is the shape of RBC? I told you the shape of RBC is biconcave. The shape of RBC from side view, it's biconcave. Hereditary spherocytosis is the disease in which the shape of RBC changes from biconcave to a sphere. Have you seen a ball, a small ball? The ball is a sphere, it's spherical. So that is the disease hereditary spherocytosis, and it's congenital, it's hereditary. The gene is mutated. So this is hereditary spherocytosis in which the biconcave shape of the RBC changes into sphere. You will say, ma'am, why? Which gene is mutated? What is the cause? Why the shape is changing? To understand this, you first understand what is the cause of biconcave shape. ये biconcave shape देता कौन है RBC को? Tell me the proteins. There are 7 proteins which are responsible. If mutation in any of them will occur, it will result in this shape. So first understand the normal shape. So hereditary spherocytosis, as I told you, it's hereditary. You have to tell me it's autosomal dominant condition. G6PD is also hereditary. This one is X-linked recessive. Okay, and these two are autosomal recessive. So if it is hereditary, now first you have to tell me the inheritance. There are 4 types of inheritance you may be knowing: autosomal dominant, autosomal recessive, X-linked dominant, X-linked recessive. So there are mnemonics for that, and I guess yesterday I have given you the list. Have I given you the list for autosomal dominant? वो familial hypercholesteremia autosomal dominant है. Have I given you? So please see hereditary spherocytosis autosomal dominant है का जो H है, that is hereditary spherocytosis. Have I given you the list? Graham Bell का G is coming here. Have I given you the list? A B C D E F G H SPW? So उसमें ये आता है. So please check it out. So you get many questions out of that. If you have not watched my yesterday's lectures, available on the same YouTube channel, and you must go for it. All the students who are new today, please watch it. It is the complete general pathology in a compact manner I have covered yesterday in just 4 or 5 hours. Okay, chalo. Hereditary spherocytosis. So first thing, it's autosomal dominant. Now you have to understand the membrane of the RBC. Let me explain you the membrane of the RBC. Now this is the RBC. The membrane of the RBC have 2 proteins in that. Intramembranous protein. The name of the protein is band 3 and glycophorin A. Band 3 and glycophorin A. You have to learn that. Just below the membrane, we have a chain. We have a protein in the form of the 2 chains. It is known as spectrin. Spectrin. It is 2 chains, alpha and beta spectrin. It is spectrin. Now we have to connect the transmembrane protein to the spectrin. We need connectors. So we need 2 connectors over here and 2 connecting protein here. So 4 connectors are there. 4 connectors are there. What is the name of these connectors? Here band 4.2, here band 4.1. Here it is ankyrin. Ankyrin. And here it is actin. What I mean? I mean to say, simple language, I mean to say band 4.2 and ankyrin connect band 3 to spectrin. And band 4.1 and actin connect glycophorin to spectrin. So total count, there are 7. 2 of them, okay, who 7? 2 of them are transmembranous. Which 2? Band 3 and glycophorin. One is spectrin, which is the main chain, and 4 connectors. You know the 4 connectors, which of them is connecting what. Now, if any of them is mutated, it will change the shape of biconcave and it will convert into sphere. Okay, got my point? Most important among them, most important for the biconcave shape is spectrin. It's an MCQ. Which is most important for biconcave? Although all are important, but most important for biconcave shape is spectrin. It's a question. But mutation don't occur most frequent in the spectrin. Most frequently mutation occurs in ankyrin. So what's the sequence of mutation? Most common mutation occur in ankyrin. It will change the biconcave to sphere. The second most common mutation occur in band 3, and third most common mutation occurs in spectrin. But most common responsible is the biconcave. How many of you got it? So these are the 7 proteins. All of them are responsible for biconcave shape of the RBC. I'm having biconcave RBCs. Okay, you are also having. So these 7 proteins are responsible for that. But the most important is spectrin. है ना? Now in hereditary spherocytosis, which is mutated, although any can be mutated, but most frequently mutation occurs in ankyrin. So there are two different questions, people. Okay, got it? So you can see this is the normal diagram shown to you here. This is the membrane, है ना? See the two transmembrane protein, band 3, make it band 3, and glycophorin, है ना? See the spectrin. This is the spectrin. And I want you to have a look on the connectors, two connectors, 4.2 and ankyrin over here, 4.1 and actin over here. है ना? Total 7 proteins are there. है ना? Most important is spectrin, which provide the biconcave shape. है ना? Now, most common mutation occur in ankyrin, followed by band 3, followed by spectrin. है ना? So most common defect in hereditary spherocytosis is ankyrin. It's a very important MCQ. There is one more disease which is known as hereditary elliptocytosis. I'm telling you, normal shape of RBC is biconcave, है ना? So there is a disease in which from biconcave shape it changes to sphere. The name of the disease is hereditary spherocytosis. In the same way, there is a disease in which instead of biconcave, the RBC become elliptical in shape, like the egg. It is known as hereditary elliptocytosis, है ना? So here most common protein which is gene which is mutated is ankyrin. Ankyrin mutation leads to ankyrin followed by band 3 followed by spectrin. And here most common is spectrin. Most common is spectrin, which leads to. How many of you got it? So let me ask you 3 MCQs, 3 confusing MCQs in your competitive exams. Anna? So let me ask 3 questions, you give me 3 answers. Let me ask first. Tell me the most common gene or protein, gene forms protein, responsible for biconcave shape of RBC. Biconcave shape of RBC. Tell me that answer. Tell me the most common gene which is mutated in hereditary spherocytosis, and tell me the most common gene which is mutated in hereditary elliptocytosis, है ना? And options will be same, you will get confused. Tell me the answers in sequence. The most common gene responsible for the biconcave is spectrin, the alpha beta chain of spectrin. Most common mutated in hereditary spherocytosis is ankyrin, है ना? And most common mutated in hereditary elliptocytosis is spectrin. है ना? Here you have to learn the sequence actually. Ankyrin followed by band 3 and followed by spectrin. Because sometime in options you don't have ankyrin, then go for band 3. If you don't have that also, then go with spectrin. But here directly go with spectrin. So please understand, give me a thumbs up if you got the 3 answers. So these are important MCQs and students usually have, you people have confusion in that. So I'm just clarifying your confusion. So same story is written. So all the 7 proteins are responsible. If mutation in any of them, most common mutation, this, any of them. So change the shape from biconcave to sphere. Okay, so what will happen if the shape is changed from biconcave to sphere? So normal RBCs are biconcave and now they change to sphere. Because of mutation in any of them, most common mutation in ankyrin. Because this shape is abnormal now. So when the RBC passes from the spleen will destroy this RBC because the shape is abnormal. So RBC get cleared from the blood, the sphere RBCs, है ना? So you tell me, is it intravascular hemolysis or extravascular? It is taking place inside the macrophage of the spleen. So it's extravascular. Yes. So in hereditary spherocytosis, person have extravascular hemolysis, that is hepatomegaly, splenomegaly, and severe jaundice. So patient presents with severe jaundice. Got it? So same story is written. So if there is mutation in any of the 7, the RBC biconcave shape changes to sphere. And spleen will clear it, and that will lead to extravascular hemolysis. The same story is shown to you. See everyone here, everyone on the screen. And a beautiful diagram. You can see this is the plasma membrane, and you can see all 7 proteins are there. All 7. Hana. If any of them is normal shape is biconcave, appreciate. If any of them is mutated, the shape changes to sphere. And spleen ka macrophage. This is the macrophage of the spleen engulfing it. So it will lead to extravascular hemolysis. Say yes, Hannah. If you take the blood sample and make a smear of that person, you will get many spheres. So it is spheres. Can you see how to differentiate normal RBC from a sphere? Normal RBC have peripheral 2/3 color and central 1/3 pallor. Spheres don't have any pallor. It's completely colored. So we can differentiate the RBC. So you get the spheres. Hannah, you get the spheres. How many of you got it? So this is the spheres, microspheres we are getting it. Okay, microspheres. Tell me a special test. Hannah, these spheres, normal RBCs are biconcave. Here the RBCs change to sphere. So they are very fragile. They are very fragile. They are not strong. They are very fragile. So there is a test to prove that. The name of the test is osmotic fragility test. Osmotic fragility test. So what we are doing in this test, we are taking a set of test tubes. Hannah, this is a normal person and this is a person with hereditary spherocytosis. This is normal and this is hereditary spherocytosis. In a set of test tube, we are taking NaCl solutions. है ना, multiple, नमक पानी के घोल. The concentration may be different, है ना. You can see it's 0.85, 0.75, 0.65, 0.55, 0.50, like that. We are taking various concentration. So if we put one drop of our blood in all of them, normally hemolysis start here. But in hereditary spherocytosis, it start very early because the RBCs are very fragile. They are very fragile. In healthy individual, it start at this point. But in normally it start at this point. But in hereditary spherocytosis, it start very early because RBCs are very fragile. They are very delicate. So they start rupturing at early concentration. So this is known as osmotic fragility test. You can get an image-based question or conceptual question over that. Okay, got it? Got it? Say yes if you got it. Say yes if you got it. Okay, Hannah. And there is a test which is known as Coombs test. Actually, Hannah, biconcave shape of RBC changes to sphere in two diseases. What are the two diseases? One is hereditary spherocytosis. Obviously, it's a hereditary disease. And one is acquired disease. The acquired disease is AIHA, autoimmune hemolytic anemia, in which body is forming antibodies against the RBC. So the change, the shape. Here the reason is mutation. And here the reason is autoantibodies. Autoantibodies. Here due to mutation, the shape change occur. And here due to autoantibodies, the shape change occur. Ultimately, both of them have spheres. The microspheres. Both of them. Now, how to differentiate? Just suppose I'm having a patient and I'm taking the blood sample of that and I'm getting spheres on that. How to differentiate? Is it this or is it this? How to differentiate? So the answer is Coombs test. Coombs test detect antibodies. So Coombs test will be negative here and positive here. So always apply Coombs test. The Coombs test will be negative here, but negative finding is important to differentiate it from AIHA. How many of you got it? So we are done with hereditary spherocytosis. Read the question and tell me the answer. Quick, fast. Read the question and tell me the answer, people. Fatafat. Read the question and tell me the answer. Yes. Fast. Huh? Shape of RBC is biconcave is due to. What is the correct answer? Yes, the correct answer is spectrin. Yes, you are not doing the mistake and I am very happy. Very good. Most common cause of hereditary spherocytosis. What is the answer now? I'm asking most common cause of hereditary spherocytosis. What is your answer? Is it still spectrin? I don't think so. The most common mutation occurs in ankyrin. Ankyrin is given in the option. If ankyrin was not there in the option, I search for band 3. If it is still not there in the option, then I will go with spectrin. So correct answer is ankyrin. I'm changing the question. Instead of hereditary spherocytosis, I am asking hereditary elliptocytosis. What is the answer now? Quick. Zara fast batayenge. Zara jaldi batayenge. Huh? What's the correct answer here, people? Fast. In that case, again, answer will become spectrin. Hannah. The next question in hereditary spherocytosis is the inherited abnormality in which of the following red cell component? So again, I'm asking the mutation in hereditary spherocytosis. What is the mutation? You say, ma'am, ankyrin, but it's not given in the option. The second option is band 3. Still, it's not given in the option. The third option, we will search for spectrin. It's given. So go with spectrin. In this case, I'm going with spectrin because the first two are not given. I was more happy if these two were given. But if it's not given, it's okay. We will go with the third choice. So here the answer is spectrin. So answer is ankyrin if it is given. If it is not given, we will go with second or third best. I'm explaining you that. Okay, got it. So coming on the next topic, before coming on the next topic, I would like to give you a small advice to the medical students, the medicos, the medical aspirants. Hannah, always strive for progress, not for perfection. Hannah, what does it mean? I have seen many students who start with a subject or who start with a topic in the morning. For example, my schedule is at 6 o'clock or 7 a.m. in the morning. I will start my studies. I'm starting a new subject or a new topic. And the subject and topic is difficult. Hannah, it's difficult. I got stuck there. It happens very frequently. We got stuck somewhere in some subject or topic because it's difficult to understand. Hannah, so what do you usually do? You tell me, what do you do? So we watch or see the same topic or subject from multiple sources. Our friend is having some other subscription, some other app. We will ask, ye wala topic dikha do. With some other educator, ye tumhara dekh lete hain, hai na? So we rent it from someone else. We watch it on the YouTube. We read multiple books. So by doing so, we are over perfecting some subjects or some topics. But ultimately, you forget while doing so, the time is limited. The time is limited and subjects are 19. You have to cover all 19 subjects. If you are following this strategy now, you are doing over perfect, 100% perfect some subjects. But at the end, some subjects will remain untouched. They will be 0. The worst strategy. You can never clear your exams with this strategy. No. So some are over perfect, some are not even touched. No, you have to manage the time. I'm okay with 70 to 80% with all subjects. Hannah, this is the best strategy. If you got stuck with that topic, with this subject, move ahead. Ek bar read kar lo, solve the MCQs, it's okay. If you don't understand completely, it's okay. You are not doing PhD in that. You are not doing masters in that. It's okay. Just MCQ ban jaye, utna kar lo, move ahead. Perfection is not important at your level because you are not doing masters. At your level, progress is more important. That is a small advice. Please follow it. Okay, so can we go ahead? Okay. Okay, so can we go ahead? Mutation again. Said, learn the sequence. What is the mutation in hereditary spherocytosis and what is the mutation in hereditary elliptocytosis? You have to just learn the sequence. Here the sequence is ankyrin, followed by band 3 and followed by spectrin, whatever given in your option. If ankyrin is given, go with that. If it is not given, go with this. If it is not given, go with this. But one of them will be there. You have to follow the sequence. But in hereditary elliptocytosis, it's directly spectrin. Only one is mutated spectrin. There is no sequence in that. Saeed, you got it. Give me a thumbs up if you got it. Can we go ahead? Anyone have any else problem? Okay. Okay. Can we go ahead? So let's go ahead. So here we are coming as the next topic. We have already covered hereditary spherocytosis and now I'm teaching you the next topic, paroxysmal nocturnal hemoglobinuria. It's also difficult to understand and you get questions on that. It's also a type of hemolytic anemia. Okay, so let me tell you what is the problem here. You know, in our blood vessel, this is a blood vessel. We have RBCs also, WBCs also, platelet also. So this is a RBC, this is a WBC and say this is a platelet. For example, we have all the three type of blood. But in the blood, we have complement also, C1 to C9. But normally the complement is inactive. All C1 to C9, they are inactive. In me, currently it's inactive. It get activated with foreign antigen. Currently, I don't have any infection. I don't have any foreign element in me. So in me, it's inactive. So normally in healthy individual, normally it remains inactive unless until the person is having some activation by some foreign antigen. Okay, so it's inactive. But during sleep, you know, whenever the person is sleeping, Hannah, normal people sleep at night. I sleep at night. I don't know about you, but that's why it's known as nocturnal because people sleep at night normally, Hannah. So during sleep, it can be at any time, Hannah. So whenever the person is sleeping, at that time, we have respiratory depression a little bit. That is physiological, because of which there is metabolic acidosis in our blood. It's physiological. In physiology, you may have read it. Hannah, the pH of the blood falls. There is acidosis. During sleep, a little bit of physiological acidosis occurs in us because during sleep, our respiratory rate is less. So there is metabolic acidosis because of that to compensate that. Hannah, it is physiological, occurs in me, you, whenever we sleep, we all sleep. Say yes if it occurs. So this causes the activation of the complement. The complement get activated when we sleep. The summary is that. Whenever we sleep, the complement get activated. You will say, ma'am, what happens if the complement get activated? Complement causes lysis of the blood cell. Hannah, so RBC, WBC and platelet all get lysed and ruptured. You say, ma'am, what are you saying? So whenever I sleep, my blood cells are ruptured and whenever I should wake up, I should have pancytopenia. But I didn't have so. I sleep every night, but in the morning, I don't have pancytopenia. Why so? Because God is great. I mean to say God has given the two guards on the blood cell. God has given the protectors, the guards. So the name of the two guards is CD55 and CD59. They are present on all blood cells, on RBCs also, on WBCs also, on platelet also. The two guards, CD55 and CD59. Learn the other names also. CD55 is known as decay accelerating factor DAF. Okay, and CD59 is known as membrane inhibitor of reactive lysis, that is miral. So DAF and miral, these are the two guards, or CD55, CD59. Hannah, these are the two guards which are present. So it's okay. Whenever I go to sleep, I don't worry that my complement will get activated and what will happen to my cells and I will have pancytopenia if I wake up. I shouldn't sleep. I don't worry. We don't worry. We all sleep, Hannah, carelessly, and we have the guards. Guards will take care of it. It's okay, Hannah. For the synthesis of these two guards, we require a gene. The name of the gene is GPI. So all our cells have the GPI in the precursors. GPI. GPI is present. So GPI is synthesizing the two guards. It's okay. Now imagine a person in which GPI is mutated. Start the process. GPI is mutated. If the GPI is mutated, the two guards are absent. No CD55, no CD59. The guards are absent. Now, everyone sleep. This person will also sleep naturally. So when the person will sleep, at that time, because of acidosis, the complement is going to be active. But the guards are absent. There is no one to protect their blood cell. So during sleep, their RBCs rupture, their WBCs rupture, their platelet rupture. So patient have pancytopenia. Say yes. Yes or no? The patient have pancytopenia. So patient have pancytopenia during night. So since the RBC are getting ruptured in the blood vessel only, it's intravascular hemolysis. I told you, there are two types of hemolysis, intravascular and extravascular. Although all three cells are rupturing, but I am interested in RBC. RBC get ruptured, patient is anemic. Although WBC and platelet is also less. But patient is anemic, it's intravascular. So hemoglobin is freely in the blood and that will go in the kidney, hemoglobinuria. So first urine in the morning is red. You will get a typical clinical question. The patient will come to you, doctor, my first urine is smoky. It's red in color in the morning, but rest all urine are normal. So it's a typical case of PNH. Come on. During the night, the hemolysis takes place and hemoglobinuria, hemoglobinuria. The first urine is hemoglobinuria. During wake up, when the patient is wake up, the urine is not red because hemoglobin is not present. Say yes if you got it. So that's why the name of the disease. Now I can prove. What is the full form of PNH? What is PNH? Paroxysmal. That is, it's not continuous hemolysis. Hemolysis occurs only during sleep. Paroxysmal means it's an attack, like asthma. So it's only during sleep. Paroxysmal. Nocturnal, it occurs during night. And hemoglobinuria, because patient have hemoglobin in the urine. So I can prove the word PNH. So this is the full form. So there is a triad. Patient have pancytopenia, patient have intravascular hemolysis, and because CD59 is absent, that the platelets will form the thrombus. So third thing is the thrombus. So this is PNH. How many of you got it? How many of you got it? Say yes if you got it. Say yes. I will share the PDF. Let this session finish. I will share both the PDF yesterday and today also. Okay. I will share it with the ProCM team and you can join their Telegram group and you can ask the team. They will provide you on the YouTube channel where you are attending it now. So I will provide to the team only and you can ask the team to provide you the PDF. Okay. Okay. So please concentrate right now. Yes, both days I will provide. Don't worry. So listen, this is the cell membrane and these are the two guards I'm talking about. This is CD55 and CD59. So learn the two guards, CD55, CD59. CD55 is known as DAF, decay accelerating factor, and CD59 is known as MIRAL, membrane inhibitor of reactive lysis, MIRL. Both of them are synthesized by a gene. The name of the gene is GPI. Okay, so the same thing. Now see the two diagrams in front of you. This is a normal person and this is a person with PNH. Okay, see here the two guards are present on the RBC. They are present during sleep. When the complement get activated, the guards are present. The complement is trying to lysis but cannot lyse, so no hemolysis because guards are present. But see the other person in PNH, the guards are absent. There are no guards because GPI is absent. The two guards are absent. Now during sleep, here also complement get activated, but there is no one to prevent it, so hemolysis takes place. It's intravascular hemolysis. Okay, got it. I was kindly asking if you can share the notes of. I don't teach anatomy, Thomas. I'm teaching pathology. So I will share the notes of the pathology. Okay. Chalo. Listen. So the same story is written. So here there is a mutation of GPI. This is the full form of GPI. What is GPI? Glycosyl phosphatidyl inositol. GPI. This is mutated. So no CD55, no CD59, no DAF, no MIRAL. So there is intravascular hemolysis. The person have PNH. There is a triad in PNH you have to learn. Patient have hemolysis, which is intravascular and nocturnal. Hemolysis takes place in night and it's intravascular. There is pancytopenia. All the three cells are ruptured and there is thrombosis. You get questions on the triad. Which of the following is not included in triad of PNH? It's a question. Okay. Now prove it. There is a test. There is screening test. There is definitive test. है ना? Screening test क्या है? The name of the screening test is HAME test. What is HAME test? For example, there is a patient coming to me. Patient is, है ना, saying, doctor, I'm having first urine in the morning, that is red, and I'm having very lethargy, है ना. If I'm doing this, taking the blood sample and doing a CBC, I found pancytopenia. So I'm having a strong suspicion that this patient is having PNH. I want to prove that. What should I do? है ना. Currently, if I check the blood, there is no hemolysis in that because person is not sleeping right now. Whenever I'm collecting the blood, at the time person is awake. है ना. So what should I do? In this blood, in this sample, in the serum, I should add artificial acid from outside. Once I add the acid, the complement system get activated and it will cause the rupture of the RBC, so hemolysis can be noticed. So that is HAME test. We collect the blood and we add the acid in that. We are acidifying it, acidifying. Once we acidify, we will see the rupture. We will see the rupture. That is HAME test. So learn the name of the test. HAME test is done for PNH. This is a question. Simply, HAME test is done for PNH. We can get image-based question on any of them. Okay, this is screening test. This is screening test. And now I'm teaching you the diagnostic or the confirmatory test. Confirmatory test is flow cytometry. I'm sure you may have not seen this instrument. Okay, I have seen that. It's an instrument, है ना, in which we put the patient's blood sample. We just put it, है ना. Now this is connected with a software. It is connected with a computer system on which when the sample is processed inside the flow cytometer, we get a graph over here. We get a graph. There are two axes in the graph, the x-axis and the y-axis, and we have to feed here what markers we want on the graph. So here I will take CD55 and CD59. है ना? On any axis we can take any. I guess you all know the graph. बचपन में graph पढ़ा है, huh? In mathematics, this is a graph. So we have 0 at the center. On the right side, it's positive. On the left side, it's negative. It's a rule. On the upward, it's positive. On the downward, it's negative. It's a rule. So we have 4 quadrants. है ना? So in this quadrant, both the things are positive. In this quadrant, both the things are negative. In this quadrant, one is negative, one is positive. In this, one is positive, one is negative. I guess ये बचपन में सबने पढ़ा है. If you have not read it, now please understand. है ना? This is a graph. This is the rule. है ना? 2 quadrants. Both are positive, both are negative. Here, one positive, one negative. This is normal. Now, if I take my blood and a person, I mean normal blood, normal control blood and PNH wala patient blood. This is normal and run it in flow cytometer, and this is PNH and run it in flow cytometer. On x-axis, I am taking CD55 and both of them, and on y-axis, I am taking CD59. Although I can flip-flap also. I can take anything. It is not fixed ki X pe lena hai, Y pe. So in normal person, in my all RBC, I am having both. So all my RBCs will fall in this quadrant. Because all 100% RBC, whatever RBC, I am having 4.5 million RBC. All of them will fall in this zone. Okay, because in my all RBCs, both are present. Hana. But if I run the blood, Hana, if I run the sample in a patient with PNH, I will get few RBCs here, few here. It is bimodal distribution of the RBCs, because here in few RBCs, both are present. In few RBCs, both are absent. So I will get, so see the graph and you can understand the difference. Say yes if you got it. See this graph and see this graph. Can you identify? You can get image-based questions. This is a graph of a normal person because all the RBCs are falling in this zone, in this quadrant where both are present. And this is a patient of PNH. Hana, here, few RBCs are falling here, few here. Hana, few RBCs, maybe half here, half here. So you are getting bimodal distribution of RBCs. Give a thumbs up. Please keep interacting now. See, Anna, that you got it. Okay. So read the question, tell me the answer. We are done with PNH. I know I'm too fast, but I think the name of the session is Remarkable Rapid Revision. It's a rapid revision. I'm assuming you know the basics. I'm brushing up your concepts. It's not a conceptual comprehensive series. It's a rapid revision. It should be super rapid. Okay. Read the question. Read the question and tell me the answer. Chalo, quick. Triad of PNH include all except. I'm asking the word except. Except what? Is it pancytopenia, renal failure, hemolysis, or venous thrombosis? What is not included in the triad? I know renal failure is not included. Pancytopenia is there, intravascular hemolysis is there, and thrombosis is there. Hana, Hem test is done for. I guess it's a super simple question. Hana, please students reply. No, what is the correct answer? At max you will be wrong, but try it. At least try it. Huh? कोशिश तो करो. कोशिश करने वालों की हार नहीं होती. Have you heard it? The famous poem. Yes, so Hem test is done for PNH. Absolutely right. It's done for PNH. Okay. PNH is associated with somatic mutation of what? Mutation occurs in which gene? Now think before you answer. Don't jump. It's a tricky question. I repeat, think before you answer. Don't jump. Don't rush. It's a tricky question. It's a tricky question. So what is the correct answer here? Is it decay accelerating factor DF? Is it miral? Is it GPI? What is the correct answer? I'm asking the mutation, the name of the gene. So name of gene is GPI and name of two guards, the proteins which are protector is DF and miral. So don't go with DF and miral. I'm asking the gene which is mutated, go with GPI. So correct answer is GPI. It's a tricky question. Okay, very correct. PNH is due to defect in what? So in PNH, is it defect in CD59, CD15, CD100 or CD20? Very easy question. In PNH, two proteins are defective, CD55 and CD59. So 55 is not given in the option. That's why I'm going with 59. If 55 is also given, that is also a correct answer. So correct answer is CD59. Hana. So we are done with this. Now I'm coming with sickle cell anemia. Hana. Hereditary spherocytosis is done. PNH is done. No. Sickle cell anemia, another important anemia. You get many questions on sickle cell anemia. Hana. Sickle cell anemia and thalassemia, you should understand the difference. Hana. Sickle cell anemia and thalassemia both are globinopathies. Acha, how many hemoglobin you have? Hana. Give me a thumbs up. You got it till now? So let's start the next anemia, sickle cell anemia. Okay. So you tell me one thing. You tell me one thing. How many hemoglobins you have in your blood? Huh? Say, ma'am, I'm having 3. I'm also having 3 type of hemoglobin in my blood. My 95 to 98% of hemoglobin is hemoglobin A. I'm having all healthy individual adults have this hemoglobin. This is the major hemoglobin, hemoglobin A. It is having 4 globin chain, 2 alpha, 2 beta. You can see 2 alpha, 2 beta, alpha 2 beta 2 is the formula. 1% of the hemoglobin we all have is hemoglobin F. Fetal hemoglobin, 1% or less than 1%. Only 1 or less than 1 in a healthy individual. It's 2 alpha and 2 gamma, alpha 2, gamma 2. It's 2 alpha. And 3 to 3.5, less than 3.5, somewhat between 1 to 3.5% we have minor hemoglobin, hemoglobin A2. This is hemoglobin A, this is A2. It is having 2 alpha 2 delta, alpha 2 delta 2. Okay, so we have 3 type of hemoglobin, alpha 2 beta 2, alpha 2 delta 2, alpha 2 gamma 2. This is major hemoglobin, hemoglobin A. This is minor hemoglobin, hemoglobin A2. only 3.5%. And this is fetal hemoglobin, hemoglobin F, less than 1%. We all have these three hemoglobin, no other hemoglobin in our blood. Maximum is hemoglobin A. Right? So this is normal hemoglobin concentration. Now I'm teaching you two type of diseases which are known as hemoglobinopathy, where there is problem in the globin. The heme is normal. The globins are defective. There is problem in the globin. Now there can be two type of problem. है ना? The globin ka quality is not good, but quantity is good. Or the quantity is less, but quality is good. है ना? So quality is not good. Qualitative defect is sickle cell anemia, in which the hemoglobin is normal. I'm a female. I should have hemoglobin more than 12. है ना? So I should have hemoglobin, although I don't have because I'm a Thel minor, but I don't have any symptoms for that. Thel minor are asymptomatic. I'm one of them. So my hemoglobin lies between 10 to 12, but I don't have any symptom. Okay. Anyways, a normal healthy individual who don't have hemoglobinopathy, the hemoglobin should be between, but the cutoff I told you, for females it's 12 gram, for males it's 13.6 gram. Okay, this is the cutoff. So here in sickle cell anemia, the hemoglobin is more than the cutoff. The person have more than 12 or more than 13.6. The quantity is normal, but qualitatively there is a defect. So it's a qualitative, structural defect. I will explain. And here in thalassemia, the quality is absolutely normal, but there is defect in the quantity. There are two types of thalassemia, alpha thalassemia and beta thalassemia. In alpha thalassemia, alpha chain is defective. It is reduced or zero. In beta thalassemia, the beta chain is reduced or zero. So that is the thalassemia. So qualitative and quantitative. Let's come on sickle cell anemia. Sickle cell anemia. So here, what is the problem? Listen. Humans have cell. Inside the cell, we have nucleus. Inside the nucleus, we have chromosome. How many chromosomes we have? We have 46 chromosomes. Rather than saying, say 23 pairs, better to say. So pair number 1, pair number 2, pair number 3, pair number 4. I am interested in 2 pairs where the genes of alpha and beta globin is present. So gene of beta is present on hemoglobin number 11. This is the pair of 11. Pair of hemoglobin number 11. Where 2 genes of beta are present. Beta have 2 genes. Present on chromosome number 11. 2 genes are present. And for alpha, it is present. The genes are present on chromosome number 16. Chromosome number 16. For alpha, we have 4 genes. We don't have 2 genes. For alpha, we have 4 genes, 2 on each chromosome. So first thing, you should know the basics. I'm assuming ye sab padh ke aaye ho. You know the basics. If you don't know, please revise it. So the gene for beta is present on chromosome number 11. And the gene for alpha is present on chromosome number 16. This is the first thing. For beta, we have only 2 genes, 1 on each chromosome. And for alpha, we have 4 genes, 2 on each chromosome. This is the basic. Now I'm teaching you the disease sickle cell anemia. Sickle cell anemia. There is problem in the beta gene. So there is problem in the beta gene. So on next page, I will draw only chromosome number 11, not 16. There is problem. There is defect in the beta gene. There is some defect. What is the defect? I will tell you. Okay. So let's draw the cell. Let's draw the nucleus of the cell. Inside the nucleus, this is the pair of chromosome number 11. There is problem in chromosome number 11. On chromosome number 11, this is the gene for beta. This is the gene, the complete gene for beta. Ye pura ka pura gene hai. And in this gene, we have codon. You know, codon is a triplet of the nucleotide. So codon number 1, codon number 2, codon number 3. So 6th codon is defective. Here, the 6th codon is defective. 6th codon. So defect lies not in the cell, in the nucleus of the cell. Imagine a cell. Imagine the nucleus of cell. Imagine the 23 pairs. Imagine pair number 11. Imagine the gene in the pair number 11. And imagine the 6th codon in that. So it should be point. What is the defect? So normally the 6th codon, what is the normal 6th codon? The normal 6th codon is GAG. It is replaced, A is replaced by T. It becomes GTG. The one defect, adenine is replaced by thymidine. Can you see GAG is replaced by GTG? The 6th codon, this is the 6th codon on the 11th chromosome. 11th chromosome, 6th codon is defective, that of gene, beta gene. So instead of adenine, it's thymidine. So whenever, it was GAG and now it is no more GAG, it becomes GTG. So I mean to say adenine is replaced by thymidine. So whenever it was GAG, it was coding for glutamic acid. But when it becomes GTG, now it is coding for valine. So basically at the 6th position, glutamic acid ki jagah aa gaya valine. So glutamic acid is replaced by valine. How many of you got it? Glutamic acid is replaced by valine. Got it? How to learn? In exam, you get a reverse option also and you get confused. So I'm having a mnemonic to learn that. Glutamic acid is gone. G for glutamic acid, G is gone. It's gone. And valine is welcome. है ना? I know the welcome spelling is from W, but you can learn like this. Valine is welcome, welcome. So glutamic acid is gone and valine is welcome. Now you will never forget. So one is gone. Instead of that, we have another. And this is happening at the 6th codon at the 6th position. So this is the defect. है ना? Got it, got it. This is the problem. So imagine a cell. Imagine the nucleus of the cell. Imagine the 23 pairs. Out of the 23 pairs, imagine chromosome number 11. Imagine the gene on that. Imagine the triplet, the 6th codon. Imagine in the 6th codon, adenine is replaced by thymidine, and because of that, glutamic acid is replaced by valine. This is the summary. So the hemoglobin which is formed is defective. This is known as point mutation. It's a question. This is known as point mutation. Say yes. This is known as point mutation. है ना? And the hemoglobin which is formed, it's not hemoglobin A. It is hemoglobin S. है ना? So inside the RBC, है ना? This is the RBC. Normal RBC have hemoglobin A. So this is hemoglobin A. This is hemoglobin A, in which at the 6th position we have glutamic acid. है ना? But now the RBC have a defective hemoglobin, which is known as hemoglobin S. At the 6th position, we have a line. So only one difference between the two hemoglobin. Here at the 6th position, glutamic acid is present. And here at the 6th position, valine is present. That is the only defect. You will say, ma'am, how does it matter? Being a human being, now in my blood, I have RBC, inside which I am having hemoglobin. At my 6th position of hemoglobin, whether I have glutamic acid or valine, how does it matter to me? Is it produce any problem? Yes, it produces any problem. In oxygenated state, both are same. This is both same, है ना? But in deoxygenated state, there is a problem. Now suppose these are the two RBCs in oxygenated state. So hemoglobin is same. Whether it is A or S, doesn't matter. Doesn't matter. है ना? This is oxygenated state. है ना? But in deoxygenated state, there is a difference. There is a difference. In deoxygenated state, actually, the hemoglobin A is still dispersed. Here it is also dispersed. Here it is also dispersed. This is hemoglobin A. This is hemoglobin A. है ना? But hemoglobin S form polymers. It form polymers. It forms rods. It is not dispersed at deoxygenated state. So to accommodate the long polymer, the shape of the RBC has to be changed. It cannot be biconcave anymore. It cannot be circle. It has to be sickle shape so that it can accommodate the long rods at deoxygenated state. This makes a sense. Now the RBCs are no more. In deoxygenated state, the RBC becomes sickle shape. है ना? So in oxygenated state, they are biconcave. Still they are biconcave. But at deoxygenated state, they become sickle. But normal RBC is always biconcave. Whether oxygenated or whether deoxygenated, this makes a sense. So whenever the person is deoxygenated, the RBC convert like this. You say, मुझसे भी क्या फर्क पड़ता है? How does it matter? अब मेरे blood के अंदर, in my blood, the RBCs are biconcave or sickle shape. How does it matter to me? I don't check my blood. What is the shape of my RBC? How does it matter? The problem is that the sickle RBCs, they are sticky. They stick with each other. है ना? So if the RBCs are biconcave, they can pass through the capillary very easily. But if the RBCs are sickle shape, they stick with each other. They are very sticky. They stick with each other and they occlude. They cause the occlusion of the capillaries. So to whatever organ this capillary is supplying, it will have ischemia. This is known as vaso-occlusive phenomenon. Vaso-occlusive phenomenon, because it is producing ischemia in multiple organs. So patients with sickle cell anemia have vaso-occlusive phenomenon, because of which ischemia of multiple organs. Say yes, this is the problem. So this is the complete pathogenesis and you get many questions out of that. You can see this RBC, say ma'am, it's spherical, it's biconcave, and see this RBC, this is sickle shape. So see the problem, adenine is replaced by thymidine, glutamic acid is replaced by valine. Hana? And this is happening at the 6th position, 6th codon, never forget. Everyone give me a thumbs up. Okay. So please learn. So what are the consequences of sickling? I told you vaso-occlusive phenomenon. So I told you, see, beautiful diagram. See this RBC in deoxygenated state and see this RBC in deoxygenated state. So in deoxygenated state, here the adult hemoglobin A is dispersed. It's like this. You can see it's dispersed. And here the hemoglobin is forming the rods, polymers, the big rods. To accommodate that, the shape of the RBC changes from biconcave to sickle, because accommodating this can be possible here, but accommodating this, it has to be sickle shape. I hope you are getting what I am saying. The sickle RBCs are sticky. You see, they are forming a clump and they are obstructing the capillary. It will produce vaso-occlusive phenomenon. Say yes. So vaso-occlusive phenomenon, it is producing. So there is anemia. One more problem. The sickle RBC, spleen ko dekhe nahi suhata. Spleen clear all the RBCs which are abnormal in shape. So spleen find it is the abnormal RBC, it will engulf it. So spleen will engulf this RBC, so it will have extravascular hemolysis. Hai? So number one, patient have extravascular hemolysis, that is hepatomegaly, splenomegaly and severe jaundice. है ना? So anemia will be there, hemolytic anemia, and vaso-occlusive phenomenon is there. Vaso-occlusive phenomenon in multiple organs. I hope you are getting it. Huh? Vaso-occlusive phenomenon in multiple organs, especially in the bones. Can you see there are 4 features in the bone on which you get image-based question. The bones of the hands, the digits and the foot, these are the end arteries. Now, pehle ye compromised hai. These are the end arteries. These all are. Now, imagine if they are occluded because of the clump formation of the sickle cell. They are sticky now. So, patient have hand-foot syndrome. Patient have hand-foot syndrome in which the fingers and the toes get swelled. They get ischemia, severe painful condition. Number 1. Hai na? Number 1. Number 2, the vertebra. Can you see the vertebra? The vertebra also have the ischemia. The vertebra are not getting the blood, है ना? Because the RBCs are forming the clumps, the sickle RBC. So they become fish shape. It is known as fish mouth vertebra. So see the fish mouth vertebra. So these 2 things are due to ischemia. These 2 things are due to ischemia. Now 2 more things I'm telling you here. Now the RBCs are getting destroyed. More and more RBCs are getting destroyed. So the marrow will try to compensate. You know, bone marrow. So especially the bone marrow of the cheekbone. We have maxillary bone here, the cheekbone that will enlarge. Because inside the bone marrow, the RBC will synthesize more. The marrow is trying to synthesize more RBC and to deliver it in the blood. Lekin jo bhi blood mein ja raha hai, it is getting destroyed. So to compensate, the marrow is expanding, especially the cheekbone. So typical faces are there in which the cheekbone is very prominent. And the skull bone is also very prominent. Sometimes you can see the skull bone. In the skull bone, you can see this appearance is there. It is known as crew cut or hair. Head on hair, है ना? Appearance, so crew cut appearance. So these are 2 compensatory mechanisms. These 2 are compensatory in which the bones are getting enlarged to compensate the loss. So this is in the bone. How many of you got it? How many of you got it? Huh? And the spleen, there is a very unique phenomenon. Can I ask you a question? In sickle cell anemia, what happens to spleen? I'm giving you 2 options. Spleen enlarge in size or reduce in size. Size of spleen. Size increase or decrease? Tell me the reason. Whatever you are saying, tell me with a reason. Don't tell the bluff. You just tell me a reason. Why? Whatever is happening, why? I'm asking you. Tell me a logical reason. Spleen will enlarge or spleen will reduce? So my answer is both. Initial stage, it will enlarge. Initial stage, it will enlarge. And later on, it will reduce. The later, it is known as autosplenectomy. Let me explain the meaning of that. So this is the spleen. This is the spleen. And this is the blood vessel supplying the spleen. Blood vessels supplying the spleen. So when the sickle cells are coming inside the spleen, the macrophage inside the spleen is engulfing the sickle cells and destroying it. That's why there is splenomegaly, because there is more and more destruction taking place inside the spleen. So spleen will enlarge in size, initial stage. But later on, these sickle cell only will form a clump here and they will obstruct the blood vessel. So spleen will not get the blood. Spleen will have ischemia and spleen will shrink and it will be small spleen. That is known as autosplenectomy. How many of you got it? How many? Yes. So sati, in initial stage, there is enlargement, but later on, initially splenomegaly, but later on there is shrinkage. That is autosplenectomy. How many of you got the reason for the both? How many of you got the reason for the both? Okay. So that's all about sickle cell anemia. Diagnosis, you know the electrophoresis we can do. Okay, read the question and tell me the answer. We are done with sickle cell anemia also. In sickle cell anemia, defect is lying in which chain? Is it alpha chain, beta chain, or both? Defect is lying in which chain? Quick, fast. The defect is lying in the beta chain at the 6th codon. You know the defect. Glutamic acid is replaced by valine. So it is always beta, never alpha. Sickle cell mutation is what type of mutation? Is it point mutation, select mutation, frame shift mutation, or nonsense mutation? I told you the mutation, adenine is replaced by thymidine. It's a pointer mutation. It is known as point mutation. Autosplenectomy is seen only in one disease, sickle cell anemia, in which spleen first enlarge and then reduce in size. Autosplenectomy. It is seen in sickle cell anemia. Okay. The last anemia I'm telling you here is the iron. I guess you know iron deficiency anemia. We can skip. It's very easy. Okay. So we have covered the important anemias and let me start the leukemias. Can I start? And after leukemias, I will teach you 4 leukemias here very quickly. So it will take nearly 40 minutes at least to teach you. 10 minutes on each. 4 leukemias I want to teach you. And after that, I will come on the systemic pathology. Okay, so maximum chunk I have covered in hemat, important all the topics, and then we will see the systemic pathology, nearly 12 to 15 important topics which are must revise before going your exam. Okay, let's start with leukemia quickly. है ना, quickly हम leukemias को revise करेंगे. It's very difficult topic, but you know I will make a cakewalk for you. ठीक है. How many types of WBC human have? Human have 5 type of WBC. 3 of them have the granules, that's why known as granulocytes, and 2 of them don't have granules, that's why known as agranulocyte. A means absent. The granules are absent. That's why agranulocyte. The ones which have granules are neutrophils. They have pink granules. Eosinophils, they have red granules, brick red color, and basophils, they have dark blue or black color granules. So these are granulocytes. And lymphocytes and monocytes, they don't have granules. You can see. So these are the 5 type of WBC. Now the point is that how does this synthesized in the marrow? They all are synthesized in the marrow, but how they are synthesized in the marrow? So I want to show you a diagram. Have a look on the diagram. Listen. Let me show you here. So this is a bone marrow. I know. In the bone marrow, the first cell is always hematopoietic stem cell. The first cell is hematopoietic stem cell. From the hematopoietic stem cell, the 2 blasts are formed. What are the 2 blasts are forming here? The first is myeloblast. The second is lymphoblast. Please understand the 2 blasts. Please, I'm highlighting because complete leukemias are based on these blasts. Please understand there are 2 blasts, myeloblast and lymphoblast. Hai now, what does this myeloblast give rise to? Myeloblast give rise to all RBCs. They don't have any types. Myeloblast give rise to all platelets also. They don't have any types. And myeloblast give rise to 4 WBC out of 5. Which 4? All neutrophil, all eosinophil, all basophil. That is granulocytes and monocytes, but not lymphocytes. Lymphoblast give rise to only lymphocytes. Hana, out of the 5 WBC, 1 is here and 4 of them are here. How many of you got it? That's why myeloblast, the myeloid series, is known as trilineage because it is giving to RBCs also, giving rise to platelets also, and giving rise to 4 WBC out of 5. Got it? So this is the basics. Now you have to learn the, I'm not interested in RBC right now and I'm not interested in platelet right now. Currently I'm interested in WBC because I'm teaching you leukemias. So I want you to tell me the intermediates over here and intermediates over here. So let's talk about the intermediates. Hannah, rather than showing, I will draw it. Okay. So let me draw a marrow. Okay. And let me draw the first cell as hematopoietic stem cell. Okay. Let me draw the 2 blasts. Let's start the story with the blast. So here we have myeloblast and here we have lymphoblast. I'm interested in WBC. So myeloblast give rise to WBC. How it giving rise? What are the precursors? So myeloblast में से बनता है promyelocyte, then myelocyte, then metamyelocyte, then band form, and finally neutrophil. Please learn it. You have to learn the sequence. There is no escape. I'm not giving you an option. You have to learn it. What is the sequence? Same as myeloblast, promyelocyte, myelocyte, metamyelocyte, band form, and finally neutrophil. These are the precursors of neutrophil. In the same way, we have precursors of eosinophil, basophil, and monocyte. Don't learn the precursors. They are more or less same. Learn the precursors of neutrophil. Hana? So this is the sequence. You have to learn the 5 precursors. Coming on the other side. Lymphoblast have only 1 precursor. Hana? Pro-lymphocyte. And finally, it gives rise to lymphocyte. Hana? So this is the sequence over here. And finally, in the blood. Let me draw a blood vessel over here. This is the blood vessel. In the blood vessel, the mature forms are coming. Premature form don't come in the blood. In my blood, all 5 WBCs are present, but their precursors are present in my marrow, not in my blood. The same story is shown to you. See. Have a look here. Everyone on the screen. Everyone. So can you see here? This is hematopoietic stem cell. This is myeloblast. This is lymphoblast. Now see the precursors: myeloblast, promyelocyte, myelocyte, metamyelocyte, band form, neutrophil. And see lymphoblast, prolymphocyte, lymphocyte. And finally, in the blood, the mature forms are coming. I repeat my words, the mature forms are coming in the blood. The precursors are present in marrow, they are not present in blood. Imagine if the blast coming in the blood. That is leukemia. So I define leukemia. What is leukemia? Leukemia is blast in blood. Blast in blood is leukemia. It can be myeloblast, it can be lymphoblast. Hannah, if any blast is coming in the blood, that is leukemia. Normally, Hannah, I'm having blast, but in my marrow. I don't have blast in my blood. That's why I don't have leukemia. Healthy persons, Hannah. But the person who have leukemia, they have blast in the blood. You will say, ma'am, why the blasts are leaving the marrow and they are coming the blood? What is the reason behind that? Now listen, there is certain mutation in these blasts. Maybe physical, chemical, or biological agents are there which are producing the mutation. Because of the mutation, they do uncontrolled mitosis. And because of which they are spitted. They become uncontrolled. They become so numerous that they are spitted in the blood. Because of the mutation. I will tell you the exact mutation also. Hannah. So blasts are coming in the blood. So now 2 types of blasts are there now. Anyone can come. Hannah. If myeloblast is coming, it is known as myeloid leukemia. Okay, and if lymphoblast is coming, it's known as lymphoid leukemia. So there are two types of leukemia. If myeloblast is coming, myeloid, lymphoblast is coming, lymphoid. Each of them can be of two type, I mean acute or chronic. It can be acute, it can be chronic, it can be acute, it can be chronic. So there are four types of leukemia. This is known as acute myeloid leukemia, AML. This is known as chronic myeloid leukemia, CML, in which the myeloblast is coming in the blood. And one is acute, one is chronic. Hana, this is acute lymphoblastic leukemia. This is chronic lymphoblastic leukemia, in which lymphoblast is coming in the blood. Actually in CLL, lymphoblasts don't come. I will tell you the details. But here it is lymphoid leukemia. One is acute, one is chronic. So we are having four types of leukemia. Give me a thumbs up. This is the basics of the leukemia. Now, don't stop here. Don't stop here. Listen. Once the blast is there, sometimes the blast infiltrate in the solid organ. And after coming in the blood, they infiltrate in the solid organ. They can go in the spleen, liver, lymph node, and they cause the hepatomegaly, splenomegaly, lymphadenopathy, and they produce the discrete masses in the solid organ. And this is known as lymphoma. So sometimes leukemia can lead to lymphoma, but it is not always lymphoma is due to leukemia. Sometimes the blast can directly come to the solid organ and then infiltrate it. So leukemia can lead to lymphoma and lymphoma can lead to leukemia. There's vice versa. Both of them. So both of them are different terms. So blast in blood is leukemia. It's a blood cancer. Leukemia is a blood cancer. Okay, you don't find any discrete mass. But in lymphoma, the blasts are present. The blasts are the tumor cells. They are present in solid organs and they produce discrete masses. So that is lymphomas. How many of you got it? Kindly respond, people. Appreciate my efforts. I'm just super compacting the pathology for you in the most easiest version possible in the world. I can challenge that. Okay, chalo, listen. So appreciate it. You got it? So what are the four types of leukemia? Currently, I'm interested in leukemia. So I told you depending which blast is coming. If myeloblast is coming in the blood, it's myeloid. It can be acute, it can be chronic, AML and CML. And if lymphoblast is coming, it's lymphoid. It can be acute, it can be chronic, it can be ALL, it can be CLL. So finally, I'm left with the four types. I'm having four types of leukemia. Now, it all depends which blast is coming in the blood. It all depends which blast is coming in the blood. Myeloblast or lymphoblast. So is it myeloid or lymphoid? So see the diagram of myeloblast and lymphoblast before starting the four types of leukemia quickly. Have a look on the myeloblast and lymphoblast. You can see myeloblast is little bit larger and lymphoblast is little bit smaller. In myeloblast, we have moderate cytoplasm, but in lymphoblast, we don't have any cytoplasm. It's very scanty. The biggest and most important difference between them is the iron rod. Can you see this is the iron rod? Iron rod is the aggregate of the granules. It is a red color rod-like structure present in the cytoplasm. So here it is present, here it is absent. Iron rod is present in myeloblast. Remember, it is absent in lymphoblast. Okay, now it's time to start the four leukemias. Can I start the four leukemias? Are you people ready? Can we start? Can we start the four leukemias? So in this sequence, I'm going to teach you very quickly. CML, AML. First, we will complete myeloid. But in myeloid, first chronic, then acute. And then we will come on lymphoid, but first acute and then chronic, because I want to give a comparison between AML and ALL. So this will be my sequence. I will teach you all leukemias in a fixed set of headings so that you can have a comparative analysis, and I want you to fill this table with me, or in the end we will fill it together. So let me teach you the four types of leukemia, and let me start with CML. Let me start. Introduction me, definition is there. You can skip that, but age is very unique. In all four leukemias, there is a unique age. So in your question, looking at the age itself, you can have a clue which type the examiner is talking about. The pathogenesis, I will tell you the exact mutation. What is the name of the exact mutation? Classification, FAP classification, I'm going to tell you here. Clinical features, lab diagnosis, treatment part I will skip because you will read it in the medicine. There is more important here I'm skipping. Prognostic factors I will tell you. Okay, so let's start the leukemias without wasting any further time. So let's start CML. I wish mere paas aur time hota. I wish. I teach you the pathology each and every corner of that. But in a limited span, we can do a limited stuff. So the target is that in the limited time, I can give you the most high yielding areas so that it will be most useful for you. Even each and every second of this lecture is useful and worth for you. Watching it, listening it. You don't feel that whosoever is watching it live or later on recorded doesn't feel that I have wasted my time. Each and every second should be crisp. It should be informative. I know the importance of your time because, okay, listen. So let me start with CML. Okay, the first leukemia. Let's start with CML. CML occurs in old age after 50 years. So you can write down the age is here after 50 years. Here 30 to 50 years. This one occurs in children 3 to 5 years. And this one occurs in after 80 years. So see age I have told you together, and looking at the age you can have a guess that what is the type of leukemia they are talking about. So here age is more than 50 years. Now what is the pathogenesis? Now that diagram only. Listen. I have to draw it again and again. Come on. So this is the diagram. This is hematopoietic stem cell. This is myeloblast. This is lymphoblast. What is the sequence? I'm interested in myeloblast. I'm teaching you AML. I'm not interested here. I'm interested in myeloblast. So myeloblast, promyelocyte, myelocyte, metamyelocyte, band form, neutrophil, eosinophil, basophil. Hana, this is a sequence. Okay, you know that. Now, what I'm saying, please open your brain, ears, and listen me carefully. I'm saying there is mutation in all these cells, all the 5 precursors. Hana, I'm saying the mutation. What's the mutation? There is 922 translocation. I will explain you what is 922 translocation. Because of 922 translocation, they all are doing uncontrolled mitosis. They all 5. And they all 5 are coming in the blood. So in the blood, I'm getting myeloblast also, promyelocyte also, myelocyte also, metamyelocyte also, band form also, along with few mature form, neutrophil, eosinophil, basophil. So what is the normal WBC count? If you know, normal WBC count in the blood is 4,000 to 11,000. Maximum up to 11,000 per deciliter. So I'm having 4 to 11,000, you also having that. But here, since all the precursors, all 5 precursors are leaving the marrow because of uncontrolled mitosis and they are coming in the blood, the count is in lakh. Minimum it is 2 lakh. Not 11,000, not 11,000. It is 2 to 3 lakh, 4 lakh. It's in lakhs. So here the total WBC count will rise. Hana? But they all are premature forms. They are not mature. Hana? Although the count is 2 lakh, person have high susceptibility of infection. You will say, man, why? Person have a strong army. WBC is the army. Instead of 11,000, they have soldiers, 2 lakh soldiers. Instead of 11,000 soldiers. Why the person is having high infection? They are all premature. They are not mature. Although the count is high, the person have high chances of infection. Now, I'm saying all these have mutation 922 translocation. That's why they are doing uncontrolled mitosis. So they replace the RBCs and platelets in the marrow. In the marrow, all 3 are synthesized. But since this is having uncontrolled mitosis, it is replacing the RBC precursors. It is replacing the platelet precursors. So person have anemia, person have thrombocytopenia. RBCs are less. Platelet are less and abundant WBC, but they all are premature. So this is the scenario in CML. In CML, multiple cells are coming in the blood. How many of you got it? How many of you got it? Now, multiple cells are coming in the blood. If I take the blood sample and make a smear, I will get multiple cells. I will get promyelocyte, myelocyte, metamyelocyte, band form, and everything is there. It is known as garden party appearance. I will show you, and why it is garden party, I will tell you. So I'm saying mutation is taking place in all of them. In all of them. That's why they all become uncontrolled mitosis and they are spitted in the blood. So what is the mutation? In all these cells. Hana? No, this is a cell. You will say, ma'am, which cell? It can be promyelocyte. It can be myeloblast. It can be promyelocyte. It can be myelocyte. It can be metamyelocyte. It can be band form. It can be any of the 5. Hana? Now this is the nucleus. Now we have 46 chromosome, 23 pairs. I'm interested in 2 pair. Pair number 9 and pair number 22. Let's draw pair number 9. This is 9. And let's draw pair number 22. This is 22. Inside these cells. Inside these cells. On pair number 9, we have a gene. I'm having it. You are having it. We all have it. The name of that gene is ABL. And normally ABL does the mitosis only. It receives the signals. Otherwise, it don't do it. On 22, we have one gene. It is known as BCR. We all have it. It's normal. And it is also doing normal mitosis when it receives the signal. Now, due to mutation, if there is any mutation, there is translocation, there is exchange. So 9 is giving something to 22 and 22 is giving something to 9. That is known as reciprocal translocation, balanced translocation. So 9 is giving ABL to 22. On 22 already we have BCR and ABL is also going there. ABL is also. So because of ABL is also going and BCR is already there, ABL BCR fusion gene is formed. A new gene is formed, which is known as ABL BCR fusion or hybrid gene. That is abnormal. That will cause uncontrolled mitosis because it will cause uncontrolled signal transduction, and that will lead to do the cell uncontrolled mitosis. In exchange, the 22 is giving an empty portion to 9, which is not important. Say yes. Say yes. Got it? Say yes if you got it. So this is 922 translocation, also known as ABL BCR translocation. This is taking place in all these cells. So all these cells do uncontrolled mitosis and they all are spitted in the blood. How many of you got it? So normally 9 is present. On 9, ABL is present. On 22, BCR is present. But in translocation, ABL, which is present on 9, it will go to 22. It will go to 22. On 22, it will fuse and it will form a hybrid gene. And it will lead to uncontrolled mitosis, and that is CML. I forgot to tell you one thing. So this is 9, this is 22. Okay. This is ABL and this is BCR. This is 9, this is 22. I'm telling you the translocation. Here the ABL is going on 22. And an empty portion from 22 is coming from here. So on 22, the fusion occurs. Fusion don't occurs on 9. So that's why chromosome number 22 is Philadelphia. It's a very important MCQ. What is Philadelphia? What is Philadelphia chromosome? Is it 9 or 22? You get confused in your exam. So 22 is the Philadelphia chromosome. This is the long arm of both of them. They are exchanging. Say yes. Got it? This is Philadelphia chromosome. So Philadelphia chromosome is formed. Okay, so this is CML. There are 3 phases in CML. Chronic phase, accelerated phase, and blast phase. It is known as CAB, CAB, CAB. Chronic, accelerated, blast. Depending, myeloblast kitne hain. Here myeloblasts are less than 10%, 10 to 20%, and more than 20%. How many myeloblasts are there? Depending on that, we are dividing in 3 phases. Okay. Now, clinical features, I told you, in the bone marrow, no RBC synthesis, no platelet synthesis. है ना? Only WBC synthesis. So RBCs are less, so patient have anemia. Platelets are less, patient have bleeding problems. And although WBC are more, still patient have high chances of infection. So that is the clinical features. है ना? Coming on the lab diagnosis. If you take the blood sample of this patient, है ना? RBCs are less, platelets are less, but WBCs are more than 2 lakh. Instead of 11,000, it's 2 lakh. And this is the diagram. This is the peripheral smear. What you can see? What you can see? Oh my God, I can see multiple cells. See. I can see the red granules. This is the eosinophil. Okay. I can see the black granules. This is the basophil. Okay. I can see this is the neutrophil. Apart from that, I can see this is promyelocyte, myelocyte, metamyelocyte, band form. So this is known as garden party appearance. Garden party appearance, because in a garden party, everyone is in different dress. It is opposite of school uniform. The next AML, I will teach you school uniform appearance. Everyone is same. That is the uniform, school uniform. This is garden appearance, garden party, I mean. In party, everyone is in a unique dress. So it is looking like that. It is known as garden party appearance. Say yes, people respond. So this is CML. Hana, in the CML, this is the blood picture. Okay, this is the blood picture. You can say this is the blood picture. Not only blood picture, that is important. Okay, Hana, prognostic factors. We have 2 types of index. Just learn the name Sokal index and Hesford index. Hana, and it is having the criteria. Don't go in the detail. Coming on the next one, AML. Can I come on AML? What's the problem in AML? Listen. I will tell you the problem in AML. Okay, I will tell you. So let me draw the marrow again. This is a marrow. Okay, this is the marrow. And this is the first cell, hematopoietic stem cell. Okay, again, it is having 2 blasts. Listen, see the difference. Myeloblast, lymphoblast. Currently, I'm not interested in lymphoblast because I'm teaching you myeloid leukemia. Hello, I'm teaching you myeloid leukemia. This is the blood vessel. Hello, tell me the complete sequence. Myeloblast give rise to promyelocyte, myelocyte, metamyelocyte, band form, neutrophil, eosinophil, basophil. What was happening in CML? In CML, all these 5 cells have the mutation. Hannah, that's why these all 5 were moving in the blood in CML. And the name of the mutation is 922 translocation, ABL-BCR translocation. We know that. But what is happening now in AML? What is happening in AML? In AML, only myeloblast have the mutation, not all. So that's why only myeloblast will come in the blood, not all. It's a school uniform appearance. In CML, all 5 were coming. Myeloblast, promyelocyte, myelocyte, metamyelocyte, and band form, along with the mature versions. Here, only myeloblast is coming. Please understand the difference. This is CML picture and this is AML picture. Okay, please understand it's school uniform appearance. Okay, and only myeloblast. What is the mutation? Here it was 922. Here in myeloblast, 3 type of mutations take place. Either 821 translocation. So like 922, we have 821. Hana, or it is 1517. There is translocation between 1517. Or there is inversion on 16. On the 16, a gene is not translocated, it is inverted on itself. So learn the three choices here. One of them. 821, 1517 or inversion 16. And there we have 922. You are getting it, huh? Or is it blunder? Is it going bouncer? Or you are getting all these, huh? So this is AML. Hana. So in AML, one of the 3 mutations take place, and that's why the myeloblasts are coming in the blood. Either 821 or 1517 or inversion 16. Hana. What is the classification? There we have 3 phases. Here we have 8 type. 8 tarah ke hote hain, including M0. So and M0 is also a type. M0, M1, M2, M3, M4, M5, M6, M7. Total 8 types are there, and this classification is FAB. French, American, British classification. So it is followed throughout the world. French, American, British, FAB classification. Hana. Don't learn their names. Hana. If you can go through it once, it's good. But these are the types. Hana. These are the types. The most important among them is M3. Hana. In M3, there is a DIC. Is pe bhi question aata hai. Disseminated intravascular coagulation is there. So treatment of M3 is different from all others that you will see in the medicine. ठीक है, ये FAB classification है. Clinical features are same, but there is one difference. There is one difference from CML. Let me tell you the difference. Listen, again, this is the marrow. This is the marrow. This is the first cell, hematopoietic stem cell. Anna, I guess you got this diagram now multiple times. Anna, band form neutrophil, and this is the blood vessel. This is the blood vessel. What I told you, what is happening in the CML? In the CML, I told you these all 5 are coming in the blood, and you got it because there is mutation in all 5. They are coming in the blood and they remain in blood only. They remain in blood only. But in AML, I told you, in AML only this one is coming in the blood. Only myeloblast, not all. Because there is mutation only in myeloblast, and mutation is also different. But there is one more difference. After coming in the blood, it enters in multiple solid organs. So in AML, after coming in the blood, this myeloblast enters in multiple solid organs and produces the infiltration in the solid organ. That is not occurring in CML. CML is limited to the blood only. It never infiltrates in the solid organ. But AML, after coming in the blood, it infiltrates in solid organ also. So in CML, the symptoms are anemia. CML में सिर्फ anemia, thrombocytopenia and infection है. Here the symptoms are these. ये तो हैं ही हैं. These symptoms are there, but organ infiltration is an additional finding here. Organ infiltration is a additional finding. So it can infiltrate in the bone, in the lymph node, in the spleen, in the liver, in the kidney. It can infiltrate in the gums. Can you see gum hypertrophy? It's very unique in AML. It is typically seen in M4 and M5. It's the question. It's MCQ. M4, M5 में gum hypertrophy is there. Sometimes it can infiltrate the orbit. It is known as chloroma. Chloroma is infiltration in the orbit, and it is typically seen in M2. It is typically seen in M2. So M2 में ये and M4, M5 में ये. So gum infiltration seen in M4 and M5, and eye infiltration is seen in M2. It is known as chloroma. Please learn it. These are your MCQs. You can get image-based questions also, and sometimes it can infiltrate in the meninges. But these two are ultra important image-based question bhi, So please learn M4, M5 and M2. These are your questions. Okay. For lab diagnosis, we will take the blood, and this is the diagram. This is the diagram. What you are getting? How many type of cell? Only one type of cell. It is school uniform appearance, and these all are myeloblast. How I recognize these are myeloblast, not lymphoblast? See the cytoplasm. Some of them, see the cytoplasm, have iron rod, the red color rod. Some of them. So iron rods ke basis pe I am identifying these are myeloblast, not lymphoblast. Now compare. I have taught you these two. Till now I taught you these two. I taught you AML. I taught you CML. Compare their peripheral smear. Here this is garden party appearance having 5 type of cell, and this is school uniform appearance having 1 type of cell. Here only myeloblasts are there, and here myeloblast is there, but promyelocyte, myelocyte, metamyelocyte and band form is also there. Say yes. So 2 are done, 2 more to go. Can we go? Can we go ahead? So 2 are done. Okay, so you see the peripheral smear. Looking at the peripheral smear, seeing the age. Here the age is more than 50 years. Here the age is middle age, 30 to 50 years, but not much difference. So age is different. The mutation is different. The peripheral smear is different. And symptoms, some are common. Both have anemia. Both have thrombocytopenia. Both have infections. But the organ infiltration seen in AML, chloromas, gum infiltration. Here we don't have organ infiltration. So based on the clinical picture, whatever you are providing, you can easily guess which type of leukemia is there. There should be no confusion in that. Ki ma'am CML like AML, there is no confusion. Come on, they are different from each other. Say yes, So this is the thing. Yeah, one more thing I want to tell you here. You have to see special stains, there are 3 special stains which are positive in AML. MPO, they are MPO positive. MPO is myeloperoxidase. Sudan black, they are positive, and NSC, they are positive. 2, they are negative, PAS and acid phosphatase, that will be positive in ALL. I will tell you in ALL, okay? So this is the thing. Please read the prognostic factors by yourself. I will provide you in the notes. Plus, please read it. What are good prognostic, what are bad prognostic, because you get questions on that. Please read it once, before going to your exam. Coming on the third type of leukemia, that is ALL. Let's come on ALL. The third type of leukemia is ALL. Can I start ALL? It occurs in children. The most important finding is that it occurs in children. It occurs in children. बच्चों में होता है ये, See, the age is drastically different. So what is the pathogenesis here, What is the pathogenesis? Now you have to see. It is of 2 types, B cell or T cell. There are 2 type of lymphocyte. Now see the same marrow. Again the same marrow will come again and again. It's all about the marrow, So here the hematopoietic stem cell. Now this time I'm not interested in myeloblast. No. I'm teaching you lymphoid leukemia. So I'm interested in lymphoblast. So lymphoblast give rise to pro-lymphocyte and it gives rise to lymphocyte. This is a cell, this is a cell, this is a cell. Now here the mutation is taking place in lymphoblast. So lymphoblast will do uncontrolled mitosis, and this lymphoblast will come in the blood. So in the blood only 1 type of cell. Again school uniform appearance, but it is lymphoblast. So this is ALL. In AML myeloblast was coming. Here lymphoblast is coming. Say yes if you got it. Only lymphoblast. So name the mutation. So it is of 2 type, as I told you, B cell and T cell. It can be B cell and T cell. If it is B cell, there is hyperploidy or hypoploidy. है ना. These are the name of the mutation. Hyperploidy more than 46 chromosome. Hyperploidy less than 46 chromosomes. है ना. Normal 46 chromosomes are there. Apart from that, there is a gene PAX. PAX5 gene is mutated. है ना. Here notch gene is mutated. है ना. Have a look on the name of the genes. You will get a very simple question. So in B, this is T, huh? Make a correction. This is T. T mein only notch is mutated. But in B, it can be hyperploidy, it can be hyperploidy, it can be PAX5. These are the type of the genes which are mutated. It is of 3 type, L1, L2, L3. है ना. In contrast to myeloid leukemia, AML, which was 8 type, M0 to M7. This is only 3 type, L1, L2, L3. L1 is most common, best prognosis. L3 is rarest and it is having the worst prognosis. Clinical features are same. It also infiltrate in the organ, but organ manifestation is different. It also infiltrate in the organ like AML. है ना. AML जैसे ये भी organs में जाएगा, but specifically it goes in the testes of the male. It goes in the brain. It goes in the mediastinal lymph nodes typically. है ना. बाकी bone में liver, spleen इसमें दोनों जाएंगे. ठीक है. Blood picture, this one. See, school uniform appearance, but they all are same. Now see the 3 diagrams. I want you to see this one, this one. Please see this one. I want you to see this one, AML, Hana, and I want you to see this one, ALL. I taught you these 3. Now see their blood picture and decide which one it is. So this is garden party having multiple cells, basically 5 type of cell. Myeloblast, promyelocyte, myelocyte, metamyelocyte, and band form. And here it is school uniform appearance, only myeloblast. And here it is school uniform appearance, only lymphoblast. How to differentiate myeloblast and lymphoblast? Both are school uniform, school uniform. This is AML, this is ALL. Huh? How to differentiate? Here iron rods are there in the cytoplasm. Here the cytoplasm ही नहीं है. Scanty cytoplasm, hardly any cytoplasm. I get only nucleus, no cytoplasm, no iron rod. This is how I differentiate. This is how I differentiate. See. Now tell me the mutations in each of them. Here only one mutation, very easy, 922 in all of them. Here 3 options I have given, 821, 15, 17 and inversion 16. You have to learn it. है ना? And here B cell and T cell. T cell में तो एक ही है, notch. है ना? And B cell में we have hyperploidy and PAX5. So you have to learn the mutations in which cell and what is coming in the blood. Appreciate it. Got it? Huh? So this is the blood picture. Okay. Now I taught you CML, which was different. Now I'm comparing AML and ALL. है ना? AML and ALL. I'm not taking CML in consideration. है ना? Here it is school uniform, only myeloblasts are coming. Here it is also school uniform, only lymphoblasts are coming. Myeloblasts have iron rod in them. And here iron rods are absent. Here iron rods are absent. Now based on the 5 special stain, we can differentiate them. Here 3 are positive. MPO is positive. Sudan black is positive. And non-specific esterase NSE is positive. These 3 are negative here. Here 2 more are positive. Here PAS is positive and acid phosphatase is positive, which are negative here. So you have to learn the special stain that I was talking about. These 3 are positive in myeloid series and these 2 are positive in lymphoid series. That is known as cytochemistry. है ना? So here you can see, है ना? These 2 are positive, PAS and acid phosphatase, and these 3 are negative. These 3 are positive in AML. How many of you got it? Prognostic factor, please read, but it's ultra important. The last one I'm teaching you is CLL. Can I teach you? है ना? CLL in a compact way. है ना? Just in 20-25 minutes, I taught you the 4 leukemias people, and I can challenge you can track any question based on that. So coming on CLL, also known as SLL. है ना? So what is the problem here? Okay, let me tell you, 13, 11, 17, and 12. Okay, so again the same, है ना? The last time I'm drawing this diagram, the marrow, है ना? So it is hematopoietic stem cell. Again, I'm not interested in myeloblast wala series. I'm interested in lymphoblast wala series. So lymphoblast, prolymphocyte, and lymphocyte. Okay, last time. So myeloblast, promyelocyte, myelocyte, metamyelocyte, band form, neutrophil, eosinophil, basophil. Let's compare and contrast the 4 leukemias. This is the master diagram. Last time I'm telling you. Listen, let's start with the first one, CML. In CML, there is mutation in these 5. That's why all these 5 come in the blood. This is CML. All 5 come in the blood. And the name of the mutation is 922 in all 5. We know that very well. Hana, coming on AML. The second is the AML. Mutation occurs only in myeloblast. The name of the only myeloblast will come in the blood. So name of mutation are 3. It's 821, 15, 17, and inversion 16. Hana, they all only myeloblast will come in the blood. The third I taught you is ALL. Hana, in which mutation occur only in lymphoblast. The name of mutation can be hyperploidy, hypoploidy, PAX5 in B type and notch1 in C type. है ना? So only lymphoblast will come in the blood. That is ALL. And finally, I'm going to teach you CLL. CLL. So what will happen in CLL? Can you give a guess? What will happen in CLL? The mutation will occur in what? The first thing you have to decide the mutation. It will occur in what? CLL. It will be on lymphoid side, not on myeloid. So mutation occur in the lymphocyte. It's in mature lymphocyte. The mutation occur in the lymphocyte. Name the mutation. Name the mutation. It can be deletion. It can be deletion of 11, 13, 17. Deletion of either 11, deletion of 13 or 17 or trisomy of 12. These are the mutation because of which they will become uncontrolled mitosis and mature lymphocyte will come in blood. You will say, ma'am, I'm also having lymphocyte, but you have only 20 to 30 or 50% of the lymphocyte, not more than that. Here, 99% of the cells are the mature side, that too abnormal. These are not normal lymphocytes. These are abnormal lymphocytes. They are very fragile. Okay, so this is the difference. How many of you got it? I tried my best to explain you. Hannah. So this is the lymphocyte. So here in a CLL, either deletion of 13, 11 and 17 or trisomy of 12. Most common deletion of 13. Hannah. So this is the thing, and here this is the blood picture. See, all of them are mature lymphocyte. Listen, one more thing. I'm having a patient. Hannah. Then the age of the patient is more than 80 years. It occurs in old age, CLL. More than 80 years. Hannah, patient is having lethargy and all. I'm taking the blood sample and I'm having a doubt the patient is having CLL. Hannah, so what I will do? You say, ma'am, collect a blood sample. It's very simple. You just collect a blood sample and make a smear. So I'm collecting the blood sample over here. The blood sample have 99% of the cells as lymphocyte. The abnormal lymphocytes, not normal lymphocytes. If my diagnosis is right, these all are immature, abnormal, mutated lymphocyte, 99% of them. Now I will make a slide. How we make a slide? You know the procedure. You say, yes, ma'am, take a slide, take one drop of blood over here, Hannah, and spread it with a spreader. I repeat, spread it at 45 degrees with a spreader. So whenever we spread it with a spreader now, actually these lymphocytes are abnormal. They just get ruptured. Many of them are complete, but many of them will get ruptured. So ruptured forms of these lymphocytes are known as basket cell or smudge cell. So basket cell or smudge cell are the ruptured version of these lymphocytes. They are not present in test tube. They are not present in the patient. They are present on the slide. While making the slide, they are formed. It is a slide artifact. How many of you got it? These are the atypical lymphocytes. They have deficiency of vimentin in their cell membrane. That's why they get ruptured. These are questions. Line se puri questions बताएं. So see, this is the diagram. In the diagram, what I can see, these all are mature lymphocyte. These all, and some of them get ruptured. This is the ruptured version. This is the ruptured. The ruptured one are the smudge cells. So see the 4. I am done. I guess you can understand the 4. Can I explain you all 4 again, or you can understand? Please see. Here it is garden party appearance. You get the 5 type of cell. This is school uniform appearance. You get only myeloblast. This is also school uniform appearance. You get only lymphoblast. Here having this IO rod is compulsory, and in CLL you get no blast. Hannah, you get mature lymphocytes along with the smudge cell or basket cell. Age is different in all of them. Presentation is different in all of them. The smear is different in all of them. The mutation is different in all of them. I am done. This is all about leukemia. I can tell you, I wish if I could have time and I can fill it up for you. The most important is the age wala column. You have to fill pathogenesis. I will tell you. Here it's 922. Hannah, here it's 8, 21, 15, 17, inversion 16. Here it's notch 1 in the T lymphocyte, and in B lymphocyte it's hyperploidy, and PAX5. Hannah, and here it's deletion of 11, 13, 17 and trisomy of 12. Hannah, I tried and I'm successful. Okay, anyways, fat classification I told you, clinical features, and main is the smear of all of them. Prognostic factors, please read yourself. Okay, this is all about leukemia. So let's take a break, and after that I am going to do super rock and crush the entire systemic pathology. I mean the high yielding topics. I cannot cover entire. I wish if I could, but we will do all important topics here. Okay, the systemic pathology. Let's take a break, Hannah, and after that I want all of you to come back if you want the same confidence in systemic pathology also. It's the most difficult portion of the pathology students feel. So we have covered general, we have covered hemat, and now it's time to do systemic one. Okay, so let's take a break, and after that we can continue. Okay, so let's take a break of 35 minutes. Anna, it's 5 minutes for 12. So we will meet again at 12:30 sharp. 12:30 p.m. sharp. Hannah, so there is a break of 35 minutes. After 35 minutes, on the same link, it will be available on the same YouTube channel, same link. Okay, so let's meet. I repeat my words at 12:30 sharp. Please come back. We will be starting systemic pathology. Don't go anywhere. Okay, I will be back. Okay, so in the systemic pathology, we are having all these systems, but out of these systems, 5 systems are ultra important, from which many MCQs are repeated very frequently. So we are going to revise those 5 or 6 systems. Okay, one by one. So let's start with the first system, blood vessels. In the blood vessels, I want to teach you 3-4 topics, or we want to revise quickly 3-4 topics. One is aneurysm. Okay, I will teach you what is aneurysm, all about aneurysm, aortic dissection, and vasculitis. So these 3 topics are ultra important, from which many MCQs are repeated every year, especially in FMGE exam. So let's start with the aneurysm. What is aneurysm? Now we know in the wall of the blood vessel there are 3 layers. There is tunica intima, which is lined by the endothelial layer, endothelial cells. There is tunica media and tunica externa. These are the 3 layers in the wall of the blood vessel. Okay, now the blood is flowing inside the lumen. Now sometimes what happens, there is weakness of the wall. So this is the blood vessel, this is the wall of the blood vessel. Now focally there is weakness at one point. For example, there is focal weakness at this point. If there is focal weakness at anywhere, so what is happening, the wall is protruding out and forming a outpouching here. So can you see this outpouch? Can you see this pouch-like structure? This is outpouching, and it is known as aneurysm. It occurs due to focal weakness of the wall at certain point. Now, the cause of the weakness can be different. Okay, there can be 3 important causes which causing weakness over here. The first important cause is atherosclerosis. If the atherosclerosis is causing the weakness, so there is protrusion. So such an aneurysm is known as atherosclerotic aneurysm. The second important cause can be syphilis. Due to the syphilis, syphilis can occur in the wall of the blood vessel in tertiary syphilis, causing focal weakness due to end arthritis. So such an aneurysm is known as lytic aneurysm, which is due to syphilis. The weakness is caused by the syphilis. And the third important cause, this weakness is caused by the infections. Now, there can be any microorganism, can be bacteria, can be virus, can be fungus, can be parasite, which is causing focal weakness in the wall of the blood vessel. So such an aneurysm, which is due to weakness, is known as mycotic aneurysm. So there are 3 types of aneurysm. The atherosclerotic aneurysm is due to atherosclerosis. The lytic aneurysm is due to syphilis. And mycotic aneurysm is due to infection. So in all of them, one thing is certain. There is focal weakness in the wall of the blood vessel that is producing a protrusion out. That is the outpouching, and that is known as aneurysm. Give me a thumbs up. How many of you got it? So this is the definition of the aneurysm. Aneurysm, you can see it here. This is protrusion. So whenever there is more stress on the wall, there is weakness of the wall, so outpouching is there. That is known as aneurysm. Now, aneurysm, we can classify the aneurysm based on 3 classification. The first classification based on the composition of the wall. So as I told you, here you can see the 3. So here you can see the screen again. Okay, now what is the first classification of the aneurysm I was telling you? I told you in the wall of the blood vessel there are 3 layers. You can see this is intima, this is media, and this is externa. Here also it's intima, media, externa. If all the 3 layers are protruding out, so intima is also protruding out, media is also protruding out, and externa is also protruding out. If all the 3 layers are protruding out, it is known as true aneurysm. So in true aneurysm, all the 3 layers protrude out. All 3 layers protrude out. That is the true aneurysm, right? This is true aneurysm. Now what is happening? Sometime there is an injury in the wall of the blood vessel. So because of the injury in the wall of the blood vessel, there is bleeding. Can you see the bleeding is taking place? So blood is coming out. The blood is coming out. To withhold that, the body is forming a connective tissue to withhold that. So actually it's a hematoma. It looks like aneurysm, but it's not an aneurysm, it's a hematoma. Because here the wall is made up of connective tissue. In the wall there is no intima, media, and externa. So this is known as false aneurysm or pseudo aneurysm. So false aneurysm or pseudo aneurysm is actually a hematoma. How many of you got it? That is the 2 type of aneurysm I taught you, the true aneurysm and the false or pseudo aneurysm. In true aneurysm, actually the aneurysm is really true and it contains intima, media, and externa as a wall. But in pseudo aneurysm, the wall is made up of connective tissue. It is not having intima, media, externa. Actually, it's a hematoma. It looks like aneurysm, but it's a hematoma. So that is the first classification. Second classification is simple. Based on the shape, it can be of 5 types. If there is only unilateral protrusion, it's known as secular. If the protrusion is 360 degree, it's 360 degree. Everywhere, it's fusiform. Okay, if it is one side, it's secular. If it is 360 degree, it's fusiform. Okay, if it is parallel, like this, it's cylindrical. If it is multiple small protrusions are there in continuity, it's known as serpentine. And if multiple blood vessels are interconnected with each other, it's known as racemose. So based on the shape, there can be of 5 types you can see. And the third, who is causing the weakness? I told you, there is focal weakness. So actually, who is causing the weakness? The weakness is caused by atherosclerosis, it is known as atherosclerotic aneurysm. If the weakness is caused by syphilis, it is known as lytic aneurysm. And if the weakness is caused by the infection, it is known as mycotic aneurysm. So based on who who is causing the weakness, it is of 3 type. Okay, Sethi, I'm coming on your query. Wait a while. Okay, so this is the aneurysm. So let me teach you, most of the aneurysm, 90% of them is atherosclerotic. Most common cause is atherosclerosis only. This is the most common cause of the aneurysm. Now, what is the most common location? Mostly they occurs in aorta. You know the different parts of the aorta. So you can see this is the right side of the heart, this is the left side of the heart, and this is the aorta arising from the heart is like this. This is the aorta. It is arising from the left ventricle like this. Okay, and you can see this is the diaphragm I'm drawing here. This is the diaphragm. Okay, so we divide the aorta into multiple parts. This is known as ascending aorta. Okay, this is known as arch of aorta. Okay, and this one completely is known as descending aorta. We divide the descending aorta into 2 portions. Above the diaphragm, it's thoracic descending aorta, and below the diaphragm, it is known as abdominal thoracic aorta. We divide the abdominal again into 2 portions. Abdominal one. Okay, let me show you. Let me draw the kidneys here. This is the 2 kidneys I am drawing, and from the aorta, this is the renal artery supplying the 2 kidney. So abdominal aorta is divided into 2 portions, suprarenal and infrarenal. This is suprarenal and this is infrarenal. The 2 together constitute the abdominal aorta. I hope you got the various parts of the aorta. Now I'm asking you, what's the most common location of atherosclerotic aneurysm? Where does it occur? Is it ascending aorta? No. Is it arch of aorta? No, it is descending. In the descending, it's not thoracic, it's abdominal. In the abdominal, it's infrarenal. To be specific, this is the most common location of atherosclerotic aneurysm, which is the most common type of aneurysm. Atherosclerotic aneurysm occurs in infrarenal portion. Can you see here? Can you see? This is the renal artery. See, appreciate the renal artery. So aneurysm is below the renal artery in the abdominal aorta. So it's abdominal aorta, intrarenal to be specific. It's a very important question. So this is the most common location. Here also you can see the complete aorta. These are the renal arteries you can appreciate, and just below the renal arteries, infrarenal portion, before the bifurcation of the aorta, you can see atherosclerotic aneurysm. This is the most common location of atherosclerotic aneurysm. How many of you got it? Okay, so I have to draw once again the heart, and I will show you the location of other aneurysm also in this diagram. So now you can understand the various parts of the aorta. I have already explained you. Okay, the various parts, ascending, arch and descending, and you can see thoracic and abdominal. Okay, so I taught you the most common location of atherosclerotic aneurysm is abdominal aorta, and that too infrarenal. This is the most common location of atherosclerotic aneurysm. Now I'm asking you the most common location of syphilitic aneurysm. Where is the most common location? The most common location of syphilitic aneurysm is ascending aorta. And just, here we have aortic wall. These are the cusp of the aortic wall. And just above the aortic wall. Aortic wall. This is the aorta arising from the aortic wall. So just the cusp of the aortic wall, there is syphilitic aneurysm. So syphilitic aneurysm most commonly occurs here. Because the syphilitic aneurysm, it is causing dilatation over here. The 2 cusps of the aortic wall, they get separated from each other, and it will lead to aortic regurgitation. So blood is regurgitating again into the left ventricle. So in syphilis, actually there is more blood in the left ventricle. Because aortic regurgitation is there, the blood is more. It is causing a stress on the wall of the left ventricle. That's why the wall of the left ventricle get thickened in syphilis. So the heart size become big, and the heart is looking like a cow's heart. It's not human heart. It's look like a big heart, a cow's heart. It is known as cor bovium. So we have cor bovium. This terminology, cor matlab, bovium matlab cow. So it is the heart of the cow. It's look like this because the size is big. So it is seen in syphilis. So in syphilis, learn 2 things. Number 1, the most common location is ascending aorta, just above the aortic ring. It is leading to aortic regurgitation, leading to left ventricular hypertrophy. The size of the heart is big because of aortic regurgitation, and that will lead to cor bovium. How many of you got the reason for the cor bovium? So this is seen in syphilitic aneurysm. This is seen in syphilitic aneurysm. So syphilitic aneurysm or lutic aneurysm, it is seen in syphilis. It is seen in ascending aorta, and that will lead to aortic regurgitation. Because of aortic regurgitation, the heart size is big. It's like cow's heart. It's known as cor bovium. Now, if you cut the aneurysm from here, the syphilitic aneurysm, and if you open it, you will see from inside it is wrinkled. The aorta is wrinkled. So if I'm cutting and opening, I can see the aorta is wrinkled like this. So it is looking like the tree bark appearance. So in syphilis also you see the tree-like bark appearance. And there is linear calcification. So these are the questions you get from syphilitic aneurysm. So we are done with aneurysm. I taught you atherosclerotic aneurysm, the details, syphilitic aneurysm, the details, and third is mycotic, which is not very important. Just learn mycotic is due to infection. Now aortic dissection. Someone among you was asking, now what is aortic dissection? Let me tell you what is aortic dissection. Listen, there are 3 layers in the wall of the blood vessel. So let me draw, this is intima, Okay, this is intima. You can see intima is the innermost. This is media. Let me draw. This is media, the middle layer. And this is externa. Externa is outermost. This one is externa. Okay, now blood is flowing inside that. Okay, blood is present in the lumen. Normal pressure of the blood is 120 by 80. This is normal blood pressure. We know that. Now, some persons have hypertension. I mean, they are not treating the hypertension. They are not controlling it. So, blood is flowing with more pressure, with high pressure. So, because blood is having more pressure, sometime because of hypertension, it produces a tear in the intima. I repeat my word, it produces a tear in the intima. Because there is a tear in intima, the blood will enter from the tear here. And it will enter in the media. In the media, you know, media is a very thick layer. It is having muscular planes. So blood is causing a dissection of the media. It is causing the dissection of the media. And it producing a one more channel, which is parallel to the main lumen. So this is the main lumen. Parallel to this, there is one more pseudo-lumen, which is present in the media. This is known as aortic dissection. It occurs in aorta. So there is dissection. Dissection of what? Dissection of the media. Who is causing the dissection of media? The blood is causing the dissection of media. It's a severe painful condition. Can you see this diagram? In this diagram, see the tear in the intima due to hypertension. Most common causes hypertension. So blood is entering from the tear. And after entering from the tear, it is dissecting the media into two portions. Inner 1/3 and outer 2/3 is the weakest point where the dissection occurs. And blood is separating the planes of the media. And this is extremely painful condition. The patient will complain, I'm having a cutting like pain inside the chest, inside the thorax. Someone is cutting with a knife. It's the pain with that intensity. So this is aortic dissection. If you take the section from here and look from above, so this is the diagram, the cross-sectional diagram. You can see this is the lumen, and you can see here is the tear, and from the tear the blood is entering in the media, and it is causing the dissection of the media. So there are two lumen, the true lumen and the pseudo lumen. The pseudo lumen is the parallel to the true lumen. How many of you got it? How many of you got it? So most common causes hypertension. In 90% of cases, the tear is due to hypertension. But in 10% of the cases, we see in normotensive person also this can occur. So in normotension, I mean non-hypertensive cases, the most common cause is Marfan syndrome. In Marfan syndrome, there is cystic medial degeneration and that causes it. You can see here. So this is the tear from which the blood is entering and forming a channel which is parallel to the main channel. So if you cut the aorta from here and look from above, you will get two lumen. This is the true lumen you can see, and this is the false lumen you can see, the parallel lumen. How many of you got it? This aorta is known as double barrel aorta. It is having two lumens, double barrel aorta. One is true lumen, one is false lumen. So there are two lumens. The false lumen is in the media itself, which is parallel to the true lumen. Got my point? Got my point? Do you have any confusion here? Can we go ahead? Just a second. Okay, so let me give you the classification of aortic dissection. In aortic dissection, the classification is important. There are two systems of classification we use, Stanford classification and DBK classification. Let's see DBK first. Okay, you can see the various parts of the aorta, the ascending, the arch and the descending. If the aortic dissection is present in all parts, in the ascending also, in the arch also, in the descending also, it's DBK type 1. If it is present only in ascending, it's DBK type 2. If it is present only in descending, it's DBK type 3. So complete aorta is involved, it's DBK type 1. Only ascending is involved, DBK type 2. And only descending is involved, it's DBK type 3. Got it? Actually, DBK type 1 and 2 together constitute Stanford A. Stanford A is either complete or only ascending. And Stanford B is descending. So this is the classification. Sometime you can get an image-based question. And I guess this classification is more or less important in the surgery portion. But you will revise there also. So coming on the next topic very quickly, the vasculitis. What is itis in pathology? Itis is inflammation of that organ. We have appendicitis, we have meningitis, we have rhinitis, we have tonsillitis. Itis is the inflammation of that organ. So vasculitis is the inflammation of the wall of the blood vessel. So there is inflammation in the three layers, intima, media and externa. It is known as vasculitis. The three layers are inflamed. Okay, so tell me the classification of the vasculitis. There are two types of classification. Maximum questions are from classifications only. Okay. So you have to learn the two types of classification. The first classification, ultra important, based on the type of the blood vessel. In human body, we are having three types of blood vessels. The large, the medium, the small. Large blood vessels are aorta and its branches. Aorta is a large blood vessel and its direct branches are the large blood vessel. The medium blood vessel is the renal artery, like all the arteries. And small blood vessels are the arterioles arising from the arteries, arterioles and venules. These are the small blood vessels. So depending which blood vessel is inflamed, of course inflammation is there. That's why it's vasculitis. Inflammation to hai. Lekin kaun sa? Is it large blood vessel, medium or small? In the large blood vessel, we are having two types of vasculitis, TT. The mnemonic is TT, temporal and Takayasu. The mnemonic is TT.
temporal and Takayasu. Temporal is also known as giant cell arthritis. Giant cell arthritis, this is the most common vasculitis from all. This is the most common one. Hana? So please learn the TT. In the medium blood vessel vasculitis, we are having three vasculitis. Okay. There are three types of vasculitis. The first is PAN. What is PAN? Polyarthritis nodosa. It is known as PAN. Okay. Second is Kawasaki and third is Berger. You can learn a mnemonic. Hana? PKB. Hana? PKB is the mnemonic. Okay? PKB. You can make some mnemonic and PKB. Okay. PAN, Kawasaki and Berger. And here we have TT. So large is done, medium is done. Now coming on small. Actually small is difficult to understand. Small are of two type, ANCA positive, ANCA negative. You will say, what is ANCA? ANCA, the full form of ANCA is anti-neutrophilic antibodies, cytoplasmic antibodies association. So I will explain you what is ANCA. Hana? ANCA are of two type, P ANCA or C ANCA. If it is ANCA positive, whether it is P ANCA or C ANCA. So you get simple questions on that. C ANCA positive is only one vasculitis. The name of that vasculitis is Wagner. And P ANCA positive are two. Hana? Here we have PAN. Here we have microscopic version of that. So it is microscopic polyangiitis, microscopic PAN. PAN, classical PAN is medium vessel vasculitis, but it's one of the variant that is microscopic PAN is small vessel vasculitis. And second is Church-Strauss. Now I will explain you again all this. First understand what is ANCA. What is ANCA? Okay. So I doubt any of you understand what is ANCA. First see the full form of ANCA. It is C. This is neutrophil. Okay, this is the nucleus of the neutrophil. We all know the neutrophil is a multilobated cell. The nucleus is having multiple lobes. Hana? And we all know the neutrophils have granules inside that. The pink color granules are present. These are the granules. So basically ANCA are the antibodies against the granules of the neutrophil. These are autoantibodies. The body is forming antibody against the granules of the neutrophil. This is our own cell. Own granules. Body is forming antibodies against that. That's why it is known as ANCA. Anti-neutrophilic cytoplasmic antibodies. So these are the antibodies against the cytoplasm of the neutrophil. That's why known as ANCA. This is the full form of ANCA. So the full form itself depicts what is the meaning. Anti-neutrophilic cytoplasmic antibodies. So these are the antibodies against the cytoplasm of the neutrophils which contains the granules. So basically these are the antibodies against the granules. Now there are two types of ANCA you told me now. P ANCA and C ANCA. What do you mean by that? What is P ANCA and what is C ANCA? So let me explain you. For that I have to draw two neutrophils to explain you C ANCA and P ANCA. I will explain you C ANCA here and I will explain you P ANCA here. So here the antibodies are formed against the granules which are present anywhere in the cytoplasm. Anywhere haphazard. So the antibodies will come and they will be present haphazardly. They will bind with their antigen. So their antigen is haphazardly everywhere in the cytoplasm. So cytoplasmic ANCA. C for cytoplasmic. C for cytoplasmic. Cytoplasmic ANCA. It is everywhere in the cytoplasm. Sometimes antibodies are formed only against the granules which are present around the nucleus. Not anywhere else. The granules are present only around the nucleus. Got it? So the antibodies are present perinuclear. Nowhere else. In the cytoplasm only, but not haphazardly throughout. See that, see this. So it is P ANCA, P for perinuclear. So say both of them are antibodies. Okay, both of them are antibodies against the neutrophil. Both of them. But this is cytoplasmic anywhere in the cytoplasm and this is perinuclear. How many of you got it? This is the meaning of P ANCA and C ANCA. I hope I am able to explain you. Say yes, got it. So tell me the granule which is present everywhere against which the antibodies are formed. Tell me that the name of that granule, the composition. It is proteinase 3. Proteinase 3, which is present everywhere and against which these antibodies are formed. And tell me the granule which is present only around nucleus. So that the antibodies is formed against that. So it is MPO, myeloperoxidase. So here the antibodies are formed against MPO. Here the antibodies are formed against proteinase 3. Here MPO is present around the nucleus. It's perinuclear. Here proteinase 3 is present everywhere. That's why it's cytoplasmic. Here we have C ANCA. Only one example. The name of that example is Wagner granulomatosis. That's it. And in P ANCA there are two examples. One is microscopic PAN. Microscopic polyangiitis, which is a variant of classical one. And the second is Church-Strauss. Give me a thumbs up, people. I'm trying hard to explain you. This is ANCA positive, ANCA negative. I've explained you. Come on. You can see. So we use fluorescent antibodies to highlight whether it is P ANCA or C ANCA. See, this is also neutrophil. This is also neutrophil. Here, the green color is reflecting the antibodies, autoantibodies. It is everywhere in the cytoplasm. That's why it is C ANCA. everywhere in the cytoplasm. And here I can see the green color around the nucleus, only around the nucleus, multilobated nucleus. So this is Priyanka. Hana, this is against proteinase 3. This is against MPO. It is seen in Wagner's granulomatosis. This is seen in microscopic pan and Chuck-Strauss. So you get many questions on that. Priyanka, Siyanka. Okay. So this is the first classification I told you of vasculitis. For vasculitis, I want to tell you one more classification. Hana, I told you. Okay. So let me draw the two blood vessels for you. How I can simplify. This is intima, media, externa. This is intima, media, externa. So I am teaching you vasculitis. Hana, vasculitis, there is inflammation in the wall of the blood vessel. So there are two types of inflammation. Either in the media, Hana, granules are formed. You know what? Granulomas are formed. You know what is granulomas? The giant cells are there. Epithelioid cells are there. Hana, lymphocytes are there with the giant cells. So multiple granulomas are formed. Hana, these all are giant cells and these are the small granulomas. Yesterday I taught you chronic inflammation, I guess. If you have missed it, you can watch. How does a granuloma is formed? At the center, we have giant cell and epithelioid cell surrounded by T lymphocytes, surrounded by fibroblast cells. So typical granuloma. This is known as granulomatous vasculitis. Granulomatous vasculitis. Sometime in the wall of the blood vessel, we don't have granulomas. In the media itself, we have necrosis. Fibrinoid necrosis. Yesterday, I taught you fibrinoid necrosis. I taught you 5 types of necrosis. The 5th one was fibrinoid. I taught you there it occurs in vasculitis. Yaad ho to. Hai na? Coagulative necrosis, liquefactive necrosis, caseous necrosis, fat necrosis, last was fibrinoid. If you have attended my yesterday's lecture. So it is necrotizing vasculitis. So we have two types of vasculitis. The diagrams are in front of you. So actual diagrams look like this. Actual diagram. Can you see the 3 layers here? This is intima, this is media, and this is externa. In the media, I can see the giant cells. These are the giant cells and these all are the granulomas. Here I can see this is the fibrinoid necrosis, the ribbon-like material. Hannah, so which of them are granulomatous and which of them are necrotizing? Which of them are granulomatous, which of them are necrotizing? So granulomatous, both the large TT will come, large vasculitis in the granulomatous. Both the small, P, polyarthritis nodosa, Berger and Kawasaki, they will come in the necrotizing. Among the small, Chuck-Strauss is coming towards the necrotizing, but microscopic pan is coming towards the necrotizing, but Chuck-Strauss and Wagner is coming towards both. Got my point? So shall I repeat? So finally, the classification of vasculitis. Let's merge the two classification and pack vasculitis. What is vasculitis? Vasculitis is inflammation of the blood vessel. How many types of vasculitis are there? There are 3 types of vasculitis. Small, medium and large. So is the small blood vessels involved? Is the medium blood vessels involved? Is the large blood vessels involved? Based on that. In the small, we have only 2 diseases, temporal and Takayasu. Temporal is most common. It is known as giant cell arthritis. In the medium, we have 3 options. Pan, okay, Kawasaki and Berger. Okay. In the small, these are of 2 types. Anka positive and Anka negative. Anka positive is important. Anka negative are not important. Anka negative. In the Anka positive, again it is of 2 types. P Anka or C Anka. P is perinuclear Anka and C is cytoplasmic Anka. Okay. Perinuclear Anka, we have 2. One is microscopic pan, which is a version of pan only. And one is Chuck-Strauss. And here we have Wagner's granulomatosis. You have to learn anyway. Now, which of them are granulomatous? So only these 2 are granulomatous. That's it. Okay. Which of them are necrotizing? So these are necrotizing. Let me explain. These are necrotizing along with microscopic pan. Pan or microscopic pan, both are necrotizing. Now, kaun do bach gaye? The 2 are left. Which 2 are left? Name them. Which 2 are left? Quick. So Chuck-Strauss and Wagner, they come in both. They are granulomatous also, necrotizing also. It's a very important MCQ. I don't know how many of you got it. Okay. ठीक है? Got it? Okay. I have written its reverse, but I mean this one is large. Thank you for reminding. This one is large, this one is small. By mistake, I have written that. Okay, forgive me for that. Okay, sorry. So this one is large, this one is small. By mistake, I have written. Okay, got it. So this is the final classification where I'm merging the 2 classification of the vasculitis. Okay, G. So can we go ahead? Anna. So we are done with classification of the vasculitis. Now let me tell you a few important topics of the respiratory system. Here I want to teach you one topic, COPD. The 4 types of COPD. Frequently you get questions on that. So let's start COPD. To understand the various types, I will teach you 4 types of COPDs here. Anna. I will teach you chronic bronchitis, asthma, emphysema, and bronchiectasis, and you should understand the differences between them. Okay, so here for understanding the various type of COPDs, you must understand the respiratory tract. So let me draw a normal respiratory tract in front of you. So respiratory tract start with the nose. This is my nose, you can see. So it will end with the nasopharynx. Behind the nose, we have pharynx. After the pharynx, we have larynx. Larynx lead to trachea. From the trachea, that bronchi arise. The right and the left bronchi that goes in the lungs. Hai na? This is the bronchi. From the bronchi, bronchioles will come. First, there is primary bronchiole, which lead to secondary bronchiole, which lead to tertiary bronchiole, which lead to terminal bronchiole, which lead to respiratory bronchiole, which lead to alveolar duct, and finally alveolar sac. You have to learn the sequence, people. You have to learn the sequence. Let me tell you again. Start with the nose. Nose will land in pharynx. Pharynx lead to larynx. Larynx lead to trachea. Trachea lead to bronchi. From bronchi, bronchioles will arise. See the sequence. First, there is primary, which leads to secondary, which leads to tertiary. From tertiary, there is finally terminal bronchiole. From one primary, many secondary are there. I have drawn only one for the simplicity. From one secondary, many tertiary. From one tertiary, many terminal bronchiole. From terminal bronchiole, respiratory bronchiole. Then alveolar duct. And finally, the balloon-like structure that is alveolar sac. Got it? Now, what is the function of the lung? What is the function of the respiratory tract? Why God has given that? For respiration. So this is the air. And I'm inhaling it. This is like this. So it is going inside, inside, inside. So the air is going in the nose, in the pharynx, in the larynx, in the trachea, so on, so on, so on, so on, so on. Finally, the air reaches the alveolar sac. What's next? What's next? Air reaches there. All the alveolar sacs are surrounded by pulmonary capillaries. So this is the pulmonary capillary, and here the exchange takes place. So whatever air we are taking, it contains oxygen. So it goes inside, 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 inside. So oxygen goes here. Carbon dioxide comes back, and we exhale in the reverse fashion. So I inhale, does the exchange, exhale. So this is the normal function. I guess everyone knows it, but just for the sake of revision. Now this is lower respiratory tract. I'm interested in the lower respiratory tract, trachea onwards. So trachea onwards, it is lower respiratory tract, and above trachea, it's upper respiratory tract. The last three structures. What are the last three structures? The last three structures, I mean respiratory bronchiole, alveolar duct, and alveolar sac. This is known as acini, acinus. This is the structural unit, functional and structural unit of the lung. Like glomerulus is the structural unit of the kidney. Here, the functional unit is the acinus. So last three structure is equal to acinus. I hope you got it. Okay, I hope you got it. So this is the complete respiratory tree which I have drawn for you. So it is trachea, which leads to bronchi, which leads to primary, secondary, and tertiary bronchiole. Finally, terminal bronchiole. Finally, respiratory bronchiole, alveolar duct, and alveolar sac. The last three structure is known as acinus. How many of you got it? Now, if there is obstruction at any level, it is known as COPD, chronic obstructive pulmonary disease. The obstruction starting from trachea till alveolar sac. At any level, there is obstruction. Exchange of the gases will not take place if I'm inhaling. So if there is obstruction at any of the level, the pure air, the oxygenated air will not reach in the acinus, in the balloons, and exchange will be affected. And the person will have COPDs. So there are 4 types of COPDs I'm going to teach you. I will start with chronic bronchitis, then I will move on emphysema, then I will move quickly on asthma, and finally bronchiectasis. You get many questions out of that. The main thing is that the level of obstruction is different in all 4. So in chronic bronchitis, the obstruction occurs in the trachea. In emphysema, the obstruction occurs in the acinus. In asthma, again the obstruction occurs in trachea and bronchi, like chronic bronchitis, but the cause is different. And in bronchiectasis, the obstruction occurs in the primary, secondary, tertiary bronchioles. So the level of obstruction is different and the cause is different. You have to understand that they all are COPDs, obviously, but the cause of the obstruction is different. So obstruction is going to be common thing, but the cause is different and the presentation is different. Got my point? So let's start the COPDs. What are COPDs? Chronic obstructive pulmonary disease, COPDs. So there are 4 COPDs. We will start them one by one. They are in front of you. Let's start with the first one, chronic bronchitis. This is chronic bronchitis. Now I told you it's a disease of trachea and bronchi. So this is my trachea, these are my bronchi. This is my trachea, this is my bronchi. They are having 4 layers. The trachea also, the bronchi also. So what are the 4 layers? Innermost layer is mucosa. This is mucosal lining. That is pseudostratified ciliated columnar epithelia. This is mucosa. After that we have submucosa. Submucosa have glands in that. This is the glands present in the submucosa. After that, we have muscularis propria, the third layer, muscularis propria. And the fourth one is the serosa. I guess ये तो हमने school में पढ़ा है. This is This is the, everyone knows it, the 4 layers of the respiratory tract, the trachea and the bronchi. My point is that the submucosa, I'm interested in submucosa. The submucosa contains the glands. What does the function of this gland? The glands do the secretion, and the secretion is, the secretion is there in the lumen. The secretion is excreted, it is given, it is secreted in the lumen. So in the lumen, now in the nose we have a sticky secretion. The same sticky secretion is present throughout the respiratory tract, and this sticky secretion present throughout the respiratory tract is formed by these glands, which are present in the submucosa, and it is secreted in the lumen after formation. You will say, ma'am, why the sticky secretion is necessary for the entire respiratory tract? So we are inhaling the air contains the dust, it contains many particles, so they will stick here only and they will not go inside the lung, they will not damage the alveoli. That is the purpose. So this sticky secretion is very important, which is secreted by the glands. You say, ma'am, everything is good, God is great, and he has a reason, the supernatural power have a reason behind everything. So we have this secretion, it is intentional, कुछ भी ऐसे ही नहीं है हमारी बॉडी में, हर चीज का एक रीजन है. Anyways, the respiratory tract is given for respiration, but some people misuse it. They do smoking. It is not given for smoking, by the way. Okay, but some people smoke still. Okay, so this is the smoke. Just suppose someone is smoking the cigar or bidi or cigarette, whatever. So smoke is going in the trachea and the bronchi. That is acting as a stress. That is acting as a stress. Because of the stress, yesterday I taught you 5 types of adaptation. The glands will have the stress. So glands will do hypertrophy and hyperplasia. What is hypertrophy and hyperplasia? If you have attended my yesterday's lecture, they will increase in size and they will increase in number. They will do both. The glands will increase in size as well as number. Since they increase in size as well as number, they will form abundant secretion. The secretion will be secreted in the lumen. In the lumen, the secretion will form a plug because it is abundant. It is abundant in nature, and that will form a, just a second, let me open the chat. It will form a plug that is known as mucus plug. This will form a plug that is known as mucus plug. So this mucus plug will obstruct the lumen of the trachea and the bronchi, and the person cannot do the respiration, and that is the disease chronic bronchitis. So in chronic bronchitis, there is obstruction. Of course, it is COPD, so there has to be obstruction. So obstruction is there in the trachea and the bronchi. And the cause of obstruction is the mucus plug. The mucus plug is formed because of hypertrophy and hyperplasia of the glands present in the submucosa because of smoking. So smoking is the culprit. Sometimes, rarely, it can occur in non-smokers also. The reason can be the pollution and other irritant. But usually it is seen in smokers, chronic bronchitis. Now, person cannot respire, so person will do the cough, so that the obstruction is relieved. In the cough, person will take the sputum out and spit it so that the obstruction is relieved and person can do the respiration. So in chronic bronchitis, the most important symptom is cough, but not dry cough. It is cough with abundant of expectoration. That is sputum. So patient will come to you, doctor, I'm having abundant of cough with bhar ke sputum. I'm having abundant of sputum. Most of the months of the year, the person cough only, and he is a chronic smoker. And the person cannot respire. That's why the person has cyanosis. Person have dyspnea, person cannot do the respiration, difficulty in respiration. That will lead to cyanosis. Because of the cyanosis, person will look blue in color. That's why these are known as blue blotters. So this is the second symptom, dyspnea leading to blue blotters. So cough and dyspnea are the 2 symptoms here. Say yes if you got it. So this is the disease chronic bronchitis. I hope you got it. So it is a disease of trachea and bronchi. Here there is a problem in the submucosa due to hypertrophy and hyperplasia of the glands, producing abundant secretion. So it is the over secretion of the mucus, of increase of the glands of the submucosa, which are increased in number and size due to smoking. Everyone give me a thumbs up. Are you people live? This is the reason. So microscopy, if I do a biopsy in such person, if I see the microscopy, this is the microscopy. Can you understand the microscopy? Now you can see this is a normal person. Biopsy, the 4 layers of the trachea, and this is the chronic bronchitis, the 4 layers of the trachea. I want you to compare the 4 layers. Compare the mucosa of both of them. See the mucosa here and see the mucosa here. Compare the mucosa of both of them. You can see the mucosa here. Even there is no change in mucosa. Here also pseudostratified ciliated columnar, here also. But there is one change. See how many goblet cell I am having here? 1, 2. But here I am having abundant goblet cell. So goblet cell hyperplasia. Again, due to smoking irritation, the goblet cell hyperplasia is there. So first thing is goblet cell hyperplasia. I can differentiate. Second thing, see the glands here, number and size, and see the glands here, number and size. So compare the submucosa. So main changes in submucosa. There is no change in musculus propria and serosa. Main changes in submucosa. Submucosa. Now I want to explain you the read index. For that I have to draw the 4 layers here, normal, and the 4 layers in the chronic bronchitis. Let me draw. So here I'm drawing the mucosa. Okay, this is mucosa, and here I'm drawing the mucosa. Pseudostratified ciliated columnar epithelium. Goblet cell are more here, I told you. Now I am interested in the submucosa. Let me draw the submucosa over here, and let me draw the submucosa over here. Okay, submucosa. After that, we have musculus propria and serosa. Here also musculus propria and serosa. There is no change in that. But main change is in submucosa. The lower portion of the submucosa contains the glands normally. Hana, this is the lower portion of the submucosa which contains the glands. Now in chronic bronchitis, the glands increase in number as well as size. This is increase in number as well as size. How many of you got it? Now there is an index which is known as Reed index. Reed index. What is Reed index? In Reed index, there is a numerator, there is a denominator. What is numerator and what is denominator? The denominator is the total thickness of the submucosa. This one. This one. So it is same in both of them. The denominator is the total thickness of the submucosa, which is same in both of them. But the numerator is the portion of the submucosa which contains glands. Hana? So here it is this portion. You can see this much. And here it is this much. This much. The portion of the submucosa which contains glands. So numerator is more in chronic bronchitis. The portion which contains the glands. Hana, but denominator is same. So in chronic bronchitis, the Reed index is more. Hana, the Reed index increased. This is the reason. How many of you got it? How many of you got it? Same thing they want to explain you. The Reed index increased in chronic bronchitis and goblet cell hyperplasia. These are the two findings in chronic bronchitis. Patient have cough, which is abundant expectoration, and dyspnea. Because of dyspnea, the patient have cyanosis, which will lead to blue in color, that is blue blotches. Everyone say yes. I hope you got it. I hope you are getting it. We are done with chronic bronchitis. The second COPD is emphysema. See what is happening in emphysema. Chronic bronchitis was a disease at this level, where the obstruction is in trachea and bronchi in chronic bronchitis. It is due to the mucus plug obstructing the trachea and bronchi. Because of the glands, hypertrophy and hyperplasia, we understood it well. Now, emphysema is a disease of acinus. Emphysema is the disease of acinus. People respond. Emphysema is a disease of acinus. The level is exactly different. Hana, it is upper respiratory tract. This is low. I'm sorry. This is the trachea and bronchi, not upper respiratory tract. And this is the last portion of the respiratory tract, that is acinus. So what's the problem in the acinus? What is acinus? Define acinus. If you want to understand emphysema and the types of emphysema, you have to define acinus. What are the components of acinus? Acinus have 3 components. Hana, respiratory bronchiole, alveolar duct and alveolar sac. Let me draw it for you. So let me draw. This is a respiratory bronchiole. Okay. Just suppose this is a respiratory bronchiole. Okay. This is alveolar duct. Okay. From one respiratory bronchiole, multiple alveolar ducts are arising. These all are alveolar ducts. Hana. And these are alveolar sac. From one alveolar duct, multiple alveolar sacs are arising. For example, this is alveolar sac. Now I'm saying emphysema is a disease of acinus. So this is acinus. Hana, multiple acinus fuse with each other. This is emphysema. Multiple acinus fuse with each other. Listen my words very carefully. Okay, multiple acinus fuse with each other, and that is emphysema. You will say, ma'am, which portion is fusing? Just suppose multiple respiratory bronchioles are fusing. So respiratory bronchiole will get dilated. Others are not dilated. So this emphysema is known as centrious emphysema. Centrilobular emphysema. Centriacinar or centrilobular, because the central part is dilated. Others are not dilated. Sometimes this portion is dilated, but not the respiratory bronchiole. Alveolar duct and alveolar sacs are dilated, but not the respiratory bronchiole. So this emphysema is known as distal emphysema. The distal portion is dilated, also known as paraseptal. Paraseptal or distal, one and the same thing. Sometimes all the 3 structures are dilated. It is known as panacinar. Panacinar or panlobular. Panlobular or panacinar emphysema, in which the complete acinus is dilated. And sometimes it's irregular, the 4th one. So there are 4 types of emphysema. What are the 4 types of emphysema? Can you tell me the 4 types of emphysema? So in emphysema, the acinus fuse with each other. The problem is that acinus fuses with each other. Acinus fuses. So which portion of the acinus, depending on that, Hana, which portion of the acinus is fusing with each other? If it is only respiratory bronchioles which are fusing, or is it alveolar duct and alveolar sacs which are fusing with each other? Is it completely all 3 structure, respiratory bronchiole as well as alveolar duct as well as alveolar sac, they are fusing? Or is it irregular? So this one is known as centriacinar. This one is known as paraseptal. Paraseptal या फिर distal, because the distal portion is dilating. This one is known as panacinar and this one is known as irregular. How many of you got it, people? How many of you got it? Understand the types, Hana, the 4 types of emphysema. Now I will tell you the reason. First, this is the 4 types. Centriacinar, centrilobular. Panacinar, panlobular. paraseptal and distal, and irregular. You got the definitions. Here, I told you, here respiratory bronchiole is dilated. That's why the central structure is dilated. So it is centriacinar. Here the distal structure is dilated. That is alveolar duct and alveolar sac, only distal. So it is paraseptal. Here all three are dilated. Respiratory bronchiole, alveolar duct and alveolar sac, all three are dilated. And this one is irregular. Now whenever I teach you multiple types, you must ask me the first question, ma'am, which is most common? Which is most common? Obviously, which is most common in humans? So my answer is irregular. Most common is irregular. But the thing is that it's clinically silent. It don't present. It's clinically silent. Maybe I'm having, maybe you are having, maybe anyone can have, but it don't present. So we don't go and check every day कि मुझे है तो नहीं. So but it is most common, but it don't present clinically. The most common which present clinically is centriacinar. This one. So this one is most common, but it is clinically silent. So you get a question which is most common, answer is irregular. But if you get a question which is most common and clinically present, so answer is centriacinar. So these are the two questions, important questions you must understand. The same thing is shown in the diagram. You can see a acinus. Only central structure is dilated. It's centriacinar. Only distal structure is dilated, not the central. It is paraseptal or distal. The complete three structures are dilated. It's panacinar. And irregular is irregular. So this one is most common but silent, and this one is most common which present clinically. Say yes, people. Samajh mein aaya? Now you must be thinking, ma'am, what is the cause? Why they are fusing with each other? This is the acinus. Why they are fusing with each other? I'm saying they are fusing with each other. Multiple acinus fuse with each other and they form big structures which are known as bullae. Bullae are formed. Multiple they are fusing and they form big balloon-like structures which are known as, all these are fused with each other and they form bullae. So the point is that why they fuse with each other? Why they fuse with each other? That is the reason. That is the question coming in your mind. Why they fuse with each other? Okay. So you have to understand the wall. Okay. In the wall of the acinus, this is the wall. There are two type of enzymes. Protease and antiprotease. Protease, also known as elastase, also known as trypsin, or antiprotease. Antiprotease, also known as anti-elastase or antitrypsin, alpha antitrypsin. So actually protease cause the degradation of the wall, antiprotease protect the wall. Elastase cause degradation of the wall, anti-elastase protect it. Trypsin cause degradation of the wall, antitrypsin protected. So in a normal healthy individual like me who don't smoke, both of them have a balance. They equal and opposite, they balance each other. Protease is equal to antiprotease. Trypsin is equal to antitrypsin. Elastase is equal to anti-elastase. So our walls do not degrade. But some people smoke. I told you, some people smoke. The respiratory tract is not for smoking. But if the people is smoking, smoking does one thing. They decrease antiprotease and they increase protease. They decrease anti-elastase, they increase elastase. They decrease antitrypsin, they increase trypsin. So the degradation is more, and preventing the enzyme which are preventing them are less. So they will degrade, and that's why they fuse with each other. This is the reason. And this is known as protease antiprotease imbalance theory. Elastase anti-elastase imbalance theory, whatever you say. So can you see, this is the person who is smoking. The person who is smoking. See, due to the smoking, antiprotease is decreasing, protease is increasing. So there is a damage. So multiple, they are fusing with each other and they form the bullae. Okay, so this is the reason the bullae are formed. How many of you got it? So these are the 4 types of emphysema I taught you. Please remember the reason and the 4 type of the emphysema. There is one trigger for all of them. You have to learn the trigger. In centriacinar, this is the most common type which present clinically. It occurs in heavy smoker. So smoking is the trigger here. Panacinar, here, panacinar, in which all 3 are fused with each other. Alpha-1 antitrypsin deficiency is the trigger here. Distal wale mein, spontaneous pneumothorax is the trigger. And irregular wale mein fibrosis or scarring is the trigger. So learn one trigger, you get a clue out of that. Most common is the regular but clinically silent. Most common which present clinically is centriacinar. I'm telling you again and again. And this is the histologically, it's the spotter image. You can see multiple acinus are fusing with each other and they form the big spaces which are known as bullae. You can see the broken spurs also. These are the tute-pute broken spurs. How many of you got it? Can I come on the third disease? The third disease is asthma. Can I start the third disease? The third disease is asthma. Say yes. Say yes. So I taught you till now. First one, I taught you chronic bronchitis. The problem is here. The mucus plug is obstructing the trachea and bronchi because of smoking, because of over-secretion of the submucosal glands, hypertrophy and hyperplasia of the glands. Then I taught you the second disease, which is emphysema. Emphysema is a disease of acinus, in which multiple acinus fuse with each other because of imbalance in protease and antiprotease. And there are 4 types of emphysema. There is no further type of chronic bronchitis, but emphysemas of 4 types. And now I'm teaching you the third disease, asthma. Asthma is again a disease of trachea and bronchi. So let me teach you asthma. It's a disease of trachea and bronchi. Hannah. So what is asthma? What is asthma? Define it. What is asthma? We all have heard this term. So, but how many of you know what is asthma? Yes, emphysema is pink puffer. Don't say bloater, city. So pink puffer, you can say. Blue bloater is chronic bronchitis. Emphysema is pink puffer because here cyanosis do not take place usually. It is pink puffer. Listen. What is happening in asthma? Listen. There is over responsiveness to certain stimulus. Different people have stimulation or allergy with different allergens. Some have with dust, some have with pollen grains, some have with particular chemical present in perfumes or anything. Just suppose I am having allergy with the dust, asthma attack with the dust. So if the air contains the dust and I am inhaling it, so the dust will go in my trachea. Hannah, if I'm a normal individual, nothing will happen. The dust will stick on the secretions or the macrophage will engulf it, but I don't have anything. But if I'm having asthma, I'm having allergy for the dust, my trachea will go into bronchocontraction. And the trachea and bronchus will go in contraction, spasm. So trachea will go in spasm and my bronchi will go in spasm to prevent the entry of the dust inside. है ना? So the dust, so body तो हमारा भला कर रही है. The body is doing good for us. The trachea and the bronchi are doing good for us. They want to prevent the dust entry. But since the trachea and the bronchi, they will go in spasm, the person cannot respire. The person have attack of asthma, dyspnea, the attack of the asthma. This is asthma. It is over responsiveness to a particular stimulus. Different people have different stimulus. Hana, it is the over responsiveness to a particular stimulus. Different people have different stimulus because of which, Hana, there is spasm of the trachea and bronchi. This is asthma. Hana, you can see when the dust is entering in a normal person, there is no spasm in the trachea. But if the dust is entering in asthma, there is spasm. There is spasm. You can see. And the person cannot do the respiration. So person have the attack and it's reversible. Either spontaneously in some time the spasm will go, or the inhalers, the pumps, the therapies are available. And the bronchodilators you read in pharmacology. Okay, so there is a triad in the asthma. In the asthma, patient have attack of dyspnea. At the time of the attack, patient have dyspnea, patient have cough, and patient have wheezing. Because the respiratory tract, the trachea is narrowed now. Now if the air is passing through a very narrow lumen, there is that sound which is created, and that sound is known as wheezing. How many of you got it? Asthma is type 1 hypersensitivity. I guess everyone know what is type 1 hypersensitivity. You may have read that. Type 1 hypersensitivity के example में asthma आता है. Now the asthma patient do the cough. If you collect the sputum of an asthma patient and make a smear, है ना? Imagine this is the patient with asthma. Okay, let me draw it a little bit. This is the patient having the asthma, for example. है ना? So this is the respiratory tract. Okay, this is the trachea and this is the bronchi. Now the patient is coughing. So I am collecting the sputum of this patient in a container. I am collecting the sputum of this patient in a container and I am making a smear out of that. So if I'm making a smear on a slide out of the sputum, what I will get? I will get triple C. You get questions on the triple C. What is triple C? Number one, sometimes the cells which are lining the respiratory tract epithelia during the sputum, when the patient is coughing very vigorously, the cells will get degenerated and they will come in the sputum. So I will get the individual cells which are pseudostratified columnar epithelia. These are known as creola body. Creola body is one cell, single cell. Sometimes when the patient cough very vigorously, not one cell, the complete strip, the strip of the mucosa get degenerated and strip ka strip bahar aata hai. I get complete strip of the mucosa. So this complete strip of the mucosa on the slide, this is known as Kochman spiral. Kochman spiral. It is a spiral strip. So if individual cell is coming, it's creola body. If complete strip is coming, it's Kochman spiral. And sometimes we get diamond shaped crystals because of eosinophilia, which is known as charcoal-laden crystals. So it is triple C. What is triple C? Kochman spiral, charcoal-laden crystal, creola body. Creola body is one cell. Kochman spiral is the complete strip and charcoal-laden crystals are the diamond-shaped crystals. I want to show you this in the diagram. You can see in the diagram, you can see this is the strip. The complete strip is coming out. This is Kochman spiral. And you can appreciate the diamond-shaped crystals I'm talking about due to eosinophilia. So these are charcoal-laden crystals. Creola bodies are not shown here. So learn the triple C. Kochman spiral, creola body, and charcoal-laden crystals. They all are seen in asthma sputum. Sputum of asthma. How many of you got it? So you get questions on that. The last COPD I'm coming is bronchiectasis. The last COPD, the fourth and the last in the respiratory tract I'm coming, is the bronchiectasis. So chronic bronchitis occurs at this level. Okay, here chronic bronchitis occur. Emphysema occurs at this level. And you know the reasons also. And the third, asthma also occurs at this reason, at this level. But the reason is different. Hannah, now I'm teaching you the fourth and the last one, bronchiectasis. It's a disease of the bronchioles. As the name indicates, bronchiectasis. It's a disease of the bronchioles. So, it's a disease of the bronchioles. Multiple bronchioles fuse with each other. They get dilated. Hannah, this is a bronchiole. It can be primary, secondary, tertiary. It get dilated. You'll say, ma'am, why it get dilated? The wall of this bronchiole become weak because of infection and inflammation. So the cause is the infection and inflammation and it get dilated. Can you see? These are dilated. The bronchioles, the primary, secondary, tertiary. Bronchioles get dilated. Hannah, so based on the shape, they can be of different type. Hannah, if the multiple dilatations are there, it's known as varicose. If they are parallel dilatation is there, it's known as cylindrical. If it is 360 degree, it's known as fusiform. It's only one side, it's known as secular, but it is dilatation. Dilatation usually occurs in the lower lung. You can see lower lung mein zyada hota hai. So it is at the base of the lung or the lower lung, the bronchiectasis is more common. The cause is only one, due to infection and inflammation, the wall get weak and it get dilated. That is bronchiectasis. Now you can see the gross of the lung. These are the bronchioles. Can you appreciate the bronchioles? They all get dilated. They all get dilated. The bronchioles get dilated. It is looking like honeycomb appearance. Madhumakhi ka chatta. It's looked like that. So you get a question, honeycomb appearance is seen in. Honeycomb appearance is seen in. So answer is bronchiectasis. Honeycomb appearance of the lung. Very important. Okay. And here is a syndrome associated with bronchiectasis. The name of the syndrome is Carter-Jenner syndrome. Carter-Jenner syndrome, please learn. So here bronchiectasis is one of the component. So people having Carter-Jenner syndrome, three things occur simultaneously. Hannah. Now here the main problem, we have cilia. Cilia. What is cilia? I call cilia as broom. झाड़ू. इसको मैं कहती हूँ झाड़ू है ये. झाड़ू. हमारे पास झाड़ू है घर में. You have broom. You do cleaning with the झाड़ू at your home. So the cilia is beating in that direction. Now with the झाड़ू, when we clean our home, we take the dust from inside to outside. We don't take opposite, outside to inside. Nahin. So there is a particular direction of the beating. We take the dust from inside to outside. We don't take the reverse. In the same way, our respiratory epithelia is pseudo-stratified ciliated columnar epithelia. God has provided us झाड़ू. Natural झाड़ू in the respiratory tract. So whenever I am inhaling, the air contains the dust or any foreign particle which should not go inside. The झाड़ू will clear it from inside to outside. For beating of the cilia, a protein is required. The cilia is made up of a protein. It is known as dynein. And this one is mutated here. This protein is mutated. Since this protein is mutated, cilia is non-functional. Here the cilia is non-functional. Since the cilia is non-functional, so patient have frequent bronchiectasis, frequent sinusitis, because now the organisms are entering, bacteria, virus, there is no one to clean them. झाड़ू खराब हो गई तो घर में कचरा होगा ना. If you don't have झाड़ू at your home, so your home is dirty always. So in the same way, the complete respiratory tract don't have the cilia. I mean the cilia is present but it is not functional because the cilia cannot beat. The beating of the cilia is not there. Cilia cannot beat because the protein inside the cilia is mutated. Dynein is the name of the protein. So that protein is mutated. Cilia is non-functional. So झाड़ू is present but it is not functional. So patient have frequent sinusitis number 1. Patient have frequent bronchiectasis number 2. So upper respiratory tract have sinusitis. Lower respiratory tract has bronchiectasis. So sinusitis number 1. Bronchiectasis number 2 in the bronchioles. So these two things are there. Number 3, the patient have situs inversus. What is situs inversus? In our body, the side right and left is fixed. We have the heart little bit on the left side. The apex is tilted towards the left side. We have liver on the right side. So right and left are fixed. Here on the person, everything is reversed. The right organs are the left is right, but person is asymptomatic because relative position is same. Got my point? In this diagram, what I can see this is the right of the person, this is the left. And where is the heart? Where is the shadow of the heart? Where is the shadow of the heart? You can see. I can see the shadow of the heart is little bit towards the right side. So this is, the heart is towards the right side. It is situs inversus or dextrocardia. So heart is on the right side. Dextrocardia is a component of situs inversus. So this is the 3 components along with the 4th component, infertility. Very good. Infertility. So this is the 3 components. The triad mein infertility is not included, but infertility also occurs in Carter-Jenner. So that is Carter-Jenner. Got it? Say yes if you got it and read it. Read it. So let me read it for you. You know, sometimes you feel that waking up in the middle of the night, sacrificing sleep, leaving bed early, skipping TV shows, turning off Wi-Fi, stopping music, canceling plans, and these all things you are currently doing just to study. Don't worry, one day you will feel proud of all these things when you will add a suffix doctor before your name. You will add a prefix, I mean, है ना? So doctor is not a prefix, है ना? It's a supernatural power before your name. So whatever is your name, you are adding doctor before that. It's a supernatural power. People believe you like you are not human now. You become God. You are second to God. There is no one equivalent to God, of course, but people believe you are second to God. So whenever they are sick, ill or diseased, whenever they are in trouble, and they want your help, they want your skills and knowledge to get them healthy again. With your knowledge, with your skills, if you are increasing the quality or quantity of someone's life even one day, your knowledge, skills is worth, your study is worth, and you will feel proud by yourself. Inside you will have a proud feeling. That moment you will feel proud that I have increased the quality or quantity of someone's life by my knowledge, by my skills. I am a doctor. I am a doctor. And now people call you doctor and you will feel blessed because of that. So all these things is worth. Okay, got it? Anyways, chalo, move further. So we are doing the important topics here. Okay, chalo. So let's move to the next unit, CVS. In the CVS, I want to teach you one ultra important topic here. Ultra super duper important topic here. That is ischemic heart disease. You cannot skip this topic here. Cardiovascular system में ischemic heart disease हम पढ़ना नहीं छोड़ सकते. You get many questions out of the ischemic heart disease, also known as coronary artery disease. So let's start ischemic heart disease or coronary artery disease here. So ischemic heart disease or coronary artery disease, it's one and the same disease. Hannah, what do you mean by that? Now see, this is a diagram of heart. I am interested in left ventricle. Can you all see left ventricle? Appreciate the left ventricle. Now when the left ventricle pump, the blood goes in the aorta and the blood is supplied to all the organs. The pure blood, the oxygenated blood is supplied to all the organs. So when the left ventricle is pumping, blood is given to the aorta. Now, why does the left ventricle pump? How does the left ventricle pump, I mean? So in the wall of the left ventricle, we have cells. These are cardiomyocytes in the wall of the left ventricle. So these cells are contracting. When these cells are contracting, the heart is doing systole, the left ventricle is doing systole. So who is providing the energy to these cells for doing the contraction? I mean, this also requires blood now. So from the aorta, there is an artery which is arising. That is coronary artery. We all know coronary artery. So from the aorta, this is the coronary artery which is arising. Can you see? This is the coronary artery. And this coronary artery supplies the blood to the wall of the left ventricle. So you are giving the blood via coronary and heart is contracting and heart is giving the blood to you via aorta. Got my point? So there is a proportion between the two. Hannah. And in the universe, there is a rule. Hannah, not only the heart. In the universe, there is a rule. Whatever you give, it comes back. है ना, तुम जितना दोगे वही पाओगे. Whatever you sow, the so shall you reap. आपने सुना होगा, जो दोगे वही पाओगे, है ना. So in the heart also we are giving a fixed amount of blood via coronary. Heart is contracting that way only, है ना. And heart is giving us the same will be the intensity of contraction. If you give more blood via coronary, heart will contract more blood will be given in the aorta. If you give less blood in the coronary, heart will contract less and less blood will be given in the aorta. You cannot give more, ask for less. You cannot give less, ask for more. Hana, this is the rule. The same is happening here. Now imagine if you are obstructing the coronary. You are obstructing the coronary. Okay. You are obstructing the coronary, so less blood will go in the left ventricle. Hana, you are giving less blood. Heart will also give you less blood. Hana, if it is okay for you, तो ठीक है, काम चल रहा है. But if you ask for more, you are doing an imbalance. You are giving less, asking more. You are giving less, asking more. So, you know, if you are giving less blood, a portion of the cells are not getting blood. Imagine this portion of the cells of the left ventricle, they are not getting blood. If they are not getting blood, they get ischemia. Hannah, they get infarction. They will not participate in contraction. So contraction will be less vigorous and less blood will come in the aorta. So this imbalance is known as ischemic heart disease. Ischemic heart disease or known as coronary artery disease. Since the coronary get obstructed, that is coronary artery disease. And whenever the coronary get obstructed, there is ischemia in the left ventricle. So whenever the coronary get obstructed, at the time the ischemia there is in the left ventricle. That's why coronary artery disease is ischemic heart disease. And the definition of both of them is imbalance. Imbalance between demand and supply. if you are doing imbalance between demand and supply of the heart. What is the demand of the heart? You are giving the blood via coronary. And what is the supply of the heart? You are taking it via aorta. There should be a balance between the two. If you are making the imbalance, you are giving less, asking for more, you are becoming greedy, है ना? You are giving less कि हम तो कम देंगे लेकिन हमको चाहिए ज़्यादा, है ना? So don't be greedy. If you are becoming greedy, the disease is known as ischemic heart disease. So that is the imbalance between the demand and supply. That is a simple funda. Okay, ischemic heart disease. Ischemic heart disease, if you want to understand now, you must understand the coronary, the blood supply. Although this is the topic of the anatomy, but you must understand it here. There are two coronaries, left coronary artery, right coronary artery. Right coronary artery have no branches, it's RCA only. But left coronary artery have two branches. It is divided into left anterior descending LAD and left circumflex LCX. So basically we are having three coronaries. One is RCA, no further branches, and two branches of the left. LAD, that is left anterior descending, and LCX, that is left circumflex. So basically we are having three coronaries. Okay, now let me show you the heart. I'm cutting the heart from here and looking from above, the cross section. So the heart diagram is like this. Okay, we are having two lumens. This is right ventricle. This is left ventricle. Okay, and this is interventricular septum. I'm cutting and looking from above. Say yes. Huh? So in the heart, we are having four walls. This is anterior, this is posterior, this is medial, this is lateral. You can see the four walls, and we are having three coronaries. So tell me which coronary supply which wall? Tell me which coronary supply which wall? I'm asking you simple question. Which coronary artery is supplying which wall? That's what I want to ask. Hana, I'm having three coronary and four walls. Most important, anterior wall is supplied by LAD, left anterior descending. Lateral wall is supplied by LCX. Hana, left circumflex, and posterior wall is supplied by RCA. What about medial wall? Medial wall have a double blood supply. Posterior 1/3 by RCA, anterior 1/3 by LAD. Now imagine if I'm doing the obstruction in the coronaries. If LAD got obstructed, there is ischemia and infarction in the anterior wall. If LCX got obstructed, there is ischemia and infarction in the lateral wall. And if RCA got obstructed, there is ischemia and infarction in the posterior wall. How many of you got it? How many of you got it? Say yes. Aayega samajh mein. Medial wall never get ischemia infection. It is having double, and it's very rare interventricular septum have infarction. So what's the sequence of the obstruction? Most common LAD get obstructed. Second most common RCA get obstructed, and least common LCX get obstructed. So the sequence of the wall having infarction is anterior, followed by posterior, followed by lateral, and medial never have infarction. So this is the question. Please learn most common coronary PP question and most common wall PP. So infarction is most common in the anterior wall of the left ventricle, and the obstruction is most common in the left anterior descending. How many of you got it? So this is the basics. Okay, got it. So same diagram is shown to you. You can see this is left ventricle. See the cavity of the left ventricle. See the anterior wall supplied by LAD. Hana, see the posterior wall supplied by RCA. See the lateral wall supplied by LCX, and see the medial wall, anterior 2/3 and posterior 1/3. They are supplied by LAD and RC. How many of you got it? Okay. Okay. Now there are four effects of ischemic heart disease. It can be angina, MI, chronic ischemic heart disease, and sudden cardiac death. So I'm directly coming on the MI. Angina, I'm skipping, not very important. Directly coming on MI. I already taught you what is happening in the MI. See, the coronary got obstructed. See, the problem is that the coronary got obstructed. That is the problem. Now, what is the cause of the obstruction of the coronary? The coronary is obstructed, so you are giving less blood to the wall of the left ventricle. Hana? So whatever coronary is obstructed, LCA, RCA, or LCX. So that corresponding wall will not get the blood. If LCA is obstructed, anterior wall will not get blood. If RCA is obstructed, posterior will not get blood. And if LCX is obstructed, lateral will not get blood. So that wall, the cells of that wall undergo infarction. Just suppose this is the portion, it is infarcted. It will not participate now in contraction. So that is MI. This is irreversible cell death. You know, coagulative necrosis happens. Yesterday, I taught you the 5 types of necrosis. I told you if ischemia occurs in any organ, there is coagulative necrosis of that cells of that organ, except brain, which is having liquefactive necrosis. So heart may coagulative necrosis is happening. Say yes if you got it. Come on, fast. Okay, so here you can see this is the thing which is happening. Now, what is the cause of obstruction of coronary here? The coronary, there are three causes. Most common, it can be atherosclerosis in the coronary, which is obstructing. There can be thrombus in the coronary, which is obstructing. And there is vasospasm in the coronary, which is obstructing. So these are the three causes which is causing obstruction in the coronary. Now, there are two types of infarcts you have to understand. Please understand. One is subendocardial and one is transmural. What do you mean by that? What do you mean by that? Okay, let me zoom this portion. Let me zoom this portion, the left ventricular wall. Can you see this is the wall of the left ventricle? This is the lumen of the left ventricle contain blood. This is the lumen of the left ventricle contain the blood. Now this is the wall of the left ventricle. In the wall of the left ventricle, we are having 3 layers. Endocardium. This is endocardium. Anna, this is complete myocardium. This is myocardium. Okay, and we have pericardium. This is pericardium. Endomyoperi. Anna, we divide the myocardium into 2 portions. Anna, inner and outer. Inner and outer. Inner is just below the subendocardium. It is known as subendocardial. Subendocardial myocardium because it is below endocardium. And this one is below pericardium. It is known as subpericardial. Subpericardial. So myocardium we are dividing into 2 portions, inner and outer. Now let me draw the coronary. So this is a coronary artery. And it is supplying the blood to the wall of the left ventricle from outer to inner. The small coronaries enter like this from outer to inner. I am doing obstruction in the coronary. This is the obstruction. Okay. So less blood will go in all these. Hannah, now I'm asking you a question. Which portion of the heart have infarction first? The myocardium, inner or outer? And why? Inner portion will have the infarction first or outer? And why? The coronary got obstructed. I'm asking you, use your common sense and tell me the answer. Huh? If the coronary got obstructed, agar coronary obstruct nahi bhi hai, if the coronary is not obstructed, the inner portion is getting less blood because the end artery. Yahan tak blood pahunchte it's very less. It is the end artery. And now sone pe sohaga, the coronary is obstructed. So inner portion is most commonly compromised. First. So infarction always start from inner side in the subendocardium. So infarction start from the subendocardium like this. Let me show you. Infarction start from the subendocardium like this. It start like here. And gradually within 24 hours it progress and involve the complete thickness. So there are 2 type of infarction. First 24 hour it's subendocardial and later on it's transmural. Transmural mein complete wall is involved. How many of you got it? So you can see only inner portion is involved. Okay. It's subendocardial. Within 24 hours. But after 24 hours it's complete wall. It's complete wall through and through. It's transmural. I hope you got it. That is the 2 type of infarct. Now coming on the microscopy, which is more important. Gross and microscopy. Imagine a person. You can imagine there is a person who is dead. And what is the cause of the death? We are suspecting the cause of the death is MI. At the time of the death, the person have chest pain and after that the person is dead. There is another person who is giving this history. That person was with me and he was dead. He was having chest pain. But the police is suspecting some foul play. Maybe this is not the cause of death and something else is there. So the body is coming for the postmortem or autopsy and I am the doctor who is performing postmortem on this. So what is my responsibility? My responsibility is to take the heart out. Cut the heart thoroughly. I will cut the heart, the left ventricle especially, into multiple slices, each 0.1 centimeter apart. So I'm having hundreds of slices. I will examine each and every slice and look for the infarct. So I will see whether infarct present or absent. Based on which the police will do the inquiry and all. It will do the further process. So I will make my postmortem report, autopsy report, medical legal cases. So we will say, am I present or absent? For example, I got the MI grossly. In one of the slice, I will see all the slices. Each slice will be like this. In each slice, there is right ventricle, there is left ventricle. So I have to take each and every slice. I'm having hundreds of them. Each and every. And I will examine all the walls, all the 4 walls of the left ventricle. Infarct can be here, can be here, can be here, can be here. We know the sequence. Rarely it is on the medial, but the other 3 walls we have to examine with a magnifying glass. So we do so. So if I got the infarct, it is not only presence or absence. We have to tell the age of the infarct. Maybe the infarct is present, and this MI is 10 years back. Now the cause of death is something else. So this infarct is 1 hour old or 10 days old or 1 day old or 10 years old. We have to tell the age. For telling the age, we have to make the slide. So for example, this is the infarct. So this is the infarct over here. This is the infarct. So we have to cut and make a slide. On the slide, we can tell the age. So this is the table. I'm not reading it, but you divide it into 10 time zones. And looking at the description, at the diagram, you can tell the age of the infarct. You want me to tell this? You frequently get questions on the aging of the infarct. Okay, I will tell it quickly. So what is the age of the infarct? Okay, age of infarct. So we divide it into 10 time zones. What are the 10 time zones? 0 to half hour, half to 4 hour, 4 to 12 hour. This is RRR. 12 to 24 hour. So this is 4 times RRR. 24 hour means 1 day. 1 to 3 days, 3 to 7 days, 7 to 14 days, and 10 to 14 days. This is all days. 14 days means 2 weeks, 2 to 8 weeks, and more than 2 months. Got it? During the first 30 minutes, you don't get anything. It's normal. absolutely normal. You missed infarct. If you are doing autopsy within 30 minutes, you are taking the heart out, you miss the infarct. You will find it's absolutely normal. You will not find infarct at all. The morphology is normal. So after 30 minutes to 4 hours, you will get waviness. What do you mean by waviness? See the lower half of this diagram. Can you see the lower half? In the lower half, you can see the cardiac cells are present. I can see the nucleus of the cardiac myocytes. I can see the striations. The only thing, instead of straight, they are wavy. They are wavy. This is waviness. They are normal, but only problem, they are wavy. So waviness is the earliest finding. It's the MCQ. In MI, the earliest finding is waviness, and it is after half an hour. Half hour to 4 hour. It's waviness. It's waviness. Say yes. Got it. After that, 4 hours to 12 hours, there is coagulative necrosis. Necrosis start. Can you see the upper half? Upper half. So you can see what is coagulative necrosis. Yesterday I told you the margins are maintained, the outline is maintained, architecture is maintained, but cytoplasmic and nuclear details are lost. You can see the fibers the cells have only outline. The outline are still maintained, but inner cytoplasmic detail is lost, nucleus is lost. So it is coagulative necrosis. It is coagulative necrosis. Now after coagulative necrosis, after 12 hours, few neutrophils will also come. You can see the same diagram. You can see all these cells are neutrophil. They all are multilobated. Few neutrophils are coming. And after 1 to 3 days, along with coagulative necrosis, abundant neutrophils are coming. See the next diagram. Coagulative necrosis is still there, but abundant neutrophils are there. Non-neutrophils will fall and macrophage will start coming. At day 3, the macrophage will start coming. Some of these cells are macrophage. You can see this one. They are not multilobated. They are macrophages. Macrophages are phagocyte. They started eating the dead muscle. Can you see the dead muscle of the upper portion is eaten by the macrophage. Lower portion is still having it. So the dead muscle, the coagulative necrosis is eaten by the macrophage, and this is granulation tissue which is formed. So granulation tissue formed at the margin, then complete granulation tissue, finally collagen and scar. So this is a time zone. Everything will go and finally scar will be formed. Collagen and scar. Finally. So this is the 10 time zones on which you get the questions. So help me. So write down the 10 time zones first. How I learn. Can I tell you? R. Then day. Okay. Then week and then month. This is 10. Count. You can count. It is 0 to half hour. Half to 4 hour, 4 to 12 hour, and 12 to 24. 24 hour means 1 day. Okay. So 1 to 3 day, 3 to 7 day, 7 to 10 day, 10 to 14 day. 14 day means 2 week. So 2 to 8 week. 8 week matlab 2 month. More than 2 month we cannot differentiate. Whether it is 2 month, 2 year or 10 year or 20 year, we cannot differentiate. Sab kuch scar hai. Got it? So this is the 10 time zones. Now tell me the answers. It's very easy. If you don't change the sequence, it's very easy. It's very easy. First is normal. Okay. Then waviness. Okay. Then only coagulative necrosis. Then coagulative necrosis plus few neutrophil. Then coagulative necrosis plus abundant neutrophil. Then macrophages. Once the macrophages will come, they eat the dead muscle. So granulation tissue at the periphery, granulation tissue completely, collagen, and finally scar. This is how I learned. I don't change the sequence. I know the side sequence. Now you get many questions. Believe me, I don't have time to show you the question, but I wish if I could. They give you question. Tell me the time zone when first time neutrophil appear. So answer is 12 to 24 hours. Tell me the time zone when first time macrophage appear. So answer is 3 days, 3 to 7 days. These are 2 most frequent asked questions. And they get you, tell me the first time granulation tissue is appearing. It's 1 week. So you get 4 options from the time zone. If you don't know this, the earliest finding is the waviness. It's very important question. And finally scar is formed. So these are the frequent questions you get from this portion. And it's a difficult portion, I think. Yes or no? So this is the thing. Now, how you do the diagnosis of MI? How you do the diagnosis of MI? There are 2 ways to diagnose the MI. Number 1, ECG. We see the ECG changes. You know, PQRST is there in the normal ECG. There are 3 changes. Either ST elevation is there, see, or T inversion is there. Normal T is a positive way. Here it got inverted. Or deep Q. Normal Q is very small. Here it is deep Q. So ST elevation, T inversion or deep Q. That will show the diagnosis of MI. The second thing is the cardiac marker. What are cardiac markers? This is the left ventricle. Okay, this is the left ventricle. What is MI? A portion. No, it is having cardiomyocytes everywhere. The left ventricular wall. It is having the cells. What is MI? Some portion. The cells are dead because they are not getting the blood. The coronary got obstructed and this portion is not getting the blood. So cells of this portion are dead. How they are dead? It is having necrosis. Yesterday I taught you na necrosis. I taught you na. So the cells are ruptured. In necrosis, the cell burst. It's a murder. Apoptosis was suicide. This is murder. Cell got ruptured. Since the cells got ruptured, there are 5 enzymes present in the cells that will leak in the blood. 1, 2, 3, 4, 5. And if I collect the blood sample in a test tube, I will get the 5 enzymes are elevated. These are known as cardiac markers. In the cardiac markers, I simply take the blood sample in a test tube. If the patient is coming with chest pain, I will take a blood sample. Quickly, I will take a blood sample in a test tube and check for the 5 enzymes. If they are raised in the blood, it means the patient is having MI. This is an indirect indication of the MI. That is cardiac marker. Now, what are the 5 enzymes? Can you name them? Myoglobin, CPK-MB, troponin T or I, SGOT, and LDH. Most specific. The earliest to come is myoglobin. It's a question. It will come within 2 hours. So patient have chest pain. If it is MI, within 2 hours it will come in the blood. When the cell bursts, सबसे पहले यही आता है. Myoglobin, earliest to come. Very important question. PYQ. But most specific is troponin T or I. Troponin T or I. Both the troponins, T or I. It is the most specific. Okay. So that's all about it. How many of you got it? How many of you got it? So this is also an important question here. Okay, got it. Now the next and I guess the last topic I'm teaching you here is the meningitis. Okay, one of the important topic I'm teaching you here is meningitis. Okay, now central nervous system have brain and spinal cord. The brain and spinal cord are covered by 3 meninges. You know the 3 meninges. We have pia meter, the innermost one, red color. The middle one is the arachnoid and outermost is dura meter. If there is inflammation in any of them, it is known as meningitis. Meningitis is the inflammation of the one of the 3 meninges. There are 3 types of meningitis. What are the 3 types of meningitis and how to differentiate between them? One is a bacterial meningitis, which is acute bacterial, also known as pyogenic, because bacteria form the pus. It's acute. The second is viral. Viral is also acute. It is also acute. And in virus, lymphocytes are raised. That's why viral is known as lymphocytic. This one is known as lymphocytic. Okay, and third one is chronic. Okay, so acute bacterial, acute viral. But chronic kaun karayega? Chronic is caused by one bacteria. The name is TB, Mycobacterium tuberculosis, and one fungus that is known as Cryptococcus. So either tubercular meningitis or cryptococcal meningitis. So first learn the 3 types of meningitis. Acute bacterial meningitis, also known as pyogenic. Acute viral meningitis, also known as lymphocytic. And the third one is chronic meningitis, that is tubercular or cryptococcal. Now what is the treatment of them? If this one, you will give antibiotic as a treatment. If this one, you will give antiviral as a treatment. If this one, you will give DOTS as a treatment. If this one, you will give antifungal as a treatment. So before treating the meningitis, it's important to know the type because treatment is different. You cannot give same treatment in all of them. All of them, the 4 have different treatment. Come on. If this and you are giving this as a treatment, the patient will die. You have to diagnose it before you give the treatment to the meningitis. How to do the diagnosis? Take CSF out. There is no blood test for meningitis. You have to take the CSF out by doing a lumbar puncture. You know how to perform a lumbar puncture? In the lumbar puncture from L3, L4 vertebra, we aspirate the CSF out in a test tube with the help of a lumbar needle. So in the CSF, the symptoms of all meningitis are same. Patient have headache, patient have fever, patient have neck stiffness. On forward bending of the neck, patient have irritation, patient have stiffness here. And sometimes changes in the mental function is there. So symptoms are same, but still you have to differentiate the 3 types: bacterial, viral, and chronic. Because treatment is different in all of them. I hope you are getting why it is important to differentiate the 3. So let me tell you the difference. So you are taking the CSF out. Normal CSF is clear and colorless. In bacterial, it becomes cloudy. Can you see like this? It's cloudy. It's cloudy because of the pus. You see the test tube is cloudy. The CSF is cloudy. It's not clear like water. It's cloudy because bacteria form pus. In viral one, it's again clear. Clear like water. You cannot differentiate the normal and the viral. It's clear. And in chronic one, on standing, it will form a cobweb. Can you see on standing, it is forming a web-like thing. It is known as cobweb because of the fibrin. It is forming the cobweb. So see, this one is purulent. This is bacterial. Write down bacterial here. This one is viral. The viral is having clear. And the chronic is forming the cobweb. Say yes if you got it. So you have to see the external appearance. The pressure, normal CSF have 150 mm of water. This is the maximum pressure. Normal CSF, currently the humans have. It is elevated in all 3. Don't learn the values, it is elevated in all 3. It is elevated. Now see the cells. Normal CSF have lymphocytes, 0 to 4 lymphocytes. Normal CSF have lymphocytes, 0 to 4 lymphocytes. In bacterial one, if you make a slide See, all the cells are neutrophils. You can see they all are multilobated. Bhar ke neutrophil hai. Bhar ke. How much? It is है ना 100 to 10,000 neutrophil per microliter. Normally it's 0 to 4 lymphocyte. Even a single neutrophil is abnormal. Even you are getting one neutrophil in the CSF, it's abnormal. The person is having bacterial meningitis. But the viral and the chronic, they also have lymphocyte like normal. Here also lymphocyte, here also lymphocyte. You say normal also have lymphocyte, but see the number is different. Normal have 0 to 4 per microliter. In viral one, it's 10 to 100. And in chronic one, it's 100 to 10,000. It's 100 to 1,000. So it's lymphocyte, but the number is different. I hope you are getting it, Hannah. So here, if you make a slide, it's lymphocyte, and here also there is no slide. But if you make it, it's lymphocyte only. Okay, so it's lymphocyte. So here we have neutrophil, and the next two we have lymphocyte. Now see the glucose and the protein. The next is you have to look for the glucose and the protein, Hannah. Now in bacteria one, the glucose will fall and the protein will rise. In chronic one also, the glucose will fall and the protein will rise. And here both are normal. In the viral, both are normal. Why? What is the reason? So suppose this is the bacterial, the CSF containing the bacteria. So where is the bacteria? This is the bacteria present in the CSF. Hana, bacteria eat glucose. It is a nutrition for the bacteria. The glucose present in the CSF is consumed by the bacteria. It is consumed by the bacteria. Okay, it is consumed by the bacteria. So if you see the glucose level, it will fall. Hana. Now the bacteria have the cell wall. All bacteria have cell wall. It is made up of protein. So if you measure the protein over here, the cell wall will also contribute in the protein. So cell wall will rise. So glucose will fall because it is consumed by the bacteria, and protein will rise because cell walls are also contributing in that. So that's why the glucose fall and protein rise. Maximum questions based on this. But viruses don't eat glucose. That's why it's normal. Viruses don't have cell wall. That's why this is also normal. So this is the difference based on which you get many questions on meningitis. For TB, if you're suspecting TB, there is a special stain, acid-fast stain. And if you're suspecting cryptococcus, there is a special stain that is India ink or negative stain. I hope you know this in microbiology. Say yes if you got it. So main is the cells, which is differentiating the three. Here we have neutrophils, here lymphocyte, but the C number is different. Normally also we have lymphocyte. So let's come on the renal system. In the renal system, I'm teaching you an important disease that is polycystic kidney disease. Okay, also known as renal cystic disease or PKD, polycystic kidney disease. So it's a disease. It's a disease in which entire kidney. This is a disease in which entire kidney converted into the cyst. Can you see the entire kidney converted into the cyst? Okay, Hannah. So it is of two types. It can occur in infants. It can occur in the adult life, Hannah, in 30 to 40 years of age. This is adult PKD. And it can occur in infancy during 1 year, first year of age. So it is infant PKD. Hannah, it is of two types, infantile PKD. So adult PKD and infantile PKD. This one is autosomal dominant. That's why known as autosomal dominant polycystic kidney disease, ADPKD. And this one is autosomal recessive. That's why known as autosomal recessive polycystic kidney disease, that is ARPKD. So in both of them, the thing is same. The kidney get converted into cyst. Due to the mutation. I will tell you the exact mutation also. Hannah, here the cysts are spherical. Hannah, the complete kidney converted into multiple spherical cysts, as small as 0.5 centimeter, as large as 4 to 5 centimeter. Here the kidney converted into cysts which are cylindrical. The cysts are cylindrical here. That's why here the kidney look like sponge-like appearance. The cysts are running from cortex to medulla. So here the cysts are spherical. Here they are cylindrical. Here the outer surface of the kidney. If you look the outer surface of the kidney in both of them. So here the outer surface of the kidney is bossolated. And here the outer surface of the kidney is smooth. So you have to learn this is adult, this is autosomal dominant, this is infantile, this is autosomal recessive. Here the cysts are spherical and here the cysts are elongated, having sponge-like appearance. The complete kidney is gone. Both are bilateral. It also occurs in both kidney. But the mutation is different. You have to learn the exact mutation. Got my point? You have to learn the exact mutation in both of them. This one occurs in adults, this one occurs in children. Okay, this occurs in 30 to 40 years of age. And this one occurs in the first year of age, infantile. Hannah, let me tell you the mutation in both of them. Okay, so Hannah, here I am drawing the adult one, ADPKD. And here I am drawing the infantile one, ARPKD. Hannah, this is the cell of the kidney. This is the nucleus of the kidney. You know there are 23 pairs. Here I am interested in pair number 16 and pair number 4. And here I am interested in pair number 6. First learn the number of the chromosome. Total 23 pairs में से कौन सा pair, which pair is involved in which one? Which pair is involved in which one? So on chromosome number 16, there is a gene. The name of the gene is PKD1 gene. This is mutated. On chromosome 4, there is another gene PKD2. So if any of them is mutated, it will lead to adult. PKD1, PKD2. PKD1 present on 16, PKD2 present on 4. Please learn that. And here only one gene is present, PKHD gene. It is not 1 and 2. PKHD1, which is present on 6. If it is mutated, it will lead to infantile 1. How many of you got it? So please learn the number of the chromosome. Hana, number of the chromosome is 16 and 4 here and 6 here. Here two genes are present, PKD1, PKD2. Here PKHD1 is present. Hana, this one occurs in adults, this one occurs in infantile. This one is autosomal dominant, this one is autosomal recessive. Hana, here the cysts are spherical and here the cysts are cylindrical, that's why giving a sponge-like appearance. Here it is associated with Barry's aneurysm also and cyst of other organs also. Here it is not associated with others. Okay, so this is the two types of PKD I taught you and you get many questions out of that. Say yes. Got it. Got it. What else topic you want from my side? One last topic I want to teach you here is just a second. Yeah, RCC. Very important. Frequently you get questions on the RCC. So renal cell carcinoma, the kidney tumors, renal cell carcinoma. There are 4 types of renal cell carcinoma. 4 types of RCCs are there. Clear cell carcinoma, papillary carcinoma, chromophobe carcinoma, and duct of Bellini, collecting duct carcinoma. Okay, let me explain you. Okay, so this is a nephron. You know the parts of a nephron? There are 5 parts of nephron. This is glomerulus. This is proximal convoluted tubule. This is loop of Henle. This is distal convoluted tubule. This is collecting duct. So I am teaching you the 4 types of cancers. The first cancer, clear cell. This is the most common. Clear cell arises from PCT. Okay, the second type, papillary, arises from DCT. These सब questions हैं. Papillary arises from DCT. The remaining 2, that is collecting duct, so obviously it is arising from collecting duct, Bellini, and the chromophobe also arises from the collecting duct. So these 2 arises from the collecting duct. So see the point of their origin from the nephron in the kidney. The 4 type of the cancers. This is most common. This is second most common. This is third most common. And this one is least common. Okay. So learn their common things and learn the type of RCC. I'm coming on nephrotic also, Mega. If you wish, I assume ये तुम्हें पता होगा. But if you have confusion, I will summarize. Okay. Let me first finish it. Okay. So there are 4 type of RCC. So first type of RCC is clear cell RCC. It is the most common type. Most common. It arises from PCT. I told you. Why clear cell is known as clear cell? Because in the diagram, most of the cells have clear cytoplasm. The cytoplasm is neither pink nor blue, neither eosinophilic nor basophilic, neither pink nor blue. It is clear because it is having abundant glycogen in that. So you get question on the glycogen. It is having abundant glycogen in that. The mutation is there in the chromosome number 3. There is a gene which is known as von Hippel-Lenido gene. So it is due to mutation in VHL gene present on chromosome 3. So learn the chromosome. Okay, the second is the papillary. The second type is the papillary. Okay, papillary. It is the second most common type. It arises from DCT. It arises. Why papillary is known as papillary? Because the tumors are originated in papilla, the finger-like projections. That's why it is known as papillary. Here, Samoma bodies are common. Samoma bodies. The third is the chromophobe. And it arises from the collecting duct I told you. And here the main feature is, you can see the tumor cells. And in the tumor cells around the nucleus, this is the tumor cell, this is the nucleus. Cytoplasm is present at the periphery. Around the nucleus, there is a clear halo. It's known as perinuclear halo, which is a unique feature here. Perinuclear halo. And last is chromophobe. It is the least common type arising from the collecting duct. Got it? Say yes if you got it. Megha is asking for the nephrotic syndrome. Let me explain. It's also very important although. Okay, so let me explain nephritic syndrome and nephrotic syndrome. Please understand, it's ultra important, which I'm going to teach you. It's very confusing topic, but I will make very simple for you. Nephritic and nephrotic syndrome is a collection of clusters. It is not one symptom. There are many types of glomerulonephritis. I will give you a table of glomerulonephritis. Just revise that table before going to your exam. The light microscopy, electron microscopy, and immunofluorescent microscopy of the main type of glomerulonephritis. So some glomerulonephritis present as nephritic, some present as nephrotic. So nephritic and nephrotic syndrome is not one disease. It is a cluster of disease. So here patient have 5 symptoms. Here also patient have 5 symptoms. Which 5 symptoms? So I will explain you both of them with the help of the diagram. Let me draw the urinary tract in humans here also. And let me draw the urinary tract here also. So this is the 2 pair of kidneys I am drawing with the ureters, bladder and urethra. You can see this is the urinary tract I'm trying to draw, है ना? And this is the aorta, and these are the renal arteries I'm trying to draw, है ना? Let me explain what is the difference between them. See, concentrate. I will say only once, I will not repeat. Please concentrate. That's why. Okay. Nephritic syndrome. Hana. Now, humans have a pair of kidney. You can see the pair of kidney. Inside each kidney, 1 million nephrons are present. Hana. Total, each human have 2 million nephron in each kidney. Nephron is the structural and functional unit of the kidney which does the excretion. Hana. Here inside the nephron, the glomerulus of the nephron get damaged. Hana. Normally, the glomerulus is like a channi. You know, sieve. Chai chante ho? Huh? You use a sieve while you चाय को छानने को क्या कहते हैं, you know, we make tea और उसको चाय को छानते, it's like a sieve having the small holes in that. So glomerulus filtration barrier is like that only. Have you ever thought अगर चाय की छन्नी के छेद बड़े हो जाएं तो, I don't know how many of you understand Hindi or don't understand Hindi, if the holes of the sieve get bigger, so whatever substance we do not want to filtrate, that also come in the filtrate, है ना? So normally if we are using a sieve and we are filtering something with the help of a sieve, है ना? So protein do not come in the urine, RBC do not come in the urine, है ना? The tea is the urine I'm comparing. It's a bad simile, but you can compare. If we are making a tea or we are using the filtration during making a tea, so chai patti is upward in the sieve and the tea is below. So this is the urine which is collecting in the woman's capsule, है ना? So if the sieve holes are bigger, so protein and urine will also come in the urine, Hana. So that is nephritis. So here the glomerular filtration barrier, the holes are bigger. The glomerular filtration barrier is damaged. So urine have blood, that is hematuria. RBCs are coming in the urine. Number 2, urine have protein in it. That is proteinuria, but mild, not much. Proteinuria. So first is hematuria, second is proteinuria. Number 1, hematuria, proteinuria, write down mild here. Mild proteinuria, number 2. Number 3, kidney stop functioning. What is the function of the kidney? To excrete the sodium and water. So no sodium excretion, no water excretion. So sodium water retention. Sodium and water retention because kidneys are non-functioning. Now more sodium, more water, patient have edema. The cause of edema is sodium water retention. Patient have edema over the body, especially around the eyes. Edema is there. Number 4. Okay. Now more sodium, more water. My blood have more sodium. My blood have more water. Normally 5 liter, instead of 5 liter, I'm having 5.5. I'm having 6 liters. So my pressure will be more, blood pressure. So hypertension. Patient have hypertension. And since the kidneys are not functioning, urine is not coming out or less urine is coming out. Patient have oliguria. You all can understand if you understood the disease. So these are the six symptoms which are present in nephritic. Say what things are present in nephritic. Summarize them. Nephritic में क्या है? Say ma'am, hematuria, है ना, blood in the urine. Proteinuria, mild protein is in the urine. Sodium water retention. Since sodium water retention, it leads to edema, it leads to hypertension. So cause of edema and hypertension is sodium water retention. And next is oliguria. How many of you got it? Give me a thumbs up. Got it? Coming on the nephrotic syndrome. What is happening in the nephrotic syndrome? Here, RBC don't come in the urine. Hematuria is never present. No, hematuria is absent here. RBC never come. Hana? That is the thing which is differentiating the two. Here, hematuria is absent. But proteinuria is there. But proteinuria is severe there. I mean, massive proteinuria. Abundant of protein, especially the albumin is excreted out. So proteinuria is massive here. Massive proteinuria is there. Most of the protein is excreted. It is albumin. So in the blood, there is less albumin. So in the blood, albumin will be less because most of them is excreted in the urine. It is hypoalbuminemia. You will say, ma'am, yahan kyun nahi tha? Here also protein is excreted, na? But here it's mild. It will not lead to hypoalbuminemia. But here it is hypoalbuminemia. Albumin will be less in the blood. Since albumin is less, the oncotic pressure is less. Oncotic pressure is less and that will lead to edema. So here also edema is there, but the reason for the edema is less oncotic pressure. That is hypoalbuminemia. Here also we have edema, but the cause of edema is sodium water retention. These are 2 questions, 2 MCQs. The cause of the edema is here is sodium water retention and the cause of edema here is hypoalbuminemia. The third thing is here is hypoalbuminemia. How many of you got it? Now here is the liver. Since most of the albumin is lost in urine, liver will try to compensate. Liver make protein, na? Liver will try to compensate कि मैं बना के थोड़ा दे देता हूँ because most of it is lost in the urine. So liver is trying to help us to compensating us in nephrotic syndrome. But liver चाह तो रहा है help करना बेचारा, लेकिन वो नुकसान कर देगा. Liver try to compensate. It is trying to help the body. But instead of making albumin, it is making lipoprotein. It is making lipoprotein. Lipoprotein is also protein. Lipoprotein is VLDL, HDL, LDL. Lipoprotein is more. So patient have lipidemia and lipiduria. Most of the lipid in the blood is more and lipid is excreted in the urine, lipidemia and lipiduria. So these are the features of nephrotic syndrome. Please learn the features of nephritic and nephrotic syndrome. Okay, tell me the most common cause. What is the most common cause of nephritic syndrome? The most common cause of the most common cause of nephritic syndrome is rapidly progressive glomerulonephritis, RPGN. Please learn that. And most common cause of nephrotic syndrome is different in children and adults. In children, the answer is minimal change disease. And in adults, the answer is focal segmental glomerulonephritis. Okay, so thank you so much. I hope you enjoyed the session, Hannah. And my best wishes are always with you, Hannah. So all the FMG aspirants, Hannah, I try to compact the pathology, the general, the hemat, and the systemic as much I can do in the 8 to 10 hours, Hannah. So I tried my best. Hopefully the session was useful yesterday and today for you. I request you to share the link of this session to all the FMG aspirants in your contact, or any medico who want to study the compact version of the pathology, who want to revise all the important things of the pathology in short duration of time. So there are 2 links in part 1, which I have taken it yesterday. So there is general, and in today's session it is hemat and systemic. My best wishes are always with you, and just get selected, just get clear your exam, licensing exam, this attempt only. So once you get cleared your exam, don't forget to contact the team and contact us, and just drop a message that you got cleared your exam. So it's very happy feeling for an educator when the educator sees such a message from the student. Thank you so much. Thank you so much.